Good morning, students. Welcome to the Fmge Marathon for January 2026. Please tell me if you can hear me and see me. I'm waiting for some of you to join in so that we can start and race through the marathon. Pura psychiatry cover करेंगे and आज rest of the day में ophthalmology and microbiology cover हो जाएगा. तीन subjects. PDF आप लोगों के पास होनी चाहिए. At this point, we are going to go through the PDF. Attendance, are you here? Psychiatry कौन पढ़ने आया है? Hi, Dr. Amit Singh. Hi, Guiding Hands. Notes तो मिलेंगे पर पहले पढ़ाई तो कर लें. PDF तो आपके पास डाउनलोडेड होनी चाहिए. We've shared the PDF जिससे हम पढ़ाने वाले हैं आपको मैराथन. Perfect. So we'll follow along, right? I want to know the preferred language. Do you want to keep it English? Do we want to keep it only and only English? I'd like to hear from most of you, please. It's enough to clear FMG. Yes, enough to clear psychiatry FMG for sure. And the other teachers are also trying their best to give you the most compact information in the shortest period of time. So definitely pay attention, follow along. Hi, Dr. Amit Singh. Hi, Urban Entertainment. No PDF is available. English, only English. Okay, let's see how many say English, how many say only English, how many say English. Dr. Vanish says English. Somebody says English. Now I'm confused, English or English. How about we keep it English with more English? ठीक है? थोड़ा बहुत Hindi, but बहुत सारा English. Will that work for most of us? Perfect. Who's feeling extremely confident about psychiatry already? Who here feels that psychiatry is sorted, boss? I know enough. Give me a thumbs up. Psychiatry is sorted. Then I will really like for you all to answer. Psychiatry is sorted? Till when it will be? Till 3 o'clock? We can wrap up early अगर आप answer देंगे तो. अगर आप लोग आंसर देंगे नो कन्नड़ा नो भोजपुरी आई कैन स्पीक मराठी आई कैन स्पीक बंगाली आई कैन स्पीक लिटिल बिट ऑफ पंजाबी आई कैन स्पीक हिंदी इंग्लिश तो हिंदी इंग्लिश में फोकस कर रहे हैं अभी कूल सो पीपल हु आर रेडी लेट्स स्टार्ट परफेक्ट सो लॉट ऑफ थम्स अप कमिंग थम्स अप प्रिपेयर्ड फॉर साइकाइट्री बढ़िया टेस्ट करते हैं नॉलेज पहला सवाल आपकी स्क्रीन पे यहां पेश हो रहा है द मोस्ट favorite topic of a lot of examiners, I wonder why, is alcohol withdrawal. सबको alcohol withdrawal आता है, right? Let's start with alcohol withdrawal. Imagine a person comes to your OPD and he says, doctor, I drink regularly. And you ask, when was your last drink? And he says, my last drink was 6 to 8 hours ago. And he's showing certain features of withdrawal. What are those features of withdrawal that you will see that qualify for alcohol withdrawal, for mild alcohol withdrawal? Tell me the features. I'm waiting for your answers, guys, because आप लोग कह रहे हैं कि आपको आता है. So I really want to hear from you all. Handwriting पे comment मत करना, मेरी बहुत अच्छी नहीं है. डॉक्टर होने का रूल नंबर 1 बैड हैंड राइटिंग राइट सो लेट्स स्टार्ट व्हाट हैपेंस इन अल्कोहल विड्रॉल इन द माइल्ड stages the patient has had alcohol last drink about 8 hours ago what kind of symptoms will they present great tremors what else आप लोग मुझे मदद करेंगे what else autonomic symptoms correct autonomic symptoms What are the autonomic symptoms? Tremors, sweating, tummy issues. Tummy will start running, right? Palpitations, good. What else? What other autonomic symptoms? Vomiting, anxiety, BP fluctuations, right? Okay, good, good. So this is the mild stage. Now in this stage, definitely the patient has had the drink 6 to 8 hours ago. Let's move on to the heart rate goes up, right? Let's move on to 12 to 24 hours. What happens in the second stage? That is the moderate stage of withdrawal. The patient has had alcohol about 1 day before. 24 hours means 1 day before, right? Now what happens to the patient? Chaliye, you guys will answer for me. A very specific thing happens here called alcoholic hallucinosis. What does that mean? The patient, yes, hallucinations with clear orientation. The patient may have hallucinations, but his orientation is clear. That is alcoholic hallucinosis. Now we are talking about 2 days later, the patient has come to you and he is in more severe withdrawal. What are likely to happen in the more severe withdrawal? Good. Alcoholic hallucinations nahi, alcoholic hallucinosis कहते हैं उसको. There's a specific term we have for it. No problem. Now you tell me what will happen when the patient has had alcohol about 2 days before. 2 days mark. How to crack NEET. अभी आप पहले जो कर रहे हैं FMG पे focus करिए ना please. Right here, right now should be our approach in life. अब क्या करेंगे? Severe withdrawal में क्या होगा? Seizures. Very good. There's a particular name for these seizures. These are generalized tonic-clonic seizures. Generalized tonic-clonic seizures. And we have a particular type of name for it called rum fits. Rum fits. Because ज़्यादातर जो लोग rum पीते हैं उनको rum छोड़ने के बाद बहुत बारी होता है. We also call them cluster seizures. Why? Because in a short span of time, many seizures will happen. Within 2-4 hours, again and again, seizure hota rahega, seizure hota rahega, seizure hota rahega. And final stage is DT or delirium tremens. What does delirium tremens means? Orientation is gone. To time, place, person, all the above things worsen. They can have, a lot of seizures also. They can have tremors also. So worsening of the previous thing as well. And this can be life-threatening stage. Very severe, life-threatening stage. Correct? We will talk about the management. I have a cheat code for you all to manage, right? So there'll be hallucinations. There'll be delirium. Delirium tremens is a full-blown, there'll be all autonomic symptoms, everything will start happening in the delirium tremens. Okay, any questions so far? Management hum baat karenge, don't worry, we'll come to it. I have a drug of choice table created for you where almost everything will be covered in one go. Any questions so far in alcohol withdrawal? Any questions? Go ahead. Perfect. Okay. Now something related to alcohol. The topic is now switching, but it's related to alcohol. जो लोग बहुत साल से अल्कोहल पी रहे होते हैं, बहुत साल से अल्कोहल पी रहे होते हैं, उनको कुछ प्रॉब्लम्स होने लगती हैं because of that excessive regular alcohol use. What is that problem? PDF will come later. First, let me do it, and you may find the PDF in the downloadable part of it. Please go to the description. You can find the PDF, I believe, there. Or you can text the concerned person and they will give you the PDF because ये PDF हमने circulate की हुई है for you all to follow along. Okay, so what happens when, yes, Dr. Anirudh is right. What happens जब कोई बहुत साल से alcohol पी रहा है? बहुत साल से alcohol पीने पे एक problem होती है. And that problem occurs because of a deficiency of something called thiamine. Thiamine deficiency causes this particular problem. Lovely. Now, onset for Wernicke's is more acute. Korsakoff is a more chronic situation, delayed. पर दोनों बहुत साल पीने के बाद होते हैं. What are the classical triad? So, we have confusion or global confusion, ophthalmoplegia in Wernicke's. Can someone tell me which cranial nerve is involved? Can you tell me which cranial nerve is involved? And ataxia. This is the typical presentation in Wernicke's. Whereas in Korsakoff, we have retrograde and anterograde. Amnesia. And making up stories, which is called confabulation. Can someone tell me which cranial nerve? Great, Dr. Rahul. Great, Dr. Shamsuzuman. Good. 6 cranial nerve is involved in Wernicke's. Now, cognition is definitely not intact here, and cognition is usually intact here, but can worsen. Matlab thinking process. Reversibility, yes. Wernicke's is reversible. Korsakoff is not that easily reversible. Fully reversible, Korsakoff is less. Wernicke's can progress. Basically, Wernicke's progresses to Korsakoff if not treated properly. Mammillary body is involved, plus other areas also get involved in Korsakoff. What is the treatment? Tell me, in which, obviously the treatment is vitamin B1, that is goes without saying. Why don't you all tell me that in which one, Wernicke's or Korsakoff, do we give IV vitamin B1 and in which one will we give oral and for how long? No glucose. Glucose is, again, anyway, glucose, that question you're mixing up. Basically, the question you're mixing up is that when a patient is brought to you suddenly in the emergency room and he has a history of chronic alcohol intake and he is non-responsive, what is the first thing you will give him? There you will give first thiamine and then you will give glucose. But this question is different. I am asking, yes, now you're right. Where will we give IV? In Wernicke's. For how long? How long? For how long? For how long? Oral in Korsakoff for up to 1 year at least. 1 year or more. Whereas IV thiamine in Korsakoff, in Wernicke's for how long, guys? How long? Yes, Wernicke's is IV. Correct. IV thiamine for how long in Wernicke's? Time duration. Here you're right. Up 1 year or more, you will give in Korsakoff orally. Orally you will give for 1 year or more. But in Wernicke's, how long will you give it for? IV. Time. Someone try? Make a guess. यार गलत हो गया तो क्या हो गया? साथ में पढ़ रहे हैं. No, 3 months. ठीक है? 3 months. Okay? 3 months. You can go up to 6 months. 3 months is the right answer. ठीक है? At least for 3 months. Yes. All right. Let's now look at your favorite thing, guys. Psychopharmacology. समथिंग जो मुझे सब लोग बार बार पूछते रहते हैं, मैडम मेरे को प्लीज साइकोफार्माकोलॉजी बता दो, साइकोफार्माकोलॉजी बना दो. शॉर्टकट में भी करेंगे, लॉन्ग कट में भी करेंगे. कोई भी चीज में पूछना होगा, स्टॉप मी एंड आस्क क्वेश्चंस. ओके, रेडी फॉर साइकोफार्माकोलॉजी. Give me a thumbs up if you're ready for psychopharmacology. Give me a thumbs up if you're ready to do psychopharmacology. Thumbs up, thumbs up, thumbs up, thumbs up, thumbs up, thumbs up, thumbs up. Cool. Fantastic. What is the drug of choice in nocturnal enuresis, which is also called bedwetting? कुछ बच्चे 5 साल के बाद भी after 5 years also they wet their bed at least 2 times in a week for 3 months. Then it is called nocturnal enuresis. Now, what do you do? What medicine do you give? What medicine do you give, guys? What medicine do you give? ADH analog. Try, guys. What medicine do you give? What is the drug of choice? Drug of choice. Drug of choice ज़्यादातर एक होता है या एक क्लास होती है या एक से ज़्यादा भी होते हैं कभी-कभी. Desmopressin. Fantastic. Can you tell me one more drug that you can give if the patient is not tolerating desmopressin? What is the second choice? Good. Fantastic batch. Well prepared. Second drug of choice. Desmopressin नहीं tolerate हुआ. अब क्या करें? Imipramine. Fantastic. Which is a TCA. Great. Next, we'll talk about obsessive compulsive disorder. What is the drug of choice for obsessive compulsive disorder? Drug of choice. So you can tell me the class of drugs, drug of choice, which is the best. Bed alarm is a very good point. Yes. अगर treatment of choice पूछा गया हो तो bed pad alarm. Treatment of choice is bed pad alarm. Drug of choice, actually मैंने treatment of choice के लिए अलग बनाया हुआ है, guys. But thank you for reminding me, Dr. Anirudh. So, what is the class of drug of choice for obsessive compulsive disorder? And then we'll talk about the gold standard. Let's talk about OCD. Drug of choice for OCD. Double MBBS काफी अच्छे से psychiatry prepared है. Good. I'm happy to see. SSRIs. Correct. SSRIs are the main group. And the main SSRI is fluoxetine. Then there is others like fluvoxamine. Now, I want to know one more class of medication that can be given for OCD. One more class of medication that can be given for OCD. One more class of medication that can be given for OCD. TCAs, good. That is clomipramine. As an add-on, we can give memantine or risperidone. These are add-on medications. Okay? Alright. Major depressive disorder. Which class of medicine would you like to give in major depressive disorders? Good. TCA, clomipramine particularly, is the one. You're right. Which class of medicine would you like to give for major depressive disorder? See, treatment of choice हम बाद में बात करेंगे डॉक्टर सैयद उस्मान. मैं treatment of choice का अलग बनाया हुआ है मैंने. अभी हम सिर्फ drug of choice की बात कर रहे हैं. ठीक है? I don't want to then skip those pages वरना मेरे को बाद में आप कहोगे कि वहाँ क्यों नहीं है. Yes, SSRI are the main drugs for major depressive disorder. Next is SNRIs. Then we have some atypical medications like NDRI, which is SSRI, as we know, is selective serotonin reuptake inhibitors, drugs like fluoxetine, escitalopram, paroxetine. SNRI, which are drugs like venlafaxine, desvenlafaxine. What are these? These are serotonin norepinephrine reuptake inhibitors. Then we have atypical drugs. For example, bupropion. Then we have mirtazapine. एंड ऑफ कोर्स हम कुछ पुराने दवाई यूज कर सकते हैं बट लेस यूज करते हैं आजकल, जो है TCAs एंड माओ इनहिबिटर्स कम यूज करते हैं. नेक्स्ट क्वेश्चन, मेलांकोलिक डिप्रेशन में क्या देते हैं? मेलांकोलिक डिप्रेशन जिसमें पेशेंट मॉर्निंग में वर्स होता है, पेशेंट को बहुत ज्यादा साइकोमोटर रिटार्डेशन होता है, धीरे धीरे काम करता है, एंड पेशेंट को बहुत ज्यादा थकावट होती है. मेलांकोलिक डिप्रेशन में क्या देते हैं? सो मेजर डिप्रेसिव डिसऑर्डर में आपने सबने SSRI कहा, आई एग्री. SNRI करेक्ट, एटिपिकल्स करेक्ट, TCS भी दे देते हैं, माउस भी दे सकते हैं, यस गिल्ट भी होती है, यू आर राइट. सो मेलांकोलिक डिप्रेशन में क्या देते हैं गाइस? melancholic depression, drug of choice in melancholic depression. melancholic depression में क्या देते हैं? I want this answer from you all. I'll give you some time. साथ माओ इनहिबिशन क्या होता है? इनहिबिटर्स होता है गाइस. साथ एटिपिकल भी पढ़ लेते हैं. चलो, ये दो थोड़े ट्रिकी होते हैं, ठीक है, ये सबको आता होता है, और ये वाला भी थोड़ा ट्रिकी होता है, इसके लिए मैं अलग से खोलूंगी एक पेज. एटिपिकल डिप्रेशन क्या होता है? एटिपिकल, नॉट सो टिपिकल. नहीं, गलत आंसर्स आ रहे हैं ज्यादातर, मैं आंसर देती हूँ. ओनली सैयद उस्मान इज गिविंग द राइट आंसर. सो मेलांकोलिक डिप्रेशन में TCAs इस्तेमाल होते हैं. एटिपिकल डिप्रेशन अलग होता है. Answer is TCAs, guys. TCAs are used in melancholic depression. But ये जो atypical depression होता है, सब कुछ उल्टा है. Means too much eating, too much sleeping. Typically क्या होता है? डिप्रेशन में नींद उड़ जाती है, भूख नहीं लगती, पर इसमें उल्टा होता है. Leaden पैरालिसिस, मतलब ऐसा लगना कि पैर बहुत ज्यादा भारी है, मैं चल ही नहीं पा रही हूँ, माई फीट आर सो टायर्ड. एंड रिजेक्शन सेंसिटिविटी, बहुत ज्यादा बुरा लग जाना, बट द मूड इज रिस्पॉन्सिव. इसमें क्या इस्तेमाल होता है? अगर मेलांकोलिक में TCAs यूज होता है, माओस, वेरी गुड, माओ इनहिबिटर्स यहाँ इस्तेमाल होते हैं, दे आर बेटर. Of course, you can use SSRIs, you can use newer drugs, but these two are redundant concepts by the way, but वैसे भी आपको आना चाहिए. Next is postpartum depression. We will do this in detail आगे. तो मैं यहाँ पे सिर्फ और सिर्फ आपसे जानना चाहती हूँ कि क्या होता है postpartum depression का ट्रीटमेंट. अगर आपको आता है ग्रेट, अदरवाइज मैं postpartum depression थोड़ा आगे जाके डिटेल में पढ़ाऊंगी, राइट? सो कैन समवन टेल मी postpartum depression में क्या ट्रीटमेंट ऑफ चॉइस? वी आर फोकस ऑन ड्रग ऑफ चॉइस. ड्रग ऑफ चॉइस होता है पोस्टपार्टम डिप्रेशन में. नहीं, नॉट सिलेजिलिन, नो. पोस्टपार्टम डिप्रेशन SSRIs दे सकते हैं, कूल, ओके. एंड कुछ न्यूअर मेडिसिन हैं चलो मैं थोड़ा सा आपको समझाती हूँ पोस्टमार्टम। Of course, you can give SSRIs plus therapy plus support. सो टिपिकली पोस्टमार्टम डिप्रेशन में क्या होता है, काफी बारी पेशेंट ना सुसाइडल हो जाती है, एंड इन दैट केस यू नीड टू डू समथिंग दैट विल एक्ट रियली रियली फास्ट. एंड व्हाट डू यू डू टू मेक इट एक्ट fast? You need something that will act really quickly, and for that you use these GABA A modulators. These are the newer drugs. Zuranolone, which is orally, and Brexanolone, which is given IV drip to the patient. July exam, fantastic, Dr. J, very good, excellent, excellent, very nice. So, yes, SSRI, congratulations to Dr. J 5831, congratulations. इतने सारे ड्रग्स को कैसे याद करना है? वाह माय डियर फ्रेंड्स, यही तो डॉक्टर होने का सबसे बिगेस्ट हाईलाइट है कि हमें ये सारी दवाइयाँ याद रखनी पड़ती हैं. लॉयर जो है वो किताब खोल के अपना पढ़ लेता है, बट हमें अपना याद रखना होता है. नो ऑफेंस टू लॉयर्स, बट दिस इज व्हाट वी आर हियर फॉर, राइट? सो बैक टू पोस्टमार्टम डिप्रेशन. पोस्टमार्टम डिप्रेशन क्या होता है मैं आगे जाके फिर से डिटेल में बताऊंगी, क्योंकि मैंने पोस्टमार्टम ब्लू के साथ उसका बना किया हुआ है. आपको ये फोकस करना है कि SSRIs आर द मेन ड्रग्स. अगर ऑप्शन में SSRI रहा तो गो फॉर इट. अगर SSRI नहीं रहा तो यू हैव टू गो फॉर ज़ुरानोलोन और ब्रेक्सिनोलोन, दोनों में से जो भी ऑप्शन रहेगा. यस, Zurzuvae is the brand name. You're absolutely right. You're absolutely correct. 1 second. All right. So, आगे बढ़ते हैं. What is the drug of choice in acute manic phase? Acute mania. Zuranolone and Brexanolone both. I just explained, Anumita. I just explained what they are. They're GABA A modulators. They act fast. FDA approved. Okay. Anhedonic with severe symptoms will be major depressive disorder. We'll come to it. We have that. I have that in my notes. Tell me the drug of choice for bipolar disorder, manic in acute phase. Bipolar disorder, manic, acute phase. जल्दी जल्दी करेंगे गाइज, धीरे चल रही है हमारी गाड़ी. लिथियम, acute phase, acute phase. You will give lithium, but it takes time, right? So what will you give first? Not lamotrigine. No. No, valproate is also a mood stabilizer. It will take time. Atypical antipsychotics. So when the patient comes, we usually give olanzapine, quetiapine, because the patient is in active manic phase. Sometimes we can also give haloperidol, which is a typical antipsychotic. We can also add benzodiazepines for making them sleep faster. But you will add lithium at that stage, but it takes time. Lithium or other mood stabilizers. These are mood stabilizers. You will add them, but they will take time to build, which is why you need quick relief. So you need to add first this. Okay? Yes. Yes, yes, correct. Bipolar depression, you use lamotrigine. Plus, you may need antidepressants, but watch for manic switch. Be careful when you give antidepressants, especially even in bipolar depression. Sometimes the patient can go into mania because of your antidepressant. Generalized anxiety disorder. How do we treat, guys? Jaldi jaldi karenge. You guys are taking time. Come on. We need to marathon our way through this. We have to finish this in the next 2-3 hours. Yeah? Okay. What do you do in GAD? Generalized anxiety disorder, guys? This part I want you all to answer. You know why? Because these are so important and इसका रिविजन अगर आपका हो गया तो आपका आधी टेंशन ऐसे ही खत्म हो जाएगी. So tell me what is the answer for GAD and also साथ साथ पैनिक का भी बता ही दो यार. लगे हाथ. GAD पैनिक. क्या आंसर्स आ रहे हैं? SSRI, SNRI और कुछ? Okay, let's see. See, we are talking about drug of choice. CBT is correct. Dr. Harsh, you are right. But we are focused on drug of choice. So, SSRIs, SNRIs are correct. There's also buspirone, which also works on the serotonin receptors. Benzodiazepines are for immediate acute relief, but habit forming, so avoid for long. Also, you can add on beta blockers. Again, avoid for long. So, the treatment for both panic and GAD is actually common. What will you do? You can give SSRIs, SNRIs, buspirone. You can give benzodiazepine, but you will give that for a short period of time. Why? Because it is habit forming. You can give beta blockers as an add-on. Therapy is of course mainstay. We are right now only talking about drugs of choice. अभी हमारा psychopharmacology चल रहा है, right? Cleared, cleared, cleared. Thumbs up. Where's the remote? Thumbs up. Okay. Let's go ahead. Cool. आगे चले? Yes बोलो. आगे चलते हैं. Okay, cool. Yes, this marathon can help for your profs also a little bit, not so much. Profs के लिए हमने अलग बनाया हुआ है, guys. Phobias, specific phobia or social. See again, similar treatment like GAD and panic. You don't prefer medication, but treatment of choice is therapy actually. But if you have to give medication, very similar to the previous one. PTSD. What is the drug of choice that you like to give in PTSD? Drug of choice in PTSD. Drug of choice in PTSD. Drug of choice with PTSD. Drug of choice in PTSD will be SSRIs. However, if the patient has recurrent nightmares, you can give something. What is the medication that you can give for nightmares? EMDR is correct, Dr. Harsh. I am so happy that you are only focusing on the treatment of choice, and that's great. But we are doing the block of psychopharmacology. I will come to the treatment of choice, I promise. Okay. Yes, prazosin. Somebody answered. Prazosin is used for the nightmares. Fantastic. Good job, guys. Let's move on to ADHD. Attention Deficit Hyperactivity Disorder. What are the main drug of choice? And what are the backup drugs that we can give? ADHD. ADHD. Main drug of choice. And what is the backup that we can give? Methylphenidate. So the block is called stimulants. And we give methylphenidate or amphetamines. Great. The other block is called non-stimulants. What are some non-stimulant medications, guys? What are some non-stimulants? Non-stimulants B. What is B? Methylphenidate, correct. So, others, I will give you clonidine. Non-stimulant, atomoxetine, reboxetine. So, SNRIs. Okay. In others, clonidine and even bupropion. Bupropion, which is a NDRI. We'll talk about it in detail. Can also be given. Alright. We will talk about some of these drugs in detail ahead also. Clonidine, correct. Bupropion. These are non-stimulants. Okay. And in stimulant, we have methylphenidate, the drug of choice, and amphetamines. Good. Atomoxetine, reboxetine, certain other SNRIs can also be used. Okay, guys. आगे बढ़ें. What is the drug of choice in Alzheimer's disease, mild to moderate? What is the drug of choice in Alzheimer's disease? Dementia. What is the drug of choice? I want the answer from you. Drug of choice. Cholinesterase inhibitors. Which one? Which ones? Good. Name some. Donepezil. And you can also give not a cholinesterase inhibitor, another thing. Good, good. Donepezil, good, good. Memantine. Okay. Memantine. Memantine. Yes, you can give other things as well. These are the two main ones that we are looking for. Next, delirium. Patient is not oriented to time, place and person. What do you do in such a case? What is the drug of choice? Yes, rivastigmine, galantamine, all of these are also correct. Lower in order, but still. Can you tell me delirium, not oriented to time, place and person? What do you do? Haloperidol, typically. Okay, good. What else? So, the difference between dementia versus delirium is that delirium is reversible, right? And dementia encompasses many things. Delirium is temporary. Okay. So the answer is a good combination of what you all are answering. We do give benzodiazepines and we also give haloperidol, which is the typical antipsychotic. But the main treatment is you treat the underlying cause. Whatever is the underlying cause, basically that needs to be taken care of. And you can try atypicals, but the first is benzodiazepine, haloperidol and then lower on cards atypical. So depending क्या option रहेगा आपको उसके हिसाब से choose करना पड़ेगा. Benzodiazepine option है तो benzodiazepine choose करना पहले. अगर haloperidol option है पहला तो haloperidol choose करना. दोनों ही है तो फिर benzos over the halos. Okay. Schizophrenia, acute. As we already know, we have typical and we have atypical antipsychotics. Can you name some typical and atypical antipsychotic students? Please, dear students, name some typical and atypical antipsychotics. Typical and atypical antipsychotics, please. Name some. Some typical and some atypical. Name some typical and some atypical. Typical, chlorpromazine, haloperidol. Very good. Flupentixol. Atypical. Okay, let me sit down. Quetiapine, olanzapine, risperidone, amisulpride, aripiprazole, ziprasidone, and everybody's favorite, clozapine. Very good. Very good. A lot of you all know all of these. Very nice. So good to see such a great batch. What do we give in treatment-resistant schizophrenia? Where many medicines have been tried and at least one atypical and typical have been tried, but there has been treatment failure for adequate time, for enough weeks, enough dosage, it has been tried, yet the patient is not responding. What is the gold standard novel drug that we use? Is this enough to pass FMG? Yes, most certainly. If you pay attention right now and follow along, we have covered all the major topics in this booklet. And by the end of it, you will realize you've covered all the important chapters. Yes, with PYQ, it is more than enough if you focus, although I do encourage every student to study more and go above and beyond. But if you're looking for a shortcut, yeah, sure. The marathon series is designed to help you all fare easily. So, clozapine, correct, is the right answer. Absolutely. What is the drug of choice for catatonia, guys? Drug of choice for catatonia. Catatonia is when somebody is holding a posture, or they're mute, or they have stupor, or catatonic features are, for example, ambivalence, ambitendency, angle poise lamp. So what do we do if a patient has catatonia? Catatonia, please. Treatment. Correct, Dr. Anumita. Absolutely right. So, you give lorazepam. In fact, you give parenteral lorazepam, IV or IM. Also, if needed, you can give ECT. ECT can also be given. ECT can also be given. Next, we're talking about NMS. Can someone tell me what is NMS? What is NMS? What is NMS? What is NMS? And then you tell me the treatment of NMS. First, what is NMS? Arey, what is NMS before you tell me the treatment? I actually want to know what is NMS before you give me the treatment. Because I don't want this to be a rectification. I want this to be conceptually understood. So, what is NMS? Neuroleptic malignant syndrome. Good. What does it entail? What happens in neuroleptic malignant syndrome? Hyperthermia, correct? Somebody said hyperthermia. Yes, it happens. What else happens? Is there any kind of rigidity that happens? It's a psychiatric emergency. Why does it happen? Because of D2 blockade. Myoglobin in urine, correct. Muscle breakdown. Muscular breakdown, correct. Muscular rigidity, correct. Correct. D2 blockade sudden. Yes. Yes, correct. Very good. There's also altered sensorium. Now tell me the treatment, guys. Now that I know that you know, what is the treatment? High temperature, CPK, correct. Now that I know that you know, can tell me the treatment. Now that I know that you know. Somebody was saying dantrolene, correct. What else? What else do we give other than dantrolene? What else? Is this enough with PYQ? Dr. Ashika, you're asking the same question so many times. Why don't we just pay attention and then we just figure it out? It is more than enough, but would you like to please participate? Bromocriptine, amantadine. These increase dopamine, right? So, suddenly D2 depletes. So, you need to give D2 agonists. Yes, it is enough, Dr. Ashika. Okay. With PYQ, it is bromocriptine, dantrolene, amantadine. Fantastic. Good job, guys. Next, what is serotonin syndrome? First, what is serotonin syndrome? And notice I gave it right after NMS for a reason. I give it right after NMS because there's some overlap. What is the overlap? Tell me. Let's go. What is serotonin syndrome, guys? What is serotonin syndrome? Serotonin syndrome. Are we stuck? Serotonin syndrome. What is it? Before you tell me the treatment. Too much serotonin. Correct? Why? Good. But why? Either SSRIs are combined with SNRIs or other serotonergic meds like triptans. Then there's something called St. John's wort. So what happens? Too much serotonin causes diarrhea. There is clonus. There is also increase in temperature. It's acute in onset. Okay. So what is the treatment? What is the treatment? Yes, overdose of SSRIs, excess serotonergic activity. Tell me, what is the treatment? You are right till here. Treatment? Treatment? Stop the drug. Okay. Stop the drugs, of course, and cyproheptadine. You may give benzodiazepine later, but mainly it is cyproheptadine. What about benzodiazepine overdose? What do you do here? What is the drug that you give in benzodiazepine overdose? Benzodiazepine overdose. Come on guys, fast करेंगे. जल्दी जल्दी चाहिए आंसर मुझे. Any idea? Benzodiazepine overdose क्या देते हैं? Yes. Flumazenil. Correct. Now, since we are on the topic of overdose, why don't you tell me opioid overdose में क्या देते हैं? Opioid overdose में क्या देते हैं? Opioid overdose में क्या देते हैं? Okay, I think I'm going to start answering some of these. Naloxone, fantastic. Short acting, right? Very good. Next, smoking cessation में क्या देते हैं? Smoking cessation में क्या देते हैं? Drug of choice. Smoking cessation में क्या देते हैं guys? Good, आप लोग आंसर कर रहे हो. I want to take it at your pace. Don't worry. We have till 3 p.m. We will take our time. We will get there when we'll get there. आप लोग आंसर कर पा रहे हो, मुझे बहुत अच्छा लग रहा है. As a teacher, the biggest joy of any teacher is when you all can answer, because it makes me feel that you all have understood and you all have studied. Bupropion is a NDRI. Yes, we can use it. But what is the drug of choice? Tell me the drug of choice. Nicotine. Nicotine is again something you can add. Nicotine gum or patch. That's add-on. Tell me the drug of choice for smoking cessation. Wernicke. Very good. Excellent. Where does it work? Alpha 4, beta 2 receptors. Very good. Suicidal ideations which are severe in depression. What do you do? Very good, guys. Suicidal ideation which are severe in depression. What do you do? Very good, filmy doctor. Very good, girly scoop. Palif. Very good. Ahmad Qureshid. Very good. All of y'all, correct answer. Can you please tell me severe suicidal ideations and depression? What do we give to the patient? Severe suicidal ideations, guys. Come on, try. Clozapine? No, that's not the right answer. Actually, ECT is what you give. And you can give lithium because it has anti-suicidal property. Yes, clozapine also has anti-suicidal property, but we do not give it in patients which are not psychotic. Okay. So here it said severe depression. It doesn't mention psychosis. ECT, lithium, anti-suicidal. And one more thing that you can give nowadays is ketamine. Okay. One more thing that you can give. SSRIs will take time to act, Dr. Harsh. That's why the answer I'm looking for is ECT, lithium. See, suicidal ideation, severe depression. That's why I said severe depression. मैंने आपको opportunity SSRI आंसर देने की नहीं दी यहाँ जानबूझ के. Got it? Understood? See, all SSRIs you can give, but it will take time. Did you understand the concept behind this? Give me a thumbs up if you understood. That why will we give ECT? Instant action. Why will we give ketamine? Instant action. Why will we start lithium? Anti-suicidal property. Understood, guys? समझा? Thumbs up दे दो, please, thumbs up दे दो. समझा, guys? समझा? Everybody? Good. Cool. Thank you. Thank you for telling me कि समझ गया. Fantastic. Okay. Now, I want to go back to a page I skipped in between. Yes. Alcohol withdrawal and alcohol dependence relapse prevention. Let's talk about withdrawal. What are the drugs of choices that you will give in alcohol withdrawal? And what are some add-on medications that you can give in alcohol withdrawal? So as we already discussed, you will give thiamine. You will make sure that the patient has enough hydration. Now tell me the drug, which is the first drug that you will give in alcohol withdrawal? Yes, benzodiazepines. So what are the kind of benzodiazepine? You can use lorazepam. You can use chlordiazepoxide. You can use oxazepam, temazepam. Especially if LFTs are bad, use these. What are the add-on medicines you will give? Fomepizole, no. B1, yes, mentioned already. What are the add-on medicines you can give? To prevent seizures, sometimes people give carbamazepine. For hallucinations, sometimes you give antipsychotics. Okay. These are add-on medications. Alright? Alright. Alcohol dependence, relapse prevention. What would you like to give in alcohol dependence relapse prevention? So, what are the drugs that you can give for alcohol dependence other than disulfiram? Of course, disulfiram can be given for relapse prevention. That works on the aversion principle. But you have to ensure that the patient is absolutely clean and not drinking for a long period of time when it comes to disulfiram. So, I want to know the various other anti-craving agents that there are. What are the various anti-craving agents? Naltrexone, fab. Acamprosate, fab. T for topiramate. And then baclofen. ठीक है? Cool. आता है सबको. अच्छा लगा जान के. Fantastic. Very good, guys. गाबापेंटिन ऑफ लेबल. ओके, तभी मैंने लिखा नहीं है. डाल देती हूँ आप कह रहे हो तो. ग्रेट. आगे बढ़ते हैं. What is the drug of choice for नींद नहीं आना? Insomnia. नींद नहीं आना. Drug of choice for नींद नहीं आना. Drug of choice. क्या बताओ ना? Rashika ji, yes, it is enough. I have said it many, many times. बहुत बारी कह दिया आपको जी, it is enough to do this plus PYQs. But then also, you must always go above and beyond, is my belief. Yes, Rashika ji, it is enough with PYQ. Okay, so we have with ourselves Z drugs. We have melatonin. We have benzodiazepines like alprazolam. Use carefully, guys. Please मत लिखा करो क्योंकि ना पेशेंट को आदत सी लगा देते हैं लोग. एक बार लिखते हैं वो पेशेंट खाता ही रहता है. Then we also have orexin receptor antagonist. For example, we have lemborexant. Sorry. That's Dayvigo. We also have certain antidepressants like mirtazapine. Then we have trazodone. We can also use TCAs at times. Some people also use antipsychotics like quetiapine or olanzapine. Don't choose to use it easily, but these are the various options. Ramilton, melatonin, yes. Yes, correct. कोई बात नहीं, सॉरी की बात नहीं है. शायद आप तब ध्यान नहीं दे रहे थे, अब आपने ध्यान दिया. आई एम हैप्पी, तो इट इज इनफ. ठीक है, चलो insomnia. So, these are the various treatment options. What is the treatment for tic disorder or Tourette's disorder? Treatment for tics disorder or Tourette's disorder. So, Tourette's is when there are two or more, at least, motor tics and one vocal tic, right? So, Tourette's में motor भी होता है और vocal भी होता है, mixed up होता है. क्या treatment होती है Tourette's की? Clonidine, risperidone. Sometimes we also use a very old drug called pimozide. ये मिलता नहीं है इतना easily market में. Haloperidol, clonidine, all of these can be used. Correct. Autism. Here also risperidone and aripiprazole have FDA approval to be used. Okay. All right. Let's now talk about an important part, which is postpartum psychosis, rapid cycling bipolar disorder, cyclothymia, dysthymia, premenstrual dysphoric disorder. I want to know, so postpartum psychosis is pretty standard, right? After the pregnancy, after the delivery, the woman presents with psychosis where she may be harmful to the child or to herself. Then it is called postpartum psychosis. We prefer giving antipsychotics, but we may also have to give ECT to the woman. Make sure you separate the child and the baby. I want to know from you all, what is rapid cycling bipolar disorder? What is define what is rapid cycling bipolar disorder, then give me the treatment. Define what is cyclothymia, define what is dysthymia. These three definitions I want in the chat. Define rapid cycling, define cyclothymia and dysthymia. Define rapid cycling, define cyclothymia and define dysthymia. I want the definition from you guys. फिर आगे बढ़ेंगे treatment में. Rapid cycling, mania and depression more than 4 cycles for a year, rapid cycling. So, how many switches? Mood switch in 1 year. So, from depression to mania or hypo or opposite. 4 or more switches in a year, mood switches in 1 year is called rapid cycling. Great. What is the drug of choice for rapid cycling? Drug of choice for rapid cycling. Pattern where patient experiences distant mood mood disorder, mania, hypomania, depression. Yes, Dr. Anumita, but there are switches. What I mean by switches is that, let me add here a slide. So, typically, if this is 0, this is plus 10 mood and this is minus 10 mood. Imagine if normal mood fluctuations are like this. You and me, we all have fluctuations, right? But in a manic episode, the mood goes unnecessarily high for no apparent reason. In a depressive episode, goes really low. Now, if a person has mania, hypomania, followed by another depressive phase, followed by, so the mood has changed how many times in this 1 year? 1, 2, 3, 4 or more. That is what is called, what is it called? Rapid cycling. Rapid cycling. What is the drug of choice for rapid cycling? I want to know. Rapid cycling drug of choice. Rapid cycling drug of choice. Rapid cycling. More than 4 switches. Valproate, lamotrigine, valproate. Ouch. Valproate, lamotrigine. Good afternoon, ma'am. I will let you all answer rapid cycling for me. What is cyclothymia? Cyclothymia is mini bipolar. Not enough to meet full criteria for more than 2 years in adults. And dysthymia is mini depressive, major depressive disorder, not enough to meet criteria, to meet the full criteria. And the duration is more than 2 years, they should have that. So here you treat similar to depression and here you treat similar to bipolar disorder. So you need to add obviously a mood stabilizer. I will leave you guys in suspense. Rapid cycling का आंसर आप लोग खोजोगे. I will leave you in suspense today. हाँ, या लास्ट में बताऊंगी. Premenstrual dysphoric disorder is the extreme mood and behavioral changes that happen in the weeks before the period, that is in the luteal phase. And what do? You give SSRIs. You can give oral contraceptives also as an add-on to some women. ठीक है? Some of you are giving the right answer, but I am still waiting for a lot of you to give the right answer for rapid cycling. Okay, next is REM sleep behavior disorder. Here what happens? Patient does not have atonia, which is lack of muscle control, and hits flails his legs or arms, can injure people. Okay, this is what is called REM sleep behavioral disorder. I don't know if many of you will know. The answer is we give melatonin and we give benzodiazepines here. Okay. Restless leg syndrome. I expect you all to know this. These are the movement that happen in the legs. There's a crawling kind of a sensation or aches and pains, which the patient moves legs to relieve symptoms. One thing you need to do in these patients is always check their hemoglobin. Can you tell me the treatment for restless leg syndrome, please? Pregabalin, gabapentin, beta blocker. No. Pramipexole, the dopamine agonist is mainly there. Pregabalin can be used as a backup, but pramipexole is the right answer. Pramipexole is the right answer. Okay. Okay, guys. Now we're talking about another important topic called TD, tardive dyskinesia. Tardive dyskinesia. Pregabalin, gabapentin, yes. Lower on cards. लिख देती हूँ आप लोगों के लिए. Mainly is pramipexole. Ropenolol also is used sometimes. Okay. Pramipexole, ropenolol. Okay. Next. What is the treatment for tardive dyskinesia? First of all, what is tardive dyskinesia? Tardive means chronic use of something. Now, the long use of antipsychotics can lead to certain movements like or kind of a weird movement of the body. Then we need to give something to this patient. Benzotropin, Benzexol. Are you sure, Dr. Harsh Rawat? Tardive है. Long से हो रहा है. Yes. VMAT2 inhibitors. There's tetrabenazine. And the more newer one, Dr. A. Rahul has actually written correct. Valbenazine. Correct. This is the more newer one. Absolutely right. Please note this is important. Okay. Tetrabenazine or valbenazine, it is tardive use, long use of the dopamine antagonist has led to lip smacking, choreiform movements. These lead to tardive dyskinesia, and the answer is VMAT2 inhibitors, tetrabenazine and valbenazine. Correct, correct. Good job, guys. Dr. Shamsuddin, correct. Correct. Okay. आगे बढ़ते हैं. What is the drug of choice for akathisia? What is the treatment for akathisia? What is the drug of choice for akathisia? Benzodiazepine and beta blocker. Okay. What is the drug of choice for acute dystonia? Somebody had answered for acute dystonia earlier. Acute dystonia and akathisia. Let me explain. Akathisia is when you start an antipsychotic or certain psychiatric medication, the patient starts feeling very internally restless. They can't sit in a place. They ask them, do you feel like there's something happening to you? They say, it feels like there's ants in my pants. I can't sit at one place. And they need to keep pacing around and walking around. This is an acute onset right after starting the medication. Similarly, we have something called acute dystonia. Acute dystonia. Acute means sudden onset. Dystonia. Tone mein disturbance. Kya disturbance? There can be painful spasm of the neck. There could be ocular crisis. This is acute dystonia. Okay? So, in akathisia, we give benzodiazepines and beta blockers. In acute dystonia, we give benzotropin and benzhexol. Correct. Now, we are talking about another drug-induced problem, which is Parkinsonism. Now, what will happen? There will be tremors, there will be rigidity, slowness, because of drugs, antipsychotic induced. What will you give here? Antipsychotic induced. What will you give in the case of antipsychotic induced Parkinsonism? Trihexyphenidyl is what you will give in the, not trifluperazine, trihexyphenidyl. Trifluperazine is an antipsychotic. Drug-induced Parkinsonism, you will give trihexyphenidyl and you will try to stop the offending agent and you will try to switch the patient to atypical antipsychotic. Okay. Next, delusional disorder. What would you like to give in delusional disorder? Of course, antipsychotics. Okay. Right. थेरेपी आ गया, थेरेपी ऑफ चॉइस आ गया. कोई बहुत देर से पूछ रहा था कि क्या करना है, थेरेपी. Now please let's focus on therapy of choice. I think we guys did a great job in covering up in 1.5 hours a lot of our bulk of the psychopharmacology, which is always the toughest part in my humble opinion. There's more that is coming. मैं लिथियम वगैरह के बारे में, क्लोजिपिन वगैरह के बारे में करूंगी डिटेल में discuss, but I think we've covered through a very big chunk. We should be very happy about it, right? Pacitine, benzoxazole, correct. Pacitine is the brand name. Benzoxazole, okay. Mild to moderate depression, what do we do? Mild to moderate depression, what do we do? Mild to moderate depression, what do we do? CBT, interpersonal therapy and cognitive behavioral therapy. Very good. These two we have already covered behind, guys. Okay. OCD, ERP, that is exposure, response, prevention. Very helpful except in hoarding. Except in a hoarding disorder. Panic, you give support, reassurance, and of course, CBT. Right? Good job, guys. I think most of you all know these ones. Let's move on to the next one. Actually, ये मैंने topic later cover किया हुआ है. Let's skip this one. I've covered it later, okay? Therapy of choice for generalized anxiety disorder. GAD. Therapy of choice for GAD. गाइस सबका आंसर देना स्टार्ट कर दो एक एक करके। ऐसे लिख दो जीएडी और सामने क्या, फिर लिख दो सोशल एंजाइटी और सामने क्या। ओके, यस, सीबीटी, social anxiety, CBT, then you obviously give some exposure. Phobias, systematic desensitization, or you can do flooding. I don't like it. Or you can do modeling. Show them. Or you can do gradual exposure. एक एक करके सारे लिखना स्टार्ट करिए गाइस। पीटीएसडी, दिस आई वांट यू टू टेल मी, पीटीएसडी में क्या करते हैं? पीटीएसडी और ऑटिज्म स्पेक्ट्रम का बता दो, पीटीएसडी और ऑटिज्म का बता दो, बाकी मैं आपकी मदद कर देती हूँ। अच्छा चलो ये भी बता देना। हाँ। पीटीएसडी में क्या ट्रीटमेंट होती है गाइस? पीटीएसडी में क्या ट्रीटमेंट होती है? फिर बताओ ऑटिज्म में क्या, स्पेक्ट्रम में क्या होती है? गाइस पीटीएसडी का कौन बताएगा? अभी तक कोई नहीं बताया। पीटीएसडी में कौन सी थेरेपी यूज होती है? पहले किसी ने बताया था जब मैं पीटीएसडी का ड्रग पूछ रही थी। नहीं पता, मैं बताऊं? Trauma informed CBT. But there is one more treatment called EMDR, which I want you to tell me the full form of. Autism, ABA speech therapy. Good job. ABA for autism. Applied behavioral analysis. Fantastic. Then there is speech therapy. There's occupational therapy. Good job. Play therapy, okay. Can someone tell me the full form of EMDR in PTSD? EMDR in PTSD? Eye movement, desensitization, and reprocessing. Okay, that is the full form. Good. And in borderline personality, DBT or dialectical behavioral therapy is the main treatment of choice. Okay. Now, let's learn some main pointers. Anorexia nervosa, bulimia and binge eating. एक सेकेंड, मेरे पास ये आगे भी है. I think मैंने anorexia की slide 2 बारी बनाई है. Nevertheless, let's just do this one. Okay. So let's do some major differences. These are all eating disorders. Guys, we'll come back to it. मुझे लगता है मैंने ये आगे पढ़ाया है. I'll just come back to it. ठीक है? आगे बढ़ते हैं. Body dysmorphic disorder. The patient is convinced that there is a perceived flaw that they have with a body part of theirs, and they are most likely to focus on their nose, chin, genitalia, and they love cosmetic or plastic surgery and procedures. It is an OCD spectrum disorder. Next is somatic symptom disorder. Patient has physical symptoms but either no or some underlying medical issue. But patient's distress is extreme about it. So they keep going from doctor to doctor for help. Conversion disorder is a type of trauma or stressor induced where some psychological feature converts into physical manifestation and there is no clear following of anatomical principle. There is something called La Belle indifference. And in the past, it used to be called hysteria. Okay. Next, illness anxiety disorder is the convinced belief that the patient has some major illness. And these are our favorite patients, right? They come from Google doctors. They do extreme research and they will convince us. They feel the doctor is dismissing them. Okay. Trichotillomania or hair pulling is again an OCD spectrum, body focused, repetitive behavior disorder. The patient can have trichobezoar in their stomach. So they keep pulling hair. Where do they keep pulling hair from? The most common are obviously head, eyelash, genitalia, armpits, legs. Okay. Kleptomania or impulse control disease. Yeah, I have done later. Okay, I'm writing later here. Insomnia, already done. One thing, add, sleep hygiene is very important when it comes to insomnia. You need to make sure you sleep on time, you eat on time, same routine, do not over caffeinate, avoid any stimulant, do not use bed for anything other than sleeping and for sex, do not overeat just before bed. These are sleep hygiene. Alcohol dependence, already done. Nicotine dependence, yeah, this not done. Nicotine, no, already done actually. Guys, कुछ topics ना बार बार मुझसे लिखे गए हैं, my mistake. Okay. Now, in the stable phase of schizophrenia, you can start what is called milieu therapy. Social skills can be taught and you try to get some occupational help or reinforcement, putting them back into the normal society. Hypochondria is a condition which a client thinks I'm suffering from disease, but not truly anything happening. Correct. Absolutely, Gustav. Delusional disorder is only one delusion, no hallucination. If hallucination is present, supports the delusion. For example, delusion of infidelity, delusion of parasitosis. Okay. Dementia. The behavioral symptoms could be irritability. In dementia, what happens? Only memory is not the problem. Patient can have hallucinations. Patient can have disorganized behavior, meaning they can do disinhibited behavior. They can go and open the fridge and urinate in the fridge, or they can even take their clothes off. They could even have sexual behavior. So, you medicate with low-dose antipsychotics or with antidepressants along with dementia medication. Okay. Tics and Tourette's already covered. I think what you need to know is vocal and motor. Two types of tics are there. Tic is nothing but a sudden urge, sudden repetitive movement or vocal in response to an inner urge. I'll give you an example. Hichki movie देखी है आपने? Hichki, Rani Mukherjee की. So a tic would look like this. So nicotine, I've covered Ahmed Khurshid. I covered the treatment of nicotine, right? Wernicke and bupropion and nicotine patches, etc. So a tic would look like this is a motor tic or this is a type of vocal tic, and the motor tic could be anything like this or like this. Those are tics. Tourette's is when there are two or more motor tics plus vocal tic. Okay. All right. Adjustment disorder happens after a stressor of normal type, not catastrophic, within 1 month and gets better with support. For example, a breakup. For example, being fired. For example, financial loss. Chota mota, bada financial loss nahi. Factitious disorder is they make up symptoms. We also call it Munchausen syndrome. And malingering means jhoot. Why? To gain something. Any doubts so far, guys? I think I'm going a little fast. I'll just drink some water. You take a moment to absorb this and ask me any doubts so far that you have. Any doubts? Free to ask me doubts, guys. Any doubt, please ask, guys. Gas response to stressor, yes, general adaptation syndrome is slightly important, not the most important topic. Abhi Factitious disorder, I'll explain in detail thoda sa aage. Dr. Bhandarupreet, yes, it is enough. GAS मैं अभी समझा देती हूँ. Tics can also happen in children. Yes, very common in children. Starts usually in adolescence. Can get better as the age goes. Okay guys, so how's the Josh? ये दोनों मैं आगे भी कर रही हूँ. You can go ahead and also read. Don't worry, I've added it. How's the Josh? Tics can happen in children? Yes. Factitious disorder, I will repeat. Is it enough for FMG? Yes. GAS response to stressor. I'll write it here on the top. शायद आपको नहीं दिखेगा, but general adaptation syndrome. There are 3 phases: alarm, resistance, and exhaustion, proposed by Hansel. Okay, आगे बढ़ते हैं. Let's now come to an important drug. Lithium. Where is lithium used? How is lithium extracted? Perfect. Good level जोश is always good. मैंने भी पानी पी के जोश बना लिया. What is the therapeutic level in acute and in maintenance? Pregnancy में should we give or is it contraindicated and why? What are the side effects and when to check the blood? What are the long-term effects and what happens in toxicity? Yes, we give it in bipolar disorder, mania. We can also give it in, it has anti-suicidal properties, right? You can also give it in schizoaffective disorder. Okay. It is excreted by kidneys. The therapeutic level, please. 1.5 for what? More than 1.5 is toxicity. Tell me the therapeutic level in acute and maintenance, guys. Tell me the therapeutic level. Tell me the therapeutic level. Anti-suicidal properties. Yes. Therapeutic level, acute and in chronic. (0.5 to 1.5 for what? 0.5 to 1.5 for what? Which one? Come on guys, acute and maintenance दोनों चाहिए मुझे. Guys, can you hear me now? There was a little lag there. Okay, good. Yeah, there was a lag. I tried to get it fixed. Lag था, अब ठीक हो गया, I think. Correct? Back? Everybody back? Everybody back with the जोश and the होश? थोड़ा एक्शन पैक करेंगे, काफी सारी चीजें मिसिंग है ना? और अभी खत्म करना है 3 बजे तक पहले वाले अगले वाले टीचर से पहले, राइट? ओके, ऑल गुड नाउ. लेट्स गो dive deep into selective serotonin reuptake inhibitors. So, escitalopram, citalopram, fluoxetine, fluvoxamine, sertraline, paroxetine. कहाँ यूज करते हैं? मेजर डिप्रेसिव डिसऑर्डर में, जनरलाइज एंजाइटी डिसऑर्डर में, पैनिक, फोबियाज, पीटीएसडी, यहां तक कि ईटिंग डिसऑर्डर में भी यूज कर सकते हैं. साइड इफेक्ट्स, स्टार्ट करने पे जीआई साइड इफेक्ट्स होते हैं. यस, इट कैन कॉज स्लीप इन सम पीपल टू इंक्रीज, किसी की उड़ा देता है. वेट गेन, sexual side effects in some, right? These are the most common pointers that you need to know. NDRI, norepinephrine, dopamine, reuptake inhibitor. ये आप लोग मुझे बताएंगे. सिंपल वाला मैंने बताया, डिफिकल्ट वाला आप बताओगे. Bupropion. Can someone tell me where is it contraindicated? Bupropion is contraindicated where? Ophthalm class is 3:30. Bupropion is contraindicated where, guys? Bupropion is contraindicated where? So, bupropion is an NDRI which is used in major depressive disorder. स्मोकिंग सेजेशन में भी काम आता है, हमने पीछे पढ़ा था. एंड ADHD में भी लिखते हैं, मैंने वहां पे भी पढ़ाया था. वीक और जब किसी को SSRI से अगर सेक्सुअल साइड इफेक्ट हो रहा हो तो हम उसको ब्यूप्रोपियन की तरफ डाल देते हैं. व्हाट इज द कॉन्ट्राइंडिकेशन फॉर व्हाट इज द कॉन्ट्राइंडिकेशन फॉर ब्यूप्रोपियन? Side effect can be definitely insomnia, and in some patients it can cause dose dependent seizures. So the contraindication is automatically seizures. Okay, seizures are the contraindication. All right, remember this. Where to find PDF? It will be in the let me find out for you. I'm not 100% sure. I have to find out for you, sorry. आई थिंक इसी में आ जाता है, ऐप में आता है. ओके, इन SNRI, सो वी हैव सेरोटोनिन, norepinephrine, reuptake inhibitors. ओके, इसमें क्या क्या होता है? वेनलाफ्लैक्सिन होता है, डेसवेनलाफ्लैक्सिन होता है, ड्यूलॉक्सिटिन होता है. Venlafaxine causes increase in blood pressure. Duloxetine causes orthostatic hypotension, उल्टा. ठीक है? Got it? It can also have sexual side effects. इसके indications same ही होते हैं. Indications same as SSRI. We can give duloxetine in somatic syndrome. Okay? Yes. We've covered. Increased BP means hypertension. No? All right. Next. Varenicline, we read, is A4B2. It's also called Champix kit, and it helps in smoking cessation. Ketamine, important. Let's study ketamine. Ketamine. Well, how can it increase BP? Explanation. Guys, we are doing marathon. I will only keep it very, very short. So, definitely norepinephrine has impact on the renal gland, on the kidney, which is why it can cause increase in blood pressure. That is why. In a nutshell, if I have to explain in one line only. Now, let's come to ketamine. Ketamine. Ketamine, I want you all to tell me before I tell you. मैं 2 मिनट बैठूंगी ताकि आप लोग का आंसर पढ़ूं, because I've been walking for now 2 hours. I've got enough steps for the day. मेरे को ketamine कौन पढ़ाएगा, कौन सिखाएगा? Ketamine is something I want you all to tell me, please. Anti-suicidal. Okay. क्या दवाई है? कीटामिन है क्या? किस बला का नाम है? कहाँ से स्टार्ट हुई? क्या चीज है कीटामिन? Can someone teach me ketamine, or am I teaching ketamine? Ketamine is actually an anesthetic agent, right? Yes, it works at the NMDA receptor. It's an antagonist. Great. It helps in giving quick resolution in suicidal patients when given in IV form. It is a dissociative anesthesia. It has abuse potential. And you get a intranasal spray. इंडिया में नहीं मिलता है अभी. It's called ketamine for a quick delivery. Okay, rapid onset of action. The only problem is short-lived action. Short-lived action. Okay, that's the only problem. Okay, great. Next, TCAs, tricyclic antidepressants. So there's amitriptyline, nortriptyline, these are the main ones, psychiatry pertinent, that I'm teaching you. They can be used in migraine prophylaxis, major depressive disorder. They can be used for chronic pain or neuralgia. Okay. The problem is the side effect profile causes dry mouth, blurry vision, constipation, and TCA overdose can also happen. Clozapine is a very important drug. I want you all to tell me something. I want you to tell me the life, no, not life. I want you to tell me the side effects of clozapine. And I want you to tell me the monitoring of clozapine. Okay, I will teach you the rest of the things. I want you to tell me the side effects of clozapine and how to monitor clozapine. Okay, so gold standard for treatment-resistant schizophrenia. It is an atypical antipsychotic. Binds on D4, D2 and serotonergic receptors used in treatment-resistant schizophrenia when there is drug-induced Parkinsonism. This also has anti-suicidal properties. Right? Now I want you to tell me, yes, weight gain, agranulocytosis. Can you tell me how to monitor? You have to watch for agranulocytosis. Siluria causes wet pillow, weight gain, metabolic side effects, sedation, cardiomyopathy, very good. Drugs, dose dependent seizures. Good. So far, everybody is on the same page. I think all of you have already studied clozapine very well. Yes, you need to check the neutrophil count. When? Monitor for constipation? No. Blood monitor. Blood. So, every week, initially, for the first 6 months. Then 6 months to 12 months, every other week. Then, after 1 year, once a month. And anytime the patient develops fever or sore throat. So, ये दवाई स्टार्ट करने के बाद आपको न्यूट्रोफिल काउंट रेगुलरली मॉनिटर करना पड़ता है. Once every week for the first few months. After that, for the second half of the year, once every 2 weeks. उसके बाद every month. एंड अगर कभी भी पेशेंट को बुखार या खांसी हो तो आपको तभी करना पड़ता है मॉनिटर. ओके. Procedure of choice for treatment-resistant depression will be ECT or ketamine. For severe catatonia, ECT. For schizophrenia with suicidality, Guys, can you now see me? वापस आ गया? Please let me know if you can see me. अटक रहा है, I am aware. Guys, can you see? Can you now hear me? Am I visible? Visible? Okay, cool. So the criteria for major depressive disorder needs to be for how many weeks? I'm sure all of you know the symptoms like anhedonia, lack of pleasure, sleep issues that could be too much or too little, appetite issues too much or too little, dysphoria, which means bad mood, fatigue for no explained reason whatsoever, right? Agitation, concentration issues, self-esteem issues, leading to extreme guilt and suicidal ideations. Can someone please tell me the duration for how many weeks? How many weeks? How many weeks? How many weeks? Not 4 weeks, 2 weeks. 14, 15 days. Okay, 2 weeks. All right, what is the difference between hypomania and mania? I had already made a graph for you earlier for hypomania and mania. Now we're going to see what is the duration of hypomania and duration of mania. You all tell me please. What is the degree of distress? Hypo means small. Mini mania. And mania means big. Now what I like to tell people directly is that देखो mania तो आपको बहुत अच्छे से याद रहेगा. There is distractibility. The patient suddenly starts talking बड़ी बड़ी बातें. Patient is convinced that he is in touch with God. बहुत fast बात करता है. उसको रोका नहीं जा सकता है. They are dangerous to self. They are making bad decisions. Their lack of need of sleep is there. Insight नहीं होता है. तो मेनिया तो समझ गया. अब उसका बेबी जो वर्जन है, छोटा वर्जन है, दैट इज हाइपोमेनिया. सो हाउ मेनी डेज डू वी नीड दीज सिम्टम्स फॉर हाइपोमेनिया एंड हाउ मेनी डू वी नीड फॉर मेनिया? प्लीज यू गाइस टेल मी. डिग्री ऑफ डिस्ट्रेस ऑब्वियसली अगर छोटा है तो माइल्ड टू मॉडरेट ही होगा ना हाइपो में, और सीवियर हो जाएगा इन टर्म्स ऑफ मेनिया. स्पीच रैपिड दोनों में ही होगी, बट यहां पे कैन बी स्टॉप्ड, पर यहाँ पे प्रेशर ऑफ स्पीच मतलब बोलना है तो बोलना है, बिल्कुल रुकना नहीं है. प्रेशर ऑफ स्पीच यहाँ पे हो रही है. थॉट, दे आर गोइंग फ्रॉम वन टू अनदर, दैट मीन्स देयर इज अ फ्लाइट ऑफ आइडियाज, बट इसमें ज्यादा है, इसमें थोड़ा कम है. इनसाइट ज्यादातर प्रेजेंट रहती है. इन हाइपोमेनिया पेशेंट कहता है हाँ मुझे लग रहा है मैं ज्यादा बात कर रहा हूं, बट मेनिया में इनसाइट नहीं रहती है. नो इनसाइट. एडमिशन मे और मे नॉट, बट ओपीडी पे मैनेज कर सकते हो हाइपोमेनिया. येस नीड्स एडमिशन और मे नीड मेडिकेशन एट होम इन द फॉर्म ऑफ मेनिया. Psychosis is not there in hypomania, may be there in mania, because mania can be with psychosis and even without psychosis. Okay, and the diagnosis, we will come to that on the next page. So there is bipolar diagnosis if depression episodes are there alternating with it. अगर एक बारी डिप्रेशन बाइपोलर 2 डायग्नोसिस दोगे अगर आप डिप्रेशन प्लस हाइपोमेनिया हुआ तो, एंड बाइपोलर डिसऑर्डर 1 डायग्नोसिस दोगे अगर आप मेनिया और कभी मेजर डिप्रेसिव डिसऑर्डर का डायग्नोसिस हुआ तो। ड्यूरेशन किसी ने बताई नहीं मुझे, मैं ड्यूरेशन के लिए वेट करती रह गई। हाउ मेनी डेज हाइपोमेनिया एंड हाउ मेनी डेज मेनिया? कम ऑन गाइस, इतना अच्छा आंसर दे रहे थे, अब मैं जवाब देने लग गई तो आप लोग का जवाब ही देना बंद हो गया। गिव मी द आंसर प्लीज। How many days do we need the symptoms for hypomania? How many days do we need the symptoms for mania? Please enlighten us. How many days? 4 days. And here 7 days or if hospitalized earlier. Okay. किसी ने जवाब नहीं दिया. Not 30 days. 4 days for hypomania, 7 days for mania or if admitted earlier. Okay. Next, let's study postpartum blues, postpartum psychosis, and postpartum, oh sorry, my bad, depression and postpartum psychosis. Why don't you tell me which is the most common? Most common कौन सा है? Which is the most common out of all of these? Postpartum blues, postpartum psychosis, or postpartum depression? What is the most common? Most common is postpartum blues. Okay. Nearly 80% women at some point can have not at some point, nearly 80% women can have postpartum blues. So let's look at the timeline. Then let's look at the severity. Then let's look at the symptoms. And then look at the management. Okay. So, postpartum blues starts within the first 3 to 5 days and resolves within 1 to 2 weeks. 3 to 5 days and resolves within 2-ish weeks. Notice, it is at this time that we usually say that postpartum depression can begin at any time in the first few weeks to months, but it will not resolve itself. So, anytime within few months, but does not resolve in 2 weeks. And we need 2 weeks for depression diagnosis. Remember, for depression, we do need 2 weeks, right? Whereas postpartum psychosis can begin within the 2 weeks and up to first 2 to 3 months. Got it? So, postpartum blues immediately birth होने के कुछ दिन बाद और 2 हफ्ता में कम हो जाता है या बंद हो जाता है. Postpartum depression किसी भी टाइम पे स्टार्ट हो सकता है फर्स्ट फ्यू मंथ्स में, बट वो 2-3 हफ्ते भी नहीं ठीक होगा, इट विल गेट वर्स. Postpartum psychosis, which is different, which is losing touch with reality, within first 2 weeks होगा और 2-3 महीने के अंदर कभी भी हो सकता है, right? Severity is mild to moderate in postpartum blues, severe to very severe in postpartum depression, and it is very severe here because baby can be at the risk. See, treatment हमने already पीछे याद की पढ़ी थी, याद है? Can somebody give me the treatment please? Can someone give me the treatment please? So, in the symptoms of postpartum blues, the woman will be slightly tearful, crying, but her mood can get better. She connects with the baby. However, in postpartum depression, all the symptoms of major depressive disorder are met with. She may not even connect with the baby. In postpartum blues, we need to give support, plus we need to give therapy. Here, we need to give SSRIs plus therapy, and we already spoke about the newer medication. What were they? Brexanolone and Zuravavi or Zuranolone. And here you need to give antipsychotics, maybe even ECT. Okay? Alright. Next, what is a delusion, my friend? A delusion is a false, fixed, firm belief in the face of irrefutable truth. सच के जानने के बावजूद भी इंसान जो मन में सोचा है वो ही बिलीव करना चाहता है. Most common delusion is delusion of persecution. कोई मुझे मारना चाहता है. Capgras syndrome is when you feel that a close person is replaced by a far or a stranger. मेरे घर में जो मेरी मदर है वो मेरी मदर नहीं है, वो कोई और है. And Fmge is the opposite. Fmge means basically changing disguise. तो इसमें एक ऐसा लगता है कि स्ट्रेंजर जो है वो बार बार कपड़े बदल रहा है आपको कंफ्यूज करने के लिए, और वो सेम ही क्लोज पर्सन है. ठीक है, इसका ऑपोजिट. सो क्लोज पर्सन, माई मदर हैज बीन रिप्लेस्ड बाय अ स्ट्रेंजर, and a stranger is my mother. It's actually my mother only. She's wearing different clothes and she's pretending to not know me. Intermetamorphosis meaning person has changed their body and mind into something else entirely. And lycanthropy means some animal has taken over the person's body. Unknown to known. हाँ देखो, close to far is unknown to is far to close. मैं C for close और C for capgras बोलना प्रेफर करती हूँ, क्योंकि unknown known अलग हो जाता है. Close means known हुआ ना, तो close तो known हो गया, right? All right. Next, Let's talk about furthermore kind of delusions. Othello syndrome is from the movie Omkara. My partner is cheating on me. Delusion. इसको कहते हैं delusion of infidelity. Cotard syndrome is a nihilistic syndrome. My insides are rotting and I am a walking corpse. मैं चलता फिरता लाश हूँ. Delusion of parasite infestation is Ekbom syndrome, where the person is convinced that there is some kind of insects in their skin. Parasite या insects. Delusion of grandeur can be grandiose ability or grandiose identity, seen obviously in mania. The person says, I can do anything, like make it rain. Or they can say identity, I am God. Okay. What are hallucinations and what are pseudo hallucinations? Hallucinations are in the absence of external stimuli, the person perceives. परसेप्शन कहाँ कहाँ होती है? 5 ऑर्गन्स में होती है. कान, नाक, आंख, मुंह, स्किन, है ना? परसेप्शन विदाउट एक्सटर्नल स्टिमुलाई. बट सूडो हेलुसिनेशन होती है परसेप्शन लाइक एक्सपीरियंस रिकॉग्नाइज्ड एज अनरियल. मतलब मुझे ऐसा लग रहा है मेरे को कान में आवाज आ रही है, पर मुझे पता है कि मेरे को कान में आवाज नहीं आ रही, क्योंकि सूडो हेलुसिनेशन में इनसाइट प्रिजर्व्ड होती है, वेरएज हेलुसिनेशन में नहीं होती है. हेलुसिनेशन में इंसान कहता है कि कान के बाहर से आ रही है आवाज, इधर कहता है कि मेरे दिमाग के अंदर से आ रही है आवाज. ऑब्वियसली हेलुसिनेशन स्किज़ोफ्रेनिया में देखते हो आप एंड अदर साइकोसिस. बट ये जो है सूडो हेलुसिनेशन, ये आप डिसोसिएशन में देख सकते हो, ये आप पीटीएसडी में भी देख सकते हो. ठीक है. Now let's talk about certain definitions. I'm going to grab some water, guys. Please feel free to ask any questions that are there so far. I'm going to drink some water. Most common hallucination is auditory. Hallucination, correct? एकदम correct. Okay, doctor, you can drink some water if you feel thirsty when someone drinks water. All right, let's talk about key pointers. एक सिचुएशन ले लेते हैं. आपने पेशेंट से पूछा, how did you come here today? A patient who is circumstantial will go round and round but come to the point. Meaning, they will say, मैं ना घर से निकला, घर के बाहर एक गाय खड़ी थी, गाय से मैंने सोचा कि अरे मेरे को दूध पी लेना चाहिए, मैं दूध पीने वापस चला गया, दूध गर्म नहीं था, मैंने गर्म किया, माइक्रोवेव खराब हो गया था, माइक्रोवेव के बारे में मैंने सोचा अरे नया खरीदना पड़ेगा, मैंने अमेजोन पे देखा क्या होता है, फिर मुझे याद आया कि मुझे निकलना चाहिए, फिर मैं निकला, फिर मैंने गाड़ी पकड़ी, गाड़ी में को बहुत ज़्यादा भीड़ थी, ट्रैफिक जो है आजकल कितना बढ़ गया है, और उसके बाद फिर मुझे गाड़ी से आते आते यहाँ पे 12 बज गए, अब मैं यहाँ पे हूँ। दैट इज सर्कमस्टेंशियलिटी। टेंजेंशियलिटी मीन्स आपने कुछ पूछा किसी से पर वो उस बात को छू के निकल गया, they did not reach the point. So all of what I said, but in the end the patient did not even tell me how they came there. That would be tangentiality. Loosening और derailment मतलब patient ने बोला, सी देखो इसकी डेफिनेशन सबको पता है, इसलिए आई एम नॉट स्पेंडिंग टाइम इन राइटिंग इट, आई वांट यू टू ऑब्वियसली know these definitions by now. You should know that, you know, never reaches a goal, sometimes reaches a goal with difficulty, illogical jumps, ये सारी चीजें आपको पता है, मैं एग्जाम्पल से बताना चाह रही हूँ। यहाँ पे क्या होगा, टॉपिक से जंप करता रहता है, तो पेशेंट डीरेल हो रहा है, रेल की पटरी से गिर गया। कैसे, आप यहाँ कैसे आए हैं? मैं एक्चुअली रोज खाना खाता हूँ, भगवान वहाँ पे रहते हैं, उसका क्या लेना देना है, आप कहाँ पे रहते हो? सो दैट इज डीरेलमेंट, ठीक है। Autistic thinking basically thinking in a very autistic manner, in a fashion that does not make sense to you and I, because the point being here that जो autism में thinking होती है ना, वो बहुत ही core होती है, how did you come here, तो उसको वो बहुत ही literally लेंगे। कैसे literally लेंगे? जैसे मैं example देती हूँ आपको, आपने पूछा okay, how did you come here, मेरी एक बहुत टाइम मशीन में स्पेस ट्रैवल करने की इच्छा थी, वो ही लेकर मैं आज आया हूँ। सो बेसिकली एक फैंटेसी जैसी डायलॉग बोलेंगे, दैट इज ऑटिस्टिक थिंकिंग। नियोलॉगिज्म मतलब न्यू वर्ड, आप यहाँ कैसे आए, मैं यहाँ पे कर डूमा में आया हूँ, तो उन्होंने कार का वर्ड बना दिया कर डूमा में आया हूँ, राइट। वर्बिजरेशन मतलब बेसिकली आपकी कोई ना कोई पार्ट को रिपीट करते रहना, रिपीटिंग सम पार्ट ऑफ व्हाट यू हैव आस्क्ड। सो आप यहां कैसे आए हैं, आए हैं, मीनिंगलेस, या फिर अपने ही कोई पार्ट को मीनिंगलेस रिपीट करते रहना। जैसे मैंने पूछा आप यहाँ कैसे आए हैं, तो उन्होंने कहा मैं यहाँ कार में आया हूँ, फिर मैंने कहा अच्छा आपने क्या खाया है, मैं यहाँ कार में आया हूँ, आपने आज क्या आज क्या कपड़े पहने हैं, मैं यहाँ कार में आया हूँ। इकोलालिया इकोलॉगिया मीन्स आफ्टर द एग्जामिनर कॉपी करना। मैंने बोला, जैसे बच्चे छेड़ते हैं एक दूसरे को, राइट, मैंने बोला क्या, तो उसने बोला क्या, मैंने बोला तो उसने बोला मैंने किया ऐसे, तो पेशेंट ने किया ऐसे। दैट इज इकोलालिया एंड इकोलॉगिया, ऑलराइट। Let's look at some phobias. Acrophobia, agoraphobia, claustrophobia, nyctophobia, social phobia and thanatophobia. और आप लोग चैट में बताएंगे आप में से किसको कौन सा फोबिया है फिर मैं बताऊंगी मेरे को कौन सा फोबिया है, ठीक है। ऑलराइट डॉक्टर देवी कृष्ण, दैट्स गुड टू नो। पहले आप बताओगे आपको कौन सा फोबिया है, फिर मैं बताऊंगी मेरे को कौन सा फोबिया है, ठीक है। एक्रोफोबिया मीन्स एक्रोबैट। एक्रोबैट क्या करते हैं, बहुत ऊंचाई पे करते हैं, so it is the fear of heights. Phobia is nothing but irrational fears is called phobia. Phobias are extremely common. Agoraphobia means fear of going out in open spaces or traveling alone or being in closed spaces from which patient feels that escape will be tough. Claustrophobia, confined spaces like a elevator, तो ये लोग सीढ़ी ढूंढते हैं हर जगह। Nyctophobia means, nycta means night, fear of darkness. चैट में लिखो आपको कौन सा फियर है, फिर मैं बताऊंगी मुझे कौन सा है। Fear of embarrassment in social setting is called social phobia. So they avoid it. Okay. And thanatophobia is fear of death. आपको कौन सा फोबिया है? क्लॉस्ट्रोफोबिया, एग्जामोफोबिया, एक्रोफोबिया, क्लोज स्पेस. गेस करो मुझे कौन सा फोबिया है. गेस करो मुझे कौन सा फोबिया है. गेस 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 करो मुझे कौन सा फोबिया है. Psychiatry is a little bit of self-discovery, right? You realize. नहीं, मुझको एक्रोफोबिया है, fear of heights. ठीक है. एरोफोबिया भी होता है कुछ लोगों को. एरोफोबिया होता है fear of planes. ये नहीं है मुझे. I like being on planes. ओके. निक्टर नहीं है मुझे, नाइट का नहीं है, डार्कनेस का नहीं है. ओके, नेक्स्ट. कन्वर्जन डिसऑर्डर. हमने पहले भी पढ़ा था ब्रीफली. कन्वर्जन डिसऑर्डर इज मोर कॉमन इन फीमेल्स who are young, who are unmarried. There may have been some trauma, especially sexual abuse history, also called hysteria in the past, or dissociative disorder. Conversion of psychological unconscious conflict or impulses is made to physical sensation is basically, and how do you know? You have to rule out causes. So जैसे कि अगर patient presents sudden onset after a trauma or a trigger or a stressor with blindness or muteness or seizure or paralysis, you have to rule out that there is no neurological deficit. Okay, they do not follow the anatomy principle. One interesting thing is labella indifference. Beautiful indifference. I like to call it मुझे फर्क नहीं पड़ता है. फर्क नहीं पड़ता है. मतलब ऐसा पेशेंट जिसको आप लाएंगे और वो पेशेंट सडन ऑनसेट ब्लाइंडनेस लेकर आई है, बट उसको कोई फर्क नहीं पड़ता है. शी इज लाइक नॉनचलांट, उसको कोई केयर नहीं है, कोई रिएक्शन नहीं है. सो दैट इज कॉल्ड लाबेला इंडिफरेंस. ओके, नेक्स्ट. सोमेटाइजेशन और हाइपोकॉन्ड्रियासिस, ये हमने पीछे पढ़ा था. सोमैटिक सिम्टम्स यहाँ पे भी होते हैं और यहाँ पे कोई डायग्नोसिस से ऑब्सेशन होती है. मतलब presenting features of somatic symptoms will be basically pains, aches, fatigue. There may be some underlying medical cause, but not so much that it causes the person that problem. However, hypochondriasis में there is few symptoms, no medical underlying cause. Both go for doctor shopping. Hypochondriacs love lab investigations. डॉक्टर साहब एक MRI करवा दीजिए, डॉक्टर साहब एक्सरे करवा दीजिए. यू हैव टू लिटरली टेल देम कि एक्सरे से जो कैंसर होने के चांसेस हैं वो बहुत ज़्यादा होते हैं. एंड सोमैटिक्स डिमांड फॉर सिम्टम रिलीफ बिकॉज दे आर ऑब्सेस्ड विद देयर सिम्टम्स. मुझे अच्छा नहीं लगता है, खाना नहीं पचता है, थकावट होती है. बट हाइपोकॉन्ड्रियाक्स आर ऑब्सेस्ड विद डायग्नोसिस. They insist that the doctor has missed something. That's why they keep running from doctor to doctor to doctor. समझा guys? Okay, guys. Now we'll talk about Munchausen and Munchausen by proxy. This is a factitious disorder जिसमें कि the patient inflicts upon self कुछ symptoms जिससे कि उसको मेडिकल केयर मिलती है, मेडिकल अटेंशन मिलती है. तो नीड क्या होती है? इमोशनल होती है. Munchausen by proxy is when person inflicts this upon someone dependent on them, जैसे कि child या someone very old. Ganser syndrome prisoners में देखा जाता है, जहां पे hallucinations, approximate answers, जिसको वो जर्मन में बोलते हैं वोर बी गे हेन. जैसे कि अगर मैंने बोला व्हाट इज 1+1 तो वो कहता है 5. ओके, यहाँ पे द पेशेंट द गैंसर सिंड्रोम में द नीड मे बी टू गेट आउट ऑफ जेल, ओके, और टू गो इनटू द इन्फर्मरी. Malingering is a lie where the patient's consistency in history is not there and they do it for secondary and tertiary gain. मतलब tertiary gain मतलब to someone close to them will not go to work. सेकेंडरी गेन मतलब उनको छुट्टी मिल जाएगी. They will get a holiday. Okay, got it? What is OCD? Obsessive compulsive disorder. Nearly 2 to 3% में देखा जाता है. Disorder of possession of thought होता है. Corticostriatal thalamocortical tract पे काम करता है. And most common comorbidity is major depressive disorder, other anxiety disorders, tics. There could be also OCD spectrum disorders. Most common obsession, most common compulsion आप लोग मुझे बताएंगे. Pharmacological treatment हम already कर चुके हैं, already done. आप लोग मुझे मोस्ट कॉमन ऑब्सेशंस एंड मोस्ट कॉमन कंपल्शंस बताएंगे. मोस्ट कॉमन कंपल्शन एंड मोस्ट कॉमन ऑब्सेशन आप लोग मुझे बताएंगे. मोस्ट कॉमन ऑब्सेशन एंड मोस्ट कॉमन कंपल्शन आप मुझे बताएंगे. कम ऑन, आई एक्सपेक्ट यू ऑल टू टेल मी दिस वन. Most common obsession, most common compulsion. Most common obsession, most common compulsion. Guys, come on. Wake up, wake up. Hello, hello. Come on. Yes, fear of contamination. And most common compulsion. Automatically, अगर मेरे को डर लगता है कि मैं गंदे हो जाएंगे हाथ तो क्या करूंगी? Washing. Very good. Good. Let's look at hoarding disorder, trichotillomania, body dysmorphic disorder, and excoriation disorder. These are OCD spectrum disorders. Okay. Hoarding means keeping useless items or things beyond need or use. जैसे कि newspapers, waste papers, etc. Trichotillomania means compulsive hair pulling. We already discussed this. Body dysmorphic disorder means obsession with perceived flaws. ये भी हमने पहले cover कर लिया. Excoriation disorder means skin picking. You could skin pick from your lips, from your hands. PTSD, post-traumatic stress disorder. Important topic hai guys, pay attention. What is it? In response to trauma, the amygdala goes on a overdrive. Okay. Now, the trauma has to be catastrophic. That means very big. So, it could be natural, like floods, earthquake, or it could be a rape or sexual assault. It could be an accident. So, it needs to be a big trauma. The patient develops avoidance to think about it, to talk about it, also develops intrusive thoughts, nightmares, hypervigilance, okay. The treatment we have already done. SSRIs, Prazosin for nightmares, and EMDR and trauma-informed CBT. One thing you should know is duration. Less than 1 month, acute stress disorder. More than 1 month, post-traumatic stress disorder. More than 6 months, delayed onset PTSD. Got it? Got it? Social withdrawal, acrophobia. अरे कुछ आंसर्स अभी आ रहे हैं guys. Okay. All right. Sensate focus is a type of focused on performance anxiety. Biofeedback is a mechanism in which the heart rate, the muscular tension, and galvanic sweat is measured. So we retrain the brain to be calm through this machine by learning our response style. Okay. CBT is cognitive behavioral therapy. Now, used in almost everything: major depressive disorder, generalized anxiety disorder. You can give it in postpartum blues. You can give it in phobias. You can give it in PTSD. You can give it in practically any particular situation. Okay? And there is a triad of thinking, feeling, behaving that we focus on in CBT. ERP is exposure, response, prevention. Where is it used? We discussed just in the previous slide, OCD, but does not have a good response. What's the difference between CBT and DBT? CBT is cognitive behavioral therapy. It is how we think. DBT are dialects. Dialects are dialogues that we say to ourselves. Think of DBT as a more refined version of CBT, specifically focused on the dialects or the inner dialogues that we have. And that's why DBT is more useful in borderline personality disorder, where the inner dialogue needs to be worked through. So that is the difference between CBT and DBT. पहले CBT आई, फिर उसका offshoot DBT आई, ठीक है? All right. Systematic desensitization used for phobias, specific phobias. You make a ladder or hierarchy of fears and you gradually expose. Plus, you teach relaxation. Okay? Milieu therapy is used for schizophrenia to reintegrate the patient back into society. JPMR stands for Jacobson's Progressive Muscular Relaxation. Okay. And stop squeeze technique is used for premature ejaculation. Premature ejaculation. Okay. What's it? Game over. Kyun game over? Okay. Flooding is when, again, used in phobias, not very often used. You open up the person to fears in one go. तो जैसे अगर किसी को डॉग से डर लगता है तो उसको 4-5 डॉग्स के सामने खड़ा कर दो. Aversion therapy means I like to think of it as yuck therapy. So what do we do in yuck therapy? Basically, disulfiram is an example that if first patient drinks on it, then we'll have a reaction and a booze reaction, which is why he will say yuck, I don't want to drink. Ab reaction is related, ये पूछा गया है PYQ में कहीं पे guys and NEET में मेरे ख्याल से, catharsis. यहाँ पे ab reaction मतलब unconscious को conscious में लाना. अब आप कहेंगे कैसे? Unconscious को conscious में लाने के लिए एक तो होती है hypnotherapy या hypnosis और दूसरी हो गई थायोपेंटॉल इंटरव्यू, जिसको कहते हैं ट्रूथ सीरम. ठीक है, अंडरस्टूड. ये कैथारसिस या अनकॉन्शियस टू कॉन्शियस को क्या बोलते हैं लाना, उसको एब रिएक्शन बोलते हैं. ये एक जगह पे एमसीक्यू था रिसेंटली. ठीक है. Now we are on to the stages. I'm going to drink more water on that and you're going to discuss with me the stages that are there in Freud's stages of development. Freud stages of development. क्या क्या हैं? फ्रॉइड की स्टेजेस कौन बताएगा? Freud stages of development, psychosexual development. Come on, guys. I need the answer from you. बड़ी देर से आंसर मैं ही दे रही हूँ. Is the truth serum the same given to criminals who confess the court? No, it's not a silly question. Yeah, it is the same thing. It is. Freud क्या बोलता है? Freud क्या बोलता है? Freud बोलता है we go through these stages. All of us do, right? हम सब इन स्टेजेस के थ्रू जाते हैं. क्या है ये स्टेजेस? तो पहली तो है बचपन में जब हम पैदा होते हैं, वी ऑल लाइक टू हैव माउथ एज अ प्राइमरी सोर्स ऑफ ग्रेटिफिकेशन. सो सकिंग इज द मेन दिस थिंग. दैट इज व्हाई सम पीपल गेट फिक्स्ड इन ओरल फिक्सेशन. So they may develop addictions. Oral source of pleasure main होता है. Next is the anal stage, which happens in 1 to 3 years, जहाँ पर basically feces या potty becomes the main focus. So we have people who become. Guys, the video has been stuck. Can you see me now? Can you see me now? Okay, great. So Oedipus complex and Lectra complex. Oedipus complex is what the boys get more attached to their mothers, and Electra is when the girls get more attached towards their fathers. Now, in the latent, nothing happens. There is just calm, relaxedness. And in the final stage, mature relationships start to bloom. Okay, that is Freud stages of psychodynamics. What all in the different stages are there? Okay, next, this is the one I had said कि मेरा आगे है, तो मैंने तब नहीं पढ़ाया था. Correct? अब हम ईटिंग डिसऑर्डर के बारे में बात करेंगे. लेट मी एक्सप्लेन ईटिंग डिसऑर्डर टू यू बिफोर आई गो इनटू डिटेल. एनोरेक्सिया नर्वोसा, बुलिमिया एंड बिंज ईटिंग डिसऑर्डर 3 टाइप के होते हैं. इसमें से बिंज ईटिंग डिसऑर्डर मोस्ट कॉमन होता है, अराउंड 50%. सबसे कम कॉमन, लीस्ट कॉमन एनोरेक्सिया होता है. Anorexia means a very thin person, okay? Typically in females, extremely underweight. They may be models or ballet dancer and the BMI is less than 17.5. In fact, they have immense body image disturbances. So they think they are fat. So as a result, they restrict food or they purge. I'll tell what purging is. Amenorrhea is common in these women. Okay? Avoidance, binge, compensation. Yes. And the weight is extremely low, as I discussed. For treatment, you may sometimes need to admit. You need to monitor closely. Obviously, therapy is important. May require SSRIs. And you must observe 2 hours after eating that they have not gone and thrown up. Now let's talk about bulimia. Bulimia means like ox. So you can see that their weight may be normal or even maybe more. They mainly are, their body image is also disturbed, but not as much as anorexia. They indulge in purging behavior, which means vomiting. They may even take laxatives, and they eat large quantities followed by purging behavior. Okay. They do not have amenorrhea. For treatment, you will obviously do therapy, you do medication. 2-3 things here. One is Russell sign. Russell sign is the callus that forms on the knuckles from the purging behavior. And you may want to remember that the enamel chips off and there could be chipmunk facies, which happens because of parotiditis. Constantly vomit करने की वजह से वो parotid gland में infection हो जाता है. Binge eating disorder is eating large quantity, small time, followed by guilt, but no purge behavior, no body image disturbance. Extremely common. Okay. Let's learn some scales. The SCOF scale, the audit scale, the CADE scale, and the FTND and MMSC. Yes, we will share the PDF after the class, but you are expected to also make your own notes as you go along in the class because it is helpful for you. Guys, थोड़ा सा ही और बचा, ज़्यादा नहीं. Sick, control, food, full, and fat. This scale is used for eating disorders where the patient feels sick, loses control. One stone is 6.1 kg. The food is eaten and there's a fear of being fat. Audit is used for alcohol use, identification, test. Cage is loss of is cut down. Cage is also used for alcohol addiction. Cut down अनोयंस, दूसरे को आपसे अनोयंस हो रही है, आपको गिल्ट हो रही है पीने के बाद, और आप आई ओपनर यानी सुबह उठते से अल्कोहल चाहते हैं। ये है फेगरस्टॉर्म टेस्ट फॉर निकोटिन डिपेंडेंस and mini mental status exam out of 30 used for dementia. Okay, all right. Let's talk about personality disorders. 3 clusters are there: A, B, and C. A is paranoid, schizoid, schizotypal. These people are odd, eccentric, aloof. The defense mechanism is usually projection. Then cluster B is borderline personality disorder, histrionic personality disorder, antisocial personality disorder, and narcissistic personality disorder. These are dramatic, self-centered, and here in borderline personality disorder, defense mechanism is splitting and DBT is used. Last one is cluster C. Last one is cluster C. Anxious, avoidant, and obsessive compulsive personality disorder, also called anancastic. They are anxious and perfectionists. OCPD is different from OCD. How? OCD is distressing to self. Thoughts are ego dystonic, whereas OCPD thoughts are not ego dystonic. This I had said earlier that I will explain later. That's why I had written later there. What is an impulse? Impulse is an internal urge that is hard to resist. जैसे मैं बोलती हूँ, it's like an itch that one needs to scratch. मेरे को बहुत impulse हो रहा है ये scratch करने को. That is an itch that I can't stop, right, from myself from scratching. Kleptomania is stealing items of not value and one can afford it. Shoplifting. Trichotillomania already covered. Hair pulling. Pyromania is setting fire. Compulsive shopping is called oniomania. किस-किसको है? मुझे नहीं है. Before you all say, मैम आपको है क्या? नहीं, मुझे नहीं है. Oniomania. Stages of sleep के बारे में बात करते हैं. Okay. So I've tried to simplify it for you. I will explain the main exam pointers. Alright. Sleep में stages होती हैं. We start with our eyes open, जैसे अभी हम हैं. Then अगर आपको थोड़ी सी नींद आने लगेगी तो थोड़ा सा आंखें बंद करके पढ़ाई करते करते वेकफुल स्टेज में चले जाएंगे. फिर आप जाएंगे NREM स्टेज 1 में, 2 में, 3 में एंड फाइनली डीप स्लीप ऑफ REM में. ठीक है. तो 3 चीजें चेक करी जाती हैं पॉलीसोम्नोग्राफी पे. पॉलीसोम्नोग्राफी ग्राफी पे क्या क्या, EEG यानी ब्रेन एक्टिविटी, EOG यानी आई मूवमेंट एंड EMG यानी मस्कुलर टोन। ना ऐसे याद रखना है, जैसे आप जागे हुए हैं आपकी आंखें तो खुली हुई हैं, आंखें तो ऐसे से मूव कर रही हैं, साथ में मसल की तो टाइटनेस है ही, जो ब्रेन है वो बहुत सुपर एक्टिव है इस समय। अगर आप थोड़ा सा स्लीपी फील करने लगेंगे, अगर आप थोड़ा स्लीपी फील करने लगेंगे तो वेव्स विल चेंज टू अल्फा, आई मूवमेंट थोड़ी कम हो जाएगी, आंखें बंद हो रही हैं अभी, और जो मसल टोन है वो भी आपके कंट्रोल में है। अब आती है एनआरईएम स्टेज 1। यहाँ पे थीटा वेव्स आने लगेंगी, आईज थोड़ी थोड़ी और घूमने लगेंगी, बंद होने लगेंगी एंड मसल टोन कम होने लगेगी। एनआरईएम स्टेज 2 में हमें मिलेंगे के स्लीप स्पिंडल्स एंड के कॉम्प्लेक्स। You have to remember the stages of sleep में क्या क्या चीज रहती है, and know the excuse that you are feeling very sleepy will not work right now. I too am feeling very sleepy, but sleep spindles, I'm feeling very hungry rather. Sleep spindles and K complexes are seen in the NREM stage 2. अब कैसा है, आई मूवमेंट जो है वो धीरे धीरे अभी भी कम ही है। सडनली हम लास्ट स्टेज में, जब इधर भी सेम ही रहेगा, जब सडनली हम लास्ट स्टेज में जाएंगे रेम स्लीप, तो हमारी ब्रेन एक्टिविटी एकदम चेंज हो जाएगी। इसको कहते हैं सॉ टूथ अपीयरेंस। एंड बहुत इंपॉर्टेंट चीज जो होगी, आईज में रैपिड आई मूवमेंट होने लगेगी, रैपिड आई मूवमेंट होने लगेगी, और आपका मस्कुलर टोन चली जाएगी, एटोनिया हो जाएगा, मतलब अपना हाथ नहीं उठा सकते क्योंकि आप इसमें ड्रीम कर रहे हैं। ये ड्रीम वाली स्टेज है। ओ sorry guys, one sec. क्योंकि आप ड्रीम कर रहे हैं। आई होप दिस इज फाइन फॉर यू ऑल, या ओके। सॉ टूथ पैटर्न इन शॉ नहीं, सॉ क्योंकि सॉ का ऐसे ऐसे होता है ना, ऐसे सॉ में ऐसे ऐसे होता है, तो दैट इज वाई। ठीक है, नाउ फाइनली सम डेफिनेशंस। दीज आर पैराफीलियाज। पैराफीलियाज आर सेक्सुअल डिसऑर्डर्स जहां पे बेसिकली अननेचुरल चीजें करता है इंसान। एग्जिबिशनिस्ट मीन्स फ्लैशिंग प्राइवेट पार्ट्स टू नॉन कंसेंटिंग अडल्ट, बिना पूछे किसी को प्राइवेट पार्ट फ्लैश करना। सेडिज्म और मैसोचिज्म ज्यादातर साथ दिखता है। सेडिज्म मतलब पेन किसी के ऊपर इन्फ्लिक्ट करना, एंड ऑन ओन इन्फ्लिक्ट करवाना पेन, जिस पे पेन इन्फ्लिक्ट हो रही है वो मैसोचिस्ट है, और जो पेन कर रहा है वो सेडिस्ट है। Pedophilic means having sexual impulses towards children. Necrophilia means having the urge to have sex with dead corpses. Transvestism and transvestitic fetishism. Transvesticism means cross-dressing, and transvestic fetishism means having sexual gratification from wearing the opposite gender's clothes. This is just plain cross-dressing, and here it is, there is sexual gratification from cross-dressing in the opposite gender's clothes. Okay, Fraucherism is rubbing parts in, like, let's say a bus against non-consenting person. Satyriasis and nymphomania, these are related, that is excessive sexual drive. So in nymphomania is in females, satyriasis is in males. Okay. Wow, we covered a lot. There's one thing I didn't answer for you all. That is, rapid cycling में कौन सा ड्रग देते हैं? बताऊं? Shall I answer? अगर आप लोग कहोगे तो बताऊंगी. अगर आप लोग कहोगे नहीं तो नहीं बताऊंगी. बताइए. बताऊं कि नहीं बताऊं? बताऊं कि नहीं बताऊं? Guys, how was the lecture? जोश कैसा है? भूख लग रही है? मुझे भी लग रही है. खाएंगे अब खाना, राइट? बताइए, बताऊं कि नहीं बताऊं? ओनली अगर पॉपुलर डिमांड होगी बताने के लिए, आई एम गोइंग ऑल द वे बैक, तो बताऊंगी. पॉपुलर डिमांड होगी तो बताऊंगी. कम ऑन गाइस. नहीं है पॉपुलर डिमांड तो नहीं बताऊं. रैपिड साइक्लिंग का आंसर बताऊं? रैपिड साइक्लिंग का आंसर बताऊं? लिथियम. ओके. You can use sodium valproate also. Both of these. ठीक है. One more thing that I think I should write here. Okay. Any other questions, guys? Any other questions, guys? Feel free to ask. I'm here for a couple of minutes. Any other questions, guys? Lamotrigine नहीं देते हैं रैपिड साइक्लिंग में. आपने बोला था बट कंसेंसस नहीं बन रहा था. कुछ लोग लिथियम कह रहे थे, कुछ लोग सोडियम वैल्प्रेट कह रहे थे. Lamotrigine नहीं, no, not rapid cycling. Lithium and sodium valproate. Typically by the time the patient has rapid cycling, उसको एक आधा मूड स्टेबलाइजर ऑलरेडी चल ही रहा होता है, तो इसलिए एक और ऐड करना पड़ता है. लिथियम चल रहा था तो फिर सोडियम वैल्प्रेट डालते हैं, सोडियम वैल्प्रेट चल रहा होता है तो लिथियम डालते हैं. That's usually how it goes in clinical practice. Any other questions, guys? Feel free to ask. Yes, I will share the PDF after the class for sure. कोई और डाउट है तो प्लीज पूछो guys. Happy to answer. नहीं है तो बता दो. Okay, I think we will call it a day. Thank you for sticking around, and a lot of you stuck around. I'm very happy. All the best for your exam. See you guys on the day of your exam.
Good afternoon, everyone. Welcome to class. Good afternoon. Am I audible and visible? Am I audible and visible? Okay, so like we will now start the ophthalmology session. Hello, everyone. Hi, everyone. I hope I'm audible and visible. शुरू करें? Okay, so today what we'll be doing is we will be doing a quick run through of the important topics that we have in Ophthal. So we will do the important topics as in a form that you should be able to answer all the important questions that come from here. तुम सब अपने प्रिपरेशन के लास्ट फेज में हो तो वी विल ट्राई टू डू इट as coherently and as as crisply as possible. ठीक है, so चलो, how long will it be? We will try to complete it in about 2.5 hours. 2.5 घंटे में खत्म करने की कोशिश करेंगे. ठीक है, so चलो, let us start with the simple topics. The first one, very very important for all exams, Vernal Keratoconjunctivitis or VKC. Vernal Keratoconjunctivitis or VKC. What kind of conjunctivitis is this? This is a recurrent allergic conjunctivitis, right? This is a recurrent allergic conjunctivitis and it is seen just prior to the onset of the summer months, and so it is also called as the spring catarrh. It's also called as the spring catarrh. It is commonly seen in boys or girls. It is commonly seen in boys between 5 to 15 years of age. Another very, very important thing to remember, what type of hypersensitivity reaction is it? It is a type 1 hypersensitivity reaction. So एक बार quickly याद कर लो, because it is a type 1 hypersensitivity reaction, that is why it is mediated by what? It is mediated by IgE. And दूसरा पूछते हैं, what type of cells are involved in this process? Correct. It is the mast cells. So it's a type 1 hypersensitivity mediated by IgE and the cells involved are mast cells. Okay. So next, what we have to remember is, what is the commonest symptom? The commonest symptom is itching. Itching, that's why the child keeps rubbing the eyes, and if the child keeps rubbing the eyes, there will be redness and there will be watering. So itching, redness and watering of the eyes, this is the complaint of the patient. Now comes the important part as far as exam is concerned, and that is these two images. Have a look at these two images. ये दोनों ही image बहुत बहुत commonly exam में पूछते हैं. तो first वाला जो image है इसको देखो. This is an image of the everted upper lid, and what do we see? We see these flat topped elevations. What are these flat topped elevations called? These flat topped elevations are called as papillae. Papillae are a sign of allergy. और ये जो appearance है of flat topped elevations, where is it seen? It is seen on the upper tarsal conjunctiva. It is seen on the upper tarsal conjunctiva, and this appearance of the conjunctiva, very good, it is called as the cobblestone appearance. It is called as the cobblestone appearance. Cobblestone appearance. Okay, so these flat topped elevations are also called as papillae, and this appearance is called cobblestone appearance. And close to the upper limbus you see these whitish dots. तो ये जो whitish dots है इनका नाम क्या है? What are these whitish dots or elevations on the upper limbus? They are called as the HT spots or the Horner-Trantas spots. They are called as the HT spots or the Horner-Trantas spots. Now please give me a minute to explain something very important. ये जो Horner-Trantas spots है, इसको बहुत सारे बच्चे जो है ना, they get confused with the Herbert Spitz of trachoma. तो हर्बर्ट स्पिट्स ऑफ ट्रकोमा के साथ कंफ्यूज नहीं करना है, बिकॉज ये जो हॉर्नर ट्रांटा स्पॉट्स है ना, दे आर वाइट इन कलर, जबकि हर्बर्ट स्पिट्स जो है दे आर ब्लैक इन कलर. हर्बर्ट स्पिट्स ब्लैक होते हैं, हॉर्नर ट्रांटा स्पॉट्स आर वाइट इन कलर. ठीक है, सो दीज आर दी conjunctival features. और corneal features में क्या है? Because of the rubbing of the papillae on the cornea, what do you get on the cornea? You may get an ulcer. What is the name of that ulcer? The name of the ulcer is shield ulcer. Again, very very common one liner. Because of the rubbing of the papillae on the cornea, you can get an ulcer or an erosion on the surface of the cornea, which is called as the shield ulcer. तो देखो, कंजंक्टिवल फीचर्स में हमें याद रखना है कॉबलस्टोन अपीयरेंस एंड HT spots. Corneal features में हमें याद रखना है shield ulcer. Now again please give me a minute. ये जो picture है ना, this kind of cobblestone appearance, the same appearance is also seen in another type of conjunctivitis which is called as giant papillary conjunctivitis. Now just give me a minute. एक बार इसको ध्यान से सुनो. तो ये सेम पिक्चर जो है ये दो क्वेश्चंस में आ सकता है. एक तो है ये, दैट इज वर्नल केरेटोकंजंक्टिवाइटिस. Then what will the question say? The question will say that this is the clinical picture of a boy about say 7 to 8 years old who has presented in the summer months with complaint of itching, redness and watering. तो अगर ये हिस्ट्री है that it's a boy between 5 to 15 years of age presented with itching in the summer months, और ये पिक्चर अगर हमें दिया गया है तो हमें क्या आंसर मार्क करना है? We have to mark the answer as VKC, वर्नल केरेटोकंजंक्टिवाइटिस या फिर स्प्रिंग कटार. लेकिन सेम इमेज के साथ क्वेश्चन को बदल सकते हैं. समटाइम्स दे गिव द सेम इमेज एंड दे से दैट दिस इज सीन इन अ पर्सन हु हैज बीन यूजिंग एन इल फिटिंग कॉन्टैक्ट लेंस फॉर अ वेरी लॉन्ग पीरियड ऑफ टाइम. सो अगर ये सेम क्वेश्चन सेम इमेज है, लेकिन अगर हिस्ट्री में यह दे हैव सेड दैट इट इज अ रिजल्ट ऑफ प्रोलॉन्ग्ड contact lens use, then the answer is going to become giant papillary conjunctivitis. समझ में आया? तो पिक्चर जो है वो सेम है, ओनली हिस्ट्री डिफरेंट होगी एंड उसके हिसाब से यू हैव टू सिलेक्ट द आंसर. दोनों ही PYQ है. So boy between 5 to 15 years of age presenting with itching summer months, and this image you have to mark VKC. A patient who has been using an ill-fitting or a loose contact lens for many months and then presents with itching and redness, same image you mark it as giant papillary conjunctivitis. ठीक है, तो वापस आते हैं टू व्हाट वी वर डूइंग. सो वर्नल केरेटोकंजंक्टिवाइटिस में अब क्या बचा है? नाउ वी हैव टू डू व्हाट इज द ट्रीटमेंट. So treatment has two aspects. One is treatment of the acute episode. Acute episode means patient जो है he has been brought to us with complaint of itching, redness, irritation, etc. और दूसरा है prevention of recurrence. And then we have prevention of recurrence. Prevention of recurrence. So देखो, first we come to treatment of the acute episode. So treatment of the acute episode में हम क्या देंगे? For symptomatic managements we give lubricants, but lubricants जो है that is only for symptomatic relief. It is not going to address the actual pathogen. So actual pathogenesis के लिए what are the drugs? For actual pathogenesis, we are going to give topical antihistaminics. Very good. So we give topical antihistaminics. If the antihistaminics do not work, then you step it up to topical steroids. Now, which are the topical steroids that are commonly used? The topical steroids which are used are fluoromethalone, loteprednol, and prednisolone. Fluoromethanol, loteprednol, and prednisolone. These are the topical steroids. And if the topical steroids also do not work, then the next is topical immunomodulators. Topical immunomodulators. अब यहाँ पे भी एक चीज ध्यान से सुनो. These are the drugs which are used in the acute management of the condition. So which are the topical immunomodulators? The topical immunomodulators are cyclosporin and tacrolimus. Cyclosporin and tacrolimus. So if we are asked what are the drugs which are used in the acute management or the acute management of acute VKC, then what will be our answer? Our answer will be lubricants for symptomatic relief, antihistaminics, steroids and immunomodulators. लेकिन see, one of you mentioned mast cell stabilizers. अब प्लीज याद रखो कि mast cell stabilizers have no role in the treatment of the acute episode. तो acute episode के लिए हमें mast cell stabilizers नहीं देना है. Then what is the role of mast cell stabilizers? The role of mast cell stabilizers is in the prevention of recurrence. This comes as a question that which of these drugs is not used in the management of the acute episode. So the drug that is not used in the management of the acute episode is the mast cell stabilizer actually. So mast cell stabilizers ka role hai only in prevention of recurrence. And which are the mast cell stabilizers which are given? We give sodium chromoglycate. Sodium chromoglycate, ketotifen and olopatadine. Sodium chromoglycate, ketotifen and olopatadine. These are the mast cells. ठीक है. वेरी 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 इंपॉर्टेंट टॉपिक. पॉसिबिलिटी इसका कैसा है? दिस क्वेश्चन हैज गॉट अ हाई पॉसिबिलिटी ऑफ कमिंग इन एवरी एग्जाम. हर एग्जाम के लिए ये इंपॉर्टेंट ही होता है. ओके. Another important type of allergic conjunctivitis, quickly याद कर लो. The other type of important allergic conjunctivitis is Phlyctenular conjunctivitis. The other type of infective conjunctivitis is Phlyctenular conjunctivitis. Now, Phlyctenular conjunctivitis में there are only a few important things to be remembered. Phlyctenular conjunctivitis में सबसे पहले पूछते हैं what type of hypersensitivity is it? So quickly will you tell me what type of hypersensitivity is it? Phlyctenular conjunctivitis is a type 4 hypersensitivity. It's a type 4 hypersensitivity. So it is actually an allergic reaction to an endogenous antigen. So what is the antigen in India? In Indian scenario, the most common association is tuberculosis. The most common association is tuberculosis, but worldwide the most common association is going to be Staph aureus. Please remember these two. Staph aureus. So it's a type 4 hypersensitivity. In India, it's a hypersensitivity reaction to the tuberculous antigen. Worldwide, it's a reaction to Staph aureus. So how does it present? It presents with a nodule close to the limbus, and this nodule close to the limbus is called as your phlycten. So agar ye aisa hai, to there will be a nodule like this close to the limbus, and this nodule is called as the phlycten. And if the phlycten is not properly treated, that it can enlarge and it can encroach the cornea here, forming an ulcer. And this ulcer that it forms is called as the fascicular ulcer. It is called as the fascicular ulcer. तो याद रखो हमने शील्ड अल्सर पढ़ा था. शील्ड अल्सर इट इज सीन इन VKC. Fascicular ulcer is seen in Phlyctenular conjunctivitis. And what is the treatment? Treatment is obviously topical steroids because it is a hypersensitivity reaction. But in India, it has to be combined with ATT because the most common cause, or we should say the most common association of phlycten in India is tuberculosis. So 3-4 words, it's a type 4 hypersensitivity. Commonest association in India is TB and worldwide is staph. It presents with a nodule close to the limbus called phlycten, enlarges and causes an ulcer which is called as the fascicular ulcer. Treatment is topical steroids under the cover of ATT in India. ठीक है, so two very important topics from conjunctiva, VKC and Phlycten. चलो आगे बढ़ते हैं. नेक्स्ट इज xerophthalmia. अगेन वेरी हाई पॉसिबिलिटी ऑफ कमिंग इन एनी एग्जाम. xerophthalmia, it is caused by deficiency of xerophthalmia, it is caused by deficiency of vitamin A. Correct, it is caused by deficiency of vitamin A. And I will just quickly revise that vitamin A, it affects the eye in two ways. Number one, it affects the rod cells of the retina, and in the rod cells there is a pigment which is called as rhodopsin. So it affects the synthesis of the rhodopsin pigment, and therefore the earliest symptom of xerophthalmia is night blindness. So look at the WHO classification. It starts with XN. XN is night blindness. So यहाँ से question पूछते हैं, which is the earliest symptom? So what is the earliest symptom? It is night blindness. Now, next, what does vitamin A deficiency do? Vitamin A deficiency, it also affects the ocular surface. So do you remember what is the epithelium of the ocular surface? The epithelium of the ocular surface is stratified, squamous, non-keratinized. The epithelium of the ocular surface is stratified, squamous, non-keratinized epithelium. And in the deficiency of vitamin A, the stratified, squamous, non-keratinized epithelium, it undergoes metaplasia. Metaplasia means it changes to stratified, squamous, keratinized epithelium. And because it becomes this kind of a keratinized epithelium, there occurs melting and ulceration of the ocular surface. So see, your xerophthalmia, it affects, number one, it affects the rod cells of the retina, and number two, it affects the ocular surface. How does it affect the ocular surface? The stratified squamous non-keratinized epithelium changes to stratified squamous keratinized, and because of this, two things happen: dryness, that is xerosis, and there is ulceration. Ulceration is called as keratomalacia. Keratomalaysia. So therefore, देखो, the earliest symptom is night blindness. Next comes the stage X1. अब इसको please ध्यान से देखो. Stage X1. Stage X1 is divided into 1A and 1B. 1A is the stage of conjunctival dryness or xerosis. Now please listen to me carefully. If we are asked which is the earliest sign of xerophthalmia, then our answer is going to be conjunctival xerosis. So इसमें mistake नहीं करना है. Earliest symptom is night blindness, but earliest sign is conjunctival xerosis. But any conjunctival xerosis or dryness जो है वो xerophthalmia नहीं है. So when are we sure that it is xerophthalmia? When we get to see this. So ये क्या है? Look at this whitish lesion which is close to the limbus. ये जो whitish lesion है that is close to the limbus, this is called as your Bitot spot. This is again a common image based question. And ये जो Bitot spot है ना, इसके बारे में याद रखना है that Bitot spot is the most specific sign. It is the most specific sign. So conjunctival xerosis is the earliest sign. Bitot spot is the most specific sign. ये हो गया stage X1. So 1A is conjunctival xerosis, 1B is Bitot spot. Next comes the stage of corneal dryness or corneal xerosis. That is stage X2. X2 is the stage of corneal xerosis. फिर comes the stage of X3. X3 is the stage of keratomalacia, मतलब corneal ulceration. तो अगर अल्सर छोटा है then it is 3A. It involves less than 1/3, and 3B, it involves more than 1/3. Now, once the cornea ulcerates, after that, if it heals, there will be formation of scar. Now, when there is formation of corneal scar, there is a loss of transparency. There is a loss of corneal transparency. As a result, this vitamin A deficiency becomes an important cause of childhood blindness. So basically, इससे हमें ये समझ में आता है that whenever there is an ulceration, after that there will be scar formation. तो यहाँ से पूछते हैं up to which stage is xerophthalmia reversible? So here also please remember that it is reversible up to X2. So X2, that is the stage of corneal xerosis, up to this it is reversible. It is reversible up to this stage. Reversible up to. So let me just go over it once more. Earliest symptom, night blindness. Earliest sign, conjunctival xerosis. Most specific sign, Bitot spot. And it is reversible up to the stage X2, which is the stage of corneal xerosis. ठीक है, फिर आता है कॉर्नियल अल्सरेशन, फिर स्कार, एंड इफ वी आर आस्क्ड व्हाट इज द एंड स्टेज ऑफ xerophthalmia, दैट इज XF, xerophthalmia fundus, which means that the whole retina is completely destroyed. ठीक है, अभी नेक्स्ट इज द ट्रीटमेंट. सो लेट अस कम टू द ट्रीटमेंट. ट्रीटमेंट इज ऑब्वियसली विटामिन ए सप्लीमेंटेशन, क्योंकि xerophthalmia जो है इट इज कॉमनली सीन इन malnourished children. So therefore, what is our treatment? Treatment is vitamin A supplementation. Now this again, I want you to please listen to me carefully. Commonly asked question, लेकिन commonly गलत होता है. Vitamin A supplementation. So vitamin A supplementation में देखो, see, for children greater than equal to 8 kgs, greater than equal to 8 kgs or greater than equal to 1 year, what is the dose? The dose is 2 lakh international units orally. 2 lakh international units orally on 3 days, day 0, day 1 and day 14. So for children greater than equal to 8 kgs or greater than equal to 1 year, it is 2 lakh international units orally on days 0, 1 and 14. And for children less than 8 kgs or less than 1 year. So for children less than 8 kgs or less than 1 year, what is the dose? The dose is 1 lakh international units orally. The regimen is the same. The regimen is day 0, day 1 and I think ये सबने याद किया है. That is for children greater than equal to 8 kgs, greater than equal to 1 year, it is 2 lakh international units orally. And for less than 8 kgs, less than 1 year, it is 1 lakh international units. Now please listen to me carefully. If the age and the weight they do not match, then what do you do? So for example, if they say that there is a patient who is say 1.5 years old but weighing only 6 kgs, देन हम डोज किस हिसाब से देंगे? मतलब उसका एज और वेट जो है वो मैच नहीं हो रहा है, विच इज़ क्वाइट कॉमन इन अ malnourished चाइल्ड. तो इन अ malnourished चाइल्ड, सपोज वो बच्चा 1.5 years ओल्ड है लेकिन उसका वेट जो है 6 kgs है, तो ऑलवेज गिव ऑन द बेसिस ऑफ द वेट, बिकॉज देखो पीडियाट्रिक्स में डोजेस आर ऑलवेज बेस्ड ऑन पर केजी बॉडी वेट. तो अगर एज एंड वेट मैच नहीं हो रहा है, देन वी हैव टू ऑलवेज गिव ऑन द बेसिस ऑफ. I hope this is clear to everyone. So if the age and the weight are not matching, then always give on the basis 8. So ये है oral dose. But see, sometimes the children are so sick that we are forced to give an IM dose. So what is the intramuscular dose? Intramuscular dose जो है, that is half of dose. Intramuscular dose जो है, that is half of. This much you have to remember. So please do not make a mistake of this anymore. So if the age and the weight they do not match, always give on the basis. Okay, so this is the treatment for 0. So this finishes the important topics under your conjunctiva. Now I come to a very, very important topic under cornea, that is the infective keratitis or the corneal ulcers. अब ये जो है ना, for the next 15-20 minutes that we will be discussing this, I want all of you to please be very, very attentive, क्योंकि ये जो है, this we have to know like the back of our hand. इसमें हम कुछ भी गलत नहीं कर सकते हैं, और इसमें से like this is almost a question which comes every year. So देखो, अंडर इन्फेक्टिव केरेटाइटिस हमें पढ़ना है 6 kgs 1.5 years अगर है, what is the dose according to 6 kgs, मतलब 1 lakh international unit. समझ में आया? तो तुम्हारा एज एंड वेट अगर मैच नहीं हो रहा है, मतलब वेट कम है लेकिन एज अगर ज्यादा है, तो एज के हिसाब से हमें नहीं देना है, वेट के हिसाब से ही देना है. अब समझ में आया? सो इफ इट इज 6 kgs, तो हमें 6 kgs के हिसाब से देना है, बिकॉज वी हैव टू गिव इट अकॉर्डिंग टू द वेट. पीडियाट्रिक्स में जो डोजेस है ना, दे आर ऑलवेज ऑन द बेसिस ऑफ पर केजी बॉडी वेट. ओके, सो 6 kg 1.5 years अगर है, तो द डोज इज 1 lakh इंटरनेशनल यूनिट. I hope it is clear now. Now let's come to the corneal infections or corneal ulcers. So corneal ulcers में देखो हमें पढ़ना है bacterial corneal ulcer, fungal corneal ulcer, viral keratitis, and acanthamoeba keratitis. So what are the symptoms? Bacterial और fungal को हम reasonably एक साथ पढ़ेंगे. So देखो symptoms same ही होते हैं, that is pain, redness, photophobia and decrease in vision. These are the symptoms. Pain, redness, photophobia, decrease in vision. But in case of a bacterial corneal ulcer, the symptoms are more pronounced. Symptoms are more pronounced. Okay, what are the causative organisms for the bacterial corneal ulcer? Causative organisms जो हैं, the causative organisms can be Staph aureus, it can be Streptococcus pneumoniae, मतलब pneumococcus. These are the common ones. So Staph aureus, pneumococcus are the common organisms. The symptoms, they tend to be more pronounced. Now, if you look at the lesion, what are the features of the lesion? The lesions are, it is a single lesion. So look at this image. If we look at the image, it is a single lesion. The margins are well defined or sharp. And if there is a hypopion, what do we mean by hypopion? Hypopion का मतलब होता है pus in the anterior chamber. Mind you, it is not pus in the cornea. It is pus in the anterior chamber. So hypopion जो है वो must नहीं है. It can be present, it may not be present. लेकिन in a bacterial corneal ulcer, if the hypopion is present, then it is mobile. Mobile matlab it is not very thick. So if you change the position of the head, the pus will move according to gravity. And it is sterile. Sterile means if I aspirate the pus, then what will I get? I will get only pus cells but no bacteria. We will get only pus cells but no bacteria, because ये जो pus है, it is in the anterior chamber and bacteria do not grow into the. Okay, so these are the important features that we need to remember for bacterial corneal ulcer. So I'll just go over it once more. The symptoms are pain, redness, photophobia, and decrease in vision. If you look at the lesion, it is a single lesion. The margins are very sharp or well defined. Hypopion, if it is present, it is mobile, meaning it moves with the position of the head, and it is sterile. Sterile means that there are pus cells, but there are no bacteria. What is the investigation? The investigation that we use is we have to do corneal scraping, and if it is, as we suspect it's a bacterial corneal ulcer, we are going to ask for a gram stain. We ask for gram stain and we ask for culture in blood agar, right? And what is the treatment? The treatment obviously is antibiotics, but these antibiotics have to be given under high concentration. So what are they called? That's called as fortified antibiotic eye drops. Fortified antibiotic eye drops. Fortified antibiotic eye. So which are the fortified antibiotic eye drops which are used? The fortified antibiotic eye drops which are cefazolin and ceftazidime. So cefazolin or ceftazidime 5% eye drops. Cefazolin or ceftazidime 5%. This is what is usually given. And इसके साथ हमें adjuvant क्या देना है? Adjuvant we give atropine eye drops. Now, why do we give atropine, ceftazidime 5% or cefazolin 5% and atropine eye drops? Atropine eye drops क्यों देना है? Because atropine is a cycloplegic and it helps in pain. Okay, it is ceftazidime or cefazolin 5% eye drops and atropine eye drops because atropine is in pain relief. Okay, so this is about the bacterial corneal ulcer. अब कैसा है? The same features we have, the same symptoms are going to be seen in a fungal corneal ulcer. So pain, redness, photophobia, decrease in vision. ये same ही है symptoms, but here the symptoms tend to be less pronounced. The symptoms are less pronounced. The patient seems to be less symptomatic, but there is a very important preceding history for a fungal corneal ulcer. There is a preceding history of trauma with vegetative matter, or the question may mention that the patient is a farmer who has presented to us in the harvest season. So ये जो है ना, ये key word है, this will always be mentioned in the question. So either they will say that the patient has presented with a history of trauma with vegetative matter, या फिर question में होगा that the patient is a farmer who has come to us in the harvest season. Now how does this look like? See, most of the time ये जो lesions हैं, they have satellite lesions, meaning there will be one large lesion and surrounding it there are multiple smaller lesions. ये जो smaller lesions हैं इनको हम बोलते हैं satellite lesion. So have a look at this image. ये जो image है again very common PYQ identify हम कैसे करेंगे? Look at this. There are multiple small lesions. ये जो multiple small lesions हैं they are our satellite lesions. They are our satellite lesions. ठीक है. And here also if there is a hypopion, what are the features? The hypopion here is a fixed hypopion. Fixed मतलब वो बहुत dense होता है, so it doesn't move with the position of the head, and it is non-sterile, meaning if I were to aspirate that hypopion, I am going to get fungal hyphae. I am going to get fungal hyphae. So fungus grows into the anterior. तो देखो आई जस्ट गो ओवर इट वंस मोर. बट सिम्टम क्वेश्चन में ना दोनों के सेम ही होते हैं, पेन, रेडनेस, फोटोफोबिया, डिक्रीज इन विजन. बट बैक्टीरियल कॉर्नियल अल्सर में द की वर्ड्स आर सिंगल लीशन, well defined margins, mobile and sterile hypopion. In case of fungal corneal ulcer, the symptoms will be the same: pain, redness, photophobia, decrease in vision, but there will be a preceding history of trauma with vegetative matter, or it will be mentioned that patient is a farmer. Lesions will be multiple or satellite lesions. Margins are typically described as feathery या फिर fuzzy. And hypopion, if present, is immobile and it is non-sterile. इसमें भी क्या करना है हमें? वी हैव टू डू अ कॉर्नियल स्क्रैपिंग ओनली. यहाँ पे भी हमें कॉर्नियल स्क्रैपिंग करना है. एंड वी विल आस्क फॉर व्हाट? बिकॉज वी आर सस्पेक्टिंग फंगस, वी विल आस्क फॉर QH माउंट एंड कल्चर इन SDA, Sabouraud's dextrose agar. Sabouraud's dextrose. And what is the treatment for, if we are asked what is the drug of choice for fungal corneal ulcer in India, it is natamycin 5% eye drops. Natamycin 5% eye drops. Now why do we give natamycin? Because most of the ulcers, they are caused by Aspergillus. Most of the ulcers in India are caused by Aspergillus, and Aspergillus jo hai, it is very sensitive to natamycin. So drug of choice for fungal corneal ulcer in India is natamycin. And along with that हमें adjuvant क्या देना है? Adjuvant again is atropine. Adjuvant again is atropine eye drops, which is meant for pain relief. ठीक है, so this is about fungal corneal ulcer. This is about fungal corneal ulcer. And will you tell me, in both bacterial and fungal corneal ulcer, what is the drug that is absolutely contraindicated? What is the drug that is absolutely contraindicated in both bacterial and fungal corneal ulcers? In both bacterial and fungal corneal ulcers, the drug that is absolutely contraindicated is topical steroids. They are absolutely indicated in both bacterial and fungal corneal ulcers. ठीक है, वेरी गुड. आई एम सो हैप्पी दैट यू आर एबल टू रिकॉल. तो ये तो हमें याद है. अभी नेक्स्ट वाले पे जाते हैं. मुझे लग रहा है कि दिस टाइम, लास्ट टाइम ऑलरेडी देयर हैज बीन अ क्वेश्चन ऑन वायरल एंड एकांथमीबा, तो इस बार शायद बैक्टीरियल फंगल का चांस ज़्यादा है, बट ऑफ कोर्स वी कैन नॉट से we have to do everything. But last exam में we had a question from viral and we also had a question from acanthamoeba. So that's why probably this time this may be more common. So chalo. Anyway, next what we will be doing is HSV, that is herpes simplex virus keratitis. HSV, that is herpes simplex virus keratitis, the viral keratitis. Now HSV keratitis जो है, how is it different from the others? It is different from the others because ये जो है, it affects each layer of the cornea separately. So we have what is called as epithelial keratitis. Epithelial keratitis matlab it affects the epithelium. Then we have stromal keratitis, disciform keratitis, and endothelial keratitis. Now epithelial keratitis ka what is the pathogenic mechanism? The pathogenic mechanism is active viral replication. Active viral replication. So the virus is actively growing inside the epithelium. That is the mechanism of epithelial keratitis. An epithelial keratitis in the early stage, it looks like this. So early stage में वो ऐसे दिखता है. So now, the early stage, what is it called? It is called as dendritic ulcer. The early stage is called as dendritic ulcer, and the late stage it is called as the geographic ulcer. Now see, viral keratitis is not actually that clearly visible in the early stages. तो जब भी कोई चीज़ क्लियरली विजिबल नहीं होती है, फिर हम क्या करते हैं? टू मेक इट विजिबल वी स्टेन इट. तो यहाँ पे ये दोनों ही इमेजेस एग्जाम में आ चुके हैं एंड दे आस्क व्हाट इज द डायग्नोसिस और दे आस्क व्हाट इज द स्टेन यूज्ड हियर. So what is the stain that has been used here? Here the ulcer has been stained with fluorescein dye. The ulcer has been stained with fluorescein dye and it is being examined under the cobalt blue filter of the slit lamp. That's why the background is blue. So इसको blue light में देखते हैं तो कि उससे contrast अच्छा आता है. So it is examined under the cobalt blue filter of the slit lamp. ये PYQ है. So this image was given in the exam and it was asked that what is the stain and what is the filter. So stain जो है that is fluorescein stain and filter jo hai that is the cobalt blue filter. Now if you look at the first picture, in the first picture you see a linear lesion like this. The linear lesion has branches and at the end it has these kind of bulbs. तो ये जो है ना दिस इज कॉल्ड एज अ डेंड्राइटिक अल्सर. इस पिक्चर को देखो, इट लुक्स लाइक दैट. एक लीनियर लीशन है, लीनियर लीशन को ब्रांचेस हैं एंड ब्रांचेस के एंड में एक टर्मिनल बल्ब है. दिस इज कॉल्ड एज अ डेंड्राइटिक अल्सर. But in the late stage, it is going to become shapeless, and once it becomes shapeless, तो वैसे दिखेगा, and then it is called as a geographic ulcer. So, epithelial keratitis is caused by active viral replication. Early stage is dendritic ulcer, late stage is geographic ulcer. To make the ulcer visible, we are going to stain it with fluorescein dye and we examine it under the cobalt blue filter of the slit lamp. अब यहाँ पे पूछते हैं what is the treatment for epithelial keratitis. अब बच्चों याद रखो कि या तो डायरेक्टली एपिथेलियल पूछेंगे या फिर दे कैन आस्क व्हाट इज द ट्रीटमेंट ऑफ डेंड्राइटिक अल्सर या फिर ज्योग्राफिक अल्सर. अब याद रखना है कि आई मीन डेंड्राइटिक अल्सर एंड ज्योग्राफिक अल्सर आर आल्सो टाइप्स ऑफ एपिथेलियल ओनली. तो इसमें कंफ्यूज नहीं होना है. ये कभी कभी ना व्हेन दे आस्क व्हाट इज द ट्रीटमेंट ऑफ डेंड्राइटिक अल्सर स्टूडेंट गेट्स कंफ्यूज्ड. But remember, dendritic ulcer, geographic ulcer, both are epithelial keratitis only. So, जो epithelial का treatment हमने पढ़ा है, वो ही उसमें लिखना है. So, what is the treatment for epithelial keratitis? The treatment, देखो, epithelial keratitis is caused by active viral replication. So, that is why the treatment is acyclovir, antiviral. Now, again, please remember, acyclovir is given in the form of 3% eye ointment. Acyclovir, this is given in the form of 3% eye ointment. अब तक हमने जो जो पढ़ा है, they are all eye drops. Acyclovir is used in the form of 3% eye ointment. And यहाँ पर भी absolutely contraindicated is topical steroids. यहाँ पर भी absolutely contraindicated is topical steroids. Because it is caused by active viral replication. So we don't want to give the steroid because the steroid will suppress the local immunity and we don't want. ठीक है. Now next is the other three types. अब other three types कौन से हैं? The other three types of keratitis are, we have stromal keratitis, we have disciform keratitis, and we have endothelial keratitis. Stromal keratitis, disciform keratitis, and endothelial keratitis. Now please remember that all these, they are caused by an immune reaction to the viral antigen. They are caused by an immune reaction to the viral antigen. They are caused by an immune reaction to the viral antigen. Okay, so therefore, for all these keratitis, what is the drug of choice? What is the treatment? So stromal disciform endothelial में it's caused by an immune reaction to the viral antigen. So the treatment is topical steroids. तो याद रखना है, for epithelial keratitis absolutely contraindicated is topical steroids. लेकिन for the other types, that is stromal disciform and endothelial, the treatment is topical steroids under the cover of oral acyclovir. Oral acyclovir, under the cover of oral acyclovir. Okay. So this is about the different types of keratitis. Now will you quickly remember and tell me what is the special feature of viral keratitis? What is the special feature of viral keratitis? The special feature of viral keratitis is decrease in corneal sensations. It is decrease in corneal sensations. Yes, stromal disciform, endothelial, all of them, they look very similar. All of them present with a localized area of corneal edema, and they are treated with the help of topical steroids. So इसमें गलती मत करना that in case of epithelial keratitis, drug of choice is acyclovir ointment and contraindicated है steroid. जबकि for the other three, the drug of choice is steroid. And the special feature of viral keratitis is very good. Decrease in corneal sensation, which in the acute stage makes the ulcer painless. Correct. So in the acute stage, the ulcer is a painless ulcer. Correct. But lack of pain is actually not good in the long run. So what is the long-term complication? The long-term complication is permanent damage to the cornea due to the lack of sensation, जिसको हम बोलते हैं neurotrophic keratopathy. Good. Neurotrophic keratopathy means permanent damage to the cornea due to loss of sensations. And neurotrophic keratopathy में हमें याद रखना है, this is not an active form of the disease. This is a long-term complication which happens sometimes months or years after the disease, the HSV has disappeared. So it's a long-term sequelae or a long-term complication. तो इसको हम कैसे ट्रीट करेंगे? द ट्रीटमेंट ऑफ न्यूरोट्रॉफिक केराटोपैथी इज lubricants, because the lubricants help the cornea to heal, and we can do a procedure which is called as lateral tarsorrhaphy. We can do a procedure which is called as lateral tarsorrhaphy. Lateral tarsorrhaphy means you stitch the upper lid and the lower lid like this at the side, so that the size of the aperture becomes smaller and the cornea will remain protected. Correct. So this is a non-healing ulcer. It's a non-healing ulcer. So यहाँ से हमें याद क्या रखना है? That viral keratitis in the acute stage is painless, because हमने bacterial और fungal में पढ़ा था, the symptoms are pain, redness, photophobia, decrease in vision. So basically pain is a very important symptom. However, viral keratitis में it's a painless ulcer in the acute stage, and the long-term complication is neurotrophic keratitis. चलो, so ये जो है, this is about HSV keratitis. ये I think सबको याद था. Now the last one is Acanthamoeba keratitis. The last one is Acanthamoeba keratitis. Acanthamoeba keratitis में we have to remember a few very important things. वो दो चार ही चीजें हैं जो घूम फिर के पूछते हैं एग्जाम में, तो उसी को याद रखना है basically. So Acanthamoeba keratitis, first of all, please tell me what is the most important risk factor for the development of Acanthamoeba keratitis. The most important risk factor it is the misuse of contact lens. Very good. So the most important risk factor for the development of Acanthamoeba keratitis is misuse of contact lenses. अब किस टाइप का misuse है? There, see, Acanthamoeba is a parasite which lives in soil and in water. So इसमें से ना कोई association with water होगा. So misuse of contact lens, that is using tap water to clean contact lens. Using tap water to clean contact lens. लेकिन recent exam में ये पहले आता था, लेकिन recent exam में what they have given is, they have given swimming with contact lens. Basically, remember, some association with water will be there, some association with water. Okay, but again, please remember that the most important risk factor for Acanthamoeba is misuse of contact lens. लेकिन अगर हमसे पूछा जाए कि what is the most common organism seen in a contact lens misuser, the answer is not Acanthamoeba. The most common organism in a contact lens misuser is Pseudomonas. ठीक है, ये दोनों क्वेश्चंस अलग है, इनको एक दूसरे के साथ कंफ्यूज मत करो. So if it asks what is the most important risk factor for Acanthamoeba, the answer is misuse of contact lens. But the most common organism seen in a contact lens misuser is not Acanthamoeba, it is Pseudomonas. तो अगर किसी contact lens misuser को corneal infection होता है, तो हमें सबसे पहले Pseudomonas ही सोचना है. But when will you think of Acanthamoeba? You think of Acanthamoeba when the ulcer looks something like this. तो ये जो अल्सर है, इसका शेप कैसा है? This is called as a ring ulcer. This is called as a ring ulcer. And another important feature of Acanthamoeba keratitis is keratoneuritis. Keratoneuritis means that there is an inflammation of the corneal nerves. And because of this becomes the most painful corneal ulcer. It becomes the most painful corneal ulcer. तो देखो वायरल में हमने पढ़ा इट इज अ पेनलेस अल्सर, एकांथमीबा इट इज द मोस्ट पेनफुल corneal. Now this also we have to do a corneal scraping. ये most recent PYQ है, so please listen to this carefully. तो यहाँ पे ना corneal scraping करने के बाद what is the stain and what is the culture medium, this came in the last INICET very recent PYQ, तो इसको please याद कर लो. So it's an uncommon organism, so that's why an uncommon stain. The stain for this is called as calcofluor white stain. The stain for this is called as calcofluor white stain, and the medium for culture is called non-nutrient agar enriched with E. coli. Non-nutrient agar enriched with E. coli. Non-nutrient agar enriched with E. coli. ये recent PYQ है, don't miss this. So the medium for the stain is calcofluor white stain. The medium for culture, non-nutrient agar enriched with E. coli. And what is the drug of choice? The drug of choice is PHMB eye drops. What is PHMB? PHMB is polyhexamethylene biguanide. PHMB, polyhexamethylene biguanide eye drops. PHMB eye drops is the drug of choice, and along with this it is a very very painful ulcer, इसीलिए we have to give atropine eye drops also. So atropine is the adjuvant for pain relief, and the drug of choice is PHMB. PHMB eye. Yes, corneal scraping is done to confirm the diagnosis of acanthamoeba also. सिर्फ वायरल में ही हम स्क्रेपिंग नहीं करते हैं. ये वायरल जो है लार्जली क्लिनिकल है. एकांथामीबा टू यू स्क्रेप इट जस्ट लाइक बैक्टीरियल एंड फंगल को हमने स्क्रेप किया. अगर हमें एकांथामीबा का स्ट्रॉन्ग सस्पिशन है तो हमें उसको भी स्क्रेप करना चाहिए. एंड सी द स्टेन एंड द कल्चर मीडियम आर वेरी अनकॉमन, बट ये रिसेंटली पूछा है इसीलिए इसको याद करो. So after corneal scraping, the stain is calcofluor white stain, and the medium for culture is non-nutrient agar enriched with. ये दोनों चीजें याद करो. The drug of choice is PHMB. Okay, so these are the 4 important types of infective keratitis. So bacterial, fungal, viral, acanthamoeba. अब बताओ मुझे ये सबको याद आ गया? I hope everybody has been able to recall this. ये recall हो जाएगा, but just to put it all together about 10 days before the exam. चल, let us go to the next topic then. The next topic that we have is keratoconus. Again, another important topic. Keratoconus. What is keratoconus? Keratoconus by definition is a non-inflammatory corneal ectasia. Corneal ectasia का मतलब है यहाँ पे protrusion of the cornea associated with thinning. It's a protrusion of the cornea which is associated with thinning. So the cornea is something like this, but the whole cornea is not protruded. Only a part of it is protruded. So it is a localized protrusion of the cornea associated with thinning. So basically the part of the cornea which is protruded, the same part of the cornea is actually thinned out. ठीक है, तो ये जो cornea तुम्हारा protruded है ना, वही cornea thin. Am I audible, visible now? I hope there is no lag. अभी ठीक है क्या? There used to be something. Okay, so see, the early sign is scissoring reflex on retinoscopy. And what are the other signs? The other signs that we have is this one, Munson sign. ये जो है Munson sign, very commonly asked question है ये. So this is your Munson's sign. So what is the Munson sign? Munson sign means when the patient is asked to look down. When the patient is asked to look down, the protruded cornea is going to press or indent the lower lid. When the patient is asked to look down, the protruded cornea presses or indents the lower lid. Next is the Fleischer's ring. What is the Fleischer's ring? It is a pigmented ring at the base of the cone due to deposition of iron. It is caused by deposition of iron. It is a pigmented ring at the base of the cone which is caused by deposition of iron. Now next is, what are the stretch lines on the cornea? Because of the stretching of the cornea, we get vogue striae or stretch lines in the cornea. अब यहाँ पे पूछते हैं that where do you get to see vogue striae? Vogue striae, these are striae on the descemet's membrane. These are striae on the descemet's membrane, and they ask that what is the direction of the vogue striae. So the direction of the vogue striae, they are vertical in direction. They are striae on the descemet's membrane and they are vertical. So these are the features of keratoconus. I'll just go over it once more. It's a protrusion associated with thinning. The most common refractive error is irregular myopic astigmatism. Now, because irregular astigmatism doesn't get corrected with glasses, that's why presenting feature is frequent change of glasses. Early sign is scissoring reflex on retinoscopy. On looking down, you get to see Munson's sign. Pigment deposition on iron deposition at the base of the cone gives rise to Fleischer's ring. Stretching of the cornea gives rise to vogue striae, which are striae on the descemet's membrane, and they are vertical in direction. And if there is a tear of the descemet's membrane, what is that called? That's called as hydrops. So hydrops is tear of the descemet's membrane. Tear of the descemet's membrane is called as hydrops. Right. Now let us see what are the treatment options for keratoconus. ये again important है, recent PYQ है, तो इसको ध्यान से सुनो please. So what are the treatment options? So first line of management, because the irregular astigmatism is not getting corrected with glasses, that is why the treatment is RGP contact lenses, rigid gas permeable contact lenses, RGP contact lens. Now, when the problem with RGP lens is that if the cornea is too much protruded, then we will not be able to fit the lens. We will not be able to fit the lens will start slipping. So if we are not able to fit the lens, then we will have to flatten the cornea. In order to flatten the cornea, we do a procedure which is called as C3R. What is the full form of C3R? Full form of C3R is corneal collagen cross-linking with riboflavin. Corneal collagen cross-linking with riboflavin, that is C3R. So C3R is a procedure which is meant to flatten the cornea. So corneal collagen cross-linking with riboflavin or C3. And next what is the other option? Then we have the option of what is called as intracorneal ring segments. Intracorneal ring segments. Intracorneal ring segments or ICRS, commercially called as intacs. ये जो word है ना intacs, it's a recent PYQ. So remember ICRS or intracorneal ring segments, commercially called as intacs. This is also a treatment option for keratoconus in advanced cases to correct the astigmatism. And if all options are not working, then the last option is keratoplasty. Keratoplasty का क्या मतलब होता है? Keratoplasty means cornea transplantation. So RGP contact lens, C3R, intracorneal ring segments, and keratoplasty. Okay, what is the difference between keratometry and topography? Keratometry is just for evaluation of the corneal curvature. Pachymetry is for thickness. And topography helps to analyze the entire surface. So तीनों अलग अलग है. Topography is actually better than keratometry. Keratometry and pachymetry are basic investigations. Keratometry helps to evaluate the curvature, pachymetry helps to evaluate the thickness, and topography helps to analyze the entire surface. Yes. So in case of a keratoconus, if I do a keratometry, what will I see? I will see that the curvature is increased. If I do a pachymetry, what will I see? In a pachymetry, I will see that the thickness is decreased. So the keratometry will show an increase in curvature. The pachymetry will show a decrease in thickness. समझ आया? So this is about keratoconus. अब एक extra चीज पढ़ लो please, because again recent PYQ है. So अब recently ना there was this question on hydrops. So hydrops क्या है? Hydrops is an emergency when there is a sudden tear of the descemet's membrane. So if there is a sudden tear of descemet's membrane, how will the patient present? The patient, it's an emergency in keratoconus. The patient presents to us with sudden onset pain and decrease in vision. So a keratoconus patient. अब इस बार जो क्वेश्चन आया था ना recent in last INICET, they did not say that it is a patient of keratoconus. They said that there is a patient who has a previous history of frequent change of glasses. he presents to us with sudden onset pain and decrease in vision. So ये frequent change of glasses जो है, that word is the clue that they are talking about keratoconus. So what they are trying to say is कि keratoconus patient हमारे पास आया है with sudden onset extreme pain and decrease in vision. So sudden onset extreme pain and decrease in vision in a keratoconus patient means hydrops. Yeah, so they had asked what is the treatment. So treatment क्या होता है? Hydrops का treatment जो है ना, the treatment is gas injection. Gas injection. You inject gas inside the eye. A gas inside the eye. वो जो gas bubble या air bubble होता है ना, that helps to position the descent back. So देखो ये जो descent है, अगर वो ऐसे torn हो गया है, I will inject gas inside. वो जो gas है, it is going to push back the descent. So intracameral gas injection is the treatment. Intracameral मतलब inside the eye. तो इसको याद करो, recent PYQ है. So what does the question say? The question said that there is a patient who has a previous history of frequent change of glasses. So ये जो frequent change of glasses है, that is actually a clue that it is saying keratoconus. How does this patient present? The patient has presented to us with a sudden onset, extreme pain and decrease in vision. This tells us that it is actually hydrops. अब पूछा था कि treatment क्या है? So hydrops is an emergency and it is treated with intracameral gas injection of gas in hydrops. हाँ मतलब इट्स नॉट परफोरेशन, क्योंकि वो थ्रू एंड थ्रू नहीं है. इट्स नॉट लाइक पूरा तुम्हारा अंदर से बाहर तक सब परफोरेटेड है, वैसा नहीं है. इट्स जस्ट अ टेयर ऑफ द डेसिमेट्स ही टॉर्न हुआ है. So treatment of hydrops is intracameral gas. So ठीक है, this keratoconus and this acanthamoeba, both of them. See acanthamoeba में calcofluor white stain पूछा था INICT. So that's the recent PYQ. Keratoconus में in the recent NEET PJ they asked intax, that is ICRS, and in the INICT they asked the treatment of hydrops, intracameral gas injection. They are all recent PYQ. तो ये तीन चीजों को अच्छे से याद रखो. So this is about the important topics from cornea. चलो अब एक she didn't say perforation. It's hydrops is not perforation. Hydrops means there is a tear of the decimates. You can say it's a perforation of the decimates, but it is not a perforation of the cornea. That's what I meant. Hydrops means that it's a perforation of the decimates or it's a tear of the decimates. Perforation of the cornea का मतलब होता है through and through. इसमें सिर्फ decimates ही perforated है, बाकी जो layers हैं वो perforated नहीं है. So the perforation of the cornea means it's a through and through lesion. What we mean to say, or what we can say, it's a tear or a perforation of the decimates membrane. Okay? Chalo. Now let's come to the next one. The next set of diseases that we will be reading are the refractive errors. अब ये भी देखो, this is an important question. So first let us go through the basic images of the refractive errors. So देखो, the first image of the refractive error ये क्या है? The parallel rays of light, they are meeting at this point F, and this point F is in front of the retina. So this is a picture of simple myopia. This is a picture of myopia or simple myopia. That is parallel rays of light meeting at a point F, which is in front of the retina. Next one देखो, these are the parallel rays of light. They are meeting at this point F, which is behind the retina. So they are meeting at a single point F, which is behind the retina. So this is simple hypermetropia. So this is simple hypermetropia. Okay, now next is the pictures of regular astigmatism. These are the pictures of regular astigmatism. How are we going to identify that these are pictures of astigmatism? We will identify that these are pictures of astigmatism because the rays of light which have come in, they have come in as a single bundle. Lekin inside they are meeting at two different points. So there are two focal points, F1 and F2. ठीक है. So देखो, ये है हमारा F1 and ये है F2. ये है F1 एंड F2. सो यहाँ पे हम क्या बोल सकते हैं? F1 is emetropic because that axis is meeting on the retina, and F2 is myopic. So one axis is emetropic and the other axis is myopic. And so this is called as what? It is called as SMA. SMA stands for simple myopic astigmatism. It stands for SMA or simple myopic astigmatism. SMA, simple myopic astigmatism. Next, chalo, then look at the next one. These are the parallel rays of light. ये F1 है and this is F1 and this is F2. इसमें हम क्या बोलेंगे? So F1 is again emetropic. F1 is again emetropic and F2 is behind the retina. So F2 is hypermetropic. So F1 is emetropic, F2 is hypermetropic. So what is this? One axis is normal and the other is hypermetropic. This is called as SHA, simple hypermetropic astigmatism. This is SHA or simple hypermetropic astigmatism. चलो once again have a look at these two images. अब ये SMA SHA हो गया. अब इसमें देखो we have F1 and F2 and F1 and F2 here are both myopic. So F1 and F2 are both myopic, but F1 is more myopic than F2. F1 is more myopic than F2. F1 and F2 are both myopic, but F1 more than F2. And so what is this called? This is called as CMA, compound myopic astigmatism. F1 and F2 are both myopic, but F1 more than F2. Now, the counterpart of this is this. Here, F1 and F2 are both hypermetropic. F1 and F2, both of them are hypermetropic, but again F1 is more hypermetropic than F2. F1 is more hypermetropic than F2, so this is called as CHA, compound hypermetropic. And the last one is this picture. In this picture, this is F1 and this is F2. So here F1 is myopic and F2 is hypermetropic. F1 is myopic and F2 is hypermetropic. So if one axis is myopic and the other is hypermetropic, we call it as mixed. समझ में आया ना? So these images you have to keep in mind these 5 types of regular astigmatism: SMA, SHA, CMA, CHA and MA. I'll just go over it once more. SMA means one axis is normal, other is myopic. SHA means one axis is normal, other is hypermetropic. CMA means both are myopic. CHA means both are hypermetropic, and mixed means one axis is myopic and the other is hypermetropic. Okay, so these are the 5 types of regular astigmatism, and if all these 5 images are put together in a single picture, what is that picture called? All the pictures, all the types of regular astigmatism put together in a single picture, this is called as your Sturm's conoid. All the types of regular astigmatism put together in a single picture, that's called as your Sturm. अब देखो, last time in the last FMG paper we already have a question on Sturm's conoid, but for like some time now we have not had any questions on glass prescription. So I think glass prescription को अच्छे से पढ़ते हैं because glass prescription has not been asked for some time. So we'll just quickly revise it. So glass prescription वाले questions में I have told you that we will, as far as the exam is concerned, हम theory में नहीं जाएंगे. Am I audible, visible now? हाँ. So देखो, we were talking about the prescriptions, that if we have a prescription, if we have prescriptions, we will try to look at कि हमारा जो prescription है, whether it is in plus or it is in minus. So this is the simple way to solve questions on prescriptions which we have discussed before also. तो चलो उसको quickly revise करते हैं कि when we get a question on glass prescription, so हमें पहले सोचना है कि whether it is in minus या फिर it is in plus. So suppose we have a minus prescription. Minus prescription में ना 3 options possible है. तो माइनस प्रिस्क्रिप्शन का मतलब होता है इट कैन आइदर बी मायोपिया, it can be SMA or it can be CMA. I told you to remember the mnemonic M for M. मतलब माइनस प्रिस्क्रिप्शन means myopia. तो माइनस में अगर प्रिस्क्रिप्शन है we have 3 options. Either it will be myopia or it will be SMA or it will be CMA. So देखो what are the options. So suppose there is a minus prescription which is only a sphere. A minus prescription which is only a sphere. For example, अगर prescription ऐसा है that is minus 4 diopter sphere. What is this? This is a prescription of myopia. This is a prescription of myopia. Now suppose there is a minus prescription which is only a cylinder. A minus prescription है जिसमें सिर्फ cylinder है. So what kind of what is an example? If I give you an example, it will be something like this. For example, say minus 2 diopter cylinder at any axis, 90 या फिर 180. So minus prescription which has only a cylinder is SMA, simple myopic astigmatism. Simple myopic astigmatism. And the third one is a minus prescription which has both a sphere as well as a cylinder. A minus prescription which has both a sphere as well as a cylinder. So let me give you an example कि ये कैसे होगा. So suppose we have a minus prescription which looks like this. Say for example minus 2 sphere and say minus 1 cylinder at whatever axis 90 या फिर 180. अगर इस टाइप का prescription है, this is a prescription CMA, compound myopic astigmatism. So if you have a minus prescription, think of 3 things: myopia, SMA या फिर CMA. So minus prescription only sphere is myopia. Minus prescription which has only cylinder is SMA. And minus prescription जिसमें sphere cylinder दोनों है that is a CMA. अभी ये सेम रूल को हम प्लस प्रिस्क्रिप्शन के लिए भी एक्स्ट्रापोलेट कर सकते हैं. So suppose we have a plus prescription which is only a sphere. For example, something like this, a plus prescription which is only a sphere, plus 2 diopter sphere. What is this? This is a hypermetropy. जैसे minus prescription which is only a sphere is myopia, plus prescription which is only a sphere is hypermetropy. अब देखो plus prescription which is only a cylinder. For example, suppose plus 1 cylinder cross 90. A plus prescription which is only a cylinder. This is what? This is SHA. This is SHA. This is SHA. And the third one is a plus prescription which has both sphere and cylinder. Just say for example, if I have something like this, plus 1 sphere and say plus 1 cylinder cross 9. So this is a prescription जिसे plus sphere plus cylinder दोनों है. This is CHA, compound hypermetropic is. Compound hypermetropic is. तो ये जो ट्रिक है या ये जो रूल है इसको अंडरस्टैंड. इफ यू रिमेंबर दिस यू शुड बी एबल टू आंसर मोस्ट ऑफ द क्वेश्चन. सो जस्ट इन योर माइंड ये सेट करो कि हमें सबसे पहले देखना है कि प्रिस्क्रिप्शन माइनस में है या प्लस में. तो सपोज इट इज अ माइनस प्रिस्क्रिप्शन. देयर आर 3 ऑप्शंस यू हैव टू थिंक ऑफ: मायोपिया, SMA, CMA. प्लस प्रिस्क्रिप्शन है तो हाइपरमेट्रोपिया, SHA एंड CHA. तो देखो, अ माइनस प्रिस्क्रिप्शन विच इज ओनली अ स्फीयर, जैसे minus 4 sphere is a myopia. A minus prescription which is only a cylinder, जैसे minus 1 cylinder at any axis is SMA. A minus prescription which is both a sphere and a cylinder is C. जैसे minus 2 sphere, minus 1 cylinder cross 90 degree. अब सेम चीज को हम प्लस के लिए भी एक्स्ट्रापोलेट कर सकते हैं. लेकिन सपोज देयर इज अ प्रिस्क्रिप्शन विच लुक्स लाइक दिस, where there is a combination of plus and minus, जैसे minus 1 sphere and say plus 4 cylinder cross 90. या फिर अगर ऐसा प्रिस्क्रिप्शन है plus 1 sphere and say minus 4 cylinder cross 90, प्लस और माइनस का अगर कॉम्बिनेशन है, this is a prescription of mixed. So this kind of prescription, this is a prescription of mixed stigma. Okay, so these are how we solve simple questions on glass prescription. Yes. Now the next is that there you can take it a step further if we get questions on with the rule and against the rule astigmatism. WTR and ATR. With the rule and against the rule astigmatism. With the rule and against the rule astigmatism. Now with the rule का क्या मतलब होता है? With the rule astigmatism means with the rule का मतलब होता है that the vertical axis is more myopic or less hypermetropic. Vertical axis is either more myopic or vertical axis is less hypermetropic than the horizontal axis. Vertical axis is more myopic or it is less hypermetropic than the horizontal axis. This is with the rule astigmatism. लेकिन if we get questions then वो कैसा है, they give us a glass prescription और वो पूछते हैं कि ये with the rule है या against the rule है, वैसे करके पूछते हैं. So then what is the thing to be remembered? Then I told you कि इसको याद करो that if you have a minus cylinder cross 180 or you have a plus cylinder cross 90, it is with the rule. माइनस सिलेंडर 180 डिग्रीज और प्लस सिलेंडर 90 डिग्रीज इज विद द रूल. और अगर इससे मैच नहीं हो रहा है तो इट इज अगेंस्ट द रूल. माइनस सिलेंडर 180 डिग्रीज प्लस सिलेंडर 90 डिग्रीज, दिस इज विद द रूल. अगर इससे मैच नहीं हो रहा है तो वो अगेंस्ट द रूल है. तो देखो हाउ डज दिस क्वेश्चन कम. ये जो क्वेश्चन है इट इज गोइंग टू कम समथिंग लाइक दिस. सपोज एक क्वेश्चन आता है फॉर एग्जाम्पल -2 स्फीयर एंड से -1 सिलेंडर क्रॉस -1 sphere, sorry, -2 sphere, -1 cylinder cross 180. This is the prescription. अब देखो सबसे पहले when we look at this prescription we have to say whether it is SMA, SHA, CMA, CHA और MA. तो ये सबसे पहले क्या है? It is CMA. Why are we saying it is CMA? Because देखो minus sphere and minus cylinder both of them are there. So because minus sphere, minus cylinder both are there, it is CMA. Now to decide with the rule and against the rule we have to look at this cylinder part. अब ये देखो सिलेंडर में माइनस सिलेंडर क्रॉस 180, माइनस सिलेंडर क्रॉस 180 मतलब इट इज विथ द रूल. सो दिस इज द आंसर वी हैव टू मार्क CMA. एक बार और सुन लो. सबसे पहले वी हैव टू लुक एट द प्रिस्क्रिप्शन एंड सी वेदर इट इज SMA, SHA, CMA, CHA और MA. तो इसको अगर हम देखेंगे इसमें देखो माइनस स्फीयर माइनस सिलेंडर दोनों ही हैं. So both minus sphere and minus cylinder means it is CMA. Now to subclassify it as WTR or ATR, हमें cylinder part of the prescription को देखना है. Now in the cylinder part of the prescription it is minus cylinder cross 180. Minus cylinder cross 180 का मतलब होता है with the rule WTR. ठीक है. अब एक और एग्जाम्पल ट्राई करो. सपोज यू हैव दिस एग्जाम्पल. इट गिव्स यू समथिंग लाइक दिस. से -1 स्फीयर and it gives say +4 cylinder cross 180. -1 sphere +4 cylinder cross 180. तो ये क्या है? This is a mixed astigmatism, right? This is MA. And if you look at this, it is plus cylinder cross 180. Plus cylinder cross 180 is against the. So MA against the. This is our answer. Mixed astigmatism and it is against. So why it is mixed astigmatism? It is mixed astigmatism because it's a combination of you say -1 sphere and +4 cylinder. तो ये MA है and it is plus cylinder cross 180, so it is against the rule. तो ये जो हमने पढ़ा है ना इसको अच्छे से याद रखना है. माइनस सिलेंडर क्रॉस 180 और प्लस सिलेंडर क्रॉस 90 मीन्स विद द रूल. अगर इससे मैच नहीं होगा तो इट इज अगेंस्ट. याद आ गया ना सबको ग्लास प्रिस्क्रिप्शंस. तो ये रिफ्रैक्टिव एरर के इमेजेस एंड ये ग्लास प्रिस्क्रिप्शन विद द रूल अगेंस्ट द रूल सबको याद आ गया. हेलो एवरीवन. Hi everyone. Am I audible and visible now? Sorry, there is some issue with the. Am I audible and visible? Okay, so देखो, we had thankfully before that connection went off, we had actually completed with refraction. So we are now going to start another new topic, and that is see extraocular muscles. So extraocular muscles and squint. One of you was just saying कि मैम we'll do extraocular muscles and squint. वही next topic है. So देखो extraocular muscles में we have like 6 extraocular muscles, that is the 4 rectus muscles, and we have the 2 oblique muscles. So 4 rectus muscles and we have 2 oblique muscles. Quickly to go over the nerve supply. What is the nerve supply? We remember the nerve supply as SO4 LR6. So SO, this is supplied by the 4th nerve. LR, that is lateral rectus, this is supplied by the 6th nerve. And जो remaining है, yes, we will get the you will get the annotated PDF. The LR is by the 6th nerve, and the others which are left, they are supplied by the 3rd nerve. So SO4, LR6. Yeah, SO by the 4th nerve, LR by the 6th nerve, and the others by the 3rd nerve. Now quickly, I will just go over what are the different eye movements. Ye bhi again, it's an important topic. What are the different movements of the eye? So first of all, if we keep the vertical axis as our center or the fulcrum, so ocular movements take place along 3 axes. What are the 3 axes? We have the vertical axis, we have the horizontal axis, and we have the anteroposterior axis. Yeah? So if we keep the vertical axis as the fulcrum, then the two movements along the vertical axis are adduction and abduction, meaning if I keep this as my fulcrum, adduction and abduction. Now quickly to go over which are our adductors and which are our abductors. So mainly which is our main adductor, adduction and abduction are the two movements on the vertical axis. Now which is our main adductor? Obviously common sense says that the main adductor is medial rectus, and it is minimally helped by 2 other muscles, that is superior rectus and inferior rectus. So MR, SR, IR, these are our adductors. Now which are our abductors? The abductors, the main abductor is obviously lateral rectus, and it is minimally helped by superior and inferior oblique. So LR, SO and IO, these are our abductors. Now if we keep the horizontal axis as the fulcrum, then what are the different movements about the horizontal axis? So if you keep the horizontal axis as the fulcrum, then the two movements are elevation and depression. So which are our elevators? We have to remember that the elevators are SR and IO. So superior rectus and inferior oblique, these are the elevators. And which are the depressors? The depressors are obviously inferior rectus and superior oblique, that is IR and SO. These are the depressors. So SR and IO, these are the elevators. IR and SO are the depressors. Now, if I keep the anteroposterior axis as the fulcrum, then what are the two movements on the anteroposterior axis? The two movements on the anteroposterior axis are intorsion and extorsion. The two movements on the anteroposterior axis are intorsion and extorsion. And इसको remember करने का mnemonic क्या है? इसको remember करने का mnemonic है sin. Sin means superiors are intorters. So which are the intorters? The intorters are SO and SR. And the extorters are IO and IR. The intorters are SO and SR, and the extorters are IO. Okay, so quickly, what are the things to be memorized? The adductors are MR, SR, IR. Abductors are LR, SO, IO. Elevators are SR and IO. Depressors are IR and SO. Which are the intorters? Intorters are SO and SR. Extorters are IO and IR. Remember it as sin. Sin means superiors are, right? This is one way in which the question can come. The other is, what is the main function of these muscles? ऐसे करके भी पूछते हैं. इसमें कैसे? The movement has been given and you have to tell which are the muscles. Now they ask, what is the primary functions? The primary function of the different muscles. So if we are asked, what is the primary function of superior rectus? What is the primary function of superior rectus? Please remember that for the rectus muscles, primary function will either be elevation or depression. Lekin for the oblique muscles, the primary function is always torsion. They are rotatory muscles. So rectus muscles के लिए primary function elevation depression होगा. Oblique muscles के लिए primary function intorsion or extorsion. So for superior rectus, the primary function is elevation, whereas to inferior rectus है उसका primary function है depression. So superior rectus elevation, inferior rectus depression. For superior oblique, it is intorsion. Remember, sin, superiors are intorters, and for inferior oblique, the primary function is extorsion. Again, very important for exam. So SR for the rectus muscles, it is either elevation or depression. So superior rectus के लिए elevation, rectus के लिए depression. For the oblique muscles, the primary function will be either intorsion or extorsion. SO के लिए intorsion. So this is about the extraocular muscles. Now quickly we have to go through the the nerve palsies that we have to learn. That is third nerve palsy, fourth nerve palsy, and sixth. So chalo, quickly we'll start with third cranial nerve palsy. Third nerve palsy probably came in the last exam. So the others are maybe like more common this time. So chalo, quickly पढ़ लेते हैं. What are the features of third cranial nerve palsy? So for third cranial nerve palsy, what are the muscles which are supplied by the third nerve? वो पहले पढ़ते हैं. So the third nerve, which is the lead muscle that is supplied by the third nerve. The lead muscle that is supplied by the third nerve is LPS, and because that is the levator palpebris superioris, and that is why the feature is going to be severe ptosis. It supplies the LPS and therefore there is severe ptosis. Number two, which are the intraocular muscles? Which are the intraocular muscles that are supplied? Will you quickly tell me which are the intraocular muscles that are supplied by the third nerve? Which is the intraocular muscles? There are two intraocular muscles which are supplied by the third nerve. The two intraocular muscles are, yes, we have the ciliary muscle, and therefore in case of third nerve palsy, there will be a loss of accommodation. In third nerve palsy, there is loss of accommodation. Next, it also supplies the sphincter pupillae muscle. It also supplies the sphincter pupillae muscle, and because it supplies the sphincter pupillae muscle, that is why we have a dilated and fixed pupil. That's why we have a dilated and fixed pupil. Lastly, it supplies all extraocular muscles except the SO and the LR. It supplies all the extraocular muscles except SO and LR. That means SO and LR are still functioning. Now, SO is a depressor and LR is an abductor. So, what does the SO do? The SO pulls the eye down and the LR pulls the eye out. So, that is why eye is down and out. Eye is down and out. So these are the features of third cranial nerve palsy. Extremely, extremely, extremely important. So what are the important things to remember in third nerve palsy? In third nerve palsy, see, it is not just a squint. There are some other features involved also. The lead muscle, LPS is involved, so there is a severe ptosis. Intraocular muscles affected are ciliary muscle and sphincter pupil. So there is loss of accommodation. The pupil is dilated and fixed. All the extraocular muscles are involved except SO and LR. So the eye is down and out. So let's have a look at this image. In this image, what are the things you can see? You can see that somebody is pulling up the lid. So somebody is pulling up the lid means that there is a severe ptosis. You can make out the eye is down and out. We can, in most cases, see that the pupil is dilated. So these are the features of third cranial nerve palsy. But though the eye is down and out, there is a significant deviation. But in spite of that, there will be no diplopia and there will be no head posture because the ptosis itself is protecting the patient. Okay, so usually there is no diplopia and there is no head posture in third nerve palsy, in complete third nerve palsy because of the severe ptosis. Okay, on the same lines, let's go and learn about fourth cranial nerve palsy. Ab yaad karo, fourth cranial nerve supplies which muscle? It supplies the superior oblique muscle, right? So what are the main functions of superior oblique? The main functions of superior oblique are, what does it do? It's a depressor and it is an intorter. So it is mainly an intorter. So intorsion and depression, these are its functions. So fourth cranial nerve palsy, fourth cranial nerve supplies the SO, that is the superior oblique. And what does the superior oblique do? Superior oblique is an intorter and depressor. So therefore, because the intorsion is affected, that is why the eye is extorted. And because the depression is affected, that's why the eye is elevated. Okay, so there is extorsion and there is elevation. So see, what is the squint? The squint is extorsion and elevation or hypertrophy. Now, because of this squint, the patient suffers from diplopia. What kind of diplopia? It is a vertical and torsional diplopia, and it is maximum in down gaze. Why is it maximum in down gaze? Because the SO is a depressor. So when the patient tries to depress, he's not able to depress, and so the diplopia is maximum in down gaze. So what are the activities that are affected? The activities that we do in down gaze are reading, writing, and climbing down the stairs. So reading, writing, and climbing down the stairs. Climbing down the stairs. So these are the activities which are affected. And what is the compensatory head posture? See, in a case of SO palsy, if you look at this eye and there is an SO palsy, see what is the squint? The squint is extorsion. So the eye is already rotated outwards. Now, because the eye is extorted, in order to correct this extortion, the patient tilts the head to the other side. देखो ये आँख जो है, it is rotated outwards. So in order to correct this, what does the patient do? The patient just tilts the head to the opposite side. So the compensatory head posture is a head tilt. Head tilt to the opposite side. Head tilt to the opposite side. Why? To overcome the extortion. To overcome the extortion. Overcome the extortion. So quickly, I'll just go over it once more. What are the features you need to remember in fourth cranial nerve palsy? देखो, fourth cranial nerve, it supplies the SO. So fourth cranial nerve palsy is SO palsy. What are the features of S? What are the functions of SO? SO, if you look at it this side, it is intorsion and depression. So therefore, the squint is going to be extorsion and elevation. Now, because of this squint, the patient gets a vertical and torsional diplopia, which is maximum in down gaze. Why maximum in down gaze? Because SO is a depressor. So when the patient tries to depress, he's not able to depress and he ends up with diplopia. So the activities affected are reading, writing, and climbing down the stairs. And in order to overcome this extortion, what does the patient do? The patient tilts the head to the opposite side. So head tilt to the opposite side is the compensatory. That is the compensatory. Okay, so this is fourth cranial nerve palsy. On the same lines, let's do the last one, the simplest one, that is sixth cranial nerve palsy. So sixth nerve supplies the lateral rectus. So sixth nerve palsy is also LR palsy. So what is the function? The function of lateral rectus is abduction. So the movement that is lost is abduction. And therefore, because the abduction is lost, that is why the eye is, it shows convergent squint. The eye is deviated inwards. So there is a convergent squint or esotropy. Because of this esotropia, there is a horizontal diplopia, which is maximum on the affected side, which means that when the patient tries to, if there is an LR palsy on this side, when the patient tries to look to the same side, there is maximum diplopia. So instead of looking to this side, the patient just turns the face to this side. So the compensatory head posture is a face turn to the affected side. It's a face turn to the affected. Let me just go over it once more. So in case of sixth nerve palsy, the muscle affected is lateral rectus. The movement that is affected is abduction. Now, because the abduction is weak, that is why the eye is in a position of convergent squint or esotropy. Because of this esotropia, there is a horizontal diplopia, which is maximum on the affected side. Why on the affected side? Because see, if there is an LR palsy on this side, when the patient tries to look to this side, he will not be able to abduct this eye. So maximum diplopia is on the affected side. So instead of looking to the affected side, the patient turns his face to the affected side. Okay, so have a look at this image. In this image, the first picture, this is the primary position. This is the primary position. So if you look at the primary position, what do you see? In the primary position, you see that the left eye is showing esotropia. The left eye is showing esotropia. And here, this is a picture of the left gaze. The patient has been asked to look to the left side. And in the left gaze, you see this eye is moving. The right eye is moving, but the left eye is not moving. So there is a limitation of abduction. So the left eye is showing esotropia and the left eye also shows a limitation of abduction. So the first picture is the primary position. Primary position, this patient is actually looking straight. So when they in a primary position, you see that the left eye is showing a convergent squint or esotropia. And on the left gaze, this eye fails to move. This eye should have moved to this corner, but it has not moved. So there is a limitation of abduction. So here the diagnosis is left-sided sixth nerve palsy. The diagnosis is left-sided sixth. तो बताओ याद आया क्या? Extraocular muscles, third foot, sixth nerve palsy, सबको याद आया? I hope everybody was able to understand. याद आ गया है? Yes, I'm sure कि याद आ गया होगा. Because like these things, I've read it multiple times. It is just that before the exam, the salient points, the most, what is most important has to be at the topmost part of our brain. बस इतना ही है. वो हमें इसीलिए ये जो high yield चीजें हैं, in the last like 8 to 10 days, go over the high yield stuff. Do not suffer from FOMO कि ये नहीं आता है, वो भूल गया है. ऐसे ही लगता है एग्जाम के आगे. Just before the exam, you will get this feeling कि सब कुछ भूल गया है, जो जो पढ़ा था कुछ याद नहीं. बट वैसा नहीं होता है. You remember everything. You have revised also. अभी ये जो last 10 days है ना, in these 10 days, look at the high yield stuff, look at the PYQs. एंड ट्राई जो जो तुमने पढ़ा है, जो तुम्हारे ब्रेन के नीचे है, उसको हमें सरफेस पे लाना है. इंपॉर्टेंट चीज. दैट्स ऑल यू हैव टू डू इन द लास्ट. ओके, चलो अब देखो द नेक्स्ट थिंग दैट वी हैव इज हॉर्नर्स सिंड्रोम. हॉर्नर सिंड्रोम. Horner syndrome, the other name for Horner syndrome is oculosympathetic palsy. The other name for Horner syndrome is oculosympathetic palsy. So it is a paralysis of the sympathetic nerve supply to the eye. So what are the structures that are actually supplied here? So number one is the Muller's muscle in the lid. Now because the Muller's muscle in the lid is affected, that's why you will have a ptosis, but it's going to be a mild, not a severe ptosis, mild ptosis. And because of this mild ptosis, the eyeball, it appears to be sunken. मतलब वो actually sunken नहीं है, just gives that kind of impression. So this is called as apparent enophthalmos. Mild ptosis and apparent enophthalmos. Next, what is affected? What is affected is the dilator pupillae muscle. So if the dilator pupillae muscle is affected, what will you have? Will have meiosis, meaning we will have a constricted pupil. And last, what is affected is the sweat gland. Now because the sweat gland is affected, we are going anhydrous. We will have anhydrous. So mild ptosis with apparent enophthalmos, then mild ptosis with apparent enophthalmos, mild ptosis with apparent enophthalmos, meiosis and anhydrosis. So now have a look at this image. इस image में हमें क्या दिख रहा है? You can make out a mild ptosis, and if you compare the size of the pupil, you will be able to make out that this affected eye, that is the right eye, is always having a mild ptosis and meiosis. ये दोनों चीजें हम make. So now, as I have been telling you multiple number of times, whenever we get a question on this, the two things which we have to keep in our mind are, what are the two things in our mind? Number one, हम याद करेंगे, it can be third nerve palsy. Number two, it can be Horner syndrome. तो थर्ड नर्व पाल्सी में क्या क्या फीचर्स अभी रिवाइज किया हमने? थर्ड नर्व पाल्सी में इट्स अ सिवियर टोसिस. Number two, the eye is deviated downwards and outward. Number three, the pupil is right. So देखो थर्ड नर्व पाल्सी में क्या क्या पढ़ा हमने? There is a severe ptosis. The eye is down and out and the pupil is dilated. जबकि अगर it's a question on Horner syndrome, तो what are the things to remember? Horner में जो ptosis है mild है, जो pupil है it is constricted. Mild ptosis and meiosis, this Horner syndrome. Severe ptosis, eye down and out and dilated pupil is third. Okay, so this is about the important types of nerve lesion. Now I come to a very, very, very important question, that is the visual pathway. ये भी देखो, it's almost a sure shot question. इसमें से कुछ ना कुछ हर साल आता है. So visual pathway में first of all, what are the structures which are there, which are a part of the visual pathway? So we have the optic nerve, one optic nerve on this side, one optic nerve on this side. Then we have the optic chiasma. So optic chiasma is a midline structure. Then they split again to form the optic tract. They form the optic tract. Then the optic tract goes into this structure. This is called as the LGB, lateral geniculate body. Then we have a radiating set of fibers, which is called as the optic radiation. And ultimately it comes to this. This is called as our occipital cortex. So what are the structures in the visual pathway? It is optic nerve, optic chiasma, optic tract, lateral geniculate body, optic radiation, and occipital cortex. तो यहाँ से हमें क्या क्या पढ़ना होता है? नंबर 1 is lesion in the optic nerve. This is lesion number 1. Number 2, lesion at the center of the optic chiasma. That's lesion 2. Number 3, lesion in the optic tract. That is number 4, lesion in the optic radiation. And last है lesion in the optics. That is number 5. Okay, अब यहाँ पे what is the crux of the visual pathway? I had told you multiple number of times that we have to remember in the visual pathway that the nasal fibers here, the nasal fibers in the retina are receiving the light from the temporal side. The temporal fibers are receiving the light from the nasal side. So the nasal fibers receive the light from the temporal side. The temporal fibers receive the light from the nasal side. So this means that anywhere in this pathway, if the nasal fibers are lost, the temporal field will be lost. And if the temporal fibers are lost, the nasal field will be lost. So इसे हमें याद रखना. Now, what is the distribution of fibers? See, all the fibers in one particular eye, they come into the optic nerve. At the level of the chiasma, the nasal fibers of both eyes, they cross and they enter the optic tract of the opposite side. लेकिन जो temporal fibers हैं, they do not cross. They continue on the same side. Yeah. So at the level of the chiasma, the nasal fibers cross. So nasal fibers का ही सिर्फ crossing होता है. Temporal fibers do not. Now let us see what are the features, what are the lesions. So number 1 is lesion in the optic nerve. So lesion in the optic nerve जो मैंने यहाँ पे बनाया है, see always in pictures of the visual pathway, remember ये तुम्हारा right है और ये तुम्हारा left है. This I have told you multiple times in the class also that visual pathway वाले pictures में right and left जो है उसको अपने hand के हिसाब से mark करना है. So this is right and this is left. Am I audible and visible now? भी ठीक से सुनाई दे रहा है क्या? I hope I'm audible, visible now. Or is the voice breaking now also? Or is it okay? It's okay? Okay. So remember, see, we had discussed that visual pathway वाले जो pictures हैं उसमें right and left जो है we have to mark it according to our own right hand and left hand, not like a clinical image. क्योंकि अगर हम clinical image बनाएंगे ना, so clinical image में right and left opposite होता है. ये right है, ये left है. Okay, so clinical image में always right and left are opposite. Whereas in case of pictures of the visual pathway, the right and left have to be marked according to your own right hand and left hand. So this is right and this is left. Now see how do we represent the lesions of the visual pathway? We represent the lesions of the visual pathway like this. So right and left hai, and again we divide it into into two parts. Inner part nasal है, outer part temporal है. So now if there is a lesion in the optic nerve, यहाँ पे देखो हमने left sided optic nerve को mark किया है. So if you look at the left sided optic nerve, so all the fibers of the left eye are lost. So all the field of the left eye will be lost. So all the field of the left eye is lost. तो इसको हम क्या बोलेंगे? This we call as monocular blindness. So lesion in the optic nerve, it causes monocular blindness. Lesion in optic nerve causes monocular blindness. Number 2 is lesion in the optic chiasma. Now lesion in the optic chiasma, so what are the fibers in the optic chiasma? It contains the nasal fibers from both eyes, right? So nasal fibers from both eyes are there at the center of the chiasma. So if the nasal fibers of both eyes are lost, then which field will be lost? It is the temporal field of both eyes. तो इसका temporal और इसका temporal, दोनों का temporal हमने black out किया है. So temporal field of both eyes is lost. So this is called as bitemporal hemianopia. And bitemporal hemianopia का दूसरा नाम क्या है? Bitemporal hemianopia is also called as heteronymous hemianopia. So bitemporal hemianopia is also called as heteronymous hemianopia. अब यहाँ पे पूछते हैं what actually affects the optic chiasma and causes this bitemporal hemianopia. It is commonly affected by pituitary adenoma. It's commonly affected by pituitary adenoma and less commonly by another tumor which is called as craniopharyngioma. So pituitary adenoma and craniopharyngioma, they affect the optic chiasma and they give rise to this bitemporal hemianopia or heteronymous hemianopia. Now, next, lesion number 3 and lesion number 4. Lesion number 3 and lesion number 4, that is lesion in optic tract or optic radiation. So lesion in optic tract or optic radiation agar hai, so then what kind of defect am I going to get? I will get a defect which looks like this. So the nasal field of one eye and the temporal field of the other eye are affected. So इसमें देखो, the nasal field of this eye and the temporal field of this other eye are affected. और इसको क्या बोलते हैं? This is called as homonymous hemianopia. So homonymous hemianopia means that the site of the lesion is the optic tract or optic radiation, but it is more commonly the optic tract only. And what actually affects the optic tract and optic radiation? They are affected mainly by vascular infarcts and they can also be affected by tumors. So mainly by vascular infarct and less commonly by tumor. So lesion in optic tract or optic radiation, it gives rise to homonymous hemianopia. And last hai lesion number 5. Lesion number 5 means lesion in the occipital cortex. Now lesion in the occipital cortex, what is the lesion in the occipital cortex? Lesion in the occipital cortex is also a vascular infarct. But we have to remember that the blood supply of the occipital cortex is not single. The occipital cortex is mainly supplied by which artery? By the posterior cerebral artery, but the central fibers are also supplied by the middle cerebral artery. So when we say vascular infarct, we actually mean what? We actually mean PCA infarct. When we say vascular infarct, we actually mean PCA infarct. So if there is a PCA infarct, the fibers of the occipital cortex will be affected, but the central fibers will be spared. है ना? So the same thing is reflected in our field also. We get a homonymous hemianopia where the central part is clear. तो ये ऐसा दिखता है. We get a homonymous hemianopia where the central portion is clear. So what is this called? This is called as homonymous hemianopia with macular sparing. अब एक मिनट प्लीज मुझे ध्यान से सुनो. A couple of years back ये क्वेश्चन आया था इन दी एग्जाम एंड लॉट ऑफ, अब ये जो ऑक्सीपिटल कॉर्टेक्स लीजन है ना, सारे बच्चे उसको मैकुला स्पेयरिंग करके याद करते हैं, विच इज़ फाइन. लेकिन अ कपल ऑफ इयर्स बैक वी हैड अ क्वेश्चन जिसमें दो ऑप्शंस थे, हेट्रोनिमस हेमियानोपिया विथ मैकुला स्पेयरिंग एंड होमोनिमस हेमियानोपिया विथ मैकुला स्पेयरिंग. So please remember that it is not heteronymous, it is homonymous hemianopia with macular sparing. Homonymous hemianopia with macular sparing, and the other name for heteronymous hemianopia is actually bitemporal hemianopia. Okay, so these are the important lesions of the visual pathway. Now see, अगर इस तरह से क्वेश्चन आता है तो आई एम श्योर दैट यू विल गेट इट राइट ओनली, बट समटाइम्स जो क्वेश्चन है वो उल्टा भी आ जाता है, दैट इज दे गिव द इमेज एंड दे आस्क द साइट ऑफ द लीशन. तो एक बार देखो, सपोज दे गिव समथिंग लाइक दिस. सो जब भी कोई इमेज है ना, उसको राइट लेफ्ट करके मार्क कर लो. सो एंड इनर पार्ट को नेजल, आउटर पार्ट को टेम्पोरल करके मार्क. So here what do you see? You see the temporal of both eyes is affected, the temporal field of both eyes is affected. So ये है हमारा bitemporal hemianopia. Bitemporal hemianopia मतलब what is, or heteronymous hemianopia means site of the lesion is your optic chiasma. Site of the lesion is the optic chiasma. अब इसको देखो, ये पिक्चर जब भी एग्जाम में आता है, एग्जाम के स्ट्रेस में ना बच्चे इसको बाइटेम्पोरल ही मार्क करते हैं, लेकिन लुक एट दिस इमेज, ये बाइटेम्पोरल नहीं है. द नेजल फील्ड ऑफ वन आई एंड द टेम्पोरल ऑफ द अदर आर अफेक्टेड. So nasal of one and temporal of the other means that it is a homonymous hemianopia. It is a homonymous hemianopia, and homonymous hemianopia can be because of optic tract or optic radiation, but usually it is because of optic tract. But it is usually because of optic tract, less commonly because of optic radiation. Now look at this last picture, then I'll come to these two. ये भी देखो, ये भी homonymous hemianopia ही है, because nasal of one eye and temporal of the other are affected, but the central part is clear, right? So ये क्या है? This is homonymous hemianopia with macular sparing, and homonymous hemianopia with macular sparing means the site of the lesion is your occipital cortex. Homonymous hemianopia with macular sparing means site of lesion is the occipital. So ये तो हमने पढ़ लिया है, but for the exam, because this is such an important question, I don't want you to miss anything here. ये दो और हैं. So these two, these are slightly difficult questions just in case it comes. तो देखो, अगर ऐसा पिक्चर आता है, when you get this also, you mark it as right and left. इसमें देखो, this is also a homonymous hemianopia, क्योंकि nasal of one eye and temporal of the other is affected, लेकिन complete नहीं है. It's a homonymous hemianopia which is only superior, है ना? So this kind of a homonymous hemianopia which is only superior, it is called as pie in the sky. इसको by heart करो, pie in the sky. Pie in the sky is also called as superior quadrantopia because it affects the superior quadrant. Right, pie in the sky or superior quadrantopia, and therefore, and if we are asked what is the site of the lesion, the site of the lesion is the temporal lobe. The site of the lesion is the temporal lobe, and this set of fibers which passes through the temporal lobe is called as the Mayer's loop. It's called as the Mayer's loop. So isko yaad karo, if I have a homonymous hemianopia which is only superior, then I will call it as pie in the sky or superior quadrantopia, and the site of the lesion is the temporal lobe or the Mayer's loop. अब इसका एग्जैक्ट काउंटर पार्ट जो है वो ये है. इसमें भी देखो होमोनिमस हेमियानोपिया है लेकिन इंफीरियर है. So this inferior homonymous hemianopia, na, this is called as pie on the floor. And as common sense will tell you, it is also called as inferior quadrantopia. Pie on the floor is also called as inferior quadrantopia. And what is the site of the lesion for pie on the floor? It is the parietal lobe. It is the parietal lobe or the Bohm's lobe. It is the parietal lobe, and this loop of fibers is called as. तो ये दोनों जो है ये एक्स्ट्रा है which you may not have read, but because the visual pathway is so important, इन दोनों को by heart करो. So pie in the sky, also called as superior quadrantopia, site of lesion is the temporal lobe or the Mayer's loop, and pie on the floor or inferior quadrantopia, site of the lesion is the parietal lobe or the Bohm's loop. Okay, so these are the defects of the visual pathway. तो चलो, विजुअल पाथवे तो रिवाइज हो गया. ये दोनों चीज ही बस, दे मे बी समथिंग विच यू मे नॉट हैव रेड, बट लर्न इट अप बिकॉज विजुअल पाथवे में से अगर कुछ और वो छूट जाए तो दैट विल बी रियली सैड. चलो, नाउ द नेक्स्ट सेट ऑफ next what we are going to read the pupillary pathway, the pupillary reflex pathways. We are going to read the pupillary reflex pathways. The pupillary reflex pathway. So quickly dekho the pupillary reflex pathway. This is our pupillary reflex pathway. So in the pupillary reflex pathway, we will first be looking at the light reflex. We look at the light reflex pathway. The light reflex pathway, light reflex kya hai? Light reflex means that if you put light in one eye, the pupil is going to constrict in both eyes. So even if I put light only in one eye, the pupil is going to constrict in both eyes. That is my light reflex pathway. Now, like all reflexes, there is an afferent, there is a center, and there is an efferent. So what is the afferent for the light reflex? The afferent for the light reflex is the optic nerve, the optic chiasma, and the optic tract. So this is the optic nerve, this is the optic chiasma and optic tract. This is the afferent. What is the center? The center for the light reflex obviously is this structure in the brain. This is called as the pretectal nucleus. Where is the pretectal nucleus located? The pretectal nucleus is located in the dorsal part of the midbrain. Now, so the pretectal nucleus in the dorsal midbrain, this is the center for the light reflex. And what is the efferent? The efferent has to be bilateral, because even if I put light in one eye, then it is going to, the pupil is going to constrict in both eyes. So the reflex, the efferent reflex has to, sorry, the efferent arm has to be bilateral. So from this pretectal nucleus, it comes to this structure. This structure, so bilaterally, it comes to a structure called EW nucleus, or the Edinger-Westphal nucleus, which is the parasympathetic nucleus of the third nerve. So from the EW nucleus, the nerve that is coming out is called as the third nerve. And the third nerve comes to this structure. What is this structure? This structure is called as the ciliary ganglion. And beyond the ciliary ganglion, it is carried by a set of fibers which are called as the short ciliary nerves. So if I were to summarize, the afferent is the optic nerve, optic chiasma, and optic tract. The center is the pretectal nucleus in the dorsal midbrain. The efferent is bilateral EW nucleus, then third nerve, then ciliary ganglion, then short ciliary nerves. Now, what is the effector muscle? The effector muscle for this reflex, the effector muscle for this reflex is the sphincter pupillae. The effector muscle for this reflex is the sphincter pupillae. And what kind of reflex is it? It is a parasympathetic reflex. It's a parasympathetic reflex because see, the EW nucleus is the parasympathetic nucleus of the third nerve. तो ये है हमारा light reflex pathway. A light reflex pathway. Now on the same lines, we will learn about the near reflex. We will learn about the near reflex. Now, what are the components of the near reflex? The components of the near reflex are accommodation. The components of the near reflex are accommodation. We have convergence of the eyeballs, and we have meiosis, that is constriction of the pupils. It is obviously bilateral. So accommodation, convergence, and meiosis, these are the components of the near reflex. And for the near reflex, the afferent is not properly discerned. What we know is the center. So the center for the near reflex is, it is in the ventral midbrain, unlike the light reflex, which is in the dorsal midbrain. So the center for the near reflex is in the ventral midbrain. Efferent is the same. The efferent is the same. Okay, so now we will this, so near reflex में हमें क्या याद करना है? The afferent is not clearly discerned. The center, it is in the ventral midbrain. The efferent is the same, meaning bilateral EW nucleus, then third nerve, then ciliary ganglion, then short ciliary nerves. So now that we have learned the pathway for these reflexes, let us quickly learn up the defects of the pathway. So the commonest defect is RAPD, relative afferent pupillary defect, also called as the Marcus gun pupil. And this is seen when there is a lesion in the optic nerve. अब याद करो हमने क्या पढ़ा था? It is diagnosed with the help of swinging flashlight test. So swinging flashlight test में what do? You have to first put the light in which eye? In the normal eye. So देखो, this is a picture of the swinging flashlight test. This is a picture of the swinging flashlight test. So when you put the light in the normal eye, so हमें शुरू कहाँ से करना है? We have to put the light in the normal eye. So when you put the light in the normal eye, what do you see? You see that both eye the pupils will constrict. Both eye the pupils will constrict, because this is the normal eye. This is the normal response. Now, when you move the light immediately to the other eye, what do you see? You will see that both eye the pupils dilate. Both eye the pupils dilate. So this dilatation is called as paradoxical dilatation. This is called as paradoxical dilatation. So here always remember, if you get an image based question, कि जो first आंख में light डाला हुआ है ना, वो normal है. हमेशा light normal eye से ही हमें start करना है. So the light is put in the left eye in this picture. So the left eye is actually the normal eye. So both eye the pupils constrict. So when I put light in the normal eye, both eye pupils constrict. When I immediately ट्रांसफर द लाइट टू द एबनॉर्मल आई, देन बोथ आई प्यूपिल्स डायलेट. इसको हम बोलते हैं पैराडॉक्सिकल डायलेटेशन. सो इस पिक्चर के हिसाब से देखो, देयर इज राइट आई RAPD. तो अगर हमसे पूछा जाए व्हाट इज द साइट ऑफ द लीशन, तो हम क्या बोलेंगे? इट इज राइट साइडेड ऑप्टिक नर्व. सो द साइट ऑफ द लीशन इज द राइट साइडेड ऑप्टिक नर्व. ठीक है ना? So this is the most common defect, that is RAPD, relative afferent pupillary defect. Next is lesion in the optic tract. Wernicke is hemianopic pupil, but Wernicke's hemianopic pupil is not practically discernible. Third is light near dissociation. Light near dissociation means, what is the site of the lesion? It is the pretectal nucleus. So what is the pretectal nucleus? देखो pretectal nucleus ये है. It is the center for the light reflex. So when there is a lesion in the pretectal nucleus, the light reflex will go, but the near reflex will remain. Why the near reflex will remain? क्योंकि the site of the center for the near reflex is in the ventral midbrain. So in case of your light near dissociation, the light reflex is absent, but the near reflex is present because there is a damage to the pretectal nucleus. Classical example is Argyll-Robertson pupil, which is seen in neurosyphilis. तो आर्जिल रॉबर्टसन प्यूपिल के बारे में 3-4 चीजें याद करो. That Argyll-Robertson pupil is seen in neurosyphilis. What is the site of the lesion? The site of the lesion is the pretectal nucleus, which is the center for the light reflex. So how does it present? It presents with light near dissociation. Light near dissociation का मतलब होता है light reflex goes, but near reflex जो है it is present. The last one is Ades tonic pupil. What is Ades tonic pupil? It is the site of the lesion is the post-ganglionic pathway. Post-ganglionic pathway matlab the short ciliary nerves, that is beyond the ciliary ganglion. So the short ciliary nerves beyond the ciliary ganglion, that is the site of the lesion. So now this is the final common pathway for both light reflex and near reflex. So therefore, isme light and near reflexes are both affected. Light and near reflexes are both affected. So what happens to the pupil on that particular side? The pupil on that particular side is large. So this is called as anisocoria. So anisocoria is an important one-liner. Anisocoria means that there is a difference in pupillary size. There is a difference in pupillary size between the two eyes. There is a difference in pupillary size between the two eyes. So let's just go over it once more. See, देखो, light reflex, both light reflex and near reflex will be affected in Ades tonic pupil. क्यों? Because the site of lesion is the short ciliary nerves, which is the final common pathway for both the reflexes. So because both are affected, that's why the pupil on that side is large and dilated. So there is a difference in pupillary size. This is called as anisocoria. ठीक है? Slightly digressing from here, with two more aniso words जो MCQ में पूछते हैं. Will you tell me what is the meaning of the word anisometropia? What is the meaning of the word anisometropia? Anisometropia means difference in refractive error or refractive power between the two eyes. Difference in refractive error between the two eyes is called as anisometropia. And anisiconia. Anisiconia. What is the meaning of the word anisiconia? Anisiconia means that there is a difference in image size between the two eyes. Difference in image size between the anisometropia is difference in refractive error, anisiconia difference in image size, and anisocoria is difference in pupillary size. ठीक है, 3 one-liners. तो देखो, आई होप दैट प्यूपिलरी रिफ्लेक्सेस एंड इट्स डिफेक्ट्स भी सबको एक बार अच्छे से याद आ गया होगा. याद आया है ना? आई होप दिस मच एवरीबडी हैज बीन एबल टू रिकॉल. ओके, चल, लेट्स जस्ट गो ओवर. Now a couple of topics from retina which are important, CRAO and CRVO. So देखो, this is a very commonly asked image in the exam. CRAO, central retinal artery occlusion. There is a sudden and severe loss of vision. Patient presents with sudden and severe loss of vision. Visual acuity is very poor. It is like counting fingers at a few meters. Anterior segment is normal and the retina shows this kind of a cherry red spot. So देखो ये है cherry red spot. How do we identify this image? Very commonly asked image in the exam. See, the retina appears edematous and pale. The retina appears edematous and pale, but only the fovea is dark or bright. So there is a bright fovea. This is called as the cherry red spot. And now what's the treatment? It's an ocular emergency. It has to be treated within the initial few hours. But unfortunately, the treatment options that we have are not very, very well directed. The idea is that you suddenly lower the intraocular pressure, and when you suddenly lower the intraocular pressure, it creates a jerk and it may dislodge the thrombus. So what are the methods of doing this? The methods of doing this is vigorous ocular massage, paracentesis or aspiration of aqueous humor, and intravenous mannitol. So all this, the idea is sudden lowering of IOP. There is a sudden lowering of IOP, and this sudden lowering of IOP creates a jerk effect and it may dislodge the thrombus. उसके साथ you also give inhalation of carbogen. Why inhalation of carbogen? Because carbogen is considered to be a vasodilator. Carbogen is considered to be a vasodilator. But unfortunately, all these treatment options are pretty empirical, and that is why the prognosis of CRAO is poor. The prognosis of CRAO is poor, one, because it is an emergency and the patient has to come within the first few hours. And secondly, the treatment options are not very well directed. On the same lines, let's do the next one, that is CRVO, central retinal vein occlusion. Again, there is a sudden and painless decrease in vision. The visual acuity is decreased, but it is not obviously as bad as it is in CRAO. Again, anterior segment is normal and posterior segment looks, it is full of hemorrhages, and it is called this, that is the splashed tomato appearance. So the whole retina is full of hemorrhages. What is the treatment? Now, fortunately for venous occlusions, most of the cases are mild. Most of the cases are mild cases, and the mild cases, they resolve spontaneously over 6 months. So most of the cases, we actually do not have to do anything. Most of the cases, they will resolve spontaneously over 6 months. So for the mild cases, the treatment is only observation, that is wait and watch. Observation or wait and watch, that is the treatment for the mild cases. However, the problem arises with the severe cases. The problem arises with the severe cases. So what are the severe cases? The severe cases are the ischemic CRVO. So these ischemic CRVO, they are going to give rise to neovascularization. They will give rise to retinal ischemia. They give rise to retinal ischemia, increase in VEGF, and neovascularization. Retinal ischemia, increase in VEGF, and neovascularization. So therefore, what will happen for these ischemic CRVO cases? We have the treatment option of laser photocoagulation, and we have the option of intravitreal injections. Laser photocoagulation and intravitreal anti-VEGFs or even steroids. So this is for CRVO. So most of the cases are mild, and the mild cases, they will resolve by themselves spontaneously over 6 months, and the treatment is only observation. Only for the severe or the ischemic cases, which will eventually lead to ischemia and neovascularization, we treat them with laser photocoagulation or intravitreal anti-VEGFs and steroids. And these cases of ischemic CRVO, if they are left untreated, what will happen? If they are left untreated, they will progress to neovascular glaucoma. They will progress to end-stage neovascular glaucoma over 3 months. And what is this end-stage neovascular glaucoma called? It is called as 100-day glaucoma. Again, important for MCQ. So 100-day glaucoma is nothing but end-stage neovascular glaucoma, which is seen in untreated ischemic CRVO. So if ischemic CRVO is left untreated, then over a period of 3 months, it will progress to end-stage neovascular glaucoma, and that's called as 100-day glaucoma. So if we are asked what is the prognosis of venous occlusion, prognosis of venous occlusion is actually good because most of the cases are mild और उसमें हमें कुछ करना ही नहीं है. It is going to resolve spontaneously over a period of 6 months. समझ आया? So these are arterial occlusion and venous occlusion. Arterial occlusion and venous occlusion. Now again, another important topic from retina, retinoblastoma. Retinoblastoma, it is the most common intraocular malignancy in children. It is the most common intraocular malignancy in children. Most common intraocular malignancy in children. The gene responsible for this is the RB gene. The location of the gene is 13q14. Now, 94% are actually sporadic and only 6% is familial. But the familial cases of retinoblastoma are associated with other malignancies like osteosarcoma. The familial cases are associated with other malignancies like osteosarcoma. It generally presents at the age of 18 months. And what is the most common presenting feature? It is what you can see in the image, that is leukocoria or white pupillary reflex. Leukocoria or white pupillary reflex. And most common route of spread. Most common route of spread. What is the most common route of spread? The most common route of spread is direct spread to the brain via the optic nerve. Direct spread via the optic nerve. Direct spread via the optic nerve. Now let us come to what is the treatment for retinoblastoma. What is the treatment for retinoblastoma? So if we have an intraocular retinoblastoma, what is the treatment for retinoblastoma? Treatment is, suppose it is an intraocular retinoblastoma, an intraocular RB. Intraocular retinoblastoma, if it is large, meaning if it is occupying more than 50% of the eyeball, then the treatment is enucleation. What is enucleation? Enucleation means removal of the eyeball with a portion of the optic nerve. Why are we removing a portion of the optic nerve? Because the most common route of spread is via the optic nerve. Now, if it occupies less than 50% of the globe, then the treatment is only focal therapy. Focal therapy means you treat the tumor without removing the eyeball. So, treatment of retinoblastoma, if it is intraocular and it occupies more than 50% of the globe, treatment is enucleation. Less than 50% of the globe, focal therapy. Now, if it is retinoblastoma with orbital extension, meaning it is a locally advanced retinoblastoma. If it is a retinoblastoma with orbital extension, then see, it is inoperable. So, to make it operable, first we have to give a few cycles of chemotherapy. Once you give the chemotherapy, the tumor is going to regress, and when it regresses, then you go for enucleation. And after enucleation, we have to follow it up with orbital radiotherapy. So for retinoblastoma with orbital extension, it is chemotherapy, enucleation, and orbital radiotherapy. And the last one is retinoblastoma with metastases. So the treatment for metastases is always palliative chemotherapy. The treatment is for metastases is always palliative chemotherapy. Now, PYQ from here, what are the chemotherapy drugs that are used here? See, the chemotherapy drugs are to be remembered as VEC. V stands for vincristine. E stands for etoposide. Vincristine, etoposide, and C stands for carboplatin. So, vincristine, etoposide, and carboplatin. This is the treatment for retinoblastoma with metastases. Right? So this, please remember that for intraocular more than large, it is enucleation. Intraocular but small, it is focal therapy. Retinoblastoma with orbital extension, neoadjuvant chemotherapy, then enucleation, then orbital radiotherapy. And retinoblastoma with metastases, it is palliative chemotherapy. The chemo drugs are vincristine, etoposide, and carboplatin. Now, one more image that you must remember from here is this one, that when you do an enucleation for retinoblastoma, you send the specimen for histopath. And here you get to see two types of rosettes. What are the two types of rosettes? We have the Flexner Wintersteiner rosette. We have the Flexner Wintersteiner rosette, which is more specific for retinoblastoma, and we also have another one, which is the Homer Wright rosette. So what is rosette? See, you will see that the tumor cells are arranged around the central lumen. So this pattern is called as the rosette pattern. There are two rosettes, Flexner Wintersteiner and Homer Wright, but what you see here is this Flexner Wintersteiner, again PYQ. So this is a picture of the Flexner Wintersteiner rosette, which is more specific for retinopathy. ठीक है. सो देखो रेटिनोब्लास्टोमा में हमने पढ़ा मोस्ट कॉमन इंट्राक्युलर मैलिग्नेंसी इन चिल्ड्रन इज रेटिनोब्लास्टोमा. अब यहाँ से एक और पीवाईक्यू याद कर लो, विच इज द मोस्ट कॉमन इंट्राक्युलर मैलिग्नेंसी इन अडल्ट्स. So the most common intraocular malignancy in adults is choroidal metastases. It is choroidal metastases. Most common intraocular malignancy in adults is choroidal metastases. Choroidal metastasis. Got it? So this was about retinoblastoma. Retinoblastoma तो obviously हमें पढ़ना ही है before the exam. Now we are almost close to the end of the session. Just a few images that I wanted to show you. Again important images जो आ सकते हैं. तो quickly बताओ ये जो image है ये क्या है? What is this image? I think all of you will be able to identify ये कौन सा cataract है? Snowflake cataract. Where do you get to see snowflake cataract? Snowflake cataract is seen in diabetes mellitus, and PYQ, it is due to the accumulation of sorbitol. So this is caused by accumulation of sorbitol. So snowflake cataract caused in diabetes mellitus, accumulation of sorbitol. ये क्या है? This is oil droplet cataract. This is oil droplet cataract, and where do you get to see oil droplet cataract? We get to see it in galactosemia. Oil droplet cataract, which is seen in galactosemia. Next, what is this one? This is actually your sunflower cataract. ये जो picture है ना, this is a picture of sunflower cataract, and where do we get to see sunflower cataract? It is in Wilson's disease. Sunflower cataract, it is. What is this one? This is typically the rosette cataract, very common PYQ, and rosette cataract, this is in blunt. So flower shaped cataract, देखो this kind of a flower shaped cataract, this is the rosette cataract. Now, what is this? This is Christmas tree cataract. You can see this kind of a shiny opacity, and if you just outline the opacity, looks something like this. This is the Christmas tree cataract, and where do we get to see Christmas tree cataract? Christmas tree cataract is seen in myotonic dystrophy. Myotonic. Chalo. Now, just a couple of instruments that I just wanted to discuss. Quickly देखो ये दो तीन बहुत important instrument है. What is this instrument? This is the Goldman applanation tonometer. This is the Goldman applanation tonometer, and this is the gold standard for IOP evaluation. This is the gold standard tonometer, or this is the gold standard for IOP evaluation. Goldman applanation. Look at this instrument. ये तो सबको पता ही होगा. This is the DO, that is the direct ophthalmoscope. Direct ophthalmoscope के बारे में 3-4 important points to be remembered. What are the important points that you need to remember about the DO or the direct ophthalmoscope? Direct ophthalmoscope में what is the magnification? The magnification is 15 times. But because the magnification is high, that's why जो field of view है, it is limited. It is limited to the central retina. It's limited to the central retina. Ab central retina can, what does central retina mean? If you remember, central retina essentially means your optic disc and your macula. Okay, so magnification is 15 times, field of view is limited to the central retina, and what kind of image is this? It is a virtual and erect image. It is a virtual and an erect image. Now, look at this one. ये क्या है? This is an indirect ophthalmoscope. Indirect ophthalmoscope, you have to wear it on the head. And in order to focus the retina, we have to use an additional lens. What is the power of the lens? The power of the lens is 20 diopters. So indirect ophthalmoscope में what is the mag? The mag is 2 to 5 times or 3 to 5 times. But because the zoom or the mag is less, that is why the field of view is much more. The field of view is up to the retinal periphery. The field of view is up to the retinal periphery. And what is the image? The image is a real and inverted image. तो देखो direct में याद रखना, it is a virtual and erect image. This is a real and an inverted image. And another very important thing to be remembered about the indirect ophthalmoscope is it's a binocular instrument. Binocular instrument matlab it helps, you have to use both eyes. The examiner gets the opportunity to use both eyes. That is why it gives what is called as stereoscopic view. Stereoscopic view का क्या मतलब होता है? It means better perception of depth. Stereoscopic view means better perception. Okay, so these are like direct, indirect ophthalmoscope be something you have to know like the back of your hand. The possibility of getting asked is very, very high. Chalo. With that, like we come to the end of this session. I tried to discuss as many important topics as possible. Now see, I would want that ये जो last 10 days है ऑफ्थैल के लिए, एक तो जो those of you who have listened to this session, हमने previously in YouTube there is a Sankalp TND session where I have discussed like about 100 important PYQs and important MCQs. तो वो जो संकल्प TND session है, please do have a look at that. And last, before the last exam, that is ये तो जैन वाला एग्जाम है, तो जून वाले एग्जाम के पहले ना मैंने एक सेशन लिया था ऑन 50 वन लाइनर्स इन ऑफ्थल्मोलॉजी. सो ये 3 चीज़ें अगर देख लोगे तो इट विल टेक यू मे बी अनदर 3 hours to do it. So वो अगर कर लोगे तो that like completes almost everything that needs to be revised in ophthalmology. हमने important theory तो revise कर ही लिया है. So those of you who have not watched that Sankalp TND, it is there in the same channel. यही इसी चैनल पे है, तो उसको सर्च करके उसमें 100 MCQs, important PYQs which have from NEET PG, INI as well as FMG I have discussed over there. So please go through that. And as I said, last June वाले एग्जाम के पहले मैंने एक सेशन लिया था 150 वन लाइनर्स इन ऑफ्थल्मोलॉजी, तो वो भी देख लेना. So thank you very much, everyone. We have just about overshot our time, and very soon you will have to rejoin for microbiology. So quickly take a break. All the very, very best for the exam. Exam में panic नहीं करना है. Before I just log off, I will just tell you 2 to 3 things which are very important in the exam. Exam में please keep your eyes open for 2 words, that is not and except. ये दोनों वर्ड्स के लिए अपनी आंखों को बड़ा बड़ा खोल के रखना. डू नॉट मिस दीज 2 वर्ड्स. सेकेंड, डू नॉट मार्क एन आंसर विदाउट रीडिंग द 4 ऑप्शंस. चारों ऑप्शन को पढ़ने के बाद ही डिसाइड करना कि कौन सा आंसर है. जो फर्स्ट टाइम में लगे, मतलब फर्स्ट ऑप्शन को देखा उसी को मार्क मत कर दो. रीड ऑल द 4 ऑप्शन. नंबर 3, एक बार किसी क्वेश्चन को अच्छे से पढ़ के सोच के जो मार्क कर लिया है, बाद में आके उसको प्लीज चेंज मत करना. डू नॉट ओवर थिंक एंड चेंज योर आंसर्स. ओवर थिंकिंग में आंसर्स यूजुअली गलत ही होते हैं. तो एक बार जो सोच समझ के मार्क किया है उसको जैसा है वैसे ही छोड़ दो, उसको वापस आके चेंज मत करो. एंड वेरी वेरी इंपॉर्टेंट, सी देखो, देर इज़ नो गारंटी दैट फर्स्ट पेपर सेकेंड पेपर में कौन सा ईजी होगा. एक थोड़ा सा हमेशा ही डिफिकल्ट होता है. तो अगर बाई चांस योर फर्स्ट पेपर इज मोर डिफिकल्ट, डू नॉट पैनिक. इट इज़ लाइकली दैट द सेकेंड पेपर विल बी ईजी, क्योंकि इस दोनों पेपर इक्वली डिफिकल्ट कभी भी नहीं आते हैं. तो अगर यू सी अ सेट ऑफ क्वेश्चंस विच आर डिफिकल्ट, अपने आप को समझाओ कि अगर एक सेट ऑफ क्वेश्चंस डिफिकल्ट है तो दूसरा सेट ऑफ क्वेश्चंस ईजी होगा, क्योंकि ये रैंडमाइजेशन है. सो डू नॉट पैनिक इफ योर फर्स्ट पेपर इज मोर डिफिकल्ट. डू नॉट पैनिक अगर एक सेट ऑफ खराब आया है, दूसरा सेट ऑफ क्वेश्चंस आएगा ही. ओके, सो बी कॉन्फिडेंट. इंपॉर्टेंट चीज़ों को रिवाइज करो, इंपॉर्टेंट चीज़ों को रिवाइज करो, PYQs को रिवाइज करो. बी कॉन्फिडेंट. आई एम श्योर यू विल ऑल डू. Chalo, all the very, very best and bye-bye, and see you on the other side of the exam once you have passed it. I'm logging off now. Very soon, Dr. will join with microbiology. So तुम्हारे पास ज़्यादा time नहीं है. So take a short break and come back. Or wait for Anusha ma'am. She'll be joining soon.
Hi everyone, how are you doing? I hope you're doing very fine, and I know that ophthalmology just got over, but I think this is the time to speed up your preparation. And of course, we could not have delayed microbiology. Hi guys, hi, how are you? So nice to see that you've joined immediately, and I know you deserved some break, but then what we can do is we can take a sprint and we can quickly finish it, and then we can have a nice good night's sleep, right? So that is one way to look at it. So have some water. I also have a glass of water. Then we shall all start. All right, shall we? Are you guys ready to begin microbiology marathon? Yes, I know, full day class, but then that is what you have to do in the very last moments. You have to really give it your all. You have to give your 100% and 1000%. And actually, this will really help because we are going to do the hard work for you, and just simply you have to follow it. Okay, chalo, let's start with it. So, of course, the very basic and the common one, the differential stains, we are going to start. This is no news. Everybody must be identifying that what are we looking at here? We are looking at a Zn stain. This is, sorry. This is a Zn stain picture, right? This is Zn stain, and what are you seeing? You're seeing the acid fast, red colored acid fast beaded appearing bacilli, and so you know that these are the bacilli that we see for Mycobacterium tuberculosis. So that will obviously, they will not ask you this. What will they ask you? They will ask you the modifications of Zn stain. So what are the modifications? Basically, if you modify the amount of H2SO4 which is used, then that is called as modifications. So if you're using 20 to 25% H2SO4, of course, you know you're staining for Mycobacterium tuberculosis, no problem at all. If you're using 5% H2SO4, then you're staining for Mycobacterium leprae. Mycobacterium leprae is also one of the mycobacteria. If you're using 1% H2SO4, then no cardia. No cardia is a long filamentous branching bacteria, which can lead to lots of respiratory infections also. So you will see the acid fast structures, but it is only acid fast to 1% sulfuric acid. Okay, then spores, you have bacterial spores which also take up the Zn stain. So around 0.5% to 0.25% H2SO4, the bacterial spores are able to resist. That is why they are stained with the 0.5% sulfuric acid. Then you have the coccidian parasites. Coccidian parasite, Cyclospora, Cryptosporidium, Isospora. What is the modification that you do? You do the co for cold staining, cold stain, or the Quinones method. Quinones method. Why the cold stain? Because what are we doing in Zn staining? We are using heat as a mordant. What are we doing? We are using heat as a mordant. And what is a mordant? A mordant is anything which helps the primary stain penetrate and stain the cells better. That is what is a mordant. So what is the heat doing over here? The heat is simply dissolving the mycolic acid covering of TB. So it is allowing for better penetration of the primary stain to go in. So what are we using in cold or Quinones method? We are simply increasing the concentration of phenol, concentration of phenol in carbolic acid. In carbolic acid, in carbol fusion. Carbol fusion. What is carbol fusion? It is the primary stain. Okay, let's not waste any more time on this. What is this? This is gram stain. Gram stain is also another type of differential stain only. This is also differential stain, because just like Zn was helping me differentiate between acid fast and non-acid fast. What is gram stain helping me differentiate between gram positive and gram negative? What will they ask you? Nobody is going to ask you the steps of gram staining. We will not waste time on that. What will they ask you? They will ask you the modifications again, modifications. So of course you know that there's crystal violet, iodine, then acetone, and then safranin, which is the staining procedure of gram staining. Everybody in the world knows about it, right? Then what is the modifications? You have the, I will write it in red, because you have the Jensen's modification. In this you use the neutral red. Neutral red is the dye which is used in Jensen's modification, and this we use for Neisseria. So if you remember, Neisseria are the gram negative cocci. So gram negative is red, so you can remember the neutral red, and you can easily remember the Jensen's, N sounds, Jensen's modification. Then you have the Brown and Bren modification. Brown and Bren modification. What is Brown and Bren? Very, very old. So one disease which takes many years to form, most commonly misdiagnosed as cancers, lumpy jaw syndrome. The disease which causes the lumpy jaw. What is that? Actinomyces. Actinomyces. So what do we use it for? Actinomyces. In fact, actino word stands for rays of the sun. So when we do the Brown and Bren modification in the histopathology of these patients, we see the sun ray appearance of the filamentous bacteria. That is why we call them actinomyces, right? Then we have the next question they can ask you is which are not gram stained. Okay, which bacteria do not take up the gram stain. So not gram stained. Not gram stain. So you have the very famous mnemonic MRCS. Yes, those who want to be surgeons, they will know that what is MRCS. You have your, of course, mycoplasma, which is such a small bacteria. It does not have a cell wall only. No cell wall, no gram stain. All right. Then you have the rickettsial group, rickettsia species. They are so small and they're obligate intracellular. They are not able to take the stain. Then you have chlamydia, same, very, very small. Earlier we thought it was a virus, but now we know it's a bacteria. And your spirochetes. Who are the spirochetes? Come on, tell me the spiral bacteria. So we always learned the mnemonic for the spiral bacteria, that they are the boring triplets. Boring. Oh God. Triplets. Boring triplets. So how will we remember? Boring means Borrelia. So Borrelia is one of the examples of spirochetes. Treponema, which causes syphilis. And then you have Let's means leptospira. So you have the boring triplets, which actually which belong to the spirochetes or the spiral bacteria. Great, awesome. Next, let's go ahead. Antimicrobial susceptibility testing, disc diffusion testing. Amongst the disc diffusion, you have the very famous Kirby-Bors. What happens in Kirby-Bors? You have this cation adjusted Muller-Hinton agar, or MHA. Then you put these discs which are coated with antibiotic, filter paper strips which are soaked in antibiotic, and you take a lawn culture or carpet culture. What is this? The lawn culture or carpet culture of bacteria. Then you put the disc on top, and then you measure this diameter. So this diameter measuring or zone diameter measuring will tell you whether the bacteria is susceptible or resistant to the said antibiotic. Compared to this, we also have the Stokes method. What are we doing in Stokes method? Instead of measuring the zones diameters, we are comparing it with a control. So I have this cation adjusted Muller-Hinton agar. I will put one control in between. Control meaning the nature of this bacteria I know already. Then in between, here I will put my patient test organism. Here I will put my patient test organism. So this is from patient 1. This is from patient 2. I will put one antibiotic disc here, one antibiotic disc here, one antibiotic disc here. Then I will look at the comparison. I know for a fact that my control is sensitive to this one, so it will give this bigger zone. My control is resistant to this one, so it will give a very, very small zone. My control is resistant to this one, very small zone. My control is sensitive, very big zone. So this is my control's nature. Then how is my test behaving as compared to the control? I see that this guy is giving such a big zone, so I know that this is susceptible. This guy is also giving a big zone, so that is also susceptible. So in my patient, I can use this antibiotic as well as this antibiotic. Similarly, in the next test, I see that there is no zone here, no zone here. So neither of the two antibiotics can be used in this patient. So basically, Herbivore, I am doing what? Measuring the diameter and talking about each one bug, because this is one bacterial culture and one particular drug. So on a single plate, I can put one patient sample, one bacteria, and I can test 1, 2, 3, 4, 5 and different antibiotics. But in the Stokes method, I can test 2 patient samples, but I can only test them against 2 antibiotics or at a time. Okay, awesome. So what then? What is it? These antibiotic discs, they have a fixed concentration of antibiotic. Okay, fixed concentration of antibiotic I'm using, whether it is I've quoted it with 300 micrograms of antibiotic or something like that. But what if I want to know the MIC? What is the MIC? MIC is the minimum inhibitory concentration. That is the minimum concentration of antibiotic which is required to inhibit the growth of my bacteria. Simply, so if I take test tubes and I put bacteria inside it and I start pouring antibiotics in different concentrations, the minimum concentration which is required so that I stop seeing the turbidity in my test tube, that is minimum inhibitory concentration. But that is a more difficult and cumbersome method to do, because you have to take many test tubes, you have to pour the broth, you have to mix the organism and everything. So what do? We make the best of both worlds. We take the best of both worlds. And now I have again taken a cation adjusted MHA, and what did I do? I did a lawn or a carpet culture of my bacteria, but instead of taking a single antibiotic disc, here what I have taken a strip, and on this strip I have put grading manner of antibiotics. So I took this strip and what did I do? I coated about 2 micrograms of antibiotic over here. Then 32 micrograms of antibiotic. Then on the next, for the next part, there is 16 micrograms of antibiotic. Then in the next part, there is 8 micrograms of antibiotic. Then as I go lower, there is now 4. As I go lower, there is 2 over here. As I go lower, there is 1. As I go lower, there is 0.5. So as I am moving up to down, the concentration of antibiotic loaded or coated in my strip is decreasing. So when I will put it on top of my bacterial culture, here at this point, the antibiotic concentration is very high. So of course, the bacteria is scared of it. So bacteria is staying away. So I see that such a broad zone of clearing is happening here. But as I'm moving down the strip, the concentration of antibiotic is reducing. So the bacteria is not scared of it. So over here, the concentration of antibiotic will be less as compared to over here, obviously. And over here it will be even more less. Yahan se yahan tak, in this point, the bacteria is absolutely not scared of the antibiotic. So it is easily growing. Okay, English, all right. तो easily grow कर रहा है, बहुत आराम से, बिल्कुल मेरी strip तक it has reached. बिल्कुल it has come right up to the filter paper strip, जहाँ तक वो पूरा अच्छे से grow कर रहा है. ये वो पॉइंट है जहां से उसको डर लगना स्टार्ट हो गया. दिस इज द पॉइंट फ्रॉम वेयर द बैक्टीरिया हैज स्टार्टेड गेटिंग स्केयर्ड ऑफ द एंटीबायोटिक, एंड एज वी आर मूविंग अप, concentration is increasing, so of course it is going to stay more and more and more far from the antibiotic. So we get this elliptical kind of a zone, and the point at which the fear starts to come in the bacteria, that becomes my minimum concentration, which is inhibiting the growth of my bacteria. So what have I done? I have taken the best of the both worlds, because the disc diffusion based methods are easier to perform. So I want to do a diffusion based method, but they are not very accurate. What is accurate is MIC based methods, for which I had to take many test tubes and do it on the do it the cumbersome way. So अब मैंने क्या किया? I took the best of both worlds. What is this E test called as? Epsilon test. Epsilon test. ठीक है? डन. एंटीमाइक्रोबियल ससेप्टिबिलिटी. अब ये जो मैंने MIC बोला था, मिनिमम इनहिबिटरी कॉन्सेंट्रेशन, वी डू इट विद द माइक्रो ब्रॉथ डाइल्यूशन मेथड्स, द MIC ट्यूब मेथड और द माइक्रो ब्रॉथ डाइल्यूशन मेथड्स. लाइक आई सेड, इन द डिफरेंट टेस्ट ट्यूब्स आई हैव टेकन डिफरेंट कॉन्सेंट्रेशन ऑफ माई एंटीबायोटिक्स. यहाँ पे कोई एंटीबायोटिक नहीं है एंड वेरी नाइसली माई बैक्टीरिया इज ग्रोइंग. यू सी द वेरी नाइस टर्बिडिटी ओवर हियर. यहाँ पे 1 micrograms per liter, 2, 4, 8, 16. As I am moving in this direction, I am increasing the concentration of antibiotic in my test tube. So I see that up till 4 micrograms per deciliter, bacteria is absolutely not scared of the antibiotic. But the moment the concentration becomes 8 micrograms per liter, the bacteria stops growing. So what is the minimum concentration of antibiotic needed to inhibit the growth of bacteria? क्या हो गया? 8 micrograms per liter. इस केस में MIC वैल्यू क्या है मेरी? 8 इज माई MIC वैल्यू. अब मैंने क्या किया? आई वॉन्ट टू टेक थिंग्स फर्दर. ठीक है, टर्बिडिटी नहीं दिख रही है मुझे, सो आई नो दैट ग्रोथ इज नॉट हैपनिंग, सो आई एम कॉलिंग दैट MIC. फाइन. बट वट डिड आई डू? आई टुक द ब्रॉथ फ्रॉम दिस एंड आई सब कल्चर्ड ऑन टू एन अगार प्लेट. When I subcultured onto an agar plate, to my surprise, इस पे तो ग्रोथ आ गई. फिर मैंने देखा नेक्स्ट ट्यूब, इससे अगली ट्यूब जिसकी कॉन्सेंट्रेशन ऑफ एंटीबायोटिक और ज़्यादा थी और इसमें भी कोई टर्बिडिटी नहीं थी, उसको सबकल्चर किया, फिर बैक्टीरिया ग्रो कर गया. तो मैं 32 वाली ट्यूब पे गई. फाइनली 32 माइक्रोग्राम्स पर लीटर वाली कॉन्सेंट्रेशन वाली एंटीबायोटिक वाली टेस्ट ट्यूब में मुझे कोई ग्रोथ नहीं मिली जब मैंने सबकल्चर भी किया. सो दैट मीन्स इट इज द 32 माइक्रोग्राम्स जब हम बैक्टीरिया को देते हैं तो वो एब्सोल्युटली किल हो जाते हैं. 8 माइक्रोग्राम्स जब हम देते हैं तो उनकी ग्रोथ इनहिबिट होती है. तो MIC हो गया 8. इस सेम ड्रग एंड बग कॉम्बिनेशन के लिए MBC बिकम्स 32 माइक्रोग्राम्स पर लीटर. अब ये MBC क्या है? मिनिमम बैक्टीरिसाइडल कॉन्सेंट्रेशन. अब मिनिमम इनहिबिटरी से बात नहीं चलेगी, मिनिमम बैक्टीरिसाइडल चाहिए. अभी बैक्टीरिसाइडल कॉन्सेंट्रेशन क्यों चाहिए होती है? व्हाई इज इट नीडेड? बिकॉज देयर आर सम बैक्टीरियोस्टैटिक एंड देयर आर सम बैक्टीरिसाइडल ड्रग्स. सो फॉर द बैक्टीरिसाइडल ड्रग्स एक्शन आई वांट टू नो दैट वेयर डज द एब्सोल्यूट किलिंग हैपन. तो बैक्टीरिसाइडल ड्रग्स के लिए मुझे MBC मेजर करना पड़ता है. राइट? Done. Let's quickly talk about the microscopes. What is this microscope? Can you identify? Of course, there is a light source. बीच में क्या लगा? Obstruction. Condenser lens पे ही एक obstruction लगा दिया जिसको हम बोलते हैं opaque patch और dark patch. It can also be written as patch stop. So आपको अगर कोई भी word मिले, patch stop word मिले या फिर opaque disc word मिले, so of course what are we talking about right here? We're talking about the dark ground microscopy. Dark ground microscopy. What do we use the dark ground microscopy for? The boring triplets, spirochetes. Boring triplets. ठीक है, नेक्स्ट पे चलते हैं, दूसरा वाला देख लेते हैं. What is this here? Very simple. The moment you see the excitation filter with the Vibgyor coming out, the many colors of white light coming out, and you see the dichroic mirror. Dichroic means two colors. What is dichroic mirror doing? It is allowing the longer wavelength to get reflected. So the blue light will reflect through it. Okay, the shorter wavelength to reflect through it. So the UV light. What is excitation filter doing? Excitation filter is taking out the UV light. So the UV light will be reflected from this mirror. इससे टकराएगी, नीचे रिफ्लेक्ट हो जाएगी. किसको हिट करेगी? स्पेसिमेन को. सो स्पेसिमेन को हिट क्या कर रही है? UV लाइट. स्पेसिमेन से एमिट क्या हो रही है? लॉन्गर वेवलेंथ ऑफ लाइट, विजिबल स्पेक्ट्रम. द लॉन्गर वेवलेंथ ऑफ लाइट, विजिबल स्पेक्ट्रम एमिट हो रही है, ग्रीन, रेड, डिपेंडिंग अपॉन विच डाई आई हैव टैग्ड इन द स्पेसिमेन. स्पेसिमेन रखा है, उसके साथ मैंने एक फ्लोरेसेंट डाई लगाई है. यूवी लाइट इसको हिट करती है, विजिबल लाइट इमिट होती है. ये जो लॉन्गर वेवलेंथ विजिबल लाइट है, दैट पासेस राइट थ्रू द डाइक्रोइक मिरर. पासिंग राइट थ्रू, तभी ये डाइक्रोइक है। दो तरह की वेवलेंथ के साथ अलग अलग बिहेवियर कर रही है, फिर यहाँ से निकल के आएगी और डिटेक्टर या आपकी आइज पे आ जाएगी। दिस इज एक्साइटेशन फिल्टर। वाई? बिकॉज इट इज एक्साइटिंग द वाइट लाइट। सो चाहे लाइट माइक्रोस्कोप हो, डार्क ग्राउंड माइक्रोस्कोप हो, चाहे फ्लोरेसेंट माइक्रोस्कोप हो, सोर्स ऑफ लाइट और सोर्स ऑफ इल्यूमिनेशन रिमेन्स वाइट लाइट, रिमेन्स वाइट लाइट। whatever changes after the source of light। कहीं पे पैच स्टॉप लगा दिया, कहीं पे हमने एक्साइटेशन फिल्टर लगा दिया और एक डाइक्रोइक मिरर लगा दिया। उसके बाद एमिशन फिल्टर सिर्फ सिलेक्ट आउट करेगा एक पर्टिकुलर विजिबल स्पेक्ट्रम को डिपेंडिंग अपॉन द डाई, और आपको ग्रीन, रेड या किसी भी तरह के फ्लोरिसिंग इमेज वहां पे दिख जाएगी। ऑफ कोर्स द मोमेंट यू लुक एट अ डाइक्रोइक मिरर और अ फिल्टर, एक्साइटेशन फिल्टर, यू नो यू आर टॉकिंग अबाउट द फ्लोरेसेंट माइक्रोस्कोप। फ्लोरेसेंट माइक्रोस्कोप, ठीक है। सो फ्लोरेसेंट माइक्रोस्कोप में डायरेक्ट फ्लोरेसेंट, इनडायरेक्ट फ्लोरेसेंट, ये हो सकता है डिपेंडिंग अपॉन अगर आप एंटीजन एंटीबॉडी रिएक्शंस यूज कर लो। आपका हेलो, आई थिंक वो स्टक हो गया है यूट्यूब। अच्छा अच्छा अच्छा। ओके, वी आर बैक, ग्रेट, ऑसम, वी आर बैक। चलो ठीक है। सो टेक्निकल फॉल्ट्स, पार्ट ऑफ लाइफ, no problem. Auramine, rhodamine. Then we also have the acridine orange dye. Acridine orange dye. These are some important dyes which are used for microbiology in the fluorescent microscope. Then what is this spaceship looking? Electron microscope. The moment you look at this picture, you know you're talking about electron microscope. What are you using instead of light? You're using a beam of electrons. यहाँ पे हमने source of light we have changed. That's the important point. Instead of using light or white light, we are now using a beam of electrons. That is what we are changing. In the all the other, the source of light remained the same. It was white light only. Then what? The glass lenses won't work here. So what are we using? We are using the electromagnetic lenses. Electromagnetic lenses is what we are using here. क्या करेंगे? Transmission electron microscope, scanning electron microscope. Two types of microscopes are there, meaning the one which goes through and through into your specimen. You have really placed very thin slices of the specimen. The beams of electron are coming and they're passing through and through this. That is transmission electron microscope, showing you the internal structures. Scanning is doing what? Suppose imagine you are on a stage, and on the stage there is a spotlight which is just falling on top of everything and lighting it up. Similarly, the scanning electron microscope, the electron beams, they come and bombard only on the top surface of the specimen that you have kept. They bombard the top specimen, tuck 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 tuck, you get an image. So सिर्फ उसका surface, the outward surface topography ही बताता है स्कैनिंग इलेक्ट्रॉन माइक्रोस्कोप। यहाँ पे बीच में हम क्या क्रिएट करके रखते हैं? वैक्यूम। ये क्या है? यहाँ पे सैंपल रखते हैं। दिस इज द सैंपल पोर्ट। ये है आपके आई पीसेस। एक्चुअली वी लुक इट ऑन टू द कंप्यूटर, राइट? ओके, अब आ जाते हैं सेल के ऊपर। सेल वॉल, वेरी वेरी इंपॉर्टेंट। लेट्स क्विकली रिवाइज इट। बार बार भूल जाते हैं, अब नहीं भूलेंगे। व्हाट इज दिस? द वेरी वेरी थिन पेप्टिडोग्लाइकन। आई हैव ऑलवेज टोल्ड यू कैसे याद करेंगे थिन एंड थिक। हम ऐसे लेते हैं, एक ऐसे बॉक्स बनाते हैं रेड कलर का पतला सा, फिर एक मोटा सा ब्लू कलर का, एंड अब हम क्या करेंगे? इनके बीच में यहाँ पे लिखेंगे माइनस और यहाँ पे लिखेंगे प्लस। याद हो गया? माइनस है पतला सा, माइनस इज वेरी वेरी थिन, सो इट हैज द थिन पेप्टिडोग्लाइकन. प्लस इज क्वाइट थिक एंड मोटू outside, so you know that the thick peptidoglycan is always your gram positive. तो ये वाला ग्राम पॉजिटिव, इतना मोटा पेप्टिडोग्लाइकन, अगर ये 100 नैनोमीटर्स है तो माइक्रोमीटर्स है, तो ये वाला 2 नैनोमीटर्स होगा, ठीक है। तो 100 टाइम्स बिगर होता है देन ग्राम नेगेटिव। सो दिस वन इज योर ग्राम नेगेटिव सेल वॉल। लेकिन ग्राम नेगेटिव की में पेप्टिडोग्लाइकन थिन है, लेकिन कॉम्प्लेक्स है, इट इज वेरी वेरी कॉम्प्लेक्स। क्या क्या है इसमें कॉम्प्लेक्स? दोनों के पास है सेल मेम्ब्रेन। सेल मेम्ब्रेन क्या है? फॉस्फोलिपिड बाई लेयर फॉस्फोलिपिड, एक फॉस्फेट मोइटी एक लिपिड मोइटी, दोनों की 2 लेयर फॉस्फोलिपिड बाई लेयर, उसके ऊपर पेप्टिडोग्लाइकन। फिर एक और आउटर मेम्ब्रेन। कैसे याद करें? सेल मेम्ब्रेन को अगर हम इनर मेम्ब्रेन बोले तो चलेगा, बिकॉज सेल मेम्ब्रेन इज इनर मोस्ट, इट इज देयर राइट आउटसाइड द न्यूक्लियस एंड एवरीथिंग। उसके ऊपर पेप्टिडोग्लाइकन। फिर सेम डिट्टो, देखो जैसी ये लेयर है बिल्कुल सेम डिट्टो ये वाली ऊपर वाली भी लेयर है। सो बिल्कुल जैसे नीचे वाली लेयर बिल्कुल वैसी बाहर वाली लेयर। तो अगर ये इनर मेम्ब्रेन है तो इसको आउटर मेम्ब्रेन बोल सकते हैं। तो आपकी ग्राम नेगेटिव सेल वॉल में क्या क्या आ जाएगा? पेप्टिडोग्लाइकन आएगा, साथ में आउटर मेम्ब्रेन आएगा। आउटर मेम्ब्रेन की कुछ बहुत इंपॉर्टेंट प्रोटीन्स होते हैं जिनको हमने बोला आउटर मेम्ब्रेन प्रोटीन्स। कौन है ये? पोरिन्स, द पोरिन चैनल्स, क्योंकि कुछ चैनल्स ऐसे बनाए हमने विच क्रिएट द पोर्स इन द सेल वॉल। अब वो क्या करेंगे? कुछ सिलेक्टेड चीज़ों को बाहर फेंकेंगे, कुछ सिलेक्टेड चीज़ों को अंदर आने देंगे। इन्हीं पोरिन्स को अगर मॉडिफाई कर लेगा मेरा बैक्टीरिया तो वो एंटीबायोटिक्स को अंदर नहीं आने देगा और रेजिस्टेंस मैकेनिज्म बन जाएगा आपका एक बहुत ज़्यादा इंपॉर्टेंट। फिर इस आउटर मेम्ब्रेन के ऊपर उसने कुछ ताज पहना हुआ है। क्या ताज है? लाइपोपॉलीसैकेराइड। क्या बोल देते हैं लाइपोपॉलीसैकेराइड को? LPS। LPS 3 लेटर है, 3 ही लेयर होगी। सबसे बाहर वाली लेयर, उसके अंदर वाली लेयर और सबसे अंदर वाली लेयर, ठीक है। सबसे अंदर वाली लेयर है लिपिड ए। लिपिड ए क्या बनाती है? आपका एंडोटॉक्सिन। हमने कितनी बार बोला है? एंडोटॉक्सिन इज अ पार्ट ऑफ द लाइपोपॉलीसैकेराइड लेयर ऑफ द ग्राम नेगेटिव बैक्टीरिया। यहां से बनता है एंडोटॉक्सिन। फिर आपका कोर पॉलीसैकेराइड कुछ नहीं है, स्ट्रक्चर प्रोवाइड कर रहा है। सबसे बाहर वाली हो गई ओ साइड चेन। ओ साइड चेन क्या होती है? स्पेसिफिक फॉर अ जीनस। तो क्या कर लेंगे इसको लेके? हम इसको लेके कर लेंगे सीरोटाइपिंग कर लेंगे इसको लेकर के, ठीक है। सो LPS 3 लेटर्स 3 लेयर्स हो गया। तो ग्राम नेगेटिव की सेल वॉल थोड़ी कॉम्प्लेक्स हो गई, एक इनर मेम्ब्रेन एक आउटर मेम्ब्रेन। इनर मेम्ब्रेन आउटर मेम्ब्रेन के बीच में बहुत पतली सी पेप्टिडोग्लाइकन लेयर। आउटर मेम्ब्रेन के ऊपर भी जूल्स लगे हुए हैं, द लाइपोपॉलीसैकेराइड लेयर। बहुत सारा पेरीप्लाज्मिक स्पेस है इसके पास, ग्राम नेगेटिव के पास, क्योंकि जो बीच की पेप्टिडोग्लाइकन थी वो तो पिचका दी हमने, वी मेड इट वेरी वेरी थिन। सो नाउ देयर इज अ लॉट्स ऑफ पेरीप्लाज्मिक स्पेस हियर। बट द ग्राम पॉजिटिव quite simple, simply a cell membrane, thick peptidoglycan, खत्म हो गई cell wall. That is all that is there in the cell wall. What is there? Almost no periplasmic space is there. Almost no periplasmic space. Attachment वाले प्रोटीन्स कौन से हैं? इसके पास भी थोड़ा सा तो ताज दे दो। ताज नहीं दे सकते हैं, we cannot give it a crown because it cannot have a lipopolysaccharide. What can we give it? We can give it a few spikes. What are that? The teichoic acids or the lipoteichoic acids. What will they do? They will help the gram positive bacteria in binding or attaching to the site for action. Okay, अगर आपके थ्रोट में बाइंड करना है, स्किन में बाइंड करना है, जिस भी टारगेट ऑर्गन में बाइंड करना है वहां पे हम बाइंड कर जाएंगे, अटैच कर जाएंगे विद द हेल्प ऑफ दीज प्रोटीन्स, ठीक है। ये सारी इंपॉर्टेंट बातें हो गई हमारी। अब अगर पेप्टिडोग्लाइकन लेयर की मैं बात करूं, इफ आई ओनली टॉक अबाउट the peptidoglycan layer, so you remember there is the repeating namnag N-acetyl glucosamine, N-acetyl muramic acid। नेम जो हमारा नाम होता है उसके आगे ही सरनेम होता है, नाम के आगे ही सरनेम होता है। तो नाम के आगे आपका क्या लगेगा? टेट्रापेप्टाइड क्या? LD कौन? पगला, P फॉर पॉजिटिव, पगला, P फॉर पॉजिटिव। सो ग्राम पॉजिटिव के पास क्या होगा? L एलानीन, D ग्लूटामीन, L लाइसीन एंड D एलानीन। पगला LD, पगला LD, ठीक है। यहीं पे कुछ चेंज कर देते हैं। ये जो पगला LD लटके हैं नेक्स्ट, इन सब के बीच में है 5 हार्ट्स, P फॉर पॉजिटिव, P फॉर 5 हार्ट। कौन? पेंटाग्लाइसिन ब्रिज। ये क्या करेगा? L लाइसिन की एक एल लाइसिन को दूसरे वाले के डी एलानिन से जोड़ेगा। आपके जो ग्राम नेगेटिव हैं, ग्राम नेगेटिव बैक्टीरिया बड़े नेगेटिव हैं, थर्ड अमीनो एसिड पे क्या लगा लिया, थर्ड अमीनो एसिड पे क्या लगा लिया इन्होंने, मीजो डायमीनो पिमेलिक एसिड। इनको नहीं चाहिए क्या, इनको नहीं चाहिए एल लाइसिन, एल लाइसिन इनको नहीं चाहिए, उसकी जगह लगा लिया इन्होंने मीजो डायमीनो पिमेलिक एसिड, पिमेलिक एसिड। और ये क्या है, नेगेटिव है, पॉजिटिव नहीं है ना, तो इनके पास पेंटाग्लाइसिन ब्रिज होंगे, नहीं होंगे, सो दे विल हैव नो पेंटाग्लाइसिन ब्रिजेस ऑल्सो, बड़े नेगेटिव है। सो क्या याद रख लेंगे, एक चीज याद रख लेंगे, पगला एलडी एलडी, पी से पॉजिटिव, पी से पेंटाग्लाइसिन, अगला से बन गया हमारा, तो ये तो पेप्टिडोग्लाइकन हो गई डिफरेंट सबकी। हमेशा याद रखेंगे नैग और नैम सीक्वेंसेस में से टेट्रापेप्टाइड किससे आ रहे होंगे, नाम के आगे ही तो सरनेम लगेगा, it is only the name which is followed by the surname, so the name will have the extensions, the amino acid sequences, all right, very very simple। motility, flagella होता है, flagellin protein से बना होता है, different तरह के flagella होते हैं बैक्टीरिया के ऊपर। आपकी motility की टाइप्स पे भी हम डिपेंड करते हैं। टम्बलिंग का क्या मतलब है, कार्ट व्हील्स, मतलब कि यू आर very very happy, when you are very very happy you do the cartwheel, and when you do the cartwheel you are hysterical। हिस्टीरिया से क्या राइम करता है, लिस्टीरिया, तो लिस्टीरिया मोनोसाइटोजिन्स क्या देगा आपको, लिस्टीरिया मोनोसाइटोजिन्स देगा आपको टम्बलिंग मोटिलिटी, ठीक है, टम्बलिंग मोटिलिटी। डार्टिंग और शूटिंग स्टार मोटिलिटी, इधर चमका इधर चमका, इधर चमका इधर चमका, देख ही नहीं पा रहे कैसे चल रहा है, कहाँ चल रहा है, इतना तेज जा रहा है, व्हाट इज इट, विब्रियो कॉलरा, विब्रियो कॉलरा। स्पाइरल, कॉर्कस्क्रू, लैशिंग, कौन है हमारे गोल गोल घूम रहे हैं, स्पाइरल, स्पाइरोकीट्स, कौन, बोरिंग ट्रिपलेट्स, बोरीलिया, ट्रिपोनीमा एंड लेप्टोस्पायरा। ग्लाइडिंग मोटिलिटी, जैसे ऐसे ग्लाइड करता है ना पैराग्लाइडर, कैसे ग्लाइड करता है पैराग्लाइडर, ऐसे ऐसे आता है, ऐसे चला जाता है, या फिर जैसे कोई जस्ट इमेजिन अ पेंगुइन जस्ट स्लाइडिंग ऑन टू द स्नो, क्या करेगा, ग्लाइडिंग, माइकोप्लाज्मा, माइकोप्लाज्मा विल डू द ग्लाइडिंग मोटिलिटी। फॉलिंग लीफ, कैसे गिरती है लीफ, ऐसे 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 ऐसे, कौन गिरता है ऐसे, ट्रोफोजोइड, ऐसे ऐसे गिरता है, किसका, जियार्डिया, जियार्डिया का ट्रोफोजोइड गिरता है, फॉलिंग लीफ मोटिलिटी। जियार्डिया कौन है, पैरासाइट है ना। वाइब्रेटिंग एंड ट्विचिंग, ऐसे ऐसे टक 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 वाइब्रेट कर रहा है, ट्विच कर रहा है, टी फॉर ट्विचिंग, टी फॉर ट्राइकोमोनास वैजिनैलिस। आगे पढ़ेंगे ट्राइकोमोनास वैजिनैलिस, हमें पता है ट्राइकोमोनास वैजिनैलिस इज ऑल अबाउट टी, हर चीज टी 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 टी, ठीक है। स्टेटली मोटिलिटी, स्लो, आलसी है, स्लगिश, स्लो स्लगिश मोटिलिटी, आलसी बहुत ज्यादा, कौन है ये, क्लॉस्ट्रीडियम, स्पेशली कौन सा क्लॉस्ट्रीडियम परफ्रिंजेंस, कौन सा नहीं, कौन सा नहीं, क्लॉस्ट्रीडियम टेटनी, टेटनी तुम्हारा टाइट है भाई, टेटनी करेगा स्वार्मिंग, ये नहीं है स्लो, ये नहीं है स्लगिश, दिस इज नॉट लेजी, स्वार्मिंग। अब स्वार्मिंग मोटिलिटी सिर्फ मोटिलिटी नहीं है, ये तो ग्रोथ का पैटर्न भी है, ये तो हमको हमारी अगार प्लेट के ऊपर ऐसे कंसेंट्रिक सर्कल्स भी दिखाता है। अब देखो मैंने क्या करा, ये कंसेंट्रिक सर्कल वाली अगार प्लेट के ऊपर एक बेचारा एस्ट्रोनॉट बैठ के पीपीटी बना रहा है अपनी, ठीक है, कितना सैड लाइफ है इसका, सो सैड। दिस इज रेड कलर का प्लैनेट कौन सा होता है, मार्स होता है ना रेड कलर का प्लैनेट। अब इस अजीब से भयानक से निमोनिक से बहुत इजीली याद कर लेंगे स्वार्मिंग मोटिलिटी के एग्जांपल्स। स्वार्मिंग मोटिलिटी कौन कौन दिखाएगा, द मोमेंट यू फाइंड दिस वर्ड, नो मैटर जो भी हिस्ट्री मिली हो आपको पता है, इनमें से ही कोई सा एक पॉइंट लिखना है। बेचारा है ना ये एस्ट्रोनॉट, बेचारा पीपीटी बना रहा है, क्या बना रहा है, पीपीटी, कहाँ बैठ के बना रहा है, मार्स के ऊपर, रेड कलर का प्लैनेट है ना मार्स, बताओ, कम ऑन, हो गया आसान। बेचारा बैसिलस सीरियस, बहुत सीरियस है ये बंदा। पी, पी फॉर प्रोटियस, प्रोटियस तो बचपन से पता है हमें, प्रोटियस इज द प्रोटोटाइप ऑर्गेनिज्म फॉर स्वार्मिंग। एक और पी ले लेते हैं, विब्रियो पैराहिमोलिटिकस ले लेते हैं, विब्रियो कॉलरी तो नहीं है ना, वो तो हमने देख लिया, शूटिंग स्टार डार्टिंग मोटिलिटी है। टी से क्या, कौन आलसी नहीं था हमारा, क्लॉस्ट्रीडियम टेटनी, तो यहाँ पे आ जाएगा क्लॉस्ट्रीडियम टेटनी। अब मार्स पे बैठा है ना, सिरेशिया मार्सेसेंस, मार्से सेल्स हो गई हमारी स्वार्मिंग मोटिलिटी, हो गई हमारी स्वार्मिंग। बैक्टीरियल ग्रोथ कर्व, अरे भाई ये जो मोटिलिटी है, ये जो ग्रोथ है, ये जो पैटर्न है, कहाँ पे दिखा रहा है? बैक्टीरियल ग्रोथ कर्व। हर समय ही क्या बैक्टीरियल ग्रोथ कर्व इस तरह से चलता है? नहीं, नेवर। सिर्फ ऑप्टिमल कंडीशंस पे चलेगा, वो भी अगर मैं इसको डाल दूंगी किसके अंदर? लिक्विड ब्रॉथ के अंदर, और एक टर्बिडोस्टैट या टर्बिडोमीटर से इसको देखूंगी। क्या करा मैंने? इधर मैंने प्लॉट करा टाइम, समय निकला जा रहा है, टाइम इज मूविंग फॉरवर्ड, आर यू मूविंग विद इट? सो टाइम इज मूविंग फॉरवर्ड। यहाँ पे क्या है? नंबर ऑफ बैक्टीरिया। सो एज माई टाइम इज मूविंग फॉरवर्ड, इफ माई नंबर ऑफ बैक्टीरिया इज इंक्रीजिंग, आई सी दिस इंक्रीजिंग कर्व। इफ माई नंबर ऑफ बैक्टीरिया इज डिक्रीजिंग, आई सी दिस डिक्रीजिंग कर्व। सबसे पहले आ जाते हैं लैग फेज। सबसे पहले तो हमको इंपॉर्टेंस रियलाइज नहीं होती कि टाइम निकला जा रहा है, हमको जल्दी से पढ़ लेना चाहिए, तो हम क्या करते हैं? खाते रहते हैं बैठ के। सिमिलरली मैंने बैक्टीरिया को डाला इस ब्रॉथ में, ब्रॉथ के अंदर सडनली उसको मिला बहुत सारा न्यूट्रिशन। इमेजिन आई हैड पुट 10 इंडिविजुअल बैक्टीरिया इनसाइड दिस ब्रॉथ। अब ये 10 बैक्टीरिया को बहुत सारा खाना मिल गया, बैठ के खा रहे हैं, रिप्रोडक्शन की नहीं पड़ी, डिवाइड करने की नहीं पड़ी, कोई एंटीबायोटिक बनाने की नहीं पड़ी, दे डोंट केयर, they're simply sitting and eating, so there is no division, no cell division happening here, only and only increase in size is what is happening। खा पी के मोटे हो रहे हैं। So if they ask you the question, in which phase of bacterial growth curve is maximum size achieved? Maximum size achieved, can you now easily say end of lag phase? जहां पे लैग फेज एंड हो रहा है, सबसे ज्यादा मोटे उसी पीरियड में होंगे वो। अब क्या शुरू हुआ? खा पी के बैठ गए, अब इनको चढ़ गई जवानी। नाउ कम्स द यूथ, यूथ ऑफ लाइफ। लॉग फेज है इनका, यूथ, यंग टाइम। जब आप यंग हैं, जब आपका यूथ चल रहा है, आप क्या करेंगे? लॉग इज इक्वल टू जॉग, log is equal to jog। आप बड़े एक्टिव हैं, you are very active, you will want to interact with everybody, so you are metabolically most active, metabolically you are most active in this phase। और क्या करेंगे आप? सारी दुनिया से बातचीत कर ली, सब कर लिया। बायोकेमिकली सबके साथ इंटरैक्ट करोगे, सबसे मिलोगे, सारी पार्टियों में जाओगे, सबके साथ बातचीत, घुलोगे मिलोगे। सो ये ओके, थैंक यू सगुफ्त खानम, I hope you enjoy the session too, right? Biochemically very very active, तो best time to do biochemical tests, यूथ, लॉग फेस। बेस्ट टाइम टू डू ग्राम स्टेनिंग, यूथ, जब हम यंग होते हैं, बड़े यंग होते हैं, हम क्या करते हैं? मेकअप लगाते हैं, वी केयर अबाउट अ ब्यूटी, रेड कलर की जैकेट पहन के घूमते हैं, ब्लू कलर की जीन्स, क्या है? रेड एंड ब्लू, ग्राम स्टेन। इस टाइम पे अगर मैं ग्राम स्टेन दे दूं इस बैक्टीरिया को, बहुत प्यारा सा कलर ले लेगा। क्या मतलब? यूनिफॉर्मली ग्राम स्टेन है मेरा बैक्टीरिया इस फेज में। अच्छा जी, और क्या करेगा? शाइनी सी कार खरीद के लाएगा, है ना? क्या लाएगा? एक शाइनी सी कार। क्या होती है ये शाइनी कार? कौन सी वो कार है जो शाइन करती है ब्लैक बैकग्राउंड पे? कैप्सूल। सो कैप्सूल की प्रोडक्शन कब होगी? लॉग फेज में। अब आपसे कुछ भी पूछ ले, मेटाबॉलिक एक्टिविटी लॉग फेज, मैक्सिमम एक्सपोनेंशियल डिवीजन, ये तो बताना ही नहीं पड़ना चाहिए। मैक्सिमम डिवीजन तो ऑब्वियसली हो रहा है, तभी एक्सपोनेंशियल शार्प राइज हो रहा है ग्राफ का, लॉग फेज। यूनिफॉर्म ग्राम स्टेन रिएक्शन, लॉग फेज। कैप्सूल प्रोडक्शन, लॉग फेज। तुम सब कंफ्यूज करते हो कैप्सूल प्रोडक्शन, कोई लिखता है लॉग फेज, कोई लिखता है स्टेशनरी फेज। अरे भैया, स्टेशनरी फेज क्या है? वॉर जोन। स्टेशनरी फेज क्या है? वॉर जोन। अब आ चुकी है लड़ाई, अब जिंदगी खत्म, अब जीने के 4 दिन फिनिश्ड, नाउ इट इज वॉर टाइम। वॉर में 2 तरह के लोग होते हैं। कुछ लोग होते हैं हाइडर्स, वो क्या करेंगे? छुप के बैठ जाएंगे, बंकर के अंदर छुपेंगे ना। तो क्या करेगा बैक्टीरिया? जब वो कंबल ओढ़ के छुप के बैठ जाएगा, स्पोर बनाएगा। So sporulation happens when? In the stationary phase. S for stationary, S for spore. Sporulation happens in the stationary phase. और बताओ और क्या करेगा? जब तुम बंकर में जाके छुप के बैठोगे, वॉर चल रही है बाहर, क्या करोगे? सारा खाना स्टोर करोगे ना, डब्बों में भर भर के यू विल स्टोर न्यूट्रिशन। क्या बनाएगा बैक्टीरिया? स्टोरेज ग्रैन्यूल्स, स्टोरेज ग्रैन्यूल्स। अगर मैं पूछूं कोराइनीबैक्टीरियम डिप्थेरी के मेटाक्रोमैटिक ग्रैन्यूल्स या वॉल्यूटिन ग्रैन्यूल्स कौन से फेज में बनेंगे? क्या है वो? स्टोरेज ग्रैन्यूल्स ही तो है। कोराइनीबैक्टीरियम डिप्थेरी अपना खाना भर के रखता है ना 2 डब्बों में 2 एंड्स पे, दैट इज स्टोरेज ग्रैन्यूल्स। कब बनेंगे? स्टेशनरी फेज में। फिर एक दूसरे तरह के टाइप के लोग होते हैं, Hanji, coming on to it, Dr. Yash, you are right. There are another type of people in the war who are fighters, who will go and put up a fight. अब जब बैक्टीरिया को फाइट करना है तो बैक्टीरिया क्या बनाएगा? एंटीबायोटिक बनाएगा, दूसरे को किल करने के लिए एंटीबायोटिक बनाएगा, और क्या बनाएगा? टॉक्सिन. अब तुम बोलते हो मैम एंडोटॉक्सिन बनाएगा या एक्सोटॉक्सिन बनाएगा? भैया बोथ, एक्सो एंड एंडो बोथ, किसी भी तरह का टॉक्सिन. अब तुम बोलोगे, आप बोलते हो एंडोटॉक्सिन इज अ पार्ट ऑफ द सेल वॉल, तो सेल वॉल का ही जब पार्ट है, लाइपोपॉलीसैकेराइड का ही पार्ट है, तो अब बना कैसे रहा है? बटन दबाने की बात है ना, इट हैज़ टू एक्टिवेट द टॉक्सिन. सो अगर टॉक्सिन उसका बना हुआ है, अगर एक्सोटॉक्सिन है तो प्रोड्यूस ही करेगा इस फेज में, अगर एंडोटॉक्सिन है तो एक्टिवेट करेगा उसको इस फेज में. दैट इज द डिफरेंस. और क्या बनाएगा? बैक्टीरियोसिन्स बनाएगा ना, बैक्टीरियोसिन्स बनाएगा. ये सब कोलिसिन्स बैक्टीरियोसिन्स क्या करेंगी? बाकी बैक्टीरिया को मारेगी. तो क्या बन गया? स्टेशनरी फेज, वॉर जोन बन गया. क्यों? अब न्यूट्रिशन कम होने लगा है ना. एक टेस्ट ट्यूब में कितना ही ब्रॉथ डाला था मैंने, कितना ही मिल गया था उसको खाने को, इसलिए अब उसका वॉर जोन स्टार्ट हो गया है. स्टेशनरी फेज में क्या हो रहा होता है? नंबर ऑफ डाइंग बैक्टीरिया इज इक्वल टू नंबर ऑफ डिविजन्स, सेल डिविजन्स. मतलब कि डेथ इज इक्वल टू बर्थ, इसलिए फ्लैट हो रहा है ग्राफ. ऐसा नहीं है कि न्यू बैक्टीरिया इज नॉट बीइंग फॉर्म्ड ओनली, बर्थ स्टिल इज हैपनिंग, लेकिन डेथ भी उतनी ही हो रही है. तो ओवरऑल ग्राफ डज नॉट मूव. अब वॉर के बाद क्या होती है? डेथ होती है, डेथ फेज या डिक्लाइन फेज. वॉर के बाद जो बॉडीज हैं कैसी हो जाती हैं? किसी का हाथ कट गया, किसी का कान कट गया, किसी का टांग टूट गया. सो दीज आर डिफॉर्म्ड, मिसफॉर्म्ड बॉडीज. ऐसी मिसशेपन बैक्टीरियल फॉर्म्स को हम क्या बोलते हैं? इनवॉल्यूशन फॉर्म्स, इनवॉल्यूशन फॉर्म्स. सो डिक्लाइन फेज में क्या देखने को मिलता है? इनवॉल्यूशन फॉर्म्स मीन्स टेढ़े मेढ़े एबरेंट शेप के बैक्टीरिया आपको देखने को मिलते हैं, इनवॉल्यूशन फॉर्म्स. ठीक है. नाउ यू वांट इंग्लिश. ओके, बिफोर दिस you wanted English, now you want, okay, fine. So let me repeat it. What did I say up till now? Lag phase means now the bacteria is just sitting and eating nicely. All it wants to do is eat. So lag phase taking up all the nutrition, only increasing in size. So there is no cell division happening in lag phase, only increase in size happening. So if they ask you a question, in which phase is the maximum size achieved? Obviously you can say end of lag phase is when the maximum size is getting achieved. Log phase, youth of life, log is equal to jog. Now the bacteria is young, they want to reproduce. So maximum division, crazy, they're dividing, multiplying like mad people. Also this is the phase you're most metabolically active, you want to run around, jump around, metabolically most active the bacteria. In this youth of life you want to interact, you want to socialize, you want to interact, you want to socialize, है ना. तो what will you do? Biochemical reactions, biochemically most active. In this phase, if I give you some makeup, you will do it very nicely, you will put on a red jacket. So if I give you a gram stain, very nicely you will take the gram stain. You want to come and impress your friends in a shiny car. The shiny car is a capsule, the shiny capsule which shines in behind a negative stain background. So capsule production, this is a very important confusing point. You guys think, when is capsule formed? In not in stationary phase, in the log phase. Why? Log is jog, it's the youth of life, that is when it is formed. Stationary phase kya hua? Now it is the war zone, now nutrition is depleting, so the number of cells which are dying becomes equal to the new number of cells which are dividing. So the overall graph becomes flat. But there are two types of people in war, hiders and fighters. Hiders will hide under a blanket, so spore formation. Fighters and hiders will also store all the food so that nobody else can eat it. So the storage granules, volutin granules, metachromatic granules, glycogen granules, any storage granule, stationary phase. Fighters will fight, antibiotic, toxins, bacteriocins, everything released to kill the other bacteria. In this war zone, if I give you a very expensive cosmetic makeup of Charlotte Tilbury, MAC Cosmetics, will you care? You will not care. So if I try to give the bacteria gram staining in the stationary phase war zone, will it take it? No. So it is non-uniformly gram stained in the stationary phase. Non-uniformly gram stained. in the stationary phase, right? And after war, after death or decline, what happens? Involution forms, the mutilated bodies. So the mutilated aberrant shaped bodies of bacteria are called as involution forms. What will you see in decline phase? Involution forms. Now come on, quickly answer. Tell me, in which phase is the maximum generation time achieved? What is generation time? Time taken by the bacteria to divide from 1 to 2. एक से दो होने में बैक्टीरिया को कितना टाइम लगता है? That is generation time. So E. coli's generation time is 20 minutes. One E. coli takes 20 minutes to become 2 E. coli. One Mycobacterium TB takes 20 hours to become 2 Mycobacterium TB. And one Mycobacterium leprae takes 20 days to become 2 Mycobacterium leprae. So in this bacterial growth curve, when do you think is the maximum generation time happening? Come on, quick. Log phase. Okay, I got one answer. I want one or two more answers. Come on, guys. Log phase, log phase, log phase. Okay, so all of you, congratulations. You are wrong. You are wrong. Generation time is constant throughout. Constant throughout. Why? What did I say? It is the time taken by bacteria to divide. One bacteria to divide into two bacteria. If one human baby is born in 9 months and the population of a country is expanding exponentially, does that mean more babies are being born, or does that mean one baby is born in 5 months? Now babies are getting born in 5 months. No, it still takes 9 months only, na. So even if more and more people are reproducing, more and more population size is increasing, does not mean one in each and every individual child has started birthing faster. No. So if E. coli takes 20 minutes to divide from 1 to 2, it will still take 20 minutes. What will happen in log phase is, I said I put 10 bacteria in that test tube. In the lag phase, 0 bacteria were dividing. In the log phase, all 10 divided. They became 20. The 20, all 20 divided, 40, 40, 80, 80, 160, 160, 320. Now it's exponentially rising, meaning each and every bacteria present inside is dividing, not that the generation time will change. So it remains constant throughout. Generation time is independent ऑफ द फेज ऑफ बैक्टीरियल ग्रोथ कर्व. ठीक है, इंडिपेंडेंट होता है, बैक्टीरियल ग्रोथ कर्व के फेज से फर्क नहीं पड़ता है. अब एक बहुत बहुत इंपॉर्टेंट बात यहाँ पे समझ लो. ये जो हम ग्राफ बनाते हैं ना बैक्टीरियल ग्रोथ कर्व का, क्या बोलते हैं? यहाँ पे टाइम है, यहाँ पे नंबर ऑफ सेल्स है, नंबर ऑफ सेल्स है. अगर मैं आपसे पूछूं इन विच फेज इज द मैक्सिमम नंबर ऑफ सेल्स अचीव्ड, आप बोलोगे एंड ऑफ लॉग फेज, है ना, या फिर बोलोगे स्टेशनरी फेज एंड लॉग फेज कांस्टेंट है, इट्स द सेम, इट्स फ्लैट. नो. इफ आई आस्क यू वायबल सेल्स, लाइव सेल्स, सो आई हैड पुट 10 live bacteria, so 10 live bacteria remained like this lag phase. All of them started dividing exponentially. क्या हुआ? log phase आया. फिर क्या हुआ? डेथ और बर्थ इक्वल हो गया तो स्टेशनरी हो गया. फिर क्या हुआ? डेथ ज्यादा होने लगी तो नीचे चला गया. ये कौन बिहेव कर रहा है ऐसे? हु इज बिहेविंग लाइक दिस? वाइबल सेल्स, लाइव सेल्स आर बिहेविंग लाइक दिस. व्हाट अबाउट टोटल नंबर ऑफ सेल्स? व्हाट इफ आई नाउ वांट टू डू बॉडी काउंट? I now want to know the body count of my bacteria, meaning total count, यानी कि live plus dead. Then how will they behave? Lag phase, everyone will remain alive. Log phase, everyone will remain alive. No death happening. Stationary phase, death starts happening. Still, body count is increasing, na? Why? Because I said death is equal to number of births. So birth is also happening, death is also happening. Both the things are happening. Total body count still increasing. It will keep increasing. End of stationary phase. Now, no new births, only deaths. So deaths, so cell is not increasing, na? Right? Got it? So now it will become constant. What is this? This is total body count. So this is how the graph will work. मतलब यहाँ पे अगर 10 थे, 10 के यहाँ पे 20 हुए लाइव. अब जब ये 20 हुए तो 20 के 40 लाइव हो गए प्लस 10 तुम्हारे डेड हो गए. दीज आर लाइव, दीज आर डेड. तो टोटल तो 50 है ना. इट इज स्टिल राइजिंग. नाउ ओवर हियर 30 आर लाइव, 20 आर डेड. काउंट इज स्टिल 50. सो इट इज स्टिल कॉन्स्टेंट. ओके, आई होप यू हैव अंडरस्टूड. थोड़ा सा ज़्यादा हो गया, कोई बात नहीं, डिटेल में जाना था. नाउ बैक्टीरियल जेनेटिक्स. सो बेसिकली दीज बैक्टीरिया They are able to transfer the genetic material horizontally, meaning mother to child or parent to child transmission pe they are not dependent. They can transfer the genetic material very easily in unrelated people. How we are doing, we are talking, we are not related. I am not your mother, you are not my child. I am not your child, you are not my father. So how are we still interacting? We are talking. Horizontal exchange of information. Genetic material क्या होता है? It is codons, it is information. एक और बार क्या? टोटल काउंट. देखो भाई, ये है मेरा बैक्टीरिया का ग्रोथ कर्व, ठीक है. यहाँ पे टाइम, आई हैव प्लॉटेड टाइम. यहाँ पे क्या प्लॉट किया? नंबर ऑफ सेल्स, ठीक है, ओके. अब बात कर लेते हैं टोटल सेल्स, मतलब कि लाइव सेल्स, ठीक है. लाइव सेल को दिखाएंगे ग्रीन. ग्रीन क्या बता रहा है? लाइव, मतलब जिंदा सेल्स. ओके, ब्लैक क्या बता रहा है? डेड सेल्स. डेड सेल्स, नहीं नहीं, ब्लैक क्या बता रहा है? टोटल सेल्स. टोटल सेल्स, ब्लैक इज टेलिंग मी टोटल सेल्स. टोटल सेल्स मतलब लाइव प्लस डेड, ठीक है. हमने क्या किया? 10 बैक्टीरिया को डाला. 10 बैक्टीरिया हमने डाले. 10 बैक्टीरिया एज इट इज थे, खा पी रहे थे, बिल्कुल डिवाइड नहीं कर रहे थे. ऑल 10 आर अलाइव. यहाँ पे क्या है? 10 के 10 अलाइव है. 10 आर अलाइव. ओहो, 10 bacteria are alive. Now exponential division will happen. Exponential division is happening. So 10 became how many? 10 became 100. Now 100 bacteria are alive. ठीक है, 100 bacteria are alive. If I want to do total count, तो क्या होगा? 10 ही है, 10 ही alive है, 10 ही है. 100 ही है, 100 ही सारे के सारे alive है. अब क्या हुआ? जब स्टेशनरी फेज हुआ तो आपकी डेथ भी होने लग गई. डेथ ऑल्सो स्टार्टेड हैपनिंग. क्या हो रहा था? यहाँ पे 10 थे, 10 के 10 अलाइव थे. यहाँ पे 100 थे, 100 के 100 ऑल वर अलाइव. नाउ डेथ स्टार्टेड हैपनिंग वाइल मल्टीप्लीकेशन वॉज कंटिन्यूइंग. मल्टीप्लीकेशन कंटिन्यू हो रही थी एंड दिस वॉज इंक्रीजिंग, बट इंक्रीजिंग स्लोली, ठीक है. सो मल्टीप्लीकेशन वॉज इंक्रीजिंग एंड डेथ वॉज ऑल्सो हैपनिंग. वॉट स्टार्टेड हैपनिंग? लाइव रिमेन्ड 100. जो 100 थे उसमें से 20 डाइड. कितने बचे लाइव? 80. और बाकी 20 और मल्टीप्लाई करके नए बन गए. न्यू बर्थ्स, दीज आर न्यू बर्थ्स. सो टोटल लाइव आर 100, total dead are 20. So what is the total count over here? 120. So the total body count is still increasing, but number of live and death is equal. 20 ही मर रहे हैं, 20 ही जिंदा हैं, तो ये 80 पे अटक गया, ठीक है. ऐसे ही आगे बढ़ता रहेगा कर्व और यहाँ पे आके फ्लैट हो जाएगा. यहाँ पे डेथ स्टार्ट हो जाएगी. तो ये तो मेरे लाइव बैक्टीरिया हैं और ये मेरे टोटल बैक्टीरिया हैं. दैट इज वाई यू हैव दीज 2 डिफरेंट टाइप्स ऑफ ग्राफ्स. ठीक है, ठीक है. रिपीट करने के लिए बोला और फिर कमेंट डिलीट किया. वेरी नाइस. चलो फाइन. अब इससे ज्यादा और रिपीट नहीं होगा. अब बात कर लेते हैं ट्रांसफरेबल ड्रग रेजिस्टेंस की, मतलब कि ट्रांसडक्शन. व्हाट हैपेंस इन ट्रांसडक्शन? ट्रांसडक्शन में द जेनेटिक exchange, the exchange of genetic material between two unrelated bacteria like you and me. We are not related to each other, but we are exchanging information. अगर हम genetic code exchange कर ले तो हम उसको बोलेंगे horizontal gene transfer. horizontal gene transfer. transduction किससे होता है? बैक्टीरियोफाज. बैक्टीरियोफाज कैसे बोलेंगे इसको? ऐसे. ये है सिंबल फाज का. जब भी ये सिंबल बनाया मतलब बैक्टीरियोफाज की बात हो रही है. बैक्टीरिया, फाज खाना. वो बैक्टीरिया वो वायरस जो बैक्टीरिया को खा जाता है. क्या करता है ये बैक्टीरियोफाज? ये रहा फाज, ये फाज का पिंक डीएनए. ये रहा बैक्टीरिया, ये बैक्टीरिया का ब्लू क्रोमोसोम. फाज आता है, फाज इसको अपना पिंक क्रोमोसोम दे देता है. पिंक क्रोमोसोम क्या करता है? बैक्टीरिया की वायरल it uses the metabolic pathway of the bacteria and starts multiplying along with the multiplication cycles of the bacteria. Meaning phage is now synthesizing many new small baby phages inside the bacterium. Then it pops, slices open the bacteria and these new baby phages with the red bacteria, the genome of the parent phage is getting released. This is how any virus multiplies, है ना? Any virus does the same thing. So bacteriophage also does the same thing. So this is called as a lytic cycle. Why? Because it is breaking open, doing lysis of the bacterial cell. Then it is also very smart. It does the lysogenic cycle also. इसमें क्या किया, यहाँ पे जब अपना प्यारा प्यारा रेड क्रोमोसोम it had given into the bacterial cell के पास अपना ब्लू भी था, रेड को ब्लू से प्यार हो गया, रेड goes and integrates inside the blue chromosome. Now it is mixed, mixing हो गई है. This is called as a prophage. Why? Because ये जो अब जो भी स्ट्रक्चर बन गया, इसको भैया ओरिजिनल बैक्टीरिया भी नहीं कह सकते, ना पूरी तरह से बैक्टीरिया है ना पूरी तरह से फाज है, ये फाज और बैक्टीरिया का मिक्सचर बन गया है. नाउ इट हैज द पोटेंशियल ऑफ बिकमिंग अ फाज इन द फ्यूचर. सो इट इज अ प्रोफाज. प्रोफाज कैसा है? टिकिंग टाइम बॉम्ब के जैसा, एक टाइम बॉम्ब के जैसा, मतलब कि अपने टाइम का वेट कर रहा है, अपना टाइम आएगा. इट इज वेटिंग फॉर इट्स टाइम टू कम. व्हेन विल द टाइम कम? व्हेनेवर देयर इज स्ट्रेस हुआ, यूवी लाइट, एक्सीजन, एंटीबायोटिक, टॉक्सिन, कुछ भी आया, एनी काइंड ऑफ स्ट्रेस. अब क्या होगा? ये जो बैक्टीरिया है ना, इसकी जिंदगी खतरे में है. द लाइफ ऑफ बैक्टीरिया इज नाउ इन डेंजर. सो व्हाट द बैक्टीरियोफाज विल डू? अपॉर्चुनिस्ट यहाँ से और यहाँ से सेपरेट हो जाएगा. इट विल सेपरेट इटसेल्फ फ्रॉम दीज 2 points and now again you see the phage DNA is separated from the bacterial DNA. Now this phage DNA will enter into the lytic cycle from here, use the machinery to make baby phages, lyse the cell and move ahead in life. तो ये lytic cycle और lysogenic cycle के बीच में घूमता रहता है हमारा बैक्टीरियोफाज. इसी प्रोसेस को यूटिलाइज करके ट्रांसडक्शन में बैक्टीरियोफाज ब्रिंग्स अबाउट अ पिक एंड ड्रॉप सर्विस. पिक एंड ड्रॉप सर्विस, ठीक है. इसमें क्या करता है? 2 तरह की ट्रांसडक्शंस हैपन. वन इज कॉल्ड एज द जनरलाइज्ड ट्रांसडक्शन. जनरलाइज्ड ट्रांसडक्शन, इसमें क्या हो रही है? मिसपैकिंग. मिसपैकिंग मतलब आप हॉस्टल में रहते हो. इफ यू लिव इन अ हॉस्टल, in your hostel there are some things which has been provided by the hostel authority and there are some items which are your own. घर से क्या लाए थे? घर से तकिया है ना, पिलो, मैट्रेस, क्लोथ, probably books. This is what you got from home. The bed, the table, the chair in your room was provided by hostel authority. When you are shifting, when you are going home, what all can you take with yourself? Your mattress, your pillow, your clothes. You cannot take the bed, chair or the table from that hostel room. You hire a packer and mover service. Who did you hire? You hired this bacteriophage. Bacteriophage bhaiya, come and help me move my hostel room. What did bacteriophage bhaiya do? He did a mispacking. He packed the table, chair and bed also along with your mattress and pillowcase. Now you have taken away hostel property. That is what happens in generalized transduction. ये रहा बैक्टीरिया, ये रहा बैक्टीरिया का क्रोमोसोम, ये आए फाज भैया ने अपना रेड क्रोमोसोम दे दिया अंदर. अब इनको क्या करना था? व्हाट वाज ही सपोज टू डू? लेटर ऑन ही वाज सपोज टू क्रिएट स्मॉल लिटिल बेबी फाजेस इनसाइड. व्हाट वर द बेबी फाजेस सपोज टू पैक? बेबी फाजेस वर सपोज टू पैक द रेड DNA, जैसे यहाँ पे हो रहा है ना, came inside, packed the red DNA only, then moved out with the red DNA. What happens here? By mistake, because of mispacking, this guy packs the blue DNA. By mistake, this guy packs the blue DNA. Bacterial lysis कराया, बाहर निकले. कौन कौन निकले? All the 3 guys came out. All the 3 guys came out. They had the phage DNA. This guy had the bacterial DNA. They will also go and infect different bacteria. This guy goes and infects this green bacteria with its yellow chromosome. What will it give it now? Now this phage will sit on top here and it will give the blue chromosome inside. Essentially what has happened? The blue chromosome of bacteria A has been transferred to the bacteria B. What is the end result? Essentially क्या हो गया? बैक्टीरिया A का क्रोमोसोम उठा के बैक्टीरिया B के अंदर दे दिया. So this becomes packing, pick and drop. Pick and drop. Pick the DNA of bacteria A and drop it into bacteria B because of mispacking. मिस पैकिंग, जैसे आपने किया हॉस्टल का सामान उठा के घर ले गए, ठीक है। अब होती है स्पेशलाइज्ड ट्रांसडक्शन। Then there is specialized transduction. It is also called as restricted transduction. What happens in restricted transduction? A restricted portion only is transferred. उसमें क्या बनेगा? इसके लिए प्रोफाज बनेगा। कैसे बनेगा? सेम हो रहा है ना, सेम हो रहा है। ये येलो बैक्टीरिया, उसका ब्लू क्रोमोजोम, यहाँ आया बैक्टीरियोफाज, अपना रेड क्रोमोजोम दिया। अब रेड क्रोमोजोम को प्यार हो गया, रेड क्रोमोजोम जाके चिपक गया ब्लू क्रोमोजोम से। अब ये क्या बन गया? प्रोफाज। क्या बन गया? प्रोफाज। दिस इज नाउ प्रोफाज। अब क्या होना था? प्रोफाज को यहां से टूट के वापस से अपनी लाइटिक साइकिल में जाना था। नाउ व्हाट हैपेंस इज मिस स्प्लाइसिंग। मिस स्प्लाइसिंग मतलब कहां से ब्रेक होना चाहिए था? यहां से ब्रेक होना चाहिए था ना। कहां से ब्रेक हुआ? यहां से ब्रेक हो गया। यहां से व्हेन इट ब्रोक ऑफ क्या बना? ये ब्लू सेपरेट हो गया, ये रेड के साथ थोड़ा सा ब्लू भी आ गया, रेड के साथ ब्लू हैज ऑल्सो कम। सो अ रिस्ट्रिक्टेड पोर्शन हैज बीन पिक्ड अप। अब बाकी साइकिल सेम चलेगी। तो बैक्टीरिया बी को उसने क्या दिया? बैक्टीरिया ए का टोटल क्रोमोसोम नहीं दिया, अ लिटिल पोर्शन ऑफ बैक्टीरिया ए हैज बीन ट्रांसफर्ड टू द न्यू बैक्टीरिया। सपोज करो इस बैक्टीरिया के पास पेनिसिलिनेज प्रोड्यूसिंग एंजाइम था, कहाँ पे? यहाँ पे लगा हुआ था। तो प्रोफाज से जब वो बाइंड किया तो वो यहाँ लगा हुआ था। प्रोफाज जब टूटा तो वो अपना पेनिसिलिनेज प्रोड्यूसिंग एंजाइम यहाँ लेके बैठ गया। सो ये जो फाइनल प्रोडक्ट बना, इसमें अ लिटिल रिस्ट्रिक्टेड पोर्शन ऑफ बैक्टीरिया ए विच द प्रोफाज हैज कैरीड विद इटसेल्फ कंटेन्स द स्पेशल जीन, अ रिस्ट्रिक्टेड जीन, दैट इज व्हाई इट इज स्पेशलाइज्ड और रिस्ट्रिक्टेड ट्रांसडक्शन। आई होप इट इज क्लियर, ठीक है। ट्रांसडक्शन क्या है? बैक्टीरियोफाज आ रहा है। Transduction is bacteriophage is coming. So what is it doing? Pick and drop service. Either it is totally mispacking the entire genome, transferring to new bacteria. That is generalized transduction. Or at the time of removing its DNA from the bacterial DNA, it takes a little portion of bacterial DNA also, specialized or restricted transduction. अब transduction के अलावा another thing is conjugation. Conjugation में किसी external force की जरूरत नहीं है. It happens through sex pilus, also called as conjugation tubes. Conjugation tubes क्या transfer हो रहा है? Plasmids. Plasmids are getting transferred. We know plasmids are the autonomous bodies. These are the independently dividing replicating genetic material or DNA material present inside the bacteria. Bacteria का main chromosome होता है, then there is the plasmids, free छोटे छोटे small genetic packets. They are very small nucleotide based pairs thick, so they are the small gene packets. These small gene packets can be easily given from me to you. बहुत आसानी से we can exchange these packets with each other. Similarly, the bacteria is also very easily able to exchange these packets with each other. क्या करेगा? ये रहा आपका डोनर बैक्टीरिया। क्यों? बिकॉज इट हैज अ प्लाज्मिड। विच प्लाज्मिड? एफ प्लाज्मिड, मतलब फर्टिलिटी प्लाज्मिड, मतलब द प्लाज्मिड विच गिव्स द एबिलिटी ऑफ द बैक्टीरिया टू फॉर्म द सेक्स पाइलस। ये है आपका एक बैक्टीरिया, इसके पास एफ प्लाज्मिड है, इसलिए इट कैन मेक द सेक्स पाइलस। सो इट कैन गिव द एफ प्लाज्मिड टू somebody, so I can call it the donor cell. I can also call it the F positive cell because it has the plasmid. Here is a bacterial cell without the plasmid. Plasmid नहीं है तो sex pilus भी नहीं बनेगा, इसलिए F minus cell बोल सकते हैं. Can it take the plasmid from this guy? Yes. It can take the plasmid from this guy. So if it can take the plasmid, I can call it recipient. So this becomes a recipient cell. What will happen? The conjugation tube will be formed. This plasmid will start to roll here. What is this called as? The transfer, the rolling circle. Rolling circle mechanism. मतलब जैसे ऐसे मेरा arm है, I rolled it out to you to hold it. Similarly, the bacteria has rolled out the plasmid for the other bacteria to hold it. अब क्या है? Plasmid छोटा सा small genetic packet ना. By the time conjugation tube breaks, transfer हो चुका होता है. Please remember, transfer is not cut and paste. It is copy paste. Copy paste, not cut paste, not cut paste. क्या मतलब इसके पास भी रहेगा प्लाज्मिड और इसके पास भी आ जाएगा प्लाज्मिड. दिस विल नॉट लूज इट्स प्लाज्मिड. दिस सेल विल नॉट लूज इट्स प्लाज्मिड. सो वंस F plus, always F plus. F minus now becomes F plus. So if I ask you what happens when an F plus conjugates with an F minus cell, both become F plus. Once an F plus, always an F plus. ठीक है. What will happen if this F factor plasmid falls in love with the chromosome? जुड़ गया. It creates an episome. Episome. What is this episome? Plasmid has fallen in love with the main chromosome. Plasmid has gone and integrated into the main chromosome. Now this plasmid F factor is integrated into the main chromosome. This is called as high frequency recombinant cell, because this joining and recombining can happen at very high frequencies. What will happen if this high frequency recombinant will conjugate with an F minus cell? This HFR is a selfish guy. He's a selfish guy. He will not give it anything. So to remember, just remember, HFR is selfish. If it conjugates with F minus, HFR remains HFR and F minus remains F minus. अब क्यों होता है ऐसा? Why does this happen? What did I say? Plasmids are small genetic packets. So their transfer can happen quickly. Now the small packet has integrated with the big packet. This has become one very big packet of genetic information. So अब जब conjugation tube बनेगी and when the rolling circle mechanism will start, सारा genetic material transfer नहीं हो पाएगा because there's a lots of information. So if this class was only for half an hour, would I have been able to give you all the information that I'm giving you? No, the connection would have broken off in between only. Then you would have said, ma'am is very selfish, ma'am did not teach us anything. But then how much could I have taught you in half an hour? Similarly, for the small time that the conjugation tube is formed, HFR has so much to give, its bacterial DNA also, plasmid DNA also, that it is not able to transfer. That is why when HFR conjugates with F minus, it remains HFR and F minus remains F minus. Now, this is a high frequency recombinant cell. है ना, हमने बोला this is a high frequency recombinant, meaning the joining and detachment happens very very fast. Now if this plasmid break up हो जाए, now they've fallen in love, so they're sticking together. Now if the plasmid breaks up with the chromosome, chromosome से break up करना है, कहाँ से करना पड़ेगा? यहाँ से करना पड़ेगा ना, chromosome को ब्रेकअप यहाँ से करना पड़ेगा, प्लाज्मिड को ब्रेकअप. सब गलतियां कर रहे हैं बैठ के. उधर बैक्टीरियोफाज गलती कर रहा था, यहाँ पे बैक्टीरिया खुद गलती कर देगा. इंस्टेड ऑफ ब्रेकिंग ऑफ फ्रॉम दिस पॉइंट, दिस गाय डिसाइड्स टू ब्रेक ऑफ फ्रॉम दिस पॉइंट. So when it breaks off from this point, what type of a cell is formed? Here is the bacterial chromosome and the plasmid now has a little portion of the bacterial chromosome. ठीक है, this is the plasmid now. Plasmid has a little portion of bacterial chromosome now. अब इसको F plus तो नहीं बोल सकते, we can't call it F plus. It started as an F plus cell, but now it is not F plus. This does not look like this also, this does not look like this also. So now I have to call it something else. So this is my F prime cell. F prime cell. F prime cell will behave exactly like an F plus cell. Why? Because अब इसको क्या ट्रांसफर करना है? प्लाज्मिड ही ट्रांसफर करना है. Even if the plasmid has a little portion of bacterial DNA, still it is a plasmid. तो 10-15 न्यूक्लियोटाइड बेस पेयर से ज़्यादा इसके पास तब भी नहीं होगा. Plasmid is always a small packet of information. It is just that now along with the plasmid information, it has a little bit of main chromosome information also. तो ट्रांसफर तो फिर भी जल्दी हो ही जाएगा. So the F prime cell, when it conjugates with an F minus cell, you get F prime and F prime. ठीक है, so very simple. Once an F plus, always an F plus, other also becomes F plus. Once an F prime, always an F prime, other also becomes F prime. HFR is highly selfish guy, nothing changes. Done, done, done. Ultimate steps, done, remembered, done. Done? Okay. आ जाओ डिसइंफेक्टेंट्स एंड स्टेरिलाइजिंग एजेंट्स. पहले बात करेंगे स्टेरिलाइजिंग एजेंट्स की. क्या है स्टेरिलाइजिंग एजेंट्स? फिजिकल एंड केमिकल. स्टेरिलाइजिंग मतलब किसको मारेगा? स्पोर को. स्पोर इज गोइंग टू गेट किल्ड. बैक्टीरियल स्पोर को अगर मारा तो आप बनेंगे स्टेरिलाइजिंग एजेंट. यस मैम, थैंक यू. ओके, ग्रेट. फिजिकल भी यूज कर सकते हैं, केमिकल भी यूज कर सकते हैं. फिजिकल में क्या यूज करेंगे? हीट यूज करेंगे. हीट में ड्राई हीट यूज करेंगे. ड्राई हीट क्या होगी? हॉट एयर अवन. हॉट एयर अवन. मॉइस्ट हीट क्या होगी? स्टीम. स्टीम बोले तो ऑटोक्लेव. 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 कोई सी भी हीट हो, इफ इट इज अ स्टेरिलेंट, इट हैज टू बी मोर देन 100 डिग्री सेल्सियस. 100 भी नहीं चलेगा, मोर देन 100, मतलब 101 डिग्री एंड अबव. 101 एंड अबव इतना टेम्परेचर होगा, तब इसको हम हीट बेस्ड स्टेरिलाइजेशन बोलेंगे. व्हाट अबाउट फिल्ट्रेशन? रिमेंबर द बैक्टीरियल मेम्ब्रेन फिल्टर्स. सो इसमें याद रख लो, हेपा फिल्टर, अल्पा फिल्टर, मास्क, ओटी रूम्स में यूज होने वाले. सो योर बैक्टीरियल फिल्टर, बैक्टीरियल फिल्टर का क्या साइज होता है? 0.22 माइक्रोमीटर्स. 0.22 माइक्रोमीटर्स. ठीक है. हेपा में क्या होता है? एनीथिंग मोर देन 0.303 माइक्रोमीटर्स को वो रोक लेता है. एनीथिंग ग्रेटर देन 0.03 माइक्रोमीटर्स इट इज एबल टू स्टॉप. रेडिएशन कौन सी? गामा. गामा रेडिएशन, एक्स रेज, ये कौन सी है? आयनाइजिंग. आयनाइजिंग रेडिएशन. एक ही बात याद रखनी है आपको, जब भी कोई चीज स्टेरिलेंट कहलाएगी, स्टेरिलाइजिंग एजेंट कहलाएगी, हाउ इज इट किलिंग द बैक्टीरियल सेल? बाय डिस्ट्रॉइंग द डीएनए. No matter if you use hot air oven, no matter if you use autoclave, no matter if you use radiation, no matter if you use ETO, no matter if you use plasma sterilizer, you are ultimately destroying the genome, the genetic material, the DNA of that माइक्रो ऑर्गेनिज्म. तो डीएनए को डिस्ट्रॉय करने के लिए चाहे आप इतनी हीट लगा दो कि ऑक्सीडेटिव डैमेज हो जाए. सो व्हाट विल हॉट एयर अवन डू? हॉट एयर अवन विल डू ऑक्सीडेटिव डैमेज. Oxidative damage. What will autoclave do? Protein denaturation. Protein denaturation. What is filtration doing? No killing. ये बेचारा no violence, only stopping. छन्नी जैसा है, सीव जैसा है ना. चाय डाली, पत्ती ऊपर रह गई, चाय नीचे आ गई. सेम फिल्टर. हमने सोल्यूशन डाला, बैक्टीरिया ऊपर रह गया, क्लियर फ्लूइड नीचे आ गया. फिल्ट्रेशन, नो किलिंग. रेडिएशन में क्या हो रहा है? आयनाइजिंग रेडिएशन. आयनाइजिंग इट इनटू मॉलिक्यूल्स. डीएनए को तोड़ के बिल्कुल इंडिविजुअल मॉलिक्यूल्स में कन्वर्ट कर दिया. दैट इज रेडिएशन. रेडिएशन के लिए क्या बोलेंगे? कोल्ड स्टेरिलाइजेशन. कोल्ड स्टेरिलाइजेशन. कोल्ड स्टेरिलाइजेशन. ठीक है. हॉट एयर ओवन में क्या रखेंगे? हॉट एयर ओवन में क्या रखेंगे? हॉट एयर ओवन. हॉट एयर ओवन में क्या रखते हैं? लेट मी राइट इट. व्हाट? हॉट एयर ओवन, ग्लासवेयर, फोर्सेप्स, स्लाइड्स, पाउडर्स, पैराफिन्स, याडा याडा याडा. ठीक है. बायोलॉजिकल इंडिकेटर, बैसिलस अट्रोफियस. बैसिलस अट्रोफियस. ओवन में क्या बनाते हैं? ब्राउनीज. सो केमिकल इंडिकेटर, ब्राउनीज ट्यूब. ब्राउनीज ट्यूब. ब्राउनीज ट्यूब केमिकल इंडिकेटर. ग्रीन हो गई तो गुड टू गो, मतलब साइकिल पास. रेड हो गई तो स्टॉप स्टॉप स्टॉप, मतलब साइकिल फेल. हॉट एयर ओवन, बैसिलस अट्रोफियस. आ जाओ ऑटोक्लेव. ऑटोक्लेव. ऑटोक्लेव क्या है? प्रेशर कुकर है, मतलब कि प्रेशर बढ़ाया तो वी हैव इंक्रीज द बॉइलिंग टेम्परेचर. नाउ वाटर इज नॉट बॉइलिंग एट 100 डिग्री. स्टीम इज नॉट फॉर्मिंग एट 100 डिग्री. व्हेन इज स्टीम फॉर्मिंग? एट 121 डिग्री सेल्सियस द स्टीम इज फॉर्मिंग नाउ. सो एट 121 डिग्री सेल्सियस if water is boiling and forming steam, latent heat inside the water will be a lot more than it would have been at normal atmospheric pressure. So what is the temperature? 121 degree Celsius at at 15 pounds per square inch for 15 minutes. So 121, 15, whatever क्या होता है 160 डिग्री सेल्सियस फॉर 120 मिनट्स. बहुत देर तक बहुत सारी गर्मी देते रहो. ऑटोक्लेव का बायोलॉजिकल इंडिकेटर जियोबैसिलस, जियो मेरे राजा, जियोबैसिलस स्टीयरोथर्मोफिलस. क्यों बोला ये हमने? बिकॉज ऑटोक्लेव हैज कंप्लीटली चेंज्ड आवर लाइफ. इट इज वेरी वेरी चीप एंड ऑल क्रिटिकल सेमी क्रिटिकल आइटम्स, योर सर्जिकल इंस्ट्रूमेंट्स, लिनन, क्लॉथ, पेपर, कुछ भी रख दो, एवरीथिंग कैन बी स्टेरिलाइज एक्सेप्ट प्लास्टिक, एक्सेप्ट प्लास्टिक. तो क्या नहीं जाएगी? अगार प्लेट नहीं जाएगी. agar plate, which is the petri dish made up of plastic, will not go, but culture media will grow. Culture media will go, meaning before I solidify the blood agar into a plate, I will, when it is in the liquid form, I will sterilize it using the autoclave. ठीक है. केमिकल इंडिकेटर कौन से थे? 3 केमिकल इंडिकेटर. इंटरनल मतलब बिल्कुल अंदर, सर्जिकल इंस्ट्रूमेंट्स के साथ एक कंट्रोल रख दूंगी. फिर आपका एक्सटर्नल मतलब कि वो जो पूरा ट्रे है विच आई एम स्टेरिलाइजिंग, उसके ऊपर एक टेप लगा दूंगी. देन देयर इज द बोविडिक. बोविडिक क्या करता है? पूरे एक ऑटोक्लेव चेम्बर के अंदर आई विल पुट 1 पेपर स्ट्रिप. एक्सटर्नल बिकम्स योर एक्सटर्नल बिकम्स योर क्लास 4 and 5. External becomes autoclave tape. Autoclave tape. What is autoclave tape? Class 1. What is bovidic? Class 2. Class 2. ठीक है. सेकेंड क्लास है ना, थोड़ा नाम ही ऐसा है बोविडिक, सेकेंड क्लास. ठीक है. चलो लेट्स गो अहेड. नाउ जियोबैसिलस स्टीरोथर्मोफिलस हो गया. अब एक आपकी लाइफ कर देते हैं बहुत ज़्यादा आसान. यहाँ क्या लिखा है? ड्राई हीट, हॉट एयर अवन. क्या था हॉट एयर अवन का? बैसिलस अट्रोफियस. उसी के सामने क्या लिखा है? ईटीओ. ईटीओ का इंडिकेटर बताओ जल्दी से. बैसिलस अट्रोफियस, सेम एज हॉट एयर अवन. ठीक है. यहां क्या लिखा है? ऑटोक्लेव. ऑटोक्लेव के सामने क्या लिखा है? प्लाज्मा स्टेरिलाइजर. बताओ इंडिकेटर, बायोलॉजिकल इंडिकेटर फॉर प्लाज्मा स्टेरिलाइजर, सेम एज ऑटोक्लेव. क्या? जियोबैसिलस स्टीयरोथर्मोफिलस. ठीक है. लाइफ हो गई बहुत आसान, बहुत आसान हो गई लाइफ. ईटीओ क्या है? इथाइलिन ऑक्साइड, गैशियस केमिकल. गैशियस केमिकल, इथाइलिन ऑक्साइड, गैशियस केमिकल, टॉक्सिक होता है. कहाँ यूज होगा? मल्टी ल्यूमेन ट्यूबिंग्स. जहां तक स्टीम नहीं पहुंच सकती वहां तक ईटीओ पहुंच जाएगी. मल्टी ल्यूमेन ट्यूबिंग्स मतलब कि बहुत सारे क्रिवाइसिस वाले ट्यूबिंग्स. अब प्लाज्मा स्टेरिलाइजर क्या है? फोर्थ स्टेट ऑफ मैटर. प्लाज्मा गैस को, किसको हमने लिया? 6% H2O2, 6% हाइड्रोजन पेरोक्साइड. उसको क्या करा? वेपराइज. वेपराइज करके क्या करा हमने? वेपराइज करके हमने इसको बना दिया प्लाज्मा. प्लाज्मा मतलब फ्री आयंस, फ्री आयंस, ओ आयन, ओ एच आयन घूम रहे हैं. क्या कर रहे हैं? डिस्ट्रॉय कर रहे हैं बैक्टीरिया, डीएनए तोड़ रहे हैं. ठीक है. क्या हो गया? स्टेरिलाइजेशन हो गया. प्लाज्मा स्टेरिलाइजर. प्लाज्मा स्टेरिलाइजर में क्या रखेंगे? इंटेलिजेंट इक्विपमेंट जिसमें कैमरा लगा हुआ है, वो वाला इक्विपमेंट रखेंगे. ठीक है. डन. ओके. प्लाज्मा स्टेरिलाइजर. सो बायोलॉजिकल इंडिकेटर ऑफ हॉट एयर अवन, बैसिलस अट्रोफियस. बायोलॉजिकल इंडिकेटर ऑफ ईटीओ, बैसिलस अट्रोफियस. बायोलॉजिकल इंडिकेटर ऑफ ऑटोक्लेव, जियोबैसिलस स्टीरोथर्मोफिलस. बायोलॉजिकल इंडिकेटर ऑफ प्लाज्मा स्टेरिलाइजर, जियोबैसिलस स्टीरोथर्मोफिलस. डन डस्टेड. फिल्ट्रेशन कर किसके ले रहे हैं? सीरा के लिए, वैक्सीन्स के लिए, एंटीबायोटिक्स के लिए. जिसको भी केमिकल नहीं लगा सकते, जिसको भी हीट नहीं लगा सकते, उस सब में फिल्ट्रेशन कर लेंगे. डन. फिनिश्ड. ओवर. अच्छा आ जाओ केमिकल्स. व्हाट आर डिसइंफेक्टेंट्स? व्हाट आर डिसइंफेक्टेंट्स? दे डोंट किल स्पोर्स. डोंट किल स्पोर्स. Don't kill spores. But if I take a high level disinfectant and I leave it overnight, forget about it and go home, then can I convert it into a sterilant? Yes, I can convert it into a sterilant. कुछ याद नहीं रखना है. Heat based method में स्टक मैसेज आ रहा है. स्टक लाइव. Okay. All right. So I think we are back now. Up till now, what did I say? Now, okay, all right. Up till now, what did I say? I told you that you don't have to remember anything in the heat. It is just pasteurization, tyndallization, inspission, which is the intermediate level of heat. Radiation is UV radiation. Aldehydes में क्या है? Gluturaldehyde means glutaraldehyde. 2 क्यों याद रखा हमने? 2% for 20 minutes. ऑर्थोप्थैल्डिहाइड, हाइफन लगाया बीच में, मीनिंग हाफ अ वर्ड. हाफ अ वर्ड मीन्स हाफ परसेंटेज, मीनिंग 0.55%. what else is there? Paracetic acid, क्या याद रखेंगे? P for point, P for 5, P for point, P for 5 मतलब 0.1% and 5 minutes, 5 to 15 minutes. सो 5 और 15 कुछ भी याद करो, 5 और 15, 5 minutes to 15 minutes. H2O2, 2 plus 2, H2O2, 2 plus 2 is 4. So more than 4% is sporicidal. So this can become your sterilant. High level disinfectant can now become a sterilant. If I leave this glutaraldehyde for 10 to 14 hours, now this will become sporicidal. So very easy to remember the concentrations. Gluturaldehyde 2%, orthophthaldehyde half a word, 0.5%, paracetic acid P for point, 0.1%, and H2O2 2 plus 2 4% is used. उसके बाद alcohols, phenols and halogens, they will become your intermediate level. Alcohol तो पता ही है 70% ethyl alcohol, hand sanitizer में यूज करते हैं. Phenolics में क्या आता है? आयोडीन, बीटाडीन, हाइपोक्लोराइड, क्लोरीन, ये सब. फिनाइल, फिनोलिक्स में आएगा फिनॉल, कार्बोलिक एसिड मतलब लाइजॉल जिससे घर पे पोछा मारते हैं. एंड हैलोजेंस में आएगा आपका आयोडीन, योर बीटाडीन एंड योर क्लोरीन विच विल इंक्लूड हाइपोक्लोराइड जो कि हाउस होल्ड ब्लीच भी है. इसमें से कौन कौन सा स्किन पे यूज कर सकते हैं? स्किन एसेप्सिस के लिए कैन बी यूज एज एन एंटीसेप्टिक, एल्कोहल कैन बी यूज एज एन एंटीसेप्टिक, and what else can be used? Iodine can be used. The betadine that we use can be used as an antiseptic. Phenolic को स्किन पे नहीं लगा सकते, क्लोराइड को स्किन पे नहीं लगा सकते, राइट? क्या है? क्लोरहेक्सिडिन, माउथ वॉश. क्या है ये? लो लेवल डिसइंफेक्टेंट, लो लेवल डिसइंफेक्टेंट. ठीक है, ज़्यादा दिमाग नहीं मारेंगे, थोड़ा बहुत कॉन्सेंट्रेशन, थोड़ा सा टाइम हमने याद कर लिया. ऑफ कोर्स वी नाउ अंडरस्टैंड द क्रक्स, द डील ऑफ इट ऑल. विच इज द control for filtration method? Biological control for filtration method. Serratia, Mars essence, the red planet. Or we can also use Brevidemonas. कौन? डाई माइन्यूटा, छोटा सा है ना, माइन्यूट है, फिल्ट्रेशन कर रहे हैं, डाई माइन्यूटा. सो हमने सारे मेजरली क्या याद रखना है? बैसिलस एट्रोफियस, जियोबैसिलस, स्टीरोथर्मोफिलस एंड ब्रेविडोमोनास. रेडिएशन के लिए क्या यूज करेंगे? रेडिएशन के लिए यूज करते हैं बैसिलस प्यूमिलिस. बैसिलस प्यूमिलिस अलग रहेगा, ठीक है, डिफरेंट है थोड़ा. Can we move ahead? Can we look at this? What are we looking at now? What are we looking at? This is a fungal cell and this is a fungal cell wall. Fungal cell में क्या क्या है? काइटिन लेयर है, तभी तो वो थिक है, तभी तो वो रेजिस्टेंट है, तभी तो बहुत सारे डिसइंफेक्टेंट्स को भी रेजिस्टेंट है. ये क्या है? बीटा ग्लूकन. कौन सा? 1,3 बीटा डी ग्लूकन. कब कब प्रोड्यूस होगा 1,3 बीटा डी ग्लूकन? जब आपके पास होगा एस्परजिलस का, सॉरी, कैंडिडा का इन्फेक्शन, कैंडिडा का इन्फेक्शन, और बहुत 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 ज़्यादा रेस्ड. कब होगा? बहुत 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 ज़्यादा रेस्ड. पीसीपी, न्यूमोसिस्टिस न्यूमोनी इन्फेक्शन, पीसीपी इन्फेक्शन में बहुत 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 ज़्यादा रेस्ड. एक और आपका बहुत इंपॉर्टेंट प्रोटीन होता है गैलेक्टोमैनन. गैलेक्टोमैनन कब रेज होगा? गैलेक्टोमैनन एस्परजिलस इन्फेक्शन में, एस्परजिलस इन्फेक्शन में. दोनों ही कब नहीं रेज होंगे? दोनों ही कब नहीं रेज होंगे? म्यूकर माइकोसिस, none of the above. Both are absent. So if they give you a fungal infection where neither galactomannan was positive nor 1,3-beta-D-glucan was positive, you know they're talking about mucormycosis or mucorale. Chitin, what is chitin? Chitin को स्टेन करता है आपका कैल्कोफ्लोर white stain. कैल्को मीन्स काइटिन, फ्लोर मीन्स फ्लोरेसेंट, वाइट कलर की डाई है, कैल्को फ्लोर वाइट स्टेन। एक बार ऊपर चलते हैं, कहाँ चलते हैं? अपने फ्लोरेसेंट माइक्रोस्कोप के पास चलते हैं। यहाँ पे हमने डाइज लिखी थी ना, यहाँ पे हम एक कैल्को फ्लोर वाइट स्टेन भी लिख लेते हैं। ठीक है, देखो कितना आगे आ गए हम। वी हैव कवर्ड most of general micro. We have now come on to mycology. ठीक है, ये क्या दिख रहा है ब्लू कलर का? ब्लू कलर का हमेशा लैक्टोफिनॉल कॉटन ब्लू, लैक्टोफिनॉल कॉटन ब्लू। एल क्या है? लैक्टिक एसिड। क्या करेगा? प्रिजर्व करेगा मॉर्फोलॉजी ऑफ फंगस। फिनॉल क्या है? अभी अभी पढ़ा हमने, फिनोलिक्स इंटरमीडिएट लेवल डिसइंफेक्टेंट, डिसइंफेक्ट करेगा, किसी बैक्टीरिया को ग्रो नहीं होने देगा। कॉटन ब्लू क्या है तुम्हारा? कॉटन ब्लू ही तो वो ब्लू कलर है जो तुम्हारी तुम्हारी फंगस ले रही है। किसको क्या ले रही है? काइटिन लेयर को ही ले रही है। ये भी कैल्कोफ्लोर वाइट भी और कॉटन ब्लू दोनों ही काइटिन लेयर को स्टेन करके ब्लू कलर का दिखा देते हैं। ये क्या है तुम्हारा? फंगस ग्रो कर रहा है। किस पे ग्रो कर रहा है? एसडीए अगार के ऊपर। व्हाट इज दिस? सैबरोड्स डेक्स्ट्रोज अगार। जब भी कभी कोई भी फंगल इन्फेक्शन का कल्चर मीडिया पूछा जाए, अगर एसडीए मेंशन्ड है तो वो ही मार्क करना है। अब तक 2-3 बार पूछ लिया, कभी स्पोरोट्रिकोसिस के लिए पूछ लिया, कभी कैंडिडा के लिए पूछ लिया। फंगस बदलते रहेंगे, कल्चर मीडिया सेम रखेंगे। एसडीए सैबरोड्स डेक्स्ट्रोज अगार। क्या इसकी स्पेशल बातें होती हैं? एसिडिक होता है इसका पीएच, इट इज एसिडिक, अराउंड 5.6 होता है इसका पीएच। सेकेंडली इसके साथ इसमें डाली जाती हैं एंटीबायोटिक्स और एंटीमाइक्रोबियल्स। क्या क्या? जेंटामाइसिन डालेंगे। क्यों? ताकि कोई बैक्टीरिया ग्रो ना करे। क्या डालेंगे? क्लोरम फेनिकॉल डालेंगे। ठीक है भाई, नहीं ग्रो करने देंगे। साथ में डालेंगे साइक्लोहेक्सेमाइड। कभी कभी साइक्लोहेक्सेमाइड कैसे लिखा होगा? एक्टीडियोन। अब ये तो एंटी फंगल है, किसको प्रिवेंट कर रहे हैं? ब्रेड मोल्ड, वॉल मोल्ड, सैप्रोफिटिक फंगस भी नहीं ग्रो करनी चाहिए ना। पैथोजेनिक फंगस बेचारी स्लो ग्रोइंग है, धीरे धीरे ग्रो करती है, उसको पूरा मौका दो ग्रो करने का, राइट? एसडीए। अब क्या हुआ? काम नहीं बना हमारा। सारी फंगस ग्रो कर रही थी, हमारे बेचारे डर्मेटोफाइट्स ग्रो नहीं कर पा रहे थे एसडीए के ऊपर। तो हमने क्या किया? इमॉन्स भैया को बुलाया। वी कॉल्ड अपॉन इमॉन्स। What did Emmons do? He did the modification. Emmons modification of SDA. He did the Emmons modification of SDA. क्या किया उन्होंने? लेके हमारा pH कर दिया न्यूट्रल, pH कर दिया न्यूट्रल, 7.4 कर दिया। साथ में एक बड़ा सा नया सा नियोपेप्टोन इसके अंदर डाल दिया। नियोपेप्टोन, थोड़ा सा डेक्स्ट्रोज भी बढ़ाया, कोई बात नहीं, छोड़ देंगे। इमॉन्स मॉडिफिकेशन किसके लिए यूज कर रहे हैं? डर्मेटोफाइट के लिए यूज कर रहे हैं। डर्मेटोफाइट से बात कर लेते हैं हम सुपरफिशियल स्किन इन्फेक्शंस की। सुपरफिशियल स्किन इन्फेक्शन करवाने वाला बहुत कॉमन है हमारा मैलासीजिया फरफर, बहुत फेमस। क्या कराता है? हाइपोपिगमेंटेड पैचेस, हाइपोपिगमेंटेड। अब भाई वर्टिगो भी तो हाइपोपिगमेंटेड है, कैसे होंगे? स्केली लीजन्स होंगे। लीजन को उठाया, एसडीए अगार KOH माउंट पे डाला। KOH माउंट पे मुझको क्या दिखाई दिया? बढ़िया सी स्पेगेटी एंड मीटबॉल अपीयरेंस। भूख लग रही है ना? डिनर टाइम। यस, अभी नहीं खाएंगे, पहले पढ़ेंगे। स्पेगेटी एंड मीटबॉल अपीयरेंस किस पे आती है? KOH माउंट पे आती है। उठा के हमने एसडीए अगार के ऊपर डाला। एसडीए अगार के ऊपर क्या? जैसे फ्राइड एग, अब तो भूख लगने ही वाली है। फ्राइड एग कॉलोनीज। और कहाँ बनती हैं फ्राइड एग कॉलोनीज? याद करो, माइकोप्लाज्मा में। पर वो कैसी होती है? माइक्रोस्कोपिक। ये कैसी है? मैक्रोस्कोपिक। माइकोप्लाज्मा की भी बात करेंगे आज की क्लास में, जब माइक्रोप्लाज्मा की बात करेंगे देन वी विल टॉक अबाउट इट। फ्राइड एग किस में बनाते हो? अंडे की भुर्जी किस में बनती है? ऑयल में ना। तो क्या डालोगे यहाँ पे? ऑयल ओवरले। ये जो मैलासीजिया फरफर है, इट लव्स ऑयल, तभी तो सिबेशियस ग्लैंड्स के पास जाके, हेयर फॉलिकल्स में जाके जाके वहाँ पे स्केली लीजन्स कराती है, वहाँ पे सुपरफिशियल इन्फेक्शन कराती है। तो इसको ऑयल बहुत पसंद है, तो हमने अगार के ऊपर भी इसके लिए फिर बढ़िया सा ऑयल डाल दिया। ऑयल ओवरले पे फ्राइड एग कॉलोनीज, स्पेगेटी एंड मीट बॉल अपीयरेंस ऑन KOH माउंट। हाइपोपिगमेंटेड स्केली लीजन को नाम क्या दिया हमने? टीनिया या पिट्रियासिस वर्सिकलर। दिस इज द डिजीज कॉज्ड बाय द फंगस। फंगस नेम इज मैलेसीजिया फरफर। मैलेसीजिया फरफर, ठीक है। और क्या कर सकते हैं? अगर हाइपर पिगमेंटेड पैचेस हो जाए, हाइपर पिगमेंटेड स्केली लीजन्स हो जाए, ऐसे ऐसे, क्या बोलेंगे इसको? टीनिया नाइग्रा। टीनिया नाइग्रा। जब भी वर्ड ब्लैक या नाइग्रा आएगा माइकोलॉजी में, माइकोलॉजी में जब भी वर्ड आएगा ब्लैक या नाइग्रा, जब भी वर्ड आएगा नाइग्रा या ब्लैक, आपको साथ में वर्ड आएगा हॉर्टिए। हॉर्टिए। अगर हॉर्टिए के आगे मैं लिख दूं वर्निकेई, हॉर्टिए वर्निकेई, तो बन गया टीनिया नाइग्रा। अगर हॉर्टिए के आगे मैं लिख दूं पिएड्रा, तो बन गया ब्लैक पिएड्रा। ब्लैक पिएड्रा इज कॉज्ड बाय पिएड्रा हॉर्टिएई। टीनिया नाइग्रा इज कॉज्ड बाय हॉर्टिएई वर्निकेई। टीनिया वर्सिकलर, oh god, टीनिया वर्सिकलर is caused by Malassezia furfur. ओके, वर्सिकलर फरफर। टीनिया नाइग्रा, नाइग्रा आते ही हॉर्टिए, कौन सा? वर्निके। ब्लैक पिएड्रा, पिएड्रा है तो वर्ड पिएड्रा यहां भी होगा, ब्लैक है तो वर्ड हॉर्टिए यहां होना ही पड़ेगा। वही पिएड्रा वाइट है, पिएड्रा क्या है? हेयर का इन्फेक्शन। ऊपर वाले क्या थे? स्किन के इन्फेक्शन। ये क्या हो गया? हेयर का इन्फेक्शन। वाइट पिएड्रा में वाइट नोड्यूल्स बनेंगे हेयर के ऊपर, सॉफ्ट वाइट नोड्यूल्स। क्या वाइट क्या होती है? बिजली। वेन एवर देयर इज अ लॉट ऑफ लाइटनिंग इन द स्काई, द बिजली चमकती है। कैसी होती है बिजली? वाइट। सो वाइट पिएड्रा इज ट्राइकोस्पोरॉन बिजेली। बिजेली यानी कि बिजली। सो बिजली से याद रखेंगे ट्राइकोस्पोरॉन बिजेली और वाइट पिएड्रा। अभी ट्राइकोस्पोरॉन है, ट्राइकोस्पोरॉन इज अ ईस्ट, तो ऐसा ऐसा लंबा लंबा रेक्टेंगुलर ईस्ट सेल्स होते हैं ट्राइकोस्पोरॉन। वहीं पे एक आपका होता है ट्राइकोफाइटॉन। अभी ट्राइकोफाइटॉन क्या है उसको अभी थोड़ी देर में यहाँ पे देखते हैं। ट्राइकोफाइटॉन, नीचे आ जाओ थोड़ा। डर्मेटोफाइट्स का एक भाई है ट्राइकोफाइटॉन। टर्मेटोफाइट्स को कैसे याद रखेंगे? टर्मेटोफाइट्स को याद करने में ना आंसू आ जाते हैं, रोना आ जाता है। क्या आता है? टू मच इमोशन। टर्मेटोफाइट्स को लर्न करने में क्या आता है? रोना। Are we good now? टू मच इमोशन की बात सब स्टक हो गया? अच्छा चलो ठीक है, बता देते हैं। हमने बोला टू मच इमोशन, T for trichophyton, M for microsporum and E for epidermophyton। अब कैसे याद रखना है कि कौन सा वाला? स्किन में, हेयर में, नेल में, कहाँ कहाँ पे इन्फेक्शन करा रहे हैं? वेयर ऑल आर दे कॉजिंग द इन्फेक्शन? दे कॉजिंग इन्फेक्शन इन ट्राई मतलब ऑल थ्री, राइट। सो ऑल थ्री विल बी स्किन प्लस हेयर प्लस नेल। स्किन के बाद हेयर, सेकंड वाला माइक्रोस्पोरम्स, तो स्किन तो तीनों में होगी, स्किन स्किन स्किन। पहले वाले में ट्राइकोफाइटॉन तो तीनों आ गए। दूसरा माइक्रोस्पोरम, माइक्रोस्पोरम, अगर किसी किसी की हैंडराइटिंग खराब होती है ना तो एम ऐसे लिखता है, कोई एम ऐसे लिखता है। अब ये एम है या एच है कैसे बता सकते हो? तो सेम सेम से दिखते हैं ना, तो एम और एच सेम दिखते हैं। ऑल्सो हेयर सेकेंड वर्ड है तो यहाँ पे हेयर आ जाएगा, स्किन प्लस हेयर। कौन बचा? नेल। इमोशन, न न का साउंड है। एपिडर्मोफाइटॉन, न न का साउंड है। कौन आएगा यहाँ पे? नेल आएगा। तो स्किन प्लस नेल। ओके, इट एंड्स विद नेल, स्टार्ट्स विद ट्राई, starts with all three, ends with nail, emotion. Okay, too much emotion. ऐसे हमने याद कर लिया the three types of dermatophytes and where all they cause infections. अब इनकी शक्ल देख लेते हैं. Let's look at the LPCB pictures. क्या दिख रहा है ये आपको? बहुत सारे छोटे छोटे न्यूमरस माइक्रोकोनिडिया, मतलब कि व्हेन यू स्टार्ट रीडिंग माइक्रो सब कुछ समझ में आता है, सब याद रहता है दिमाग में, बहुत सारी माइक्रो। तो जो पहला वाला है टू मच इमोशन, ट्राइकोफाइटॉन, क्या होगा? टू मच माइक्रोबायोलॉजी ही नोज, सो ट्राइकोफाइटॉन में देयर विल बी टू मच माइक्रोकोनिडिया और बहुत थोड़े से मैक्रोकोनिडिया, फ्यू मैक्रोकोनिडिया। और जो फ्यू मैक्रोकोनिडिया हैं भी, ये भी कैसे दिखते हैं? They look like spindle shaped, not spindle, pencil shaped or cigar shaped. कैसा दिख रहा है? पेंसिल जैसा, सिगार जैसा। So cigar or pencil shaped. So if you see, if they tell you that we see few pencil or cigar shaped macroconidia and abundant or numerous many microconidia, you know that we are in the earlier phase of life when we used to learn lots of micro. So there is trichophyton. Then too much emotion का दूसरा much, microsporum. माइक्रोस्पोरम में क्या हो रहा है? बिग स्पिंडल शेप्ड मैक्रोकोनिडिया, स्पिंडल शेप्ड मैक्रोकोनिडिया। अब क्या हो रहा है आपका? माइक्रो कम होती जा रही है, एज यू आर एडवांसिंग इन एज माइक्रो इज बिकमिंग लेस, सो देयर इज फ्यू माइक्रोकोनिडिया हेयर, फ्यू माइक्रोकोनिडिया हेयर। कौन आया? माइक्रोस्पोरम। अब लास्ट तक क्या होता है? सारी माइक्रो वैनिश्ड, towards the end you don't remember any microbiology, so all micro vanished from your brain. So no, नहीं है। क्या नहीं है? नेल में है, न। इमोशन नेल में होगा, इमोशन नो माइक्रोकोनिडिया। कहाँ गई माइक्रो? लास्ट तक आते आते सारी माइक्रो भूल गए, उड़ गए। क्या है? बड़े बैट शेप्ड, बिग bat shaped macroconidia and only macroconidia, absolutely no microconidia. तो देखो, टू मच इमोशन, शुरू से बात शुरू करी, बहुत सारी माइक्रो समझ में आई, लास्ट तक आते आते सारी माइक्रो उड़ गई। अबंडेंट माइक्रोकोनिडिया, नो माइक्रोकोनिडिया। इमोशन न, स्किन एंड नेल, ट्राइकोफाइटॉन, ट्राई 3, स्किन हेयर प्लस नेल। कौन बचा? माइक्रोस्पोरम, ओनली स्किन एंड नेल। इंपॉर्टेंट स्पीशीज ऑफ ट्राइकोफाइटॉन, सबसे ज्यादा इंपॉर्टेंट ट्राइकोफाइटॉन स्पीशीज कौन सी? ट्राइकोफाइटॉन रूबरम। अब जरा रूबरम से बात कर लेते हैं, रेड पिगमेंट प्रोड्यूसिंग फंजाई की। रेड पिगमेंट प्रोड्यूसिंग फंजाई, रूबरम जिसके नाम में, ट्राइकोफाइटॉन रूबरम। और कौन? मार के लाल किया, टेलारोमाइसिस मारनेफी, टेलारोमाइसिस मारनेफी, मार के लाल कर दिया। और रूबरम, टू इंपॉर्टेंट रेड पिगमेंट प्रोड्यूसिंग फंजाई। डर्मेटोफाइट्स की डायग्नोसिस के लिए और क्या करते हैं हम? हेयर परफोरेशन टेस्ट, मतलब कि थोड़ी सी हमने उठाई फंगस और एक छोटे से बेबी का नाइव हेयर उठा के लाए, उसके ऊपर थोड़ी सी फंगस रख दी हमने, वी टुक सम फंगस एंड पुट इट ऑन द नाइव हेयर ऑफ अ स्मॉल बेबी। सो आफ्टर सम टाइम वी विल सी दैट द फंगस हैज ईटन अप द हेयर, व्हाट इज योर निमोनिक? हु कैन डू दिस? भाई आप थिंक। men can। कौन सा men? ट्राइकोफाइटॉन, मेंटाग्रोफाइट्स, ट्राइकोफाइटॉन मेंटाग्रोफाइट्स एंड माइक्रोस्पोरम कैनिस। Microsporum canis. This test is done for dermatophytes. ठीक है. Another very important test, यूरिएज प्रोड्यूस. इसको पिंक से लिखते हैं बिकॉज यूरिएज पिंक इज पॉजिटिव ना, पिंक कलर्ड यूरिएज इज पॉजिटिव. सो यूरिएज पॉजिटिव फंजाई, यूरिएज पॉजिटिव फंजाई DCM. कौन पढ़ा था एम से आज? मैलेसीजिया फरफर, मैलेसीजिया फरफर. तो क्या क्या पढ़ा मैलेसीजिया फरफर में? फ्राइड एग, स्पेगेटी मीट बॉल, साथ में यूरिएज भी. और सी से कौन आएगा तुम्हारा? क्रिप्टोकोकस, क्रिप्टोकोकस. अभी तक तो उसकी बात ही नहीं करी है हमने. फंगस है, मेनिंजाइटिस कराएगा. और सारे के सारे डर्मेटोफाइट्स, सारे के सारे डर्मेटोफाइट्स. हो गया, डन है ना. अब इसको देख लेते हैं कौन है ये. पेनीज, कॉपर पेनीज. What happened? Why are you guys angry? Why are you angry in the comment box? फिर से अटक गए क्या हम? We are not stuck ना? Seems like we are not stuck. चलो, कॉपर पेनी बॉडीज, इनको और क्या बोलेंगे? मेडुलर बॉडीज, मेडुलर बॉडीज. करेक्ट. क्रोमोब्लास्टोमाइकोसिस. कौन है ये? क्रोमोब्लास्टोमाइकोसिस. किससे होता है? फॉन्सीकिया, फॉन्सीकिया. क्या है ये? ब्लैक कलर की फंगस. क्या बोलते हैं ब्लैक कलर की फंगस को? डिमाटिएशियस, डिमाटिएशियस. और फियोइड फंजाई, फियोइड फंजाई. ठीक है. कैसे होता है ये? इस बार बोला था INICT में थॉर्न प्रिक आया तो 3 चीज, तो ये भी होगा आपका स्किन एंड सबक्यूटेनियस टिश्यू. स्किन एंड सबक्यूटेनियस टिश्यू के इन्फेक्शन से. किससे? थॉर्न प्रिक से. थॉर्न प्रिक. जैसे ही बोले थॉर्न प्रिक, 3 बातें सोचनी है. क्रोमोब्लास्टोमाइकोसिस, क्रोमोब्लास्टोमाइकोसिस, या फिर मदुरा फुट, मदुरा फुट, यूमाइसेटोमा, मेड्यूरेला माइसिटिस. और बताओ चैट बॉक्स. हाँ, स्क्लेरोटिक बॉडी भी ठीक है. करेक्ट. ये बताओ, थॉर्न प्रिक जैसे ही बोला क्या क्या बोलेंगे? क्रोमोब्लास्टोमाइकोसिस, मदुरा फुट और स्पोरोट्रिकोसिस, है ना? रोज गार्डनर्स, स्पोरोट्रिकोसिस. इन तीनों में से ही कोई देंगे अगर थॉर्न प्रिक है तो. यस, तुम्हारी बात सुन लेते हैं. इनको ही स्क्लेरोटिक बॉडीज भी बोलते हैं, स्क्लेरोटिक बॉडीज भी बोलते हैं. ठीक है, ओके. वहीं पे आ गया तुम्हारा स्पोरोथ्रिक्स शेंकी. अभी बोला हमने स्पोरोट्रिकोसिस करने वाला स्पोरोथ्रिक्स शेंकी. और क्या करता है? रोज गार्डनर्स डिजीज. तुमको हिस्ट्री दी नहीं कि भाई रोज गार्डन हिमालय का पेशेंट, उत्तरांचल का पेशेंट, हिमाचल प्रदेश का पेशेंट, क्या कश्मीर का पेशेंट रोज उगाता है? तुम्हें पता है रोज गार्डनर्स डिजीज दे आर टॉकिंग अबाउट. सबसे इंपॉर्टेंट चीज इसमें क्या दिख रही है आपको? ये क्या है? हिस्टोपैथ. हिस्टोपैथ किस पे करते हैं? पेशेंट के टिश्यू पे करते हैं. पेशेंट का टिश्यू किस पे होगा? 37 डिग्री सेल्सियस पे होगा. क्या दिखाई देगा मुझे? ईस्ट फॉर्म. ये रहा सेंट्रल ईस्ट. सेंट्रल ईस्ट के चारों तरफ ये पिंक पिंक क्या है? व्हाट इज दिस पिंक पिंक हियर? दिस इज योर एस्टेरॉइड बॉडी. एस्टेरॉइड बॉडी क्या है ये? स्प्लेंडर हॉपली फिनोमिनन. कैसी है ये एस्टेरॉइड बॉडी? सिगार शेप की, सिगार शेप की. क्या बोला जाता है इसको? स्प्लेंडर हॉपली फिनोमिनन, स्प्लेंडर हॉपली फिनोमिनन. ठीक है, ओके, डन. और बताओ, ये तो देखा टिश्यू के अंदर. कल्चर के अंदर क्या देखूंगी? कल्चर के अंदर फंगस देखूंगी. क्या? ब्यूटिफुल फ्लोरेट्स, फ्लोरेट लाइक कोनिडिएशन. ये आया था नीट पीजी में. नीट पीजी का PYQ है फ्लोरेट लाइक कोनिडिएशन. किस पे दिखेगा भैया? LPCB फ्रॉम SDA कल्चर. जब SDA के कल्चर से LPCB बनाओगे तब आपको ऐसी फूलों जैसी फ्लोरेट लाइक कोनिडिएशन दिखाई देगी ऑन कल्चर. पेशेंट के अंदर क्या दिखेगा? ऐसे अलोंग द लिम्फेटिक नोड्यूल्स, नोड्यूल्स अलोंग द लिम्फेटिक्स. नोड्यूल्स अलोंग दी लिम्फेटिक्स, ये दिखाई देगा पेशेंट के अंदर, पेशेंट के अंदर ये दिखाई देगा। तो ये किस पे है, ये फ्लोरेट लाइक कोनिडिएशंस किस पे हैं, 25 डिग्री सेल्सियस पे। ये एस्टेरॉइड बॉडी किस पे है, 37 डिग्री सेल्सियस पे। इससे हमको क्या याद आएगा, इससे हमको याद आएगा डायमॉर्फिक फंजाई, डायमॉर्फिक फंजाई, डायमॉर्फिक फंजाई क्या होती हैं ये, मतलब कि दो दो मॉर्फोलॉजी, डाईमॉर्फिक टू मॉर्फोलॉजी, मतलब कि वो फंगस जो कि एट 37 डिग्री सेल्सियस तुम्हारी ईस्ट बन के रहती हैं एंड एट 25 डिग्री सेल्सियस प्यारी सी मोल्ड बन के रहती हैं, और अगर इस ईस्ट को उठा के 25 पे रख दूं तो मोल्ड बन जाएगा, इस मोल्ड को उठा के 37 पे रख दूं तो ईस्ट बन जाएगा। इंटरचेंजेबल होता है, दे कैन कीप रिवर्सिंग देयर शेप। अब जब ऐसी कोई फंगस है जो कि जब मैंने उसका कल्चर लगाया तो मोल्ड लग रही है और बॉडी से सैंपल उठाया तो ईस्ट लग रही है, तो मुझे शायद ऐसा फील होगा कि जो मेरी बॉडी की हीट थी 37 डिग्री सेल्सियस की, उसने शायद इसकी शेप को चेंज कर दिया है। तो मुझको क्या लगेगा कि बॉडी हीट probably, I am not very sure, so it's a double P, probably changes shape, है ना। तो B से क्या बनेगा मेरा, B से बनेगा ब्लास्टोमाइसिस, ब्लास्टोमाइसिस। H से क्या बनेगा, हिस्टोप्लाज्मा। P एंड P, कौन सा P, पेनिसिलियम। अरे यार कब तक पेनिसिलियम बोलोगे, टेलेरोमाइसिस, मारनेफी बोल दो ना, अभी अभी पढ़ा था, मार मार के लाल किया, रेड पिगमेंट प्रोड्यूसिंग टेलेरोमाइसिस मारनेफी। एक और ले लो P से, कौन, बहुत बड़ा सा नाम, पैराकॉक्सीडियोडोमाइसिस, उसी का भाई कॉक्सीडियोडोमाइसिस। शेप से कौन, अभी वाला स्पोरोथ्रिक्स शेंकी, स्पोरोथ्रिक्स शेंकी, ठीक है, कोई दिक्कत नहीं। इन सब में से, इन सब में से ये क्या करता है, अपॉर्चुनिस्टिक इन्फेक्शन, ये चैंपियन भाई है हमारा, इम्यूनो कॉम्पिटेंट होस्ट दे दिया तो कुछ करना बस की नहीं है। लेकिन एक बेचारा HIV पॉजिटिव एड्स डिफाइनिंग इलनेस करेगा, पेनिसिलियम मारनेफी, ये क्या करेगा, सबक्यूटेनियस टिश्यू, क्या लग रहा था, थॉर्न प्रिक, ये क्या है आपका सिस्टमिक माइकोसिस, ब्लड स्ट्रीम इन्फेक्शन करेगा। बाकी दोनों सिस्टमिक माइकोसिस, ब्लड स्ट्रीम इन्फेक्शन करेंगे। अगर आपसे पूछ लिया जाए सिस्टमिक माइकोसिस करने वाली डायमॉर्फिक फंजाई, बॉडी हीट probably changes, मतलब कि ब्लास्टोमाइसिस, हिस्टोप्लाज्मा, पैराकोक्सीडियोइडिस एंड कोक्सीडियोडोमाइसिस। एक काम कर लेते हैं, थोड़ा सा नीचे आ जाते हैं, पहले इन लोगों को डिस्कस कर लेते हैं। थोड़ा सा नीचे आ जाओ गाइस, कम ऑन, थोड़ा सा नीचे आ जाओ, कम ऑन टू योर पेज नंबर 18 ऑफ योर वर्कबुक्स, कम ऑन टू दी पेज नंबर 18 ऑफ योर वर्कबुक्स, थोड़ा सा नीचे आ जाओ। अभी अभी डायमॉर्फिक फंगस की बात करिए, डायमॉर्फिक फंगस की बात करके खत्म कर लेंगे। कौन है ये, फिगर ऑफ 8, 8 जैसी लग रही है, मतलब ये देखो, ये एक फंगल सेल है, कलर बदल लेते हैं, ये एक फंगल सेल है, ऐसा है ना, ईस्ट है, इसकी जो बड निकल रही है, डॉटर कहाँ से निकल रही है, ऐसे ब्रॉड से बेस से निकल रही है। What is this called as, BBB, BBB, मतलब के ब्रॉड बेस्ड बडिंग। इतना ज़्यादा BB आ गया, क्या होना पड़ेगा इसको, क्या होना पड़ेगा इसको, ब्लास्ट, करेक्ट करेक्ट, ब्लास्टोमाइसिस। वो भी कौन सा, ब्लास्टोमाइसिस डर्मेटिडिस, डर्मेटिडिस। अब एक कहानी सुनते हैं, एक कहानी सुनते हैं। सिस्टमिक माइकोसिस की क्या है, हॉट बॉयज पार्टी, हॉट बॉयज कैन पार्टी, मतलब कि हिस्टोप्लाज्मा, ब्लास्टोमाइसिस, कोक्सीडियोइडिस एंड पैराकोक्सीडियोइडिस, ये 4 हमने पढ़े थे सिस्टमिक माइकोसिस। सो हॉट बॉयज कैन पार्टी। अब जो हॉट बॉय आपको मिलेगा वो बैड बॉय तो होगा, है ना। इफ यू विल फाइंड दिस हॉट बॉय, इट हैज़ टू बी अ बैड बॉय। कौन सा अडेसिन प्रोटीन हो गया, बैड 1 एंटीजन, बैड 1 एंटीजन रहेगा मेन एंटीजन फॉर ब्लास्टोमाइसिस। अभी जो बैड बॉय है कहाँ मिलेगा आपको, कहाँ मिलेगा आपको बैड बॉय, बैड बॉय का नाम गिलक्रिस्ट रख लेते हैं, तो गिलक्रिस्ट डिजीज इसको बोल देंगे हम। नॉर्थ अमेरिका में मिलेगा ना, तो नॉर्थ अमेरिकन डिजीज, नॉर्थ अमेरिकन डिजीज। सो बिग बैड बॉय, वेयर विल यू फाइंड हिम? नॉर्थ अमेरिका। ब्लास्टोमाइसिस, BBB, ब्रॉड बेस्ड बडिंग ब्लास्टोमाइसिस डर्मेटिटिस। अच्छा बता दो कौन सा स्टेन है ये? ब्लैक कलर की फंगस दिख रही है भाई, गोमोरी मीथामीन सिल्वर स्टेन होना ही पड़ेगा। द मोमेंट यू सी ब्लैक कलर्ड एनीथिंग यू नो इट्स अ सिल्वर स्टेन, क्योंकि सिल्वर गिव्स इट द ब्लैक कलर। सो GMA स्टेन। अब यहाँ पे आ जाते हैं, क्या हो रहा है? ऐसा लग रहा है Popeye has entered the conversation. Popeye with his mariner's wheel and the Mickey Mouse appearance. So mariner's wheel और pilot's wheel और sailor's wheel या फिर मिकी माउस अपीयरेंस। कौन है बैड बॉय? कहाँ ले गया आपको? बैड बॉय वॉज अ पायलट, तभी तो तुमको हॉट लगेगा, तभी तो तुम उसके बातों में फंसोगे, राइट? सो बैड बॉय, हॉट बॉय, वेयर हैज ही टेकन यू? ही हैज टेकन यू टू साउथ अमेरिका नाउ। साउथ अमेरिका ले गया आपको। साउथ अमेरिकन डिजीज, साउथ अमेरिकन डिजीज। साउथ में कहाँ ले गया? साउथ अमेरिका में कहाँ लेके गया? ब्राजील, ब्राजीलेंसिस, ब्राजीलेंसिस। कौन सा भाई? P फॉर पायलट, P फॉर पैराकोक्सीडियोइडिस, ब्राजीलेंसिस। पायलट व्हील, करेक्ट, सही बोल रहे हो। पैराकोक्सीडियोइडिस ब्राजीलेंसिस, साउथ अमेरिकन डिजीज। सेलर्स व्हील, मिकी माउस अपीयरेंस, पायलट व्हील, मैरिनर्स व्हील, कहीं भी ले जाओ। अच्छा, हॉट बॉयज कैन पार्टी बोला था, पार्टी करने कहाँ ले गया? साउथ अमेरिका ले गया, ब्राजील ले गया। कैन पार्टी, C फॉर कैन। कूलेस्ट पार्टीज कहाँ होती हैं भाई? एक रह गया आपका कैन। कोक्सीडियोइडिस, कोक्सीडियोइडिस कौन सा? इमीटिस, इमीटिस। कहाँ होती हैं आपकी कूलेस्ट पार्टीज? वेयर डू द कूलेस्ट पार्टीज हैपन? इन लास वेगस। कूलेस्ट पार्टीज दे हैपन इन लास वेगस। लास वेगस क्या है? लास वेगस क्या है? इट्स अ वैली। क्या बोल दूं? वैली फीवर, वैली फीवर। किससे होगा? कोक्सीडियोइडिस इमिटिस। क्या होगा? वैली फीवर, वैली फीवर। कैसा बनेगा? ऐसा एक बड़ा सा स्फिरूल जिसके अंदर आपके स्मॉल लिटिल स्पोर्स विल बी देयर। अच्छा, ये हॉट बॉय क्या करेगा आपको? डेजर्ट रूमेटिज्म फीवर, वैली फीवर, लास वेगस इज अ डेजर्ट, कुछ भी बोलो। क्या करेगा विल द हॉट बॉय? ही विल गोस्ट यू। सो आपके गोस्ट सेल्स भी बनेंगे। आपको वैली में ले जाके, डेजर्ट में ले जाके, लास वेगस में ले जाके ही इज गोइंग टू गोस्ट यू। सो यू विल गेट द गोस्ट सेल्स। मतलब कि ये एक फंगल सेल भरा हुआ, ये एक फंगल सेल भरा हुआ, बीच में एक एम्प्टी सेल आ गया, फिर एक भरा हुआ, फिर एक भरा हुआ, ये जो है बीच का खाली, दिस इज अ गोस्ट सेल। सो कोक्सीडियोइडिस इमिटिस, coolest parties happen in Las Vegas, they happen in the desert, desert rheumatism, rheumatic valley fever, and वहाँ पे जाके hot boy has ghosted you, ghost cells. Hot boy was a North American guy, he was a bad boy, blastomyces dermatitis, कहाँ ले गया पार्टी करने? साउथ अमेरिका, ब्राजील ले गया, पैराकोक्सीडियोइडिस ब्राजीलेंसिस। एक्चुअली कूल पार्टीज कहाँ हो रही थी? लास वेगस में, वैली फीवर में गोस्ट सेल बन रहे थे, कोक्सीडियोइडिस इमिटिस। आई होप दिस स्मॉल लिटिल स्टोरी हेल्प्स यू रिमेंबर ऑल द डिफरेंट सिस्टमिक माइकोसिस, सिस्टमिक माइकोसिस। वापस चलें ऊपर, वापस चलते हैं ऊपर। कम ऑन गाइस, लेट्स कम बैक एंड लेट्स कम बैक टू पेज नंबर 13। पेज नंबर 13 पे आ जाते हैं, वापस चलते हैं। कम ऑन, चले गए वापस। क्या दिख रहा है? कोई दिक्कत ही नहीं है मुझको तो। बढ़िया सा शाइनी कार, शाइनी कार। शाइनी कार क्या है? कैप्सूल है। कहाँ बनती है? जॉग फेज, लॉग फेज, यूथ ऑफ लाइफ। क्या दिख रहा है मुझे? ये तो काला काला बैकग्राउंड तो नहीं है, इमेज गंदी है, लेकिन इंडिया इंक, नाइग्रोसिन स्टेन, कुछ भी ले लूँ। व्हाट आर दीज एग्जाम्पल्स ऑफ? दीज आर एग्जाम्पल्स ऑफ नेगेटिव स्टेन। नेगेटिव स्टेन है ये तो। ओके जी, फाइन। और क्या करें, और क्या बात करें? कैप्सूल है ना, कैप्सूल का एंटीजन भी तो डिटेक्ट कर सकते हैं। एंटीजन डिटेक्शन टेस्ट भी तो इसका कर सकते हैं। किससे करेंगे? रैपिड कार टेस्ट, रैपिड डायग्नोस्टिक टेस्ट, ICT से कर लेंगे, वो भी बहुत अच्छा इसका टेस्टिंग मैकेनिज्म होता है। और क्या करेगा? करता क्या है कौन ये? बताओ जल्दी, क्रिप्टोकोकस भाई, क्रिप्टोकोकस सबसे इंपॉर्टेंट कौन, नियोफॉर्मेंस, उससे इंपॉर्टेंट कौन, गैटाई, दोनों ही इंपॉर्टेंट होते हैं, ज्यादा इंपॉर्टेंट कौन, क्रिप्टोकोकस, नियोफॉर्मेंस। करता क्या है, मेनिंजाइटिस। देखो हमेशा एक बात याद रखना जिंदगी में, मेनिंजाइटिस कहाँ होता है, ब्रेन में होता है, खोपड़ी में होता है। वेयर इज द ब्रेन लोकेटेड, इनसाइड योर स्कल। स्कल इज लाइक अ कवरिंग फॉर द ब्रेन। तो जो भी बैक्टीरिया, जो भी फंगस ब्रेन को इन्फेक्ट करेगी, वो अपना स्कल लेके आती है, अपनी कवरिंग लेके आती है। क्रिप्टोकोकस मेनिंजाइटिस करता है, अपना स्कल, अपना कवरिंग, अपना कैप्सूल है उसके पास। जल्दी से बताओ, कैप्सुलेटेड बैक्टीरियल मेनिंजाइटिस के कॉजेस। बैक्टीरियल मेनिंजाइटिस कौन कर रहा है, आपका स्ट्रेप्टोकोकस निमोनी, क्या है उसके पास, कैप्सूल है। एच इन्फ्लुएंजी, क्या है उसके पास, कैप्सूल है। निजीरिया मेनिंजाइटिस, क्या है उसके पास, कैप्सूल है। जितने भी मेनिंजाइटिस कराएंगे सबके पास अपनी खोपड़ी, अपना कैप्सूल होने ही वाला है। तो क्रिप्टोकोकस नियोफॉर्मेंस के पास तो मेनिंजाइटिस ही कराने का एक तरीका है, मेनिंजाइटिस ही कराएगा। ये भी आपके इम्यूनो कॉम्प्रोमाइज पेशेंट्स में भी करा सकता है। लैम्ब प्लस फ्लूसाइटोसिन इंडिया इंक कैप्सुलेटेड डेजर्ट, वेरी नाइस, वेरी नाइस, वेरी नाइसली यू आर आंसरिंग, वेरी वेरी गुड। ठीक है, अपॉर्चुनिस्टिक फंगस है, ये भी अपॉर्चुनिस्टिक केसेस में आपका करेगा। ये क्या है, दिस इज एक्चुअली अ ट्रू ईस्ट। हम तो कैंडिडा को ईस्ट बोल बोल के बदनाम करते रहते हैं, वो तो बेचारी फॉल्स ईस्ट है, सूडो हाइफे बनाती है। ट्रू ईस्ट है ये, एक्चुअल सच्चा। कैसी बडिंग होती है, राउंड राउंड कलर का ईस्ट है, लेकिन जो बडिंग देगा ना वो नैरो बेस्ड देगा, नैरो बेस्ड बडिंग देगा, नैरो बेस्ड बडिंग। कैसा ईस्ट, राउंड ईस्ट सेल, राउंड ईस्ट सेल। सही बोल रहे हो, फ्लूसाइटोसिन दे दो, फ्लूसाइटोसिन दे दो। ठीक है, एम्फोटेरिसिन बी प्लस फ्लूसाइटोसिन दे दो। ग्रेट, ऑसम। और कुछ बताओ, और कुछ जाना है इसके बारे में। कौन सा इसका सिलेक्टिव कल्चर मीडिया, सिलेक्टिव कल्चर मीडिया। कॉफी बहुत पसंद है क्रिप्टोकोकस को। सी फॉर क्रिप्टोकोकस, सी फॉर कॉफी। कॉफी मतलब कैफेइक एसिड। कैफेइक एसिड किस पे बन रहा है, बर्ड सीड अगार। काली काली इसकी आती हैं कॉलोनीज, तो क्या बोल देंगे, नाइगर सीड अगार। नाइगर सीड अगार जैसे ही बोला, बर्ड सीड अगार जैसे ही बोला, कैप्सूल जैसे ही बोला, मेनिंजाइटिस जैसे ही बोला, नैरो बेस्ड बडिंग राउंड ईस्ट सेल जैसे ही बोला, और यूरिएज पॉजिटिव जैसे ही बोला, यू नो यू आर टॉकिंग अबाउट क्रिप्टोकोकस। इससे ज्यादा क्या चाहिए भाई, राइट। और आ जाते हैं मोल्ड्स की तरफ चलते हैं। एस्परजिलस एंड म्यूकर की बात कर लेते हैं। बहुत सिंपल सी बात, सबको समझ में आती है। व्हाट इज दिस, थिन हाइलाइन। हाइलाइन मतलब कलरलेस। अब तक हमने कलरफुल फियोइड डिमिटेशियस फंगस कौन सी देखी है, क्रोमोब्लास्टोमाइकोसिस अब तक हमने देखी है ना, फंसीकिया स्पीशीज वाली। थिन हाइलाइन कैसी भाई, सेप्टेशंस नहीं दिख रहे हैं ये तुमको, कितना प्यारा सेप्टेशन, कितना प्यारा सेप्टेशन, कितना प्यारा सेप्टेशन। और कैसी ब्रांचिंग, अक्यूट एंगल ब्रांचिंग, कैसी डाइकोटमस, मतलब ये मेन स्टॉक और ये जो दो ब्रांच निकली दोनों की विड्थ है बराबर। तो ये अक्यूट एंगल बना, ये और ये तीनों की विड्थ है बराबर। सो दीज आर अक्यूट एंगल एंड डाइकोटमस ब्रांचिंग। डाइकोटोमस ब्रांचिंग क्या है ये, हाइफा किसका बनेगा, एस्परजिलस का बनेगा। म्यूकर पे आ जाते हैं। म्यूकर क्या है, रिबन। रिबन, बहुत खुशी की बात है, म्यूकर हो गया, अब आपकी जान जा सकती है। बट अपॉर्चुनिस्टिक है, इम्यूनो कॉम्पिटेंट में कुछ बस की नहीं है, इम्यूनो कॉम्प्रोमाइज में बहुत खतरनाक। क्या, थिक, थिक नहीं ब्रॉड, थिक नहीं बोलेंगे हम बोलेंगे ब्रॉड। ब्रॉड हाईलाइन, फियोइड नहीं होगा कोई सा भी। ब्रॉड हाईलाइन रिबन लाइक, मतलब कि ए सेप्टेड। अरे यहाँ सेप्टेड बोला था, नहीं बोला, अब बोल देते हैं। थिन हाईलाइन सेप्टेड, सेप्टेड, सेप से एस्परजिलस, एस्परजिलस। यहाँ पे क्या, रिबन लाइक, ए सेप्टेड, ए सेप्टेड, ए सेप्टेड, broad hyaline ribbon like aseptate hyphae with obtuse angle branching, ऑब्ट्यूज एंगल ब्रांचिंग। कौन कौन कौन? म्यूकोरेल्स, म्यूकोरेल्स, सुनो म्यूकोरेल्स। इसमें म्यूकर भी आता है, इसमें राइजोम्यूकर भी आता है, इसमें राइजोपस भी आता है, एब्सीडिया भी आता है, लिक्थीमिया भी आता है। म्यूकर का मतलब म्यूकोरेल नहीं है, म्यूकोरेल आपकी फैमिली है जिसको हम जाइगोमाइसिटिस भी कहते हैं, जाइगोमाइसिटिस। उसमें एक मेंबर है म्यूकर, ठीक है, उसमें एक मेंबर होता है म्यूकर। अब इसको अगर हम एलपीसीबी माउंट बना लेंगे, क्या दिखा? बढ़िया सा आपको हाइफा दिखा जिसमें सेप्टेशंस थी, उससे निकला क्या? उससे निकला कोनिडियोफोर। कोनिडियोफोर के ऊपर खोपड़ी, वेसाइकल, वेसाइकल के ऊपर उंगलियां लगी हुई हैं, मेट्यूले, फाइलेट्स, बाइसिलेट, यूनिसिलेट, ऊपर गोल 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 कोनिडिया। क्या बन गया? एस्परजिलस। एस्परजिलस क्या दिख रहा है? यही दिख रहा है, देखो कोनिडियोफोर निकल रहा है, ये रहा वेसाइकल, ये रहे तुम्हारे मेट्यूले, ये सिंगल सिंगल कोनिडिये। बढ़िया, अब इधर देख लो सेम चीज, ठीक है, ये रहे सिंगल सिंगल कोनिडिये, ये रहा वेसाइकल, ये है कोनिडियोफोर, एस्परजिलस। इसको देखो, इसको क्या हुआ? यहाँ पे क्या है? राइजोइड्स, रूट लाइक स्ट्रक्चर्स, और कॉलमेला स्पोरेंजियम, बड़ा बड़ा गोल गोल। जहां जहां राइजोइड दिखे मतलब कि म्यूकोरेल की बात हो रही है, राइजोपस की बात हो रही है। कल्चर प्लेट दिख जाए अगर आपको, फ्लेवस, फ्लेवर कैसा? लाइम ग्रीन, लाइम ग्रीन से याद रखेंगे फ्लेवर, फ्लेवर, फ्लेवर से याद रखेंगे फ्लेवस, यानी कि एस्परजिलस फ्लेवस होगा आपका लाइम ग्रीन या लेमन ग्रीन। वहीं पे ऑलिव ग्रीन होगा एस्परजिलस फ्यूमिगेटस, फ्यूमिगेटस मतलब गंदा गंदा, डर्टी डर्टी ग्रीन। ये क्या? ब्लैक, बताने की जरूरत नहीं है, एस्परजिलस नाइगर, ठीक है। इतनी सारी बातें, इतनी सारी बातें क्लियर्ड, राइट। और क्या रह गया? और क्या रह गया इसमें? ये कौन है? ये कौन है? पूरी प्लेट भर दी, पूरी प्लेट भर दी, लिड उठा के फेंक दी कल्चर प्लेट की, लिड लिफ्टर, लिड लिफ्टर। ये क्या किया? पूरी ट्यूब को फिल कर दिया, ट्यूब फिलर, ट्यूब फिलर। ये देखो यहाँ पे इस वाले को देखो, कितने प्यार से एस्परजिलस बैठा है ना, ट्यूब के अंदर गैप भी छोड़ा हुआ है, इसने पूरी ट्यूब आगे तक भर दी है। सो दिस इज अ ट्यूब फिलर और अ लिड लिफ्टर। इतने भयानक तरह से कौन ग्रो करता है? हमारा म्यूकोरेल्स, म्यूकोरेल। सो अगर आपको बोले कि एक इन्फेक्शन था उसमें ब्रॉड एसेप्टेड ऑब्ट्यूज एंगल ब्रांचिंग हाइफ, अब ठीक है, 2-3 दिन से बहुत स्टक हो रहा है यूट्यूब। क्या बोला था मैंने? एस्परजिलस क्या कराएगा? ब्रोंकोपल्मोनरी एस्परजिलोसिस, एलर्जिक ब्रोंकोपल्मोनरी एस्परजिलोसिस। म्यूकोरेल्स क्या करेंगे? राइनो सेरेब्रल और बाइटो म्यूकर माइक्रोसिस। नोज से स्टार्ट हुआ, क्रिबिफॉर्म प्लेट को तोड़ा, ब्रेन में गया, आई में गया, सारा कुछ इन्वॉल्व कर लिया डायरेक्ट एक्सटेंशन से। कहाँ जाता है? आयरन लविंग है, ब्लड वेसल्स के साथ साथ घूमता है। ट्रीटमेंट ऑफ चॉइस, मैंने बोला ट्रीटमेंट क्या कर लोगे? क्या कर लोगे ट्रीटमेंट? एस्परजिलस हुआ तो वोरिकोनाजोल देना पड़ेगा। वोरिकोनाजोल इज द ड्रग ऑफ चॉइस, ड्रग ऑफ चॉइस फॉर एस्परजिलोसिस। सीरम में क्या उग रहा था, क्या आ रहा था? गैलेक्टोमैनन, याद आया? गैलेक्टोमैनन। और करो म्यूकोरेल, ना गैलेक्टोमैनन आएगा ना बीटा 1,3-डी ग्लूकन आएगा, लिड लिफ्टर आएगा। क्या दे दोगे? एंजियो इन्वेजिव है, अभी बोला, ब्लड वेसल के साथ साथ चलेगा। क्या दे दोगे? क्या दे दोगे? लाइपोसोमल एम्फोटेरिसिन बी, लाइपोसोमल एम्फोटेरिसिन बी। और आपको क्या करना पड़ेगा? सर्जिकल डिब्राइडमेंट, पूरा निकालना पड़ेगा वो पर्टिकुलर ऑर्गन या वो पर्टिकुलर पोर्शन, ठीक है। सर्जिकल डिब्राइडमेंट करना पड़ेगा, ठीक है। आ जाते हैं, मैंने क्या बोला? बीटा 1D13 ग्लूकन। यहाँ पे क्या आ रहा था? एस्परजिलस में गैलेक्टोमैनन, म्यूकर में कुछ भी नहीं, कुछ भी नहीं। तो अगर बीटा 1,3-डी ग्लूकन आ गया तो मैंने बोला दो चीजें हो सकती हैं आपके साथ, कैंडिडा भी हो सकता है और पीसीपी भी हो सकता है। कैंडिडा के लिए क्या करते हैं? क्या दिख रहा है? ये जर्म ट्यूब टेस्ट। कौन बताएगा जर्म ट्यूब क्या होती है? सूडो हाइफे क्या होता है? ये देखो, ये एक ईस्ट सेल है, ईस्ट सेल, मम्मी ईस्ट सेल, मदर ईस्ट सेल क्या देगा? डॉटर ईस्ट सेल बनाएगा। डॉटर ईस्ट सेल यहाँ बनेगी, कुछ दिन बाद क्या होगा? डॉटर ईस्ट सेल अलग हो जाएगी, मम्मी ईस्ट सेल अलग हो जाएगी। फिर ये डॉटर ईस्ट सेल बनाएगी, ये डॉटर ईस्ट सेल बनाएगी, कुछ दिन बाद क्या होगा? ये अलग हो जाएगी, ये अलग हो जाएगी, ये अलग हो जाएगी, ये अलग। ये नॉर्मली होता है ना, दिस इज नॉर्मल मैकेनिज्म। अब क्या हुआ? दिस डॉटर वॉज चिपकू, दिस वॉज अ चिपकू डॉटर, नेवर लेफ्ट द मदर, चिपक के बैठ गई है। अब क्या होगा? बड़ी तो होगी ना, यहाँ पे बड़ी हो गई, ये बड़ी होगी, अपना बच्चा देगी, इसने भी अपना बेबी दिया, देन दिस गेव इट्स बेबी, दिस गेव इट्स बेबी, दिस सब ऑल डॉटर्स आर अटैच टू द मदर। ऊपर से माइक्रोस्कोप में मैंने देखा, मुझे क्या लगा? अरे ये तो कोई सेप्टेट हाइफे जैसा दिख रहा है, पर एक्चुअली दिस वाज नॉट अ सेप्टेट हाइफे। सो व्हाट डिड वी कॉल्ड इट? सूडो हाइफे। फेक है, झूठ बोल रहा है। सूडो हाइफे, फॉल्स हाइफे। किस में बना? कैंडिडा स्पीशीज में बना। फिर जर्म ट्यूब क्या हुआ? जर्म ट्यूब में हुआ, मेरे पास ईस्ट सेल था, मैंने बहुत सारे पेशेंट्स का सीरम पूल करके उसके ऊपर डाला, ये मेरा ईस्ट सेल था, इसी की वॉल, इसी ईस्ट सेल की ही वॉल आगे को ऐसे एक्सटेंड हो गई और एक ट्यूब जैसा स्ट्रक्चर बना लिया। सो दिस इज अ सिंगल ईस्ट सेल जिसकी खुद की वॉल एक्सटेंड हो गई है। यहाँ पे नए नए ईस्ट सेल बन रहे हैं जो एक दूसरे से चिपके हुए हैं। दैट इज द डिफरेंस बिटवीन सूडो हाइफे एंड जर्म ट्यूब। अच्छा जी, कोई बात नहीं, इतनी सारी नॉलेज लेके कहाँ जाएंगे? हमसे तो सिर्फ पूछा जाएगा जर्म ट्यूब टेस्ट पॉजिटिव कौन देता है। हम याद कर लेंगे कैंडिडा एल्बिकेंस और कैंडिडा डुब्लिनेंसी। अब कैसे डिफरेंशिएट करें एल्बिकेंस और डुब्लिनेंसीज के बीच में? हम कर लेंगे कॉर्न मील अगार या डलमाउ कल्चर। डलमाउ कल्चर और कॉर्न मील अगार। क्या किया मैंने? कॉर्न मील क्या होती है ना, न्यूट्रिशनली डेफिशिएंट होती है, इसको CMA भी लिखा हुआ मिल सकता है आपको। न्यूट्रिशनली डेफिशिएंट है। कॉर्न बोला जाता है कि गरीब का खाना होता है, मक्का मेज, इट्स अ पुअर मैंस ग्रेन। अब इतना न्यूट्रिशनली डेफिशिएंट कर दोगे कुछ तो उसको अपने क्लेमाइडोस्पोर्स, स्पोर्स बनाने पड़ जाएंगे। अब ईस्ट को क्या स्पोर बनाया? उस स्पोर को बोला क्लेमाइडोस्पोर। ठीक है, जब भी अनफेवरेबल कंडीशन आएगी स्पोर बनाएगा ना, बैक्टीरिया है तो भी स्पोर बनाएगा, फंगस है तो भी स्पोर बनाएगा। ये जो स्पोर कैंडिडा ने बनाया इसको हमने बोला क्लेमाइडोस्पोर। क्लेमाइडोस्पोर नॉर्मली नहीं दिखाई देंगे आपको, जब आप उसको न्यूट्रिशन छीन लोगे सिर्फ तभी। कैसे छीनोगे? कॉर्न मील अगार या डलमाउ प्लेट कल्चर पे उसका न्यूट्रिशन यू विल टेक इट अवे। तो जो क्लेमाइडोस्पोर बने अगर वो टर्मिनल है एंड सिंगल है, ये देखो टर्मिनल है ना, ये सूडो हाइफे, यहाँ पे क्लेमाइडोस्पोर बना दिया, टर्मिनल एंड सिंगल, देन यू नो you're talking about Candida albicans. Terminal and single, you know you're talking about Candida albicans. एक और बहुत अच्छा तरीका कैंडिडा एल्बिकेंस को पहचानने के लिए, तो अगर आपके पास कैंडिडा एल्बिकेंस या कैंडिडा है तो आप कॉर्न मील अगार कर लो, टर्मिनल क्लेमाइडोस्पोर देख लो, जर्म ट्यूब टेस्ट कर लो। दूसरा आप क्या यूज कर सकते हो? क्रोम अगार। बड़े सारे कलर्स में लिख देते हैं, क्रोम। कौन सा कलर रह गया? ब्लैक ही रह गया। क्रोम अगार क्या है? ये क्रोम अगार अलग अलग कलर प्रोडक्शन हो रही है जिसकी वजह से इट इज टेलिंग मी द डिफरेंट स्पीशीज ऑफ कैंडिडा। सो डिफरेंट स्पीशीज ऑफ कैंडिडा आई कैन आइडेंटिफाई इन क्रोम अगार। ओके मैम, इंग्लिश। ओके ओके ओके, फाइन गाइज, व्हाट डिड आई से? I said that if whenever there is unfavorable condition, then they will make the microorganisms form spores. So if it's a bacteria, it will form spores. If it's a fungus, it will form spores. So what have I done? Corn meal agar. Corn or maize is the grain of the poor people. So corn meal agar is a nutritionally deficient agar. When I put my candida in a corn meal agar, it has to create spores. The spores that candida forms I am calling chlamydospores. These chlamydospores are terminal. This is a pseudohyphae, this is a pseudohyphae. In the end there are two terminal chlamydospores. This is a pseudohyphae, this is a terminal chlamydospore. If this terminal chlamydospore is single, it is Candida albicans. Another method of identifying Candida albicans along with germ tube test and terminal chlamydospore is the chrome agar. It is also called as Candida chrome agar. Why have we written in different colors? Because it produces different colors, which tells me that if it is white, it is Candida auris. If it is bright green, it is Candida albicans. If it is metallic blue, it is Candida tropicalis. If it is pink, it is Candida krusei. It happens like that. और हमने क्या बोला था, बीटा 1,3-D ग्लूकन, दैट इज व्हाट वी सेड इन द वेरी नाउ यू आर सेइंग मैम इंग्लिश. Okay guys, it's the perfect mix of English and Hindi, so I will say something in Hindi, I will try my best to repeat it in English also. Let's go with the flow of the class. All right, so one teacher, just don't ask me to take classes in French, then I'll have to learn it. I'm not saying I won't take, but I'll have to learn it. Okay, what did I say? Beta 1,3-D glucan, beta 1,3-D glucan positive आएगा, then you have two options. कौन से दो option? Candida और PCP. Candida abhi we have seen. What is PCP? PCP, crushed ping pong ball appearance. Have you seen ping pong, the table tennis ball? If I pitchcow it from the top, if I crush it from the top, I will get this kind of a picture. Crushed ping pong ball appearance, mad hatter's appearance, any of these things can be said. Which stain? Again, GMS, Gomori methamine silver, black color, crushed ping pong ball appearance. What are we looking at? We are looking at PCP. Now, earlier PCP was called PCP because they used to call it Pneumocystis carinii pneumonia. Now you know carinii is not a human infecting species. Carinii infects animals. हमको कौन infect करता है? Pneumocystis jirovisi. Pneumocystis jirovisi. ठीक है, but why do we still call it PCP? Because we like to call it plasma cell pneumonia. Plasma cell pneumonia. If you want to call it PJP pneumonia, then you can also call it PJP. So PJP, PCP, same thing. Why do we call it plasma cell? Because they go and affect the plasma cells. Plasma cells increase a lot in the alveolar exudates. Alveolar exudates when this happens. और क्या दिखेगा आपको? Radiologically you will see the ground glass opacities or bilateral infiltrates. Just bilateral lung infiltrates. And very importantly, what is going to be what is going to be your CD4 count? CD4 less than 200. Therefore, PCP becomes your AIDS defining illness. चैंपियन है, सिर्फ बेचारे इम्यूनो कॉम्प्रोमाइज में डिजीज कराएगा. नो औकात इन इम्यूनो कॉम्पिटेंट पीपल. ठीक है, got it? It's a champ. You know, we say champ are the opportunistic infections. That is why. Cool, correct. Bilateral lung infiltrates, PCP. You're getting AIDS defining illness, your plasma cell pneumonia. Anything else remaining from this? No, not remaining. Let's go ahead. This we have already discussed. Amazing, congratulations. We will now come on to bacteria, and in bacteria we have to start with bacterial food poisoning. Okay, bacterial food poisoning we have to start with. So the very important bacterial food poisoning immediately happening within 1 to 6 hours. You know, it is the emetic type. Staph happens from Staph aureus. Staph aureus, where will you get it from? From the milk products. So if you get milk, cheese, pastry, etc., then it will be Staph aureus. It will happen within 1 to 6 hours. Which is the toxin? It is the enterotoxin. Which enterotoxin? A2P except F, which is a exfoliative toxin. This is a type of a what? This is a type of a super antigen. Okay, super antigen. Who else causes food poisoning in 1 to 6 hours? It is Bacillus cereus. Two types of toxins. Emetic type toxin. The emetic type toxin is heat stable. That is why when you will reheat the fried rice, reheated fried rice syndrome, you will get nausea, vomiting within 1 to 6 hours. This is a preformed toxin. Both of these are preformed toxins. They are already formed in the food, so you are directly ingesting the toxin. आप सीधे toxin ही ingest कर रहे हो, आप bacteria नहीं खा रहे हो. You're not eating bacteria which is then releasing toxin in your gut. Directly you're eating the toxin only because the bacteria has released the toxin into your food. What is another kind of a toxin produced by Bacillus cereus? If Bacillus cereus produces the diarrhea type toxin, that it will produce in your own gut. That produces diarrhea in 16 hours. 16 hours. Majorly diarrhea, not so much nausea, vomiting. These guys will cause a lot of nausea and vomiting because they stimulate the vagus nerve. Vagus nerve. ठीक है, emetic type toxin, right? Then of course more than that you have Campylobacter Clostridium perfringens. इसी आपके 16 hours में एक हो गया Bacillus cereus, another is your Clostridium perfringens. कहाँ से आएगा Clostridium perfringens? From your chicken, poultry. Okay, great. What is this happening here? बहुत ही simple है, blood agar है. What can you see? The zone of clearing. What is this? Beta hemolysis. Beta hemolysis on blood agar. क्या है ये? Narrow zone of beta hemolysis, pinpoint colonies, big colonies. What is this? Staph aureus. Staph aureus. Aureus means golden. Which pigment? Beta carotene. Beta carotene pigment which is produced. What does it cause? Staph aureus causes skin and soft tissue infections. Yeah, but it can cause a whole range of infections. ये क्या है? So what is the selective media? Selective media for Staph aureus. What is this? Selective media for Staph aureus. What do we call it? We call it mannitol salt agar. Mannitol salt agar. What happens? Mannitol ka fermentation. Mannitol ka fermentation which will be done by Staph aureus. So you will get, because of fermentation, acid production. You will get the yellow colonies. Yellow colonies of Staph aureus on mannitol salt agar or MSA becomes selective media for Staph aureus. Okay. Then what is, if you get GPC in chains and you get alpha hemolytic colonies, you're talking about pneumococcus or viridans. Beta hemolytic streptococcus. So you have two beta hemolytic streptococci. Beta hemolytic streptococci can be group A based on Lancefield grouping or group B. So what is group A? It is Streptococcus pyogenes. Pyrogenes. And A is not A. So group B is A galacti. Streptococcus A galacti. Okay. So what do we do to differentiate the two? Camp test. Camp test. What is camp test? So you know that Streptococcus, beta hemolytic Streptococcus and Staphylococcus both produce beta hemolysis. So बीच में हमने क्या किया? We put a streak. In the middle, we put a streak of Staph aureus. Staph aureus is producing the beta hemolysis. यहाँ पे मैंने लगाया कौन? यहाँ पे मैंने लगा दिया group A और group B. Which one? Group B streptococcus. यहाँ पे मैंने लगा दिया group A streptococcus. I see that group B streptococcus के पास there is an enhancement in the zone of hemolysis. This enhancement in the zone of hemolysis is camp test positive. Camp test positive, right? Another test I can do. I have put bacitracin disc in between some beta hemolytic colonies. These are beta hemolytic colonies. If I see a zone of clearing, if I see no zone of inhibition, or I see this little zone of inhibition or zone of clearing, so this means bacitracin sensitive, bacitracin susceptible or sensitive. How do I remember? How do I differentiate between the two? Just remember the mnemonic boot camp and remember the mnemonic abs. Abs. ठीक है? Boot camp मतलब group B is camp positive and abs group A is bacitracin susceptible or sensitive. Abs. Okay. Abs. Boot camp and abs. That is how you differentiate. And A galacti and pyrogenes, A is not A. So group B is A galacti and group A is pyrogenes. Okay? This becomes your beta hemolytic streptococci. What about alpha hemolytic strep? Alpha hemolytic streptococci. You have two important. You have Streptococcus viridans. That is a commensal of the mouth. But what can it cause? It can cause endocarditis. Bacterial endocarditis can still happen because of it. Because you're brushing the teeth, Strep viridans goes into your heart. Important one, the main pathogen one is the Streptococcus pneumoniae, which we also call as pneumococcus. Also called as pneumococcus. ठीक है? Pneumococcus. We will just see about pneumococcus. Before that, let's talk about the selective media for streptococci. Selective media for strep. What is the selective media? For staph, we have seen MSA. What is the selective media for strep? Crystal violet blood agar. crystal violet blood agar. Actually होता क्या क्या इन्फेक्शन करता है? ग्रुप ए causes your sore throat or pharyngitis, and it can also cause rheumatic heart disease as a complication, you know. And then A galacti, it is a part of vaginal flora, so it will cause neonatal infections. Neonatal sepsis karega क्योंकि vaginal flora में present है, and while the baby passes through the birth canal, it will attain the infection, right? Then we were saying Streptococcus pneumoniae. So what are all the features of Streptococcus pneumoniae? The thing is, Streptococcus pneumoniae is gram-positive diplococci, 2 gram-positive bacteria in pairs which are capsulated. So gram-positive diplococci which are capsulated, that becomes your Streptococcus pneumoniae. Now, what are all the ways in which you can identify what is this bile solubility? Basically, आपने क्या किया? You took a turbid broth. You took a turbid broth in which there was strep pneumoniae. Then you added some bile salts and you saw that a clearing of turbidity has happened, meaning that there was the property of autolysis. Autolysis property or autolysin toxin is produced by Streptococcus pneumoniae, which gets activated in presence of bile salts. Bile salts, अगर हमने bile salts दिया, then autolysin gets activated and the bacteria lyses itself. Another important thing is optochin sensitivity. Optochin susceptible, if it is, then it is Streptococcus pneumoniae. So if I have to say Streptococcus pneumoniae, I know that autolysin is there, so it will be bile soluble. So bile solubility test is positive, and it is also optochin sensitive, and it is inulin. Inulin is a sugar, so it will ferment inulin. Inulin fermentation is positive. What else is there? Alpha hemolysis. We have just seen that alpha hemolysis. How else do you want to identify? The flame shaped or lanceolate shaped. These are the diplococci which look like flames. So if I draw these diplococci, you know, they are like this, flame type. So this is lanceolate or flame shaped. What are we talking about? Streptococcus pneumoniae. Streptococcus pneumoniae. So if you find these words, you know they are talking about strep pneumoniae. ठीक है? ये क्या है? What is this? Pus cells है बहुत सारे. In between pus cells, you see these small little gram-negative diplococci. So now we are gram-negative diplococci. Two most important gram-negative diplococci that you have to talk about are Neisseria meningitidis, because that is meningococcus, so it is Neisseria, and Neisseria gonorrhoeae, gonococcus. Acha, another important thing about strep pneumoniae, it gives the carom coin colonies. Carom coin colonies, like the coins of a carom board, na? Carom coin colony is also called as draftsman colonies. Draftsman colonies. ठीक है? Done. Then your Neisseria, meningococcus and gonococcus, Neisseria meningitidis and Neisseria gonorrhoeae. क्या करता है Neisseria gonorrhoeae? Urethritis. What will this do? It is actually a sexually transmitted disease, STD. What will meningitis do? It will do meningitis, no problem. Okay, what kind of a meningitis can it cause? You will, in Neisseria meningitidis, you will see the rash, purpuric rash. If you see purpura, petechiae in the brain, rashes in the patient, meningitis features, you know they are giving you the history of Neisseria meningitidis or, yes, draftsman, correct, or meningococcus. ठीक है? What is the difference? What is the most important virulence factor of Neisseria gonorrhoeae? If I say gonococcus, then most important virulence factor. Come on, tell me. Most important virulence factor, pili or fimbriae. Most important because it has to attach to the mucous membrane. If it can't attach to the mucous membrane, it cannot cause infection. So, jahan bhi mucous membrane milegi, gonococcus will go and bind. So, can it cause Conjunctivitis, it can cause conjunctivitis. Can it cause urethritis? It can cause urethritis. Can it cause proctitis, meaning rectal infection? It can cause proctitis. Wherever it finds, mucosal membrane, it goes and bites. So gonococcus can lead to a whole range of sexually, yes, Fmge. Maltose sugar, easy differentiate meningitis. Kya baat hai. Very nice, correct. Binding pili, that is why. Also, very, very importantly, how can you differentiate? Neisseria is going to be, Neisseria is obligate एरोब, एरोब है, तो सारे जो एरोब होंगे वो क्या होंगे? ऑक्सीडेज पॉजिटिव. Neisseria is going to be oxidase positive, oxidase positive. ठीक है, और क्या होगा? मेनिंगोकोकस इज कैप्सुलेटेड, क्या बोला था? खोपड़ी, स्कल, हमारे पास भी स्कल, बैक्टीरिया के पास भी स्कल. So meningococcus is going to be capsulated, but gonococcus is going to be non-capsulated. Non-capsulated. दोनों ही ग्राम नेगेटिव डिप्लोकोकाई होंगे, पेयर्स में रहेंगे हमेशा. ठीक है, गॉट इट. Which one is kidney shaped? Which one is kidney shaped? ओके, गोनोकोकस. चलो नेक्स्ट चलते हैं. फाज कोडेड टॉक्सिन्स मीन्स बैक्टीरियोफाज कोडेड. देयर इज अ बैक्टीरिया विच हैज बैक्टीरियोफाज, some bacteriophages have the ability to produce certain toxins. If my bacteriophage decides to give its own genetic material to the bacteria, it will also give the ability to produce the toxin to the bacteria. अगर ability to produce toxin दे दिया तो now the bacteria will also start producing toxin. Very, very important and very, very easy to remember. What is the mnemonic? What am I doing? A, B, C, D, E. Waterhouse syndrome, Waterhouse Friderichsen syndrome. Very nice. Actually, it is water can perineum. Water can perineum can also be seen with Neisseria gonorrhoeae, because it can spread very, very much and lead to water can perineum, Waterhouse Friderichsen syndrome, Fitz-Hugh Curtis syndrome. If you will tell me the selective medium for Neisseria, come on, अब जब तुम इतनी बातें कर ही रहे हो तो बता ही दो फिर अब. Selective medium for Neisseria, Fitz-Hugh Curtis syndrome, gonorrhea. Very nice. Come on, then tell me the culture media. Selective medium बताओ. Sexually transmitted disease, New York City medium. एक और बताओ. कोई नहीं बता रहा. थेयर मार्टिन. अच्छा, ट्रांसपोर्ट मीडियम बताओ. ट्रांसपोर्ट मीडियम, कम ऑन. सेक्सुअली ट्रांसमिटेड डिजीज किसको हुआ? मैं हमेशा बोलती हूं, एक कपल जिसको हो गया गोनोरिया, किसको? एमी एंड स्टुअर्ट को. एमीज और स्टुअर्ट्स मीडियम. एमी और स्टुअर्ट को गोनोरिया हो गया. ठीक है, Amies and Stewarts. All similarity with time, place and person is totally coincidental, and this is my disclaimer. Okay, anyways, phage coded toxins A, B, C, D, E. Streptococcal, pyrogenic, exotoxin A and C. क्या करता है streptococcal, pyrogenic, exotoxin A and C? Which disease? Chat box. Which disease? जब तक तुम नहीं बताओगे मैं नहीं लिखूंगी. अच्छा, कोई सा फीवर लो, कोई सा फीवर. ठीक है. बी से बॉट्यूलिनम टॉक्सिन, और कॉम्प्लिकेट करना है तो बॉट्यूलिनम टॉक्सिन सी एंड डी. सी क्लोस्ट्रिडियम नहीं, कॉलेरा. कैरी ब्लेयर कर लो यूज, कैरी ब्लेयर. But Amies and Stewart's is better. Carrie Blair is better for Campylobacter, for Vibrio. Their Carrie Blair is better. Shigella, Salmonella. ठीक है. For Neisseria, Amies and Stewart's is better. कोई बात. Cholera toxin. D for diphtheria toxin. डिप्थीरिया टॉक्सिन। ई फॉर ई कोलाई, कौन सा ई कोलाई? एंटेरो हेमेराजिक ई कोलाई कौन सा टॉक्सिन प्रोड्यूस करता है? वीरोसाइटोटॉक्सिन, वीरोसाइटोटॉक्सिन। ए बी सी डी ई, अभी कोई नहीं बता रहा है मुझे कौन सा फीवर भाई? स्कारलेट फीवर। क्या हो गया? स्कारलेट फीवर, स्ट्रॉबेरी टंग, सैंड पेपर रैश। यस, ये क्या है? ये तो कोई भी बता देगा, ये तो कोई भी बता देगा। व्हाट इज दिस? एल्बर्ट स्टेन, वॉल्यूटिन ग्रैन्यूल्स, और क्या बोलते हैं इन ग्रैन्यूल्स को? बेब्स अर्न्स ग्रैन्यूल्स, वॉल्यूटिन ग्रैन्यूल्स। कोराइनीबैक्टीरियम diphtheria, also called as Klebsiella bacteria. कौन कौन सा स्टेन करते हैं इसके लिए? प्लान, पॉन्डर्स स्टेन, लॉफलर्स मिथिलिन ब्लू स्टेन, एल्बर्ट स्टेन एंड एन से क्या करूं बताओ? प्लान, प्लान, पॉन्डर स्टेन, एल्बर्ट स्टेन, लॉफलर्स मिथिलिन ब्लू स्टेन एंड नीसर स्टेन। ठीक है क्या ये? व्हाट इज द अरेंजमेंट, व्हाट इज द पैटर्न? वी शेप्ड, चाइनीज लेटर, cuneiform, anything. What are these? Metachromatic, meaning I put some stain, they took some other stain. डाला था हमने टॉल्यूडीन ब्लू एंड मैलाकाइट ग्रीन, निकल के क्या आया? पर्पल कलर। मेटाक्रोमैटिक ग्रैन्यूल्स। यस, नीसर करेक्ट। और दे आर एक्चुअली पॉलीमेटाफॉस्फेट ग्रैन्यूल्स। है क्या? स्टोरेज ग्रैन्यूल्स। क्या बोलते हैं इनको? वॉल्यूटिन ग्रैन्यूल्स। ये और कौन बनाता है वॉल्यूटिन ग्रैन्यूल्स? अदर देन कोराइनीबैक्टीरियम डिप्थेरी, हु एल्स कैन फॉर्म वॉल्यूटिन ग्रैन्यूल्स? Gardnerella vaginalis. What does this Gardnerella vaginalis cause? Bacterial vaginosis. It causes bacterial vaginosis, which is dysbiosis of my own flora. ठीक है? No other special pathogen coming in, the own vaginal flora getting disturbed. Bacterial vaginosis. पर रुक जाते हैं, अभी हम कहाँ घूम रहे हैं? थ्रोट में। थ्रोट में क्या करा रहे? कोराइनीबैक्टीरियम डिप्थेरी। व्हाट इज इट कॉजिंग? इट इज कॉजिंग pseudo membranous colitis. What is it causing? It is causing pseudo membranous colitis. Am I right? No. Colitis कैसे करा देगा थ्रोट में? pseudo membranous pharyngitis. Who was causing colitis? Clostridioides difficile. Totally different. So do not disturb, do not confuse. Yes, Babes Earns granules. You're correct. चलो लिख देते हैं Babes Earns. तुमको मन कर रहा है तो लिखने का। ठीक है। Pseudomembranous pharyngitis. ये क्या है? ब्लैक कलर्ड कॉलोनीज किस पे दिख रही हैं? KTBA, PTA भी बोलते हैं इसको, पोटेशियम टेल्यूराइट ब्लड अगार। क्या है ये? इट इज अ सेलेक्टिव मीडियम फॉर कोराइनीबैक्टीरियम डिप्थेरी। सेलेक्टिव मीडियम है ना? और क्या है इसका सेलेक्टिव मीडियम? LSS, लॉफलर्स सीरम स्लोप। इट इज एन एनरिच्ड मीडियम। अब क्या है इसका? स्टेरिलाइजेशन प्रोसेस, टिंडलाइजेशन और इंस्पिजेशन। ठीक है, विच इज इंटरमीडिएट लेवल ऑफ हीट बेस्ड स्टेरिलाइजेशन। और कुछ जानना है आपको इसके बारे में? टॉक्सिन्स के बारे में बात कर लेते हैं. डिप्थीरिया टॉक्सिन इज प्रोड्यूस्ड बाय Corynebacterium diphtheria, no problem. What is the mechanism of action? ADP ribosylation of elongation factor 2, ultimately leading to inhibition of protein synthesis. Yes. Same mechanism is shared by whom? Exotoxin A, produced by Pseudomonas aeruginosa. Pseudomonas aeruginosa. Tetanus toxin. It is also called as titanospasmin. Titanospasmin. Clostridium tetani. Clostridium tetani. Mechanism of action causes spastic paralysis. So inhibits the inhibitor. Inhibits GABA glycine. So it leads to spastic paralysis. Spastic paralysis. Alex gel precipitation. Wow. Very nice. Very nice. Very nice, guys. Corynebacterium diphtheria के लिए हम करते हैं Alex gel precipitation reaction to see toxin demonstration, to see the toxinogenicity. कि ठीक है, Corynebacterium diphtheria तो है, but is it even toxigenic? Does it even produce toxins? Alex gel precipitation reaction. Good, cool, awesome, very nice. Botulinum toxin, Clostridium botulinum. This will lead to flaccid paralysis. So it has to inhibit what? It has to inhibit the stimulators. So it will inhibit the acetylcholine. Acetylcholine, ACH. Schick test. Schick test बता दो जरा क्या होता है? Schick test. Which type of hypersensitivity is Schick test? Come on, tell me. चलो आगे बढ़े. Labile toxin and stable toxin. कौन प्रोड्यूस करेगा? ई कोलाई. ई कोलाई. ई कोलाई का लेबाइल टॉक्सिन एंटेरोटॉक्सिजेनिक ई कोलाई से होगा. स्टेबल टॉक्सिन एंटेरोटॉक्सिजेनिक ई कोलाई से ही होगा. दिस विल इंक्रीज कैम्प. दिस विल इंक्रीज कैम्प by binding to which receptor? GM1 ganglioside. GM1 नंबर 1. स्टेबल टॉक्सिन शांत है थोड़ा सा. क्या? साइक्लिक GMP. GMP ये क्या है? शीगा लाइक टॉक्सिन. और इट कैन ऑल्सो बी द वीरोसाइटोटॉक्सिन. अभी जो देखा था फाज कोडेड टॉक्सिन वाला, कौन करेगा? शिगेला. और कौन कर सकता है इसको अदर देन शिगेला? एंटेरोहेमेराजिक ई कोलाई अभी देखा था ना. ये क्या करेगा? ये भी आपका कैंप को बढ़ा देगा, जस्ट लाइक द लेबाइल टॉक्सिन. It will also increase the it will inhibit protein synthesis. I'm sorry, guys. Virocytotoxin will inhibit protein synthesis. How? By binding to the 60S ribosomal unit. Inhibit protein synthesis by inhibiting 60S ribosomal subunit. ठीक है. कॉलरा टॉक्सिन क्या करता है? सीटी टॉक्सिन. ये बढ़ाता है कैंप. इसका रिसेप्टर सेम है, GM1 गैंग्लियोसाइट रिसेप्टर सेम है. ठीक है. कौन है? विब्रियो कॉलरी. नो प्रॉब्लम. अल्फा टॉक्सिन कौन प्रोड्यूस करता है? अल्फा टॉक्सिन प्रोड्यूस करता है क्लोस्ट्रिडियम परफ्रिंजेंस विच कॉजेज गैस गैंग्रीन. गैस गैंग्रीन ये क्या करेगा? मायोनेक्रोसिस. ये टिश्यू का ब्रेक डाउन करेगा. इट्स मैकेनिज्म ऑफ एक्शन इज मायोनेक्रोसिस. एंड यू नो व्हाट डज दिस अल्फा टॉक्सिन डू? दिस अल्फा टॉक्सिन प्रोड्यूसेस लेसिथिनेज. Produces lecithinase. This lecithinase detection I will do in the form of Nagler's reaction. तो एक काम करें, पहले Nagler's reaction पे चलते हैं. तो 26 पे चलते हैं पहले. What is this happening here? This is called as Nagler's reaction. Test of susceptibility, botulinum snare. क्या बात है. Very nice, guys. नेगलर्स रिएक्शन किसमें होता है? क्लोस्ट्रिडियम परफ्रिंजेंस। अच्छा, क्लोस्ट्रिडियम परफ्रिंजेंस क्या करेगा? गैस गैंग्रीन। तो हम गैस गैंग्रीन से एक बात याद रख लेंगे इसके बारे में, इट विल गिव मी द स्टॉर्मी क्लॉट रिएक्शन। स्टॉर्मी क्लॉट रिएक्शन, it will look like the टेस्ट ट्यूब में, लिटमस मिल्क टेस्ट ट्यूब में स्टॉर्मी क्लॉट हो गया है। किसके अंदर? लिटमस मिल्क टेस्ट के अंदर स्टॉर्मी क्लॉट आ गया। नेगलर्स रिएक्शन क्या है? प्लेट को डिवाइड किया, यहाँ पे एंटीटॉक्सिन डाला, यहाँ पे एंटीटॉक्सिन नहीं डाला। ओके, देयर इज नो एंटीटॉक्सिन हियर। ओपेसिटी इज प्रेजेंट, meaning alpha toxin present. Okay, now if we put antitoxin, alpha toxin removed, so opacity vanishes, meaning positive test. Okay, that means it was producing a toxin and the antitoxin has totally vanished the opacity. Negelar reaction क्यों आ रही थी opacity? Lecithinase production की वजह से। Where was lecithinase formed? By the alpha toxin. So Clostridium perfringens का alpha toxin produces lecithinase which gives opacity onto the agar medium. If I put antitoxin on one side, the alpha toxin will be inhibited, so lecithinase will not be produced, so opacity is not going to be seen, it will vanish, which will be called as the positive test. Simple. Okay. It also shows me on blood agar the very important double zone of hemolysis, double zone of beta hemolysis, and that is called as the target hemolysis, What is it? It is an anaerobe only, na? I hope guys you remember that this is an anaerobe. Clostridium species are spore forming anaerobic bacteria. These are spore forming anaerobes, Clostridium species, right? So this spore forming anaerobe will give me what? Subterminal spores. Okay? This will give me subterminal spores. But inside tissues, it gives me the boxcar appearance. Matlab in the tissues, it will be just gram-positive bacilli like dabba, like boxes. Okay, boxcar appearance also can be called as, boxcar is actually malgadi. You know the old trains which are like box dabbas, they are called boxcar. So it gives me the boxcar appearance, and importantly, it will give me reverse camp. So camp was boot camp, group B streptococcus, but reverse camp test is given to me by Clostridium perfringens. ठीक है, डन. ओके, ऑलराइट. इधर आते हैं वापस. आर स्माइलिंग अंकल. What is this called as? He's not smiling. He's stuck in a position of grin. Rhizus sardonicus. Happening because of Clostridium tetani. What is Clostridium tetani? Gram-positive bacteria with oval round spores. This is called as drumstick appearance. जो हम drums बजाते हैं, the drums we play, the sticks, they look like this ना. So the drumstick appearance of the bacteria. Okay, drumstick appearance. ठीक है. Terminal round bulging spores. All Clostridium species are bulging spores. So what is this? Terminal round bulging spore giving me the drumstick appearance, right? अभी हमने देख लिया, it is because of the tetanospasmin toxin. How do we transport this? In the RCM broth, Robertson cooked meat broth or Robertson cooked meat medium. This gives me the proteolytic reaction or the black color turning of the RCM broth, and the saccharolytic reaction is given, that is the red turning of the broth is given by Clostridium perfringens, Clostridium perfringens, okay. And tetanus, remember, bichara, PPT on Mars, PPT on Mars, so it will show me the swarming, T for tetany, swarming on blood agar, it will show me. And you give the toxoid vaccine which is created by the toxin of the your Clostridium tet, ठीक है. और कुछ रह गया इसमें? Rhizus sardonicus is a complication. Another important complication is complications are Rhizus sardonicus and opisthotonus. Like a bow-shaped body which is stuck in that position. Let's move ahead quickly. What is this? Bacillus anthracis. Bacillus anthracis causes anthrax. Bacillus anthracis is an obligate aerobe. Anthrax can be of two important types. There can be the cutaneous anthrax, which we called as Hyde Porter's disease. So every time you get a history of somebody who deals with beef skin, cow, cattle handlers, milk producers, so, and they tell you that a black eschar is formed on the skin, that is called as Hyde Porter's disease, the black eschar formation which you are going to see on the skin. The most deadly and dangerous and the one which can be used as a bioterrorism is pulmonary anthrax. Pulmonary, which can become bioterrorism category agent also. Pulmonary anthrax, also called as wool sorter's disease. The people who are sorting the wool all the time, the spores of Bacillus anthracis float about and they can enter in their respiratory tract. So this becomes wool sorter's disease. Wool sorter's disease. Okay, pulmonary anthrax, which can also be a bioterrorism agent. Also, what is important about Bacillus anthracis, that the capsule, I always tell you that the capsule of all bacteria is polysaccharide, sugars, nice and sweet. There are two gym buddies who like to go to gym together. Bacillus anthracis, the big A, the biggest bacteria ever, and Yersinia pestis. Now the people who go to the gym, they need to eat lots of protein. So sugar will not work for Bacillus anthracis. So it has to have a protein capsule. So the capsule is made up of protein. So Yersinia pestis and Bacillus anthracis are the only bacteria with a protein capsule made up of polydglutamate. Okay? No problem. The polydglutamate. And so Hyde Porter's is carcass of dead animals, wool of dead animals, capsule is there, it's an obligate aerobe. और आप लोग क्या लिख रहे हो? Medusa head colonies. Medusa head colonies, very nicely said about Bacillus anthracis. When you see the growth on the agar, you see Medusa head colonies. Which to demonstrate the capsule, which stain am I using? McFadden stain, wherein I see the blue bacteria with the purple capsule, right? What is this? This is, what kind of a stain am I using? Polychrome methylene blue. Yes, the McFadden stain. And non-motile. Of course, it is non-motile because it is called as the big A. Big A. It is such a big and brawny bacteria that it is not able to move about. So it's slow, sluggish, non-motile, obligate aerobe, non-motile. Okay? No flagella it has. And McFadden stain. And like you said, Medusa head colonies. Okay? Great. Awesome. Nice, guys. Nice to see that you are also getting involved. अब ये क्या है? Green colored agar plate with yellow and green colonies. Yellow is lactose fermenter and green is non-lactose fermenter. What is this? Urine specific clade agar for all the uropathogens. What does cysteine do? It gives me dwarf colonies, small colonies. What does lactose do? It helps me differentiate between lactose fermenter and non-fermenter. What is ED? ED is electrolyte deficient. What is electrolyte deficient doing? It is inhibiting the swarming of Proteus. Swarming of Proteus, because Proteus is an important uropathogen. If some patient has Proteus in their urine, Proteus will swarm on the entire plate. Now other patient samples will go bad, so I don't want that to happen. So this is the CLED agar. What is the indicator used? Bromothymol green, bromothymol green or bromothymol blue, which at alkaline pH is green. So if it is alkaline, it is green. So of course your non-lactose fermenter, lactose not eaten, no acid produced, green colored colonies. If lactose fermenter, lactose eaten, acid produced, you are going to get yellow colonies. So what is the indicator? Bromothymol green. Another agar which looks exactly like this and is also green, let's go to 2 pages down, guys. Let's go 2 pages down. It is TCBS. This is also green agar. What is TCBS? Thiosulfate citrate, bile salt, sucrose, agar. So it's such a long name. Don't stop anywhere you want to stop. Just keep on saying. Thiosulfate, citrate, bile salt, agar. You see the yellow colonies. Yellow colonies are of Vibrio cholerae. Yellow colonies are of Vibrio cholerae. And the green colonies are of Vibrio parahemolyticus. But just know that Vibrio cholerae gives me the yellow color. Why? Because the bile salt is going to selectively inhibit it, and it's an it is a selective medium. So the yellow colony is because of the sucrose fermentation. The sucrose fermentation by Vibrio cholerae is giving me the yellow colored colonies, right? What is the transport media, selective media for Vibrio cholerae? It loves alkaline pH. So alkaline peptone water, autoclaved sea water, Venkatraman Ramakrishnan medium, VR medium, and Monsieur's telluride taurochlorate bile salt sulfate agar. Okay, MTTBA. ठीक है, कोई बात नहीं, छोड़ दो. तो ग्रीन से याद रखना दो, TCBS एंड क्लेड. तो याद रख लेंगे ग्रीन से. अब नीचे आ जाते हैं, क्या दिख रहा है ये? इंडोल टेस्ट, इम, MR, VP, सिट्रेट, इम, विक. पिंक इज पॉजिटिव, रेड इज पॉजिटिव, VP रेड इज पॉजिटिव, सिट्रेट ब्लू इज पॉजिटिव. ठीक है, हमेशा इमविक के लिए 2 इंपॉर्टेंट बस ऑर्गेनिज्म याद कर लेंगे, बाकी सब इतने जरूरी नहीं होते हैं. ई कोलाई एंड क्लेब्शियला निमोनी. क्लेब्शियला निमोनी क्या है तुम्हारा? कैप्सुलेटेड है ना. इमविक प्लस प्लस माइनस 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 प्लस प्लस. सिंपल सी बात याद हो गई हमको. ठीक है, इकोलाई जैसे ही बोलेंगे, एक लैक्टोज फर्मेंटर है जो इंडोल पॉजिटिव है, MR पॉजिटिव है, हमारा इकोलाई हो गया. एक लैक्टोज फर्मेंटर है जो कि म्यूकॉइड कॉलोनीज देता है. क्यों म्यूकॉइड देता है? क्योंकि इसके पास कैप्सूल है. इट हैज द कैप्सूल इज हाइग्रोस्कोपिक इन नेचर. सो कैप्सूल एब्जॉर्ब्स ऑल द वाटर and therefore it gives the mucoid colonies. So string test colonies and indole negative and MR negative, but citrate positive. So this becomes your Klebsiella pneumoniae. Isko in fact I tell you to remember at MVQ plus plus minus 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 plus plus plus, because urease is also an important differentiating factor between the two. ठीक है, सिंपल सी बात हो गई कवर. अब डायरिया जेनिक इकोलाई. डायरिया जेनिक इकोलाई कौन कौन सा डायरिया करता है? डायरियाजेनिक इकोलाई, एंटेरोपैथोजेनिक इकोलाई, एंटेरोटॉक्सिजेनिक इकोलाई, एंटेरोहेमोरैजिक इकोलाई, एंटेरोइन्वेजिव इकोलाई, एंटेरोएग्रीगेटिव इकोलाई, एंड डिफ्यूजली एडहेरेंट इकोलाई. Enteropathogenic, P for peds, so it causes infantile diarrhea. Okay. अटैचमेंट इफेसमेंट टाइप लीजन्स. अटैचमेंट इफेसमेंट मतलब क्या किया? बस जाके ऊपर बैठा एंड वहां का शेप बिगाड़ दिया, चेंजेस द शेप. अटैचमेंट इफेसमेंट टाइप लीजन्स. ETEC, T फॉर टॉक्सिजेनिक एंड T फॉर ट्रैवलर्स डायरिया. ठीक है, EHEC, enterohemorrhagic O157H7 also leads to hemorrhagic uremic syndrome, HUS. Konsa toxin, verocytotoxin, also called as Shiga-like toxin. Enteroinvasive E. coli, the virulence marker antigen. Enteroaggregative stable toxin 1. This can also lead to traveler's diarrhea. Diffusely adherent, just diffusely adheres to those places. Okay? Hemorrhagic colitis can happen. So wherever there is blood, then enterohemorrhagic. So dysentery, important causes enterohemorrhagic E. coli. EHEC is an important cause of dysentery. What is happening here? Vibrio cholerae we had started talking about. We were saying that TCBS, yellow colored colonies we are seeing on Vibrio colony. Now there are two types of biotypes. You have the of the O1 strain, you have the LTOR and the classical biotype. How to remember the differences? LTOR can also actually be called as THOR. LTOR. I think we've lost so much time just lagging only. Are we back? Yeah, okay, we are back. Chalo. Halophilic vibrios. Very nice mnemonic we have. People vacation in Andaman. People vacation in Andaman. Halophilic vibrios. Obviously, vibrios which love salt. So the vibrios you're going to find in salty water. Vibrios you're going to find near seas. So where is sea present? In Andaman. Where do people go to vacation? In the Andaman. So the three important species of halophilic vibrios or salt-loving vibrios is Vibrio parahemolyticus. Vibrio parahemolyticus. V for vacation. V for Vibrio vulnificus. A for Vibrio alginolyticus. Yes. Another reason why we are remembering it in this format is how much salt is tolerated by them. Salt percentage tolerated by them. 7% by parahemolyticus, 8% by vulnificus, 10% by alginolyticus. So alginolyticus is actually the most salt tolerant or the most halophilic out of all of these. Vulnificus is also called as wound maker. So you get skin and soft tissue infections with vulnificus. Alginolyticus gives you the swimmer's ear. So ear infections, alginolyticus. What does parahemolyticus do? Actually, parahemolyticus gives you dysentery. When you eat oysters and seafood, so you'll go to Andaman, you'll eat seafood and your people, so you will get Vibrio parahemolyticus. Remember the mnemonic Bichara PPT on Mars, second P was parahemolyticus. So this is showing me swarming, and this is actually showing me that on TCBS it does not give me yellow colonies. On TCBS, not yellow but green colonies it will give me. So that is how I am able to differentiate between Vibrio colony and Vibrio parahemolyticus, right? And it will not show me darting. No darting motility is shown. So darting is only Vibrio cholerae, not Vibrio parahemolyticus. They can give you this to confuse you in exam. Okay, just because your brain is so trained to mark Vibrio, the moment you look at darting, you want to mark any Vibrio they give you for darting. So don't mark Vibrio parahemolyticus for darting. It is only and only Vibrio cholerae. Campylobacter also, but amongst the Vibrio, not parahemolyticus. No darting is shown by it. Then, what is the important phenomenon shown by the parahemolyticus? It is the Kanagawa phenomenon on Vagatsuma agar. What is it? It simply means an alkaline blood agar on which you are seeing the beta hemolysis. alkaline blood agar in which you are seeing the beta hemolysis. That is all that is meant by Kanagawa phenomenon on Vagatsuma agar. Already हमने boring triplets की बात करी, spirochetes आ रही है और boring triplets बेचारा. boring triplets में कौन कौन आया आपका? बोरीलिया. बोरीलिया कौन सा बोरीलिया? बोरीलिया 3 है. बोरीलिया बर्गडॉर्फेरी, बोरीलिया बर्गडॉर्फेरी यानी कि बीबी. बीबी गाना गाने वाला बेबी जस्टिन बीबर, क्या हुआ था उसको? लाइम डिजीज. लाइम डिजीज जस्टिन बीबर से याद रख लेंगे. लाइम डिजीज कैसा है? टिक बॉर्न, टिक से होता है. बोरीलिया बर्गडॉर्फेरी. बोरीलिया रेकरेंटिस बार बार हो रहा है, रिलैप्सिंग है, तो यानी कि रिलैप्सिंग फीवर. रिलैप्सिंग फीवर, रिलैप्सिंग फीवर. और क्या है? बोरीलिया विंसेंटाई, क्या करेगा? विंसेंट इंजाइना, विंसेंट इंजाइना. बोरिंग ट्रिपलेट्स, ट्रिप ट्रीपोनीमा, ट्रीपोनीमा. अब ट्रीपोनीमा पैलिडम, अगर पैलिडम है तो क्या करेगा? सिफिलिस. नो प्रॉब्लम, इट विल कॉज मी सिफिलिस. व्हाट इफ इट इज ट्रीपोनीमा पर्ट्यूनी, पर्ट्यूनी. व्हाट इफ इट इज ट्रीपोनीमा एंडेमिकम? व्हाट इफ इट इज ट्रीपोनीमा केरेटियम? आप बताओ क्या होगा भाई? पर्ट्यूनी मतलब कि आपको हो गया यॉज, इट्स अ स्किन एंड सबक्यूटेनियस टिश्यू इन्फेक्शन. केरेटियम आपको हो गया है पिंटा. एंडेमिकम मतलब अब है एंडेमिक सिफिलिस. ठीक है. फिर हमारा बहुत इंपॉर्टेंट लेप्ट, बोरिंग ट्रिपलेट, लेट लेप्टोस्पायरा. लेप्टोस्पायरा, लेप्टोस्पायरा क्या करेगा आपको? आर 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 रेन राइस फील्ड रैट यूरिन, रेन राइस फील्ड रैट यूरिन यानी कि व्हील्स डिजीज. व्हील्स डिजीज क्या था? हिपैटो रीनल हेमराजिक फीवर. इक्टरस होगा, जॉन्डिस होगा, हेमरेज होगा, किडनी फेलियर होगा, लिवर फेलियर होगा. अगर आपको कोई मिले सैनिटेशन वर्कर एक्सपोज टू रैट यूरिन, राइस पैडी फील्ड फार्मर, रेन लिविंग पर्सन, अंडमान इनहैबिटिंग पर्सन, अंडमान हेमराजिक फीवर, अंडमान हेमराजिक फीवर. उसको क्या हुआ? जॉन्डिस हुआ, स्क्लीरा हुआ, एक्टरस हुआ, उसका लिवर फंक्शन चला गया, किडनी फेल हो गई. यू नो यू आर टॉकिंग अबाउट व्हील्स डिजीज. व्हील्स डिजीज कौन सा इसका कल्चर मीडिया होता है दैट वी यूज? EMJH, EMJH, एलिंगोसन मैकॉलफ जॉनसन हैरिस, एलिंगोसन मैकॉलफ जॉनसन हैरिस और Korthoff's. Korthoff's medium is the culture medium. But what is the test which we do for it? MAT, microscopic agglutination test. Everyone knows the famous mnemonic. Cat sat on a mat with my brother Lee. Cat sat on a mat with my brother Lee. So cat is mycoplasma. Sat is brother. Standard agglutination test is brucellosis. And Lee is leptospira and it is MAT, microscopic agglutination test. फिर से लैगिंग है क्या? नहीं, अभी तो लैगिंग नहीं है. ओके. 28-year-old man presents with painless ulcer on his genitalia. There is no history of trauma. On examination, ulcer has indurated edges and a clean base. Regional lymphadenopathy is present but non-tender. Most likely diagnosis. बता दो जल्दी से chat box. Come on. इंड्यूरेटेड पेनलेस अल्सर, बात ही खत्म हो गई. 1 सेकेंड में आंसर निकलना चाहिए. इंड्यूरेटेड पेनलेस अल्सर. सिफिलिस. सिफिलिस कौन सा? प्राइमरी सिफिलिस. इंड्यूरेटेड अल्सर बन रहा है ना. अच्छा, शैंक्रोइड किससे होता है? हीमोफिलिस ड्यूक्री. हर्पीस जेनिटैलिस, हर्पीस सिंप्लेक्स वायरस. लिम्फोग्रानुलोमा वेनेरियम, LGV, 3 letters, 1 2 3, 3 letters. So L1 L2 L3. What? Chlamydia trachomatis. LGV 1 2 3 L1 L2 L3 क्लेमाइडिया ट्रैकोमैटिस। ठीक है, एक और आपका इंपॉर्टेंट होता है यहाँ पे डोनोवनोसिस। डोनोवनोसिस कॉज्ड बाय क्लेप्शियला ग्रैन्युलोमेटिस। ग्रैन्युलोमेटिस ग्रैन्युलोमेटिस। एच ड्यूक्री सेफ्टी पिन अपीयरेंस। क्लेप्शियला ग्रैन्युलोमेटिस सेफ्टी पिन अपीयरेंस याद करो, कैन बी वेरी हाई यील्ड। सेफ्टी पिन अपीयरेंस, ठीक है, सेफ्टी पिन अपीयरेंस। सेफ्टी पिन बाइपोलर, ये भी है सेफ्टी पिन बाइपोलर स्टेनिंग। ठीक है, अब कैसे याद करें जेनाइटल अल्सर्स? देर इज अ वेरी वेरी इजी वे टू रिमेंबर जेनाइटल अल्सर्स। जेनाइटल अल्सर में सबसे पहले तो तुम बताओ कि जो जेनाइटल अल्सर है, इज इट पेनलेस और इज इट पेनफुल? If the genital ulcer is painless, then how are the lymph nodes? Are the lymph nodes painless? So meaning both painless, or the lymph nodes are painful, meaning ulcer is not important, ulcer is painless, but the lymph nodes are very important, lymph nodes are very very painful. And whenever there is a painful ulcer, the lymph node is actually always painful. So both painful, only lymph node important, or nothing, both are not there. So your prototype of this is syphilis only always. And then you can remember dono nahi. Okay, you don't want this much Hindi also. So dono nahi, meaning both are not there. No pain in ulcer, no pain in lymph node. So dono nahi, dono vani, dono vanosis, दोनों नहीं दोनों वनी। ओके, डोनोवनोसिस। पेनफुल लिम्फ नोड, ओनली लिम्फ नोड पे फोकस हो रहा है यहाँ पे। लिम्फो ग्रैन्युलोमा वेनेरियम, ओनली लिम्फ नोड इज इंपॉर्टेंट राइट नाउ। अल्सर इज नॉट इवन दैट इंपॉर्टेंट एनीमोर। सो लिम्फो ग्रैन्युलोमा वेनेरियम, whenever there is painful lymph node and painful this thing ulcer, then if it can be chancroid or genital herpes. So if it is chancroid, it has the O sound, then it is unilateral ulcer and unilateral bubo. Bubo means painful lymph node. Only one side of bubo and only one side of ulcer. O sound, oid. And if it is genital herpes, how many words? 2 words. So this one is bilateral lymph node and bilateral multiple painful vesicles ulcers, multiple vesicular ulcers, and both will be your painful and bilateral. ठीक है, इजी हो गया ना बहुत कुछ। एक और चीज, डोनोवनोसिस, बीफी रेड अल्सर, all of those which have the D sound will have blood involved. Beefy red ulcer and chancroid bleeds on touch. So we also call it soft chancre. And syphilis we call as hard chancre. Okay, all the genital ulcers summed up very nicely and very easily. Now if they ask us any permutation combination, we can talk to them about these permutations and combinations. Let's look at this guy. What are we seeing here? We are seeing the fried egg colonies. Fried egg colonies, which are actually microscopic. They are 300 micrometer in size. Now it can be mycoplasma. So it can be Mycoplasma pneumoniae. It will cause your atypical pneumonia, walking, talking pneumonia. There will be pneumonia, but patient will come walking to you into your OPD. And it can be Mycoplasma genitalium. which will cause genital diseases, right? Urea plasma, urealyticum is also the same. What is this agar where it is showing these fried egg colonies? This is PPLO agar, pneumonia-like organism, because this has no shape. It has no cell wall. Mycoplasma has no cell wall. It has sterols in its cell wall. It has cholesterol in its cell wall, which gives sturdity. So PPLO agar. Another stain which is used is Dine's stain. For Mycoplasma pneumoniae, it is Dine's stain. So remember, Dine's stain is for Mycoplasma. But another phenomenon is called as, let's divide it here. Phenomenon is called as Dine's phenomenon. Dine's phenomenon. That is shown by Proteus. So if there is one strain of Proteus which is swarming onto the plate, just next to it if I put another strain of Proteus which is also swarming, the two swarms while coming together will never touch. There will always be a gap between the two. This gap is called as Dine's phenomenon, which is shown by Proteus. Okay, done? Great. Very clear, ma'am. Okay, very nice. Okay, so 10-year-old child from Dehradun. Look at this. So we are talking about scrubby vegetations. Uttarakhand presents with 5-day history of fever, abdominal pain, vomiting, painless black eschar. The moment you see painless black eschar, you either think of anthrax or you think of scrub typhus So behind the left ear, lab investigation revealed thrombocytopenia and elevated liver enzymes. Which of the following is likely diagnosis? Dengue fever, no, black eschar. Scrub typhus, black eschar possible. Leptospirosis, elevated liver enzyme possible. Typhoid fever. So actually the answer becomes scrub typhus. Scrub typhus. Scrub typhus where you get the black eschar. This is also called as chiggerosis. This is also called as chiggerosis because it is not the bite of the mite. It is the bite of chiggers or chigger bites. Yes, chigger bites. What is the test we do for diagnosis of scrub typhus? We do the Wheal-Felix test. Wheal-Felix test or Wheal-Felix reaction. What is it? It is a type of a heterophile antigen. And how do we remember? We have the mnemonic Mira scrub. So there is a girl called Mira. You're asking her, okay Mira, now you scrub. So this is your mnemonic, that the OX-K antigen of Proteus mirabilis cross reacts with scrub typhus. Got it, guys? The OX-K antigen of Proteus mirabilis cross reacts with scrub typhus. Then the OX2 and the OX19 is for all the other rickettsial group. So OX-K is scrub typhus and OX-K belongs to Proteus mirabilis. Then OX2 and OX19 will go to Proteus vulgaris and that will go to the other rickettsial group. So now we talk about the rickettsial group, and I always tell you to remember the rickettsial railway station. What is happening in the rickettsial railway station? There are two trains, typhus train and there is the spotted fever express. For spotted fever express में हो रहा है Rocky Mountain spotted fever and Indian tick typhus. Rocky Mountain spotted fever and Indian tick typhus. Spotted fever express pe there is a guy who's Rocky, he's American, he's climbed. Along with him an Indian prince has also climbed up. So what will happen with ticks? From ticks, what will happen? Ticks se ho jayega Rocky Mountain spotted fever and Indian tick typhus. Indian tick typhus is Indian prince. So Rickettsia conori, crown prince hai na, conori. And for Rocky Mountain spotted fever, we always remember Rick mountain tick. So what is rick? Rickettsia rickettsii. Rickettsia rickettsii. Okay, so remember these two together. Then on the typhus strain, there is a soldier who's pro-war. This is a soldier who is pro-war. So if he is pro-war, it is Rickettsia provasicae. And there is a rat infested with rat fleas, and he is a tough rat. A tough rat. So it is Rickettsia typhi. Rickettsia typhi. Okay, so you all know when the soldiers, they live in crowded conditions. They live in crowded conditions, so they will lead to lice or head louse. So Rickettsia provasicae, which is, and I always tell you, louse will always lead to epidemics. Whenever in school one child got the louse, a whole school got the louse. Okay, and the pro-war soldier who's living in the crowded places, he's lice infested, he has lots of lice in his hair, so this will lead to epidemic typhus. Epidemic typhus. Okay, this is soldier. Pro-war, Rickettsia provasicae, epidemic typhus. Then Rickettsia typhi is caused by the tough rat, which is rat infested. It has the rat flea. So then this will lead to endemic typhus. No problem for me to now remember that endemic typhus. So if they ask you endemic typhus, just remember the rat flea and remember the tough rat. So Rickettsia typhi. If they ask you epidemic typhus, just remember the pro-war soldier. War hai to lice hoga, so louse born, and it is epidemic typhus. The moment they say Rocky Mountain spotted fever, you have to talk about rick mountain tick. And which rat flea is this? Which rat flea? Xenopsilla chiopis. What else does Xenopsilla chiopis cause? It also causes the bubonic plague. Bubonic plague, which is by Yersinia pestis, है ना? Yersinia pestis. ठीक है, चलो फिनिश्ड. बहुत सारा पढ़ा बैक्टीरियो, बहुत सारा बैक्टीरियो पढ़ लिया. अब क्या करें, थोड़ा सा जल्दी से वी विल टॉक अबाउट पैरासाइट्स एंड सम इंपॉर्टेंट वायरसेस. जल्दी से. 35-year-old male presents with abdominal pain, bloody diarrhea, weight loss of 2 weeks. On stool microscopy, trophozoites with ingested red blood cells are seen. Which of the following treatment true about the causative organism? Produces cysts that are quadrinucleate and infectious. It is a flagellated protozoan. Does not invade tissues. Causes intestinal disease and no extraintestinal manifestations. बता दो क्या लग रहा है आपको? Trophozoites with ingested red blood cells. मतलब कि we are definitely talking about Entamoeba histolytica. है ना? Entamoeba histolytica we are talking about. अब क्या हो रहा है इसमें? क्वाड्रीन्यूक्लिएटेड है. ठीक है. Flagellated protozoan. Is it a flagellated protozoan? No, it is an amoeba. It has pseudopodia. Then does it not invade tissues? It invades the tissues. Na? Its name is histolytica. Intestinal disease, no extraintestinal. Of course, it leads to what? It leads to amoebic liver abscess. ALA it leads to. So which of the following is true? Then the first one, cysts are quadrinucleate and quadrinucleate cysts are what is infectious. So ये देख लो, ये आपका trophozoite होता है with the ingested RBCs, and this is a cyst with the quadrinucleate and the single nucleus. Yes, so now the cysts of Entamoeba histolytica and Entamoeba dispar, Entamoeba Bangladeshi, they cannot be differentiated from each other, right? So based on the stool microscopy, we can only say that this is Entamoeba. Mostly it is Entamoeba histolytica only. अब बताओ, amoebic liver एप्सिस अगर करेगा, अमीबिक लिवर एप्सिस ALA अगर करेगा, तो उसमें कैसा दिखेगा आपको? फ्लास्क शेप्ड अल्सर्स विल कम ना, फ्लास्क शेप्ड अल्सर्स विल कम, एंड ऑल्सो एंकोवी सॉस पस. जैसे एंचोवी सॉस होती है तो एंकोवी सॉस पस फ्लास शेप अल्सर्स एनी ऑफ दिस यू गेट इन द हिस्ट्री यू नो दे आर टॉकिंग अबाउट amoebic liver abscess caused by Entamoeba histolytica. जल्दी से चलते हैं. 20-year-old male presents with history of swimming in freshwater lake. Few days later, he develops high-grade fever, headache, photophobia, and neck stiffness is also there. So now meningitis or kind of a encephalitis. मतलब कि brain involvement is happening, rapidly deteriorates and dies. Immediately fatal, quickly fatal. Naegleria fowleri has been identified. Obviously, it leads to what? Primary amoebic meningoencephalitis. Which of the following statement is true regarding Naegleria fowleri? Causes chronic meningoencephalitis in immunocompromised? No, competent. That's the point about it. It is highly fatal. Free living amoeba that enters through the GI tract? No, it enters through inhalation or through the cribriform plate. Yes, causes primary amoebic encephalitis by entering through nasal mucosa. This looks like a correct thing to me. Is it a ciliated protozoa? No, it is not ciliated. It is also amoeba. So it also has pseudopodia. It has the lobopodia. So which is the correct answer? C. Causes primary amoebic encephalitis. Let's look at Naegleria fowleri. This is the amoeboid trophozoite with this lobopodia. It has the flagellate form also, but no cilia are there. And then the cyst form. Keeps interchanging between the two. And the who's the best friend of these free living amoeba? What are these? These are all free living amoeba. So two important free living amoeba, Naegleria fowleri and Acanthamoeba. ठीक है. अब अकैंथामीबा के पास क्या है? स्पाइन्स हैं, स्पाइन्स, एंड इट हैज द डबल वॉल्ड रिंकल्ड. सो डबल रिंकल्ड cyst and the spines in trophozoite. ठीक है. This becomes Acanthamoeba. Acanthamoeba causes granulomatous amoebic encephalitis. It causes a chronic infection. It will take a long time. Whereas this primary amoebic encephalitis is immediately fatal. Within 12 days, the patient will die only. What else will Acanthamoeba cause? One very important disease that Acanthamoeba causes. Come on. Contact lens keratitis. ठीक है. Contact lens keratitis. Correct बोल रहे हो? C. Correct. Right? Awesome, guys. You're doing very well. I know it's 9:30, but you're going very, very strong. I think we'll be able to finish very, very quickly now. So just stay strong. लगे रहो, बहुत अच्छा कर रहे हो. 45-year-old pig farmer. क्या बोला? Presents with abdominal pain and bloody diarrhea. Stool microscopy reveals large ciliated trophozoites with a kidney-shaped macronucleus. यहाँ पे वर्ड है पिग, यहाँ पे है किडनी शेप्ड मैक्रोन्यूक्लियस. मोस्ट लाइकली कॉजेटिव ऑर्गेनिज्म. जियार्डिया का कोई मतलब है? नहीं है. एंटामीबा का कोई मतलब है? नहीं है. बैलेंटिडियम कोलाई, मैंने हमेशा बोला है, बाल मीन्स सीलिया. ठीक है. तो बैलेंटिडियम कोलाई, दो तरह के न्यूक्लियस होते हैं, माइक्रोन्यूक्लियस एंड मैक्रोन्यूक्लियस. ठीक है, दोनों होते हैं. ये कौन है? 8 to 10 micrometers का cyst with the parabasal body and the four-eyed nucleus and the old man looking trophozoite with the pear-shaped body. कौन है ये ओल्ड मैन? दिस इज जियार्डिया लैम्बलिया और जियार्डिया डुओडिनालिस. ठीक है, जियार्डिया लैम्बलिया. क्या करेगा ये? डायरिया, वाटरी डायरिया, अपर जीआई डिजीज. एंड हमने अभी देखा ना फॉलिंग लीफ मोटिलिटी हम देख चुके हैं. व्हाट इज द बेस्ट सैंपल फॉर जियार्डिया? अप watery diarrhea, upper GI disease na, upper GI disease. So this will be duodenal aspirate. किससे लेंगे? अब एंडोस्कोप से लेंगे. पहले कैसे लेते थे? स्ट्रिंग टेस्ट. How did we used to take it earlier? String test. Give a sticky capsule to the patient to ingest. All the trophozoites will stick to the string test. String test में also what used to come positive was, one was Giardia trophozoites and another thing was strongyloids. Strongyloids stercoralis. Okay, the larvae of strongyloids stercoralis, they can all stick to it. बढ़िया. अब ये कौन है? This is not Giardia, but this is also a trophozoite with the 4 anterior flagella and the one undulating membrane attaching going till the end. One undulating long flagellum. And an exostyle. And an exostyle in the middle. What is it? Come on. Bolo. थक गए सब. T for Trichomonas vaginalis. Ab, why have I not shown a cyst says? Because T means only trophozoid. Only trophozoid. This is the guy which has no cyst stage. It has only a trophozoid stage. And what kind of a history will you find? History will be green frothy discharge. Green frothy discharge, which will be there. And you will have the strawberry cervix, macula colpitis, macularis colpitis. So, strawberry cervix. Strawberry cervix. And auntie loves diamonds. So, diamonds media. Diamonds media. Okay. And T for twitching motility also. Told you already, na? Right? Now, quickly, एक छोटी सी story सुनेंगे and very nicely in a single picture mnemonic, we will be discussing the leishmania, the trypanosoma, all the American sleeping sickness, African sleeping sickness, which causes what, how to remember so many things. Now, we will divide it into two. Okay? So, of course, you know that every time you see this kind of an image, you are talking about trypanosoma. Trypanosomiasis or trypanosoma. ठीक है? Trypanosoma or trypanosomiasis. इस तरफ चलते हैं. Who is he? He is Tom Cruise. So this will be Trypanosoma cruzi. Isn't he American? He's an American. So this becomes American sleeping sickness. American sleeping sickness because Tom Cruise is American. So American sleeping sickness is caused by Trypanosoma cruzi. American sleeping sickness is caused by Trypanosoma cruzi. ठीक है? It is also called as Chagas disease. Chagas disease. Who is she? She is Romana. Romana. Romana is a red-haired girl. She's a red-haired girl and they have fallen in love. If they have fallen in love, then this is the kissing disease. Kissing disease. She's a red-haired girl. So not kissing disease, I'm sorry. Kissing, it is spread through the kissing bug. Along with that, everything will be big. So mega colon, all of this she will get. So American sleeping sickness, summed up in one picture. Just imagine that there is Tom Cruise who's fallen in love with Romana. That's all you need. And they are going together in the Mercedes C-Class. That is all you need to remember. So Tom Cruise hai, American hai, Romana hai, red-haired hai, Reduwate, triatomine, kissing bug, benzonidazole, Chagas disease, everything covered with this little picture. ठीक है? अब इधर आते हैं. यहाँ पे कौन है? This is Bruce Lee. Now the only other disease left is actually African sleeping sickness. Now I know Bruce Lee is not African, but an important easy way to remember that the sleeping sickness is caused by the Glossina species or the Sessafly. African sleeping sickness is caused by the Glossina species or the Sessafly. Now what is happening here? Over here, your Bruce Lee is riding the G-Wagon in winters. In winters. So winter, you remember the winter bottom sign. Winter bottom sign. What is winter bottom sign? It is the post-auricular nodules which are formed. Okay. What is this? G-Wagon and Bruce Lee. Bruce Lee. So just remember Trypanosoma brucei. Trypanosoma brucei. Now which brucei? The G-Wagon. Trypanosoma brucei with the G-Wagon. So you have the Trypanosoma brucei gambiensis. Trypanosoma brucei gambiensis in winters, na? In the G-Wagon, sorry. Oh, why is it stopping? The G-Wagon. So gambiensis in West African sleeping sickness. Trypanosoma brucei gambiensis is West African sleeping sickness. So your East African sleeping sickness becomes Trypanosoma brucei rhodonensis. ठीक है. So just remember G-Wagon and Bruce Lee. So you have G-Wagon, West African sleeping sickness, Trypanosoma brucei gambiensis, and East African then obviously has to be rhodonensis, and African sleeping sickness, Glossina or Sassafly. ठीक है, Sassafly. Very, very important. Done. What is here? Very simple. The big hepatosplenomegaly with the black discoloration, काला आजार. क्या बात कर रहे हैं हम? We are talking about visceral leishmaniasis. So we are talking about Leishmania donovani. क्या दिखता है ये? बड़ा सा मैक्रोफाज है, उसके अंदर you see small little kinetoplast with the big nucleus. What are these called as? Leishman-Donovan bodies, LD bodies, seen in bone marrow. Another important test we can do for it, RK39 antibody test. All of this for leishmaniasis. What is a complication of visceral leishmaniasis? Post Kala Azar dermal leishmaniasis, PKDL, post Kala Azar dermal leishmaniasis happens in whom? When we do suramine therapy. In the people who take suramine therapy and they go and get exposed to sunlight. So that is why we give now liposomal amphotericin B is the treatment of choice. Visceral leishmaniasis is going to be caused by Leishmania donovani complex. So it has Leishmania donovani and Leishmania trichomonas. क्या लिख रहे हो बेटा? It is trypanosomiasis, not trichosomiasis, trypanosomiasis. ठीक है. Leishmania, very important. ये कौन है? तीन भाई, ये तो इनको तो सब जानते हैं. These are the coccidian parasites. In coccidian parasites में you have Cryptosporidium. ठीक है, क्रिप्टोस्पोरिडियम. फिर यहाँ पे कौन है तुम्हारा? साइक्लोस्पोरा. और यहाँ पे कौन है? सिस्टोआइसोस्पोरा. ठीक है. अब जो लंबा वाला, सबसे लंबा वाला आइसोस्पोरा और सिस्टोआइसोस्पोरा, नाम ही है. सिस्टो मीन्स सिस, आइसो मीन्स सेम. तो अंदर इसके दो सिमिलर स्पोरोसिस्ट हैं. ये इसका बिल्कुल कॉपी है और ये ओवल है. दिस इज सिस्टोआइसोस्पोरा. 2 स्पोरोसिस्ट. अंदर कितने स्पोरोजोइट? 8. इसमें कितने? 4. 1 2 3 4. 2 स्पोरोसिस्ट हैं लेकिन गोल है, तो साइक्लो, ओवल. दिस इज क्रिप्टो, हिडन, छोटा सा. इसके पास डबल वॉल भी नहीं है. इट हैज द नेकेड स्पोरोजोइड्स. ये स्पोरोजोइड्स एकदम नेकेड है, बाहर है. ये क्या होगा आपका? स्मॉल. this guy is small. It is about 5 to 6 micrometers and it is uniformly acid fast. Uniformly acid fast मतलब कि सारे all the spores are going to be red and acid fast. But this cyclospora here, it's a little big. 5 to 6 का double कर दो, 10 to 8 to 10 micrometers. 8 to 10 micrometers. This is non-uniformly acid fast. कुछ blank भी दिख रहे हैं, है ना? There is the red ones and the blank ones. So not all take acid fast in. And then this is long. This is very long. Make it double. 20 to 30 micrometer. इधर इसका width कितना? Half. 10 to 15 micrometer. This is isospora. Okay? Isospora. Very, very easy to remember now. Yes. Cryptosporidium. What is important to understand about cryptosporidium? Crypto hai, hidden hai, so no autofluorescence. The other two show autofluorescence. This one does not show autofluorescence. And also it is immediately infectious. Immediately infectious. क्योंकि क्या है? Naked है. Double cyst नहीं है इसके पास. Both of them have double cyst walls. एक sporocyst है, उसके बाहर एक बड़ा सा cyst wall है. इसके पास sporocyst नहीं है. So it is immediately infective because of the naked sporozoites which are present inside and क्या होता है? That is why, because of being immediately infective, it can lead to auto infections. ठीक है? Auto infections. Cryptosporidium can lead to auto infections out of the three. ठीक बात है. So we have just seen all of these properties. Sporulated. हाँ, अब immediately infective और क्यों होता है? क्योंकि this guy which is excreted out in the feces is sporulated oocyst comes out. इन दोनों का unsporulated आता है. Infection कराने के लिए all three have to be sporulated. You have to ingest a sporulated oocyst only, then only the sporozoites will release into your intestine. Otherwise, they will not release, right? So, infective form is sporulated oocyst for all. Diagnostic form is sporulated only for crypto. For the other two, it is unsporulated, meaning when you're passing in the feces, only cryptosporidium sporulated oocyst is coming out. दोनों बाकी दोनों का unsporulated आ रहा है. ठीक है? 4 to 6, 8 to 10, 20 to 30 हमने देख लिया. Round oval हमने देख लिया. 4 and 8 we have seen sporozoites. Uniformly acid fast variable we have just seen this. Autofluorescence also we have seen, not there. In the rest too it is there, right? Treatment: nitazoxanide and the other two cotrimoxazole. Nitazoxanide. Okay, for cryptosporidium, this you have to remember. टॉक्सोप्लाज्मा के लिए बहुत हमारा प्यारा सा एक निमोनिक होता है. टॉक्सोप्लाज्मा गोंडाई एक्चुअली कॉजेज दिस इन्फेक्शन एंड वी ऑलवेज नो दैट द कैट इज द डेफिनेटिव होस्ट. Cat is the definitive host for a Toxoplasma gondii, है ना? So we always say that this is a very important congenital toxoplasmosis. Congenital toxoplasmosis is a very, very important question. Congenital toxoplasmosis क्या होता है? Cat feces में unsporulated oocysts come out. Okay, cat feces में unsporulated oocysts come out which we can ingest. Congenital toxoplasmosis में हमेशा मैं बोलती हूँ remember a baby cat. Okay, so this is a baby cat. So a baby cat will have a big head. Big head होगा तो हम याद रख लेंगे hydrocephalus. ठीक है? अब now we will give this cat some small little dots on the head. Let's give this cat some dots on the head. What are these dots now? These dots become intracranial calcifications. ठीक है? Now let's give her red eyes. Let's give her these red colored eyes. So what is red colored eyes? It is chorioretinitis. What is this? This is the triad of congenital toxoplasmosis. ठीक है? Triad of congenital toxoplasmosis. Triad of congenital toxoplasmosis: hydrocephalus, intracranial calcifications and the chorioretinitis, the red eyes. Okay, अब ये देखो, जो ये है हमारा toxoplasmosis, इसमें बहुत important होता है. 3 stages are there. So you have the Toxoplasma gondii. It has the tachyzoid, which is the free living state. Okay, which is like this bow shaped or bow shaped like this. Okay, then you have the tissue cyst, जहाँ पे वो tissue में फंस के बैठ गया, so it is not multiplying very fast, so we can call it slow. Tachy means fast, so fast multiplying. Brady means slow, so bradyzoid is a tissue cyst, right? And then finally in the end, there is also tachyzoid, bradyzoid, and then we also have the cyst stage. The cyst stage. The cyst can be called as oocyst. Now, important thing you have to remember is freshly passed cat feces excretes unsporulated oocyst. ठीक है, unsporulated oocyst. Then this goes in the soil. In the soil it be right. So what are the when you do the detection? So yeah, you have the important malarial parasite pigments also. Malarial parasite pigments also. So for Plasmodium falciparum, you can remember which pigment is produced by Plasmodium falciparum? Anybody? No? Okay, everyone's tired. Which pigment is produced by Plasmodium falciparum? Nobody? So what is the mnemonic? Orange juice. Plasmodium ovale produces the James dots. James dots. Okay. Then what is happening? Very smart. Are we lagging? Someone's saying lagging. Lagging or not lagging? Now okay? Lagging now okay. अच्छा. ठीक है. ठीक है. Very smart. Vivax is your Schaffner's dots. Schaffner's dots. Then we have Manila Zoo. Manila Zoo. Manila Zoo. Plasmodium malari is Zeeman dots. Zeeman dots. And finally we have falciparum. So for falciparum we have it can be fatal. So the only one remaining is falciparum. For that we have, it keeps saving. For falciparum we have Morer's dots. Morer's dots. Okay. Okay. So you can imagine Manila Zoo has some fancy monkeys. So for this you can imagine fancy monkeys. Fancy monkeys. So the Manila Zoo has some fancy monkeys which are very smart and drink orange juice. So fancy monkeys, falciparum, Morer's dot, Manila Zoo, malari, Zeeman dot, very smart, Vivax Schaffner's, and ovale James. orange juice. So this is your mnemonic for remembering all the dots or pigments of malaria. Okay. Then amongst the antigen detection, if you want to do the lab diagnosis of malaria, then for antigen detection, if you want to detect plasmodium falciparum, then you can detect the histidine rich protein 2 HRP2, and you can detect the LDH, which is specific for plasmodium falciparum LDH. If you want to detect others, all the others, then you can do the pan LDH for all, and the aldolase. What are these are the rapid detection tests, or the rapid card tests, which we use for malaria. Who's the best friend of malaria? BFF of malaria. BFF of malaria is Babesia. It shows me the Maltese cross. And it is Babesia microti. Babesia microti. Okay, we are back. Okay. So what all had I covered? So I had told you that Babesia microti also shows me the Maltese cross. It is caused by the ticks. Then cestodes. Amongst the cestodes, you have the non-bile stained eggs. Neha. Remember Neha. Nicator americanus, Enterobius vermicularis, H. nana, and Ankylostoma. So hookworm, pinworm, and H. nana, they are non-bile stained. Over here, you can see the hexacanth embryo and the polar filaments and polar thickening and the non-bile stained egg. So this is H. nana's egg. Over here, you can see the operculated eggs. The operculated eggs are, हाँ बेबीसिया की बात से कर रहे हैं बेटा. So the operculated eggs are the dhakkan eggs, the eggs with the dhakkan. So all the trematodes except the schistosomes, which have the spine, schistosome, S for spine, or the knobs, and the dhakkan of the cestode family is the D-latum, who has the operculated egg of the dhakkan. Okay. Then you have this radial striations. The radial striations are present in the egg of Taenia, and you cannot differentiate between the species of Taenia and seeing the egg. So all Taenia species, Taenia saginata, Taenia solium, the eggs, they all have the same morphology, the striations which are present. Okay. Then I was talking about hydatid cyst. The hydatid cyst disease is caused by Echinococcus granulosus, which is the dog tapeworm. Here, human is the dead hand host or the intermediate host, because dog is the definitive host of this guy. This actually leads to anaphylactic reactions. That is why the treatment that we do for it is called PAIR, that is percutaneous aspiration, injection, and repair. So very slowly we go inside, aspirate out the hydrated fluid, and then fill it back with normal saline, so that the hydrated cyst can be killed. So hydrated cyst is actually the diagnostic form, actually the causing the pathogenesis. It's the pathogenic form. Okay. Hydrated cyst. Then let's talk about trematodes. We have just seen the trematodes are the operculated eggs. These are called as the flukes. The important thing you have to remember about trematodes is that they have intermediate hosts. How many? They all have two intermediate hosts. So it can be fresh plants, right? Fresh plants, or it can be your, fish. So the fresh aquatic plants is always fasciola. So Fasciola hepatica, Fasciolopsis busci, they will all have the fresh aquatic plants as the intermediate host. So one intermediate host always has to be snail, and then the second one can either be this or it can be fish. So remember, clonorchis or clonorfish is going to have fish as the intermediate host, and fresh plants is Fasciola hepatica or Fasciolopsis busci, always in the trematodes. For the trematodes, it is by the ingestion of Metacercaria larva. Ingestion of the Metacercaria larva, right? Except the schistosomes, obviously the schistosomes have the Cercaria larva, they only have snail as an intermediate host, right? So when we look at the schistosomes, they have the spines. They have these spines. So you know, schistosoma hematobium causes urinary carcinoma, and very easy to remember that it has a terminal spine. How do you remember that it has a terminal spine? If I draw the bladder, then the bladder also looks like this, na? The bladder also looks like this, like the terminal spine. So this guy also looks like this with the terminal spine. So it is easy to remember that terminal spine will be there in hematobium and japonicum. So you can say that Japanese people are cute as a button. Japanese people are cute as a button. Cute as a button. Okay, so this button or this knob which is present, this is called as schistosoma japonica. Okay, with the oval round egg which is there. Then schistosoma mansoni is the other one with the terminal spine only, right? Now amongst the schistosomes, you have to understand that all the exceptions which are there, they belong to the name schistosome only. So just write schistosomes. Okay, so SC actually means Cercaria larva and skin penetration. So while for all the trematodes it's ingestion of metacercaria larva, in schistosomes it's skin penetration by the Cercaria larva. S2, so two sexes. All trematodes have a single sex or hermaphrodite, and but schistosomes have two sexes, male and female are there. Then S means spine. So there is non-operculated eggs. All have dhakkan or operculated eggs. This has non-operculated eggs with the spine in the eggs. And then the slit-like body. There is no, these don't look like flukes. They don't look like flukes or leaf-like body. They have a slit-like body. What else? What else is the exception? Snail only, slit-like body, two sexes, skin penetration, Cercaria larva. So these are all the exceptions of schistosomes. Okay? All the exceptions of schistosomes. Yeah, and snail only. Snail only. So only one intermediate host. Only one intermediate host. Two intermediate hosts are not there in the schistosomes. ठीक है? उसके बाद ये कौन है दो? This is the egg of Ascaris. You know it. What is this? This is the unfertilized egg of Ascaris. And this is the fertilized egg of Ascaris. No problem here. The fertilized one is bigger and the unfertilized one is smaller. So the unfertilized one actually floats in saturated salt solution. Okay, these are both going to be bile stained. Then what is this with the blastomeres? The whipworm. Can you appreciate? And this is the coconut cake rectum that I was talking about. So of course trichiura with the dysentery is going to show you all of this. Come on, quickly, let's finish. Lag, फिर से lag. क्या हुआ आ गया. It's back ना. ठीक है. Okay, I think we are back. करे? Yeah. Okay, fine. What is this? Elephantiasis or lymphatic filariasis. अभी पूछ लिया था बहुत easy सा सवाल. What is the mode of action? It is actually obstruction. So this is filariasis, goes and obstructs the lymphatics. Yes. So then what are these? These are the different microfilaria of filariasis which they are showing. The different microfilaria very easily has the sheath. Wuchereria bancrofti, Brugia malai and Loa. All three are going to be sheathed. They are all going to have the sheath. Then what it depends upon the nuclei. So Wuchereria bancrofti, I can also call it as bankrupty. So if it is bankrupty, there is no nuclei. It is bankrupt, right? And if it is Brugia malai, it is bi. Bi means two. So it is going to be binucleate, two widely spaced nuclei. And if it is Loa Loa, means line of nuclei. Loa Loa means line of nuclei. So you see the column of nuclei extend to the tail tip. Okay, so that is what we are talking about. Bankruptcy, no nuclei in the tail end, two nuclei in the tail end, and line of nuclei in the tail end. And then if you don't have the sheath, no sheath, you have onchocerca and manzanella. Manzanella. Over here, can you see this? This is Loa Loa, Loa Loa, or loesis in the eyes, right? Onchocerca volvulus, what does it cause? It will river blindness, hanging groin. So onchocerca volvulus, if they tell you that we have taken the skin sample, and in the skin sample I am seeing the microfile area, then they might be talking about onchocerca volvulus. Okay, DNA viruses, the very happy viruses. Y looks like 4, so we have HAPPPP, the 4 P's. Yes, the 4 P's. So the herpes viridae, herpes viruses. Then you have the hepadina, PADNA, partial DNA, the hepatitis B virus. Only hepatitis virus which is DNA virus, also partial DNA virus. Name itself says partial DNA. Adenovirus, Papova viridae, parvovirus, pox virus, and the other P is Phage. These PAP, these 3 PAP are actually, not these 3, these 3, the PAP. क्या PAP है DNA viruses का? That they are non-enveloped. These 3 out of all are non-enveloped. All DNA viruses are double DNA virus, double stranded DNA viruses. Parvo तो single stranded DNA है. Okay, so parvovirus is the only single stranded DNA virus. Okay, this P is Phage, bacteriophage. Okay, डन. ये क्या है? इतना सारा क्लस्टर ऑफ वेसिकल्स और ब्लिस्टर्स. दिस इज herpes simplex, genital herpes. ऐसा कोई भी फोटो आए, so this might be genital herpes or skin herpes. Basically they're talking about herpes simplex virus 1 and 2. Basically what will they give you? They will give you the history of Zank smear, and you are going to see the multinucleate giant cells. The multinucleate giant cells or MNGCs in the herpes simplex. क्या दिखेगा? Multinucleate giant cells. The moment you see hear these words, multiple painful vesicles, multinucleate giant cells, Zank smear, you know they are talking about herpes simplex virus 1 and 2, which is a DNA virus again. What is happening here? This is mumps. Can you see the bull neck? The bull neck of the mumps actually belongs to the Paramyxoviridae family. It actually belongs to the Paramyxoviridae. It actually belongs to the Paramyxoviridae family, right? So there is these are what? These are RNA viruses. It can lead to bilateral parotitis. क्या हो रहा है यहाँ पे? Parotitis हो रहा है, ठीक है? Enlargement of the parotid gland. Epididymorchitis हो सकता है. Orchitis, basically involving the epididymis, involving the testes. If it is the female, then it can lead to oophoreitis. What is the vaccine strain of mumps? Vaccine strain, Geril went up the hill, got mumps and came down. So the Geril strain mumps, okay, for the vaccine. Then amongst the Paramyxoviridae family, what do you have? MMRP. So you have measles, mumps, and obviously not rubella, so respiratory syncytial virus. Para-influenza and Hantanepa. Now, all of these paramyxoviruses, they have hemagglutinin and neuraminidase. Not all have hemagglutinin and neuraminidase. If both hemagglutinin and neuraminidase are present, that belongs to Orthomyxoviridae, which is the influenza virus. If only hemagglutinin is present and neuraminidase is absent, then it is less. Less what? हाँ है and ना नहीं है. ओके हाँ है एंड ना नहीं है. मीजल्स. मम्प्स में क्या हो रहा है? दोनों हैं. बोथ आर प्रेजेंट इन मम्प्स. देन RSV में बोथ आर नॉट देयर. पैरा इन्फ्लुएंजा में बोथ आर देयर. नीपा में बोथ आर नॉट देयर. ठीक है. दैट इज हाउ वी रिमेंबर पैरामिक्सोविरिडी फैमिली. वेरी वेरी इजी टू रिमेंबर. Measles, mumps, RSV. So they are all RNA viruses. All RNA viruses. So easy to remember. If they ask you what type of a virus is Nipah virus, it is an RNA virus. Then viral exanthems of childhood. In the childhood, you have the viral exanthems: measles, rubella, scarlet fever. Then erythema infectiosum. Most favorite of everyone, the parvovirus B19, with that happy child lying with the slapped cheek appearance. Yes, the slapped cheek appearance of the child with the erythema infectiosum, called by parvovirus B19. Abhi we saw parvo to single stranded DNA hai, right? So it leads to the slapped cheek appearance. Then roseola infantum is actually human herpes 6 and 7. It is also called as the sixth disease. Parvovirus also called as the fifth disease, right? Then you have the hand, foot, mouth disease by the Coxsackie group of viruses, the Coxsackie A virus, where in the hand, foot and mouth there is the blisters which is formed in the child. So all of these can lead to the viral exanthems of childhood. What is important about measles? The three C's, which is the cough, coryza and conjunctivitis. Cough, coryza and conjunctivitis, which is the three C's which is there. Then on the 12th day he is going to have the Koplik's spots, which are the spots on the against the third molar tooth, right? On the third molar tooth. And then on the 14th day there will be the rashes. So how does the timeline of measles work? On day 1 or on day 10 you're going to have the 3 C's. Then day 12 you're going to have the Koplik spots, and day 14 you're going to have the rash. Okay, that is measles for you. Correct? Done? Okay. Then amongst the viral hemorrhagic fevers causing arboviruses, you have very important families. Amongst arbo means arthropod borne. This is not a taxonomic classification. This is a normal classification telling you that arthropod borne viruses are the arboviruses. Amongst them you have the choga or the toga. So choga is like chicken, na? So choga or toga. What is this? This is a choga. Choga is like a cape. So choga or toga viridae. So who will wear a choga? The ones who chicken out. So chikungunya. Chikungunya is your toga viridae, which is an arbovirus. And then what is this? This is a kid, and this kid is wearing a yellow vest. So yellow vest kid is DJ. Yellow से क्या याद रखेंगे? Flaviviridae. Flavi means yellow. So you have yellow fever, West Nile encephalitis, Kaisanur forest disease, Zika virus, and dengue and Japanese encephalitis. They all belong to the Flaviviridae. Then the silver bullets, यानी कि Chandipura. So it belongs to the Rhabdoviridae. It's a bullet-shaped virus, just like rabies virus. Chandipura is a Rhabdoviridae bullet-shaped virus, just like rabies virus. So amongst the viral hemorrhagic fever causing arboviruses, Togaviridae, Flaviviridae and Rhabdoviridae. Very, very important. 3 families. Usme kya ho gaya? Chikungunya and the others, right? So if they ask you Japanese encephalitis, it is actually the most common cause of encephalitis, very commonly in the Gorakhpur belt. So the moment they give you any history of UP, Gorakhpur, child, encephalitis, meningoencephalitis, you should think about Japanese encephalitis. These are arthropod borne. So who is going to transmit chikungunya? It's going to be mosquito. यहाँ पे सब में भी सब mosquito होने वाले हैं. Silver bullets में मैं हमेशा बोलती हूँ, remember that the bullets are lying in sand. So you have the sand fly here. और हम कैसे याद रखेंगे? टिक बॉन्ड कौन से हैं? टिक बॉन्ड C and K. The tick-borne are the C and K. So the Kaisanur forest disease and the Crimean Congo hemorrhagic fever. These are tick-borne. Rest all are mosquitoes. Okay. And this is sandfly. Rest all mosquitoes. Rest all mosquitoes. Yes. So CCHF and KFD is tick-borne, rest all mosquito-borne and sandfly-borne is Chandipura. अब हम बात कर रहे थे Japanese encephalitis. This is also going to be your mosquito-borne. कौन सा? Aedes aegypti. Aedes aegypti है ना, obviously. And this is an epidemic potential. It has epidemic potential. So it can lead to epidemics. सबसे important बात इसमें क्या है? That pigs are your amplifier hosts. Pigs are your amplifier hosts. Then there is the birds such as the herons. Birds such as the herons. What are they? They are the reservoirs. Reservoirs, right? Then you have humans. Humans now are the accidental host or the dead end host. Right? What is the strain, vaccine strain? RA1414-2 strain of vaccine, which is a live vaccine. Okay, live vaccine. What are the injectable strains? Nakayama and Beijing strain. Nakayama and लग रहा है लैग हो रहा है जी. ओके. आई थिंक रात के 10:30 बजे लैग ही होगा, बट वी हैव ऑलमोस्ट कंप्लीटेड एवरीथिंग. वी आर ऑन द वेरी लास्ट लेग. So अभी lag ना हो तो अच्छा है, because we are on the very last leg and we are very soon going to finish everything. Now let's discuss about inclusion bodies and very quickly we will be able to discuss about all inclusion bodies. ये क्या दिख रहा है आपको? Owl eye. Owl eye किस में होता है? Cytomegalovirus. Very simple. What is happening here? This is Henderson-Peterson bodies. Henderson-Peterson bodies or HP bodies caused by molluscum contagiosum virus. This belongs to the pox viruses family. Yes, pox viruses family. ये क्या दिख रहा है यहाँ पे आपको? eosinophilic nigri bodies. Nigri bodies कहाँ से आएंगी? किस में आती है? Rabies में आती है, right? So you have to talk about the inclusion bodies. So if when I say viral inclusion bodies, there can be 3 arms to it. Okay. Now, if they are blue or basophilic, they can be intranuclear inclusion bodies. They are blue because they are basophilic. The intracytoplasmic inclusion bodies are red because they are eosinophilic. Then there can be both intranuclear and intracytoplasmic. When I say both, my mnemonic is Chief Minister of both the states. So CM. So you have the cytomegalovirus and the measles virus. What was happening in cytomegalovirus? Owl eye inclusions. What was happening in measles? Warthin-Finkeldy cells. Yes. What was happening in intracytoplasmic? Let's talk about intracytoplasmic. Now, I have always told you pox viruses are like big box viruses. So imagine pox in a box. So a box which is so big that box cannot fit inside a nucleus. So it has to stay in the cytoplasm. So all the pox viruses actually are the intracytoplasmic inclusion viruses. So let's talk about all the pox viruses now. सबसे पहला OG स्मॉल पॉक्स. ठीक है. स्मॉल पॉक्स में 2 स्ट्रेन्स होंगे. वन इज वैरियोला स्ट्रेन विच कॉजेज द डिजीज एंड द वैक्सीनिया स्ट्रेन विच इज यूज एज अ वैक्सीन. व्हाट इज द डिजीज? पॉक्स. पी से याद रखो पैस्चन. सो इफ दे आस्क यू पैस्चन बॉडीज, इट इज द वैरियोला स्ट्रेन ऑफ स्मॉल पॉक्स. एंड वैक्सीन वॉज गिवन किससे इंस्पायर होके? काउ पॉक्स. काउ मतलब गाय. गाय से याद रखो ग्वारनेरी. So Guarneri bodies is the vaccinia strain. Then we have the foul pox, very famous mnemonic. Foul कब करते हैं? जब बॉल से खेलते हैं. So Bollinger bodies. Bollinger bodies. Then we have the molluscum contagiosum virus. Just seen Henderson-Peterson bodies or molluscum bodies, HP bodies, right? And then the Negri bodies. अभी अभी देखा rabies वाली Negri bodies. Negri bodies in the rabies. Very important, done. 4 important intracytoplasmic inclusion bodies, done. Intranuclear में क्या होता है ना? There are 2 types of intranuclear. Cowdrey type A and Cowdrey type B. Based on Cowdrey, उन्होंने दिया था. क्या निमोनिक है? हे बाप. हे बाप. इसमें से काउड्री टाइप ए ये हो गया, काउड्री टाइप बी ये हो गया. एच से क्या बना? हर्पीस सिंप्लेक्स वायरस. वाई से क्या बना? येलो फीवर. येलो फीवर. ए से क्या बना? अडीनो वायरस. पी से क्या बना? पोलियो वायरस. सो काउड्री टाइप बी इज पोलियो एंड अडीनो. काउड्री टाइप ए इज HSV एंड येलो फीवर. HSV में क्या मिलेगा? मल्टी न्यूक्लिएटेड जाइंट सेल्स मिलेंगे. येलो फीवर में क्या? ओ I think we are back. So हम बात कर रहे थे, we were talking about the hepatitis viruses and we were saying that hepatitis B virus is the only DNA virus. Rest all hepatitis viruses are RNA viruses and the family which it belongs to itself has the name Hepadina, partial DNA in its name, PADNA in its name. ठीक है? And then the envelope is only present in the middle 3, it is not present in the last 2. तो अगर envelope हटा देंगे तो icosahedral symmetry दिखाई देगी. If we keep the envelope, then spherical they will look like. Feco-oral transmission is A and E viruses, feco-oral transmission, and rest all are blood transfusion, sexual, needle stick injury. Rest all 3 will be your blood transfusion, sexual route, needle stick injury, etc. ठीक है. उसके बाद डिजीज क्या करेंगे ये वाले? दिस विल कॉज एन अक्यूट डिजीज. Yes, this will cause an acute disease. C for chronic, C for cancer, C for cirrhosis. So this guy is very dangerous. It's going to be chronic. It is going to lead to cirrhosis. It is going to lead to hepatocellular carcinoma. C for carrier. Okay, so it is going to be leading to almost 80% carrier state also. Rest all are going to be just acute. Okay. Cirrhosis will not be there in A and E, no carrier, no hepatocellular carcinoma, right? It can happen in hepatitis B because that is why hepatitis B is dangerous. The thing is, hepatitis D can also lead to all of this. What is more important? Hepatitis C will lead to a more chronic carrier and, cancer kind of a stage. Right? Then incubation period, very, very simple. Just write 30, 40, then in the middle, write 50. What are these days? 30 days, 40 days, and 50 days. ठीक है? So hepatitis A, E, and C. Hepatitis B is 60 to 90 days. 60 to 90 days. Now hepatitis D, which is a defective virus, does not have a surface protein. So it will always borrow the protein of hepatitis B. So that is why it will always follow whatever hepatitis B is doing. So if hepatitis B is doing 60 to 90 days, this guy will also do 60 to 90 days. This guy will also do 60 to 90 days. Prognosis of hepatitis C is very, very poor. Very, very poor. Prognosis of hepatitis D is also poor because what does D lead to? It leads to super infection or co-infection. Meaning either it will infect when the person already has hepatitis B infection and on top of it D will also come. Or person was already a chronic carrier of hepatitis C and then D also came on top. So D will only give infection when B is present, either in chronic form or acute form. So if D will come, then it will be very poor prognosis again. right? For hepatitis B, it depends. It can be good to poor, but A and E is like excellent prognosis is there, very very good prognosis. 100% recovery will happen in hepatitis A and hepatitis E. Are there vaccines available for A and E? Yes, available. What about hepatitis B? लेते तो रहते हैं सारा time. We keep talking about, बचपन से we are taking the pentavalent vaccine. Hepatitis D के लिए do you need to make a vaccine? I said surface antigen, it is borrowing from hepatitis B only. So why can't I just give hepatitis B surface antigen vaccine only for the hepatitis D? काम हो जाएगा. The worst part is that for hepatitis C we have no vaccines because it is highly antigenically variable also. So if you think about it, the hepatitis C is actually the most notorious and the most difficult to treat one. Okay. Then if you want to talk about the antigens and antibodies in the blood, the first antigen to rise in the blood is always the hepatitis B surface antigen, because that is the topmost. It is just floating about in the blood, so it is seen at the first time. Then what happens after that? The pre-core antigen, that is the infectious antigen, also comes up. The antigen will rise and fall, rise and fall. Whenever the antigen has fallen, only then the antibodies will start rising, not before it. So which is the first antibody to rise in the body? It is actually anti-HBC, the core anti-hepatitis B core antibody, because my body really wants to hurt the virus. So if you want to hurt the virus, the first thing that you should attack is the core value of a person. So instead of making anti-HBs antibodies for the first antibody produces anti-HB core antibody. Then your anti-HBs will come, and then your anti-HBe will come. So that is how they will follow the pattern, right? So if you are given this scenario and this situation and you are asked that what is the circumstance here? So every time the HBs antigen is present, so just remember S means sick. S means sick. Whenever HBs antigen is present, we are dealing with a diseased patient. Diseased patient we are dealing with. ठीक है, this cannot be vaccinated individual, this cannot be recovered individual has disease currently, it has to have disease currently. Okay, then if antigen is present, antibody will never be present, so antibody is not present. What about hepatitis C? Sorry, not hepatitis C, the core antigen, the core antibody. Core antibody can be present, na? It was the first one to rise. It started rising over here only. So if we are somewhere here in the disease, then your core antibody can be there. If core antibody is not there, only surface antigen is there and only DNA is there, that means we are in the very acute phase. Extremely acute phase we are in. Infection is just started. Now antigen is also there. Core against IgM has been formed. Then also we are in the acute phase and we are highly infectious because the pre-core antigen is also there. So we are acute and we are infectious. We are highly infectious at this point of time. Okay, if IgG has now started coming in, hepatitis C, hepatitis B core, then now we are moving towards, it becoming an old kind of an infection. Right now, if only hepatitis B surface is there, IgG is there, and anti-HBe has formed, and DNA is there, then you are getting into the carrier state. You're getting into the carrier state. Now, nobody will ask so much of detail, but you have to understand how the antibodies are working. Right? What is most important to focus on over here is this. Whenever antibodies are present, antigen will not be there. Now it can either mean recovered or it can mean vaccinated. How do we find that out? If core की जगह IgG बना हुआ है, means the body has seen the core antigen sometime. And if IgG के against कुछ नहीं है, बाकी कुछ नहीं है और बाद में DNA भी नहीं है, that means body only saw the surface antigen at point of time in life, made antibodies about it. Baki hepatitis B core, hepatitis B pre-core, any other antibody, nothing else is there in the body. That means simply we had taken the spike protein and injected. So that means the person is vaccinated, na? Vaccinated hai. अब अगर उसने IgG बनाई है कोर के अगेंस्ट, दैट मीन्स इट हैज सीन द कोर एट सम पॉइंट ऑफ टाइम, दैट मीन्स ट्रू इन्फेक्शन had occurred, but now since HBS antibody I am finding, the patient has recovered from the disease. रिकवर्ड फ्रॉम द डिजीज. ठीक है, ये 4 चीजें मेन इंपॉर्टेंट थी. बाकी रेस्ट ऑफ द टेबल यू आर फ्री टू सॉल्व, बट अदरवाइज सो मच डिटेल ना नोबडी विल आस्क. Mrs. 1, a newly diagnosed person living with HIV, has a 3-month-old baby who is breastfeeding. What will you do next? So you have to now talk about infant diagnosis, early infant diagnosis of HIV, early infant diagnosis of HIV. Early infant diagnosis of HIV. That means if the child is less than 18 months of age. Less than 18 months of age. So you have the dried blood spot. The dried blood spot test that you do, and in this you detect the HIV RNA and you do the PCR or the DNA. What is preferred is actually R. So HIV RNA PCR in the form of dried blood spot test is what you have to do for less than 18 months of age for this child. Okay, right? 29-year-old IV drug abuser presents with fever, loss of an oral thrush. Oral thrush. So of course it is HIV positive. Which test you want to do? HIV 1 and 2 antigen antibody combination immunoassay. Do you want to do combination? Let's see. Antibody differentiation, only antibody. Do you want to do HIV RNA PCR? No. This is for viral load. CD4 T lymphocyte. This is a good test just to tell you the status of the patient, not necessarily for diagnosis. What is preferred these days? A. What is this? This is the 3rd or the 4th generation ELISAs which is preferred. 4th generation ELISAs. So for children you have to do the PCRs. In adults the PCR is only done when you want to do the viral load detection, and this CD4 count monitoring is your non-specific monitoring. Non-specific monitoring, or you can do the disease progression monitoring. Disease progression monitoring matlab, is my treatment working? Is the disease really progressing? Is the patient really becoming bad? Or is the patient improving on my ART therapy? Okay. Chalo, we have covered so much today. Really congratulations to you guys for really attending such long sessions for such a long time and staying with us, and the class really extended by a lot. I am also tired. You guys also must be tired. So, really happy learning. I hope you really enjoyed this session, and kudos to you guys. Of course, your exam is going to be very, very good. All the best, guys. Stay tuned, stay blessed, and hopefully we will enjoy very soon with your results. All right, thank you so much guys. I will see you guys soon for some other exciting session. So we have really tried to cover a lot today. It becomes a lot, but then that is what a marathon is about, just quickly flipping through all the information and putting everything inside our brains. All right guys, so the workbook is going to be available very, very soon. I will see you soon next time. Take care. Bye bye.